But we will all honor to stick to the time so that we can finish our talk in the evening and inaugural session could be started right on the time. First, may I respect our honorable chairpersons to come on the dais. Dr. S.S. Chatterjee, past President CSI Bihar Chapter, ex-Director IGIC. Dr. Uma Shankar Prasad Sir, ex-HOD Medicine, Nalanda Medical College, and my teacher. Dr. B.P. Singh, ex-HOD IGMS Cardiology and past President, not of CSI Bihar Chapter, rather he was Vice President and President interim for 3 months for the National CSI. So IGMS has grown under his leadership. Dr. Vijay Chari, is he there? No. Then I invite panelist Dr. Seal Avnish. Seal Avnish, HOD, CTVS? No. Dr. Rajan Kumar, Dr. Anup Singh, my friend, IGIC, and Dr. Arundhati Patna. Please come on the dais. I request chairpersons to invite first speaker.
Good morning, everybody. On behalf of CSI Bihar Chapter, I welcome you all, and I invite Dr. Ajay Kumar to speak on a very important subject which is not very well known to many of us and which is not very common in the clinical practice at the moment. A 40-year-old patient, old past PCI patient with high LPA without traditional coronary risk factors, how to approach.
A few words regarding Dr. Ajay Sinha. He is the director in clinical cardiology, Jai Prabha Medanta Hospital, a very brilliant student from Patna Medical College, and also obtained MD from a very prestigious institute, PGI Chandigarh. Thereafter, he obtained so many fellowship, and he is always engaged in academic activity. Over to Dr. Sinha, please.
Thank you. Good morning, and let me thank all the chairpersons, Umaji, who has been my senior mentor, and Dr. B.P. Singh, a great person who has inspired me a lot. Dr. Chatterjee is a super person. He has always inspired us, and we have tried, to do better and better under the leadership of everyone. And and the panelist, Anup, a very younger brother to me, Arundhati, and all the. So thank you, CSI Bihar, people sitting in the front, Ashok, Dr. Nishant, Dr. Sanjeev, and sir, I'm forgetting name. Yes, Sanjay Pandey. Dilip ji is here. Again, he's been a great inspirer. I've got a lot of inspiration from him. See, I was just talking to Dr. Chatterjee, and we are trying to recapitulate who was the person who gave the first concept. And this was Enas and Enas. And, it was just came from our mind that the first person who wrote everything on lipids was Enas and Enas. Indian guy who is settled abroad, and so I have been challenged with this topic, that 40-year-old post-PCI patient. So he is a relatively young person with a high LP content without traditional coronary risk factor. I mean, this kind of question only Nishant and Ashok can do, I know. I mean, they are very, because I know them from my core of heart. So this is a clinically important but tricky issue. And the catch point is that there was no traditional risk factor like diabetes, hypertension, and so on and so forth. But lipoprotein was raised. They did not give me any figure. So let me see what I can do. Before we go to this topic, we like to make you aware that what is this LPA business. LPA is basically LDL-like particle which are attached to ApoA and phospholipid which is oxidized. So these three components have got different actions. That's very important. So what are the functions? How is the devil doing? Devil is targeting three things. One is it is atherogenic. Secondly, it is prothrombotic. And third is pro-inflammatory. My God, so everything is done. Whatever you want in a coronary artery disease in a younger individual, this is all done. And we should not remember that another issue is aortic valve stenosis has got a great bearing with this molecule. So we have to remember that. So almost 20-25% of the world population is having raised LPA. India, we have two persons I have seen who have worked, Dr. Professor Gambhir and one more guy, I'm forgetting. So two people have done a lot of work in this area. Why this is important? Why this is important? Because, you know, it somehow causes a vulnerable plaque, which many people will talk today. And we have seen in CT scan and carotid intima media thickness and all those things, and even the higher imaging things, that LPA, raised LPA, makes our plaque more vulnerable. So this is a genetically determined condition. It's an independent risk factor. It doesn't require triglyceride or anything. It is an independent villain, I would say. Atherosclerosis, thrombosis, and premature CAD. And the level remains static throughout the life. So what is, I call it pleiotropic LPA. It has got a pleiotropic effect, which we have discussed, and I discussed about oxidized phospholipid. So this is the case. Forgive me for giving something extra, which I thought was not given to me. LPA level was 85 for this patient. And so how to manage post-PCI? Statin therapy was maintained to optimize LDL cholesterol level. And we know that there are several residual risk factors we have to think about. Genetic counseling, of course, has to be done. So how much raised LPA is important in ACS? More than 50, normally it is said. People give in millimoles also. Why millimoles? Why millimoles? Because millimole is the real thing, which will give us an idea of, you know, atherogenicity and other things. If you are giving in milligram, probably we are measuring the whole weight. But millimoles indicates the number of particles. So that's very important. Normal, we know that less than 30 is important. So younger individuals we define less than 60 years, and less than 50 milligram is important. It raises the chances of ACS by 3 times. And with every 10 milligram rise, 4% increase in ACS chances. So that's very important. And it has a relation with coronary artery complexities also. People have said that syntax score more than 22 will be there. So how to diagnosis is very easy. You make a diagnosis. We have already given this. Family screening is very, very important. And sequential imaging is important. We should not be happy about whatever we have done. That's all. You know, we should be following up those patients and their family with coronary CT angiogram or whatever modality we have. So what is the treatment? What is the management? Aggressive secondary prevention is very, very important. And LDL target is what? Less than 55. And less than 40 if there was a recurrence in less than 2 years. So what do? As we know, all of us know that statin plus ezetimibe is the answer. But if the target is not achieved, then we go with PCSK9 inhibitor, which is available in Indian market now. And they lower the LPA level by 20 to 30%. Risk factor optimization, nothing to say about it. We have to maintain a zero tolerance. Zero tolerance means, everything and everything. Just I want to highlight a new villain, and that is chronic kidney disease with ACS. I presume that this patient's creatinine was normal. Yeah. But then, if the creatinine is raised, if person has got CKD, then this is another villain adjoining this. Antiplatelet, we know that sometime, double antiplatelet can be continued beyond the guidelines-based thing. You can go beyond 1 year in presence of a high LPA. So take home is 40-year-old PCI raised LPA, treat very high risk, and then we have discussed about high intensity plus ezetimibe. And before I go into my conclusive slides, I would give a two case which was presented at ACC 25. ACC 25. And these cases, both the cases were, I have copied from ACC 25. And this is 30-year-old woman who presented with inferior valami, angiography revealed total occlusion of RCA and SCAD. And after thrombectomy and stenting, she had recurrent non-ST elevation MI due to RCA instant restenosis. Hypercoagulable workup was negative, but LPA was elevated at 202 nanomole. Genetic testing was done, and this patient, post-aspiration thrombectomy and things like that, and it was found that he had a raised LPA level. Another patient, again this example comes from ACC 25, again similar thing. Coronary image angiogram shows a spontaneous coronary artery dissection, distal circumflex artery with thrombus, and right coronary artery resolved right coronary artery thrombus. So the whole era of LPA started in 2018-19, and a lot of paper, a lot of research workers started working on this, and this was the guidelines which came in 2019, and this says that LPA measurement should be considered at least once in each adult person's lifetime to identify those with very high inherited LPA level. And LPA should be considered in selected patient with family history of premature CVD. So premature CVD, your eyes should be open. That you must measure LPA. So what is there? We have talked about the PCSK9 inhibitors. Now I like to focus your attention towards emerging therapy in this field. And they are antisense oligonucleotides. Pelicarsen is in the phase 3 trial. So many molecules are coming. And oral agent is also coming. Mubalapine. And what is the target? Target is spoil ApoA. You destroy ApoA and you are done. And there are so many trials coming on, and this is several specific LPA lowering medications. And I would like to just enumerate you. Niacin is there, but niacin has not shown any clinical benefit. That is very important. It is there, it reduces the level. And other thing is lipoprotein apheresis, which is very, very effective, but very costly, not available everywhere. Research is on. See, these are the trials. Even for Orion 11 on inclisiran, this is shown to improve the LPA profile. So this is a very nice article which came in ACC, JAC, and this is the ODC platform. Should we measure LPA post ACS? What should we do with the result? So we have all discussed about it, and I keep the question open to you. Again, this is another one. So way forward is raised LPA and increased risk of MACE, stroke and cardiovascular death in PCI patient. We have discussed about the target, stand therapy and PCSK9 inhibitors. So this is my final answer for this patient, which we have already discussed. We try conventional therapy, we try reducing LDL, we try if doesn't suffice, then we go for PCSK9 inhibitor. If it doesn't suffice, then we go for newer drugs which are coming up. So with this, I think I'll give you a summary slide, which is this, very simple to understand, nothing great in it. And quick take is lipoprotein A is an independent risk factor for atherosclerotic cardiovascular disease and calcific valvular stenosis. That's very important. Now we are in the era of, we are changing the valve surgically, TAVR. So in the era of TAVR, if you don't do LPA, that is bad. You think about it, because many patients are coming again and again. So re-TAVR, 3 times TAVR. So this is a reality. So with this, I think I will say that we are still improving. We will be learning till the end of our career. And there are many unanswered questions, which I am not going to discuss here. But there are many questions, queries on this molecule. But soon it will be sorted out very well. Thank you very much, sir.
Thank you, Dr. Sinha, for the brilliant review on the subject. Can you comment in one line?
Yes.
Inclisiran, role of inclisiran in
Yes.
management high LPA
Yes.
and
So-
oral PCSK9.
Yes,
The
only
two drugs.
trial, which is Orion 11 trial, which has shown that this molecule, this inclisiran can reduce LPA level, but not to the extent which we have seen in other newer drugs. But inclisiran definitely has got some role. In fact, the guy who, they are makers of inclisiran, they sent me few slides yesterday night, and I saw them that this is one of them.
Thank you, Dr. Sinha. I have just one question. That
Yes.
I fully agree with what you said about LP(a), but among all the international societies and the guidelines, only I think ESC and National Lipid Association USA recommend that they have a class 1 recommendation, at least once in lifetime it should be measured.
Yes.
Others, it is class 2A or it may be considered.
Yeah, wherever the guidelines have given, this is 2A. You see the guidelines 19 2A, and now we are coming with a lot of the recent consensus has given heavy weight on this, and I think in coming 1 year time, we'll have many undiscovered things coming up.
And thank you. Just one question that. Just one question that
Yes, yes.
we do have alirocumab, evolocumab that reduce about LDL by about 60%. They do have a reduction, as you mentioned, about 20 to 27%, 25%, even with for LP(a).
Quite
LPA.
right. Quite right. Quite right.
Yeah.
Yeah, PCSK9 has got definite role. If thank you.
Thank you, Dr. Ajay Sinha, for your brilliant presentation. The second talk of this session is, the topic is adult vaccination for cardiovascular prevention in a patient with high cardiovascular risk. And the speaker is none other than Dr. Shamsad Alam. And Dr. Shamsad Alam is currently Associate Director in Interventional Cardiology, Jayaprabha Medanta Hospital, Patna. He is a brilliant young cardiologist of Patna. Regarding adult vaccination, all of us will agree that vaccination in children is universal. Vaccination in pregnant ladies is also very common, but vaccination in adult population is not common. I am basically a physician. I do find that very few persons in the adult population, they are vaccinated. Let us see what Dr. Shamsad has to speak on adult vaccination in cardiovascular protection. Over to Dr. Alam.
Yeah, good morning, everyone. So it's an early morning, and let's start with a very uncommon topic. But nowadays, after the advent of SARS-CoV-19 infection all over the world, the importance of vaccination, especially for prevention of respiratory infection of heart failure patient, has increased. And we will know that why it is important. We have a lot of trials. Basically, it is not like that vaccination has to be done. We have a lot of evidence. Large trials have been available, and it is known that in cardiac patient, the mortality is not per se only due to the complications of cardiovascular disease. It is not that only sudden cardiac death and heart failure and cardiogenic shock and atherosclerotic cardiovascular disease leads to death. The other risk factors, other factors which can lead to death are these comorbidities, especially the respiratory infections. So this will be our agenda: why vaccination in adult cardiac patients, how it is linked, what are the key vaccines, what are the recommendations for new guidelines, ESC and AHA, and safety issues, because a lot of issues has been the concern regarding, especially regarding COVID-19 vaccine infection and how we should stratify it. So this is very important because acute cardiovascular events can be triggered by respiratory and systemic infection, such as myocardial infarction and stroke. Large epidemiological studies have shown a marked short-term increase in risk of AMI, and also preventing infection from vaccination. There is a significant reduction in potential of hospitalization and even mortality. So this is the most recent paper which has been published in June 2025, this is very important because it has been a consensus statement from everyone, from European Society of Cardiology, along with combination of Heart Failure Society, and also in combination of American Heart Association. So the studies, they have shown that there has been 3% of death and 5% of hospitalization with influenza and pneumonia, and it can be attributed to heart failure due to respiratory infection. Second, the attributable risk of population for coronary artery disease due to influenza, it is almost 3.9%. The data from the ERIC study, it suggested that there is 5% increase in monthly influenza activity, and it is associated with 24% increase in hospitalization rates due to heart failure or coronary artery disease. COVID-19, it has increased to substantial cardiovascular risk, especially in the early pandemic. It was seen that patients were suffering from heart failure, patient had events of sudden cardiac arrest, patient had events of coronary artery disease, patient had event of increased thrombogenicity leading to acute myocardial infarction. Other part, it is not important that only influenza and COVID-19 infection is important. Apart from that, respiratory syncytial virus, parainfluenza, pneumococcal pneumonia, it also increases the cardiovascular morbidity and mortality. So what I said that as per my topic, it is not important only in those unhealthy patients with high cardiovascular risk. It is also important in healthy individuals. When it was studied as compared to healthy individuals and susceptible groups, especially who were older individuals, those with congenital heart disease, and those who were pregnant. So potential benefit was very significant in those patients who were at high risk. But also potential benefit with MACE-free survival was seen in those patients who were vaccinated, especially healthy individuals. So overall, the MACE is decreased significantly in the high-risk group, and also MACE was decreased in the healthy substate of the patient. This is the global burden. As we know, day by day, the global burden of cardiovascular diseases in the form of acute myocardial infarction, heart failure, and stroke, it is increasing and increasing more in males as compared to females, what as per the data all over the world is saying. And this is the implication. What does respiratory infection, influenza infection, pneumococcal infection leads? The cardiovascular implication: myocarditis, pancarditis, pericardial disease, cardiomyopathy, ECG abnormalities. We can see vasculitis leading to myocardial infarction, cystic obstruction, and myocardial ischemia. These are the precipitating factors. So how we link? Acute infection, they trigger a surge of pro-inflammatory cytokines. The level of IL-1 and IL-6 is significantly increased, and they lead to destabilization of the stable atherosclerotic plaque. So this is the mechanism how active influenza infection and active pneumococcal infection leads to acute myocardial infarction. Endothelial activation occurs and endothelial dysfunction is there, which leads to increased vascular permeability, and vasodilatation is impaired. Thrombogenicity in this case, what we have seen incidences of both arterial thrombosis as well as venous thrombosis in COVID-19 infection. The hemodynamic stress due to fever, tachycardia, and hypoxemia. The myocardial oxygen demand is increased. So that's why the morbidity due to heart failure, it is significantly increased in these patients. And these are the clinical impacts: acute coronary syndrome, arrhythmia in the form of sudden cardiac death, VTVF, as well as bradyarrhythmias are seen with the viral infections and heart failure exacerbation. What I can say that almost 1/3 of heart failure hospitalization, they can be attributed to recent respiratory infection. Whenever any patient is admitted with heart failure, we just ask him whether he was having any kind of respiratory infections in the recent 3-4 weeks, or whether he has been in contact with any person who was having active respiratory infection. So these are the inflammatory mechanism which leads to the occurrence of atherosclerotic acute events or occurrence of heart failure hospitalization. Basically, all of these are related to increase in the pro-inflammatory cytokines levels and endothelial related dysfunction, the mechanism which leads to all of these. These are the main mechanism which leads to the complication, morbidity, and mortality due to these things. These are the data from the IME. Actually, 2 major trials were very important: IME trial and the ongoing DanFlu-2 and DanFlu-1. DanFlu-1, the data is available. DanFlu-2, the data is yet to come because it is yet to be completed. But the data is quite convincing. There has been significant decrease in heart failure hospitalization. There has been significant decrease in morbidity and mortality of the patients. So 5 major trials were done. InvesTED trial with influenza, these are the 5 major trials with influenza vaccinations. So InvesTED trial, no significant mortality benefit was seen. IME trial, there was after influenza vaccination, or when it was done early after myocardial infarction or in high-risk coronary artery disease, it leads to significant decrease in all cause of death, myocardial infarction, stent thrombosis, and also decreased risk of all cause death and cardiovascular death was seen even after the interval of 1 year. In DanFlu-1, the incidence of hospitalization was significantly decreased, and it also decreased the all-cause mortality due to influenza infection. And the DanFlu-1, it has almost more than 12,000 patients recruited. So it was a big trial. The DanFlu-2 trial, which is already undergoing, it has almost recruited up till 3.5 lakhs of patients till now, and the data are quite convincing. But yet it has to be published so that we can get a quite strong and data so that we can propagate it further in our guidelines very strongly. The vaccine against the viruses, the important one is the COVID-19 influenza, papilloma virus, and respiratory syncytial virus. So syncytial virus vaccination, it is not available to us. The risk of decreasing by long COVID is almost 43%. HPV, why it is important? We were only talking about the those viral infections which are leading to respiratory infection, but HPV vaccination, it was seen that with HPV infection, there was 4-fold rise in the risk of coronary artery disease and a stroke. So basically, it leads to increased thrombogenicity. So almost it appeared to 100%, the vaccine appears effective in almost 100% individuals. With one study, it showed that normalization of excess cardiovascular risk was there in vaccinated women also. So coronavirus disease, the benefits of vaccination was the severe infection was significantly reduced, the hospitalization was reduced. It was seen that myocarditis was found, the increased incidences of myocarditis was found in those patients who were recently vaccinated with coronavirus. So everyone is confused that this coronavirus vaccine is the main culprit of cardiovascular morbidity and mortality. So let me be clear, when the data it was re-studied, it was found that myocarditis due to vaccination and myocarditis due to COVID-19 infection, there was a significant gap. if it is occurring, suppose one patient is in out of 100, he is suffering from myocarditis due to COVID-19 vaccination. But when it was compared to those patients who had COVID-19 infection, so due to COVID-19 infection, 6 times higher incidence of myocarditis was seen as compared to those patients who were vaccinated and they were having myocarditis. So better to get vaccinated with COVID-19 to avoid the incidence of COVID-19 associated myocarditis. Now, the next viral vaccination is herpes zoster. So, shingles, whenever active shingles is there, it leads to vascular inflammation. So, risk of stroke and myocardial infarction is increased. So, basically, vaccination in adult patients, especially in elderly patients with shingles, it may prevent the infection-associated triggered vascular event. The different observational study in meta-analysis showed there was significant lower risk of a stroke and myocardial infarction after shingles vaccination. So, it is recommended in all older adults for prevention. In younger adults, it is usually not recommended because in the guidelines, it has been postulated that all patients above 65 years, it has to be vaccinated with shingles, and above 55, it has to be done to most of the patients if required, or those who are at high risk. The RSV vaccination, recently approved RSV vaccinations are there, which have shown high efficacy, but the data with RSV vaccination to decrease cardiovascular mortality and morbidity is yet to come in our trials. Against bacteria, we were talking about the vaccination for viral infection. For bacteria, pneumococcal is the most important infection which leads to respiratory morbidity and which further culminates into heart failure, coronary artery disease, and acute myocardial infarction. So it was seen that when our patients were vaccinated with pneumococcal vaccine, it was almost 60 to 70% effective in preventing an invasive disease. So whenever an invasive disease is yet to occur, it can be prevented by almost 2/3 times by active vaccination with pneumococcal vaccination. And the meta-analysis, it showed that there is a significant almost 10% reduction of any cardiovascular event, even including myocardial infarction in those patients who were elderly, who were above 65 years. So the data are quite convincing with pneumococcal vaccination, and it has come in trials also. So robust evidence is not needed for this because we have a lot of robust evidences. So now the question is when to vaccinate. All of us are a lot of confused that if my patient is admitted with acute heart failure, if my patient is recovering in hospital from acute heart failure hospitalization, whether my patient has to be vaccinated with influenza and pneumococcal vaccine or not. Yes, influenza and pneumococcal, it can be given in hospital whenever a patient is admitted with heart failure, or even with active respiratory tract infection, it can be given. Simultaneous vaccination, at times we advise our patient to take influenza vaccine now and to take pneumococcal vaccination after 7 days. It is not recommended. You can give simultaneous vaccination with influenza as well as pneumococcal. And COVID-19, it can be given in acute heart failure hospitalization also, and simultaneous vaccination can be done. And regarding herpes zoster, it is said that in active infection, it should be avoided, and the schedule has to be maintained at different intervals. It is said that at every 5 years interval, you take shingles vaccine. Now, we have a special group of patients which are those who are at very high risk, those with pregnancy, those with congenital heart disease, and those who are going to have heart transplant. So with congenital heart disease, especially in those patients who are having association of asplenia, basically these patients had to be vaccinated with pneumococcal vaccine just after the age of 2 years, because after the age of 2 years, the protection from pneumococcal, the innate protection from pneumococcal, it is lost. So every 5 years, they have to be vaccinated with pneumococcal vaccine. Second, those with moderate to severe or cyanotic congenital heart disease, they should be vaccinated with pneumococcal as well as influenza vaccine and COVID-19 vaccine. And finally, an entity called a DIGEAUS syndrome. These patients have altered cellular immune deficiency. So basically, these patients should avoid live vaccine, and other vaccine can be given to them. Now, coming to pregnancy, influenza, the COVID-19 and RSV vaccination can be given safely, and the active live vaccine should be avoided in these patients. whenever a patient is planned for cardiac transplant, these are the 10 vaccines which should be given. It is mandatory to, because as per the ISHLT guideline checklist, these patients should be vaccinated with these 10 vaccines before undergoing cardiac transplant. These are the recommendations. The recommendations are very strong. The 2024 ESC guidelines, it recommends vaccination against influenza, pneumococcal disease, and COVID-19 infection to prevent the complication of chronic coronary syndrome. The 2023 AHA-ACC guidelines, it also told that in patients with chronic coronary disease, an annual influenza vaccine is recommended to reduce cardiovascular morbidity, cardiovascular death, and all-cause death. The AHA guideline, it also recommends annual influenza vaccine in patients with ACS. Whenever we get a patient of acute myocardial infarction, STEMI or non-STEMI, admitted in our hospital, whether he is having LV dysfunction or he is not having LV dysfunction, better to get him vaccinated in hospital so that he doesn't misses that vaccination after discharge, so that the morbidity and mortality is decreased. In heart failure, when it comes to heart failure, it is quite mandatory to get my patients vaccinated with both influenza as well as pneumococcal vaccination, and including COVID-19 vaccination if it has not been taken earlier. So this is very important. So 5 important vaccine: COVID-19, flu vaccination, respiratory syncytial virus vaccination, shingles vaccination, and pneumococcal vaccination. It has been approved as per the AHA guidelines. What we take the message, so non-vaccination, it is an active decision. Let it be, if a patient doesn't want to get, not get vaccinated, so let him decide. But from our side, we should advise vaccination of all these 5 entities to my patients of coronary artery disease as well as heart failure, because the risk of vaccination, the risk due to vaccination, they are minimal, and they can be overshadowed by the health risk of non-vaccination of these patients. Thank you.
Thank you, Samsad, for brilliant view on the subject. Any comment? Kandesh, Anu?
Dr. Samsad.
I have a question, Dr. Shamsad. You mentioned about COVID vaccine myocarditis. Now, whatever myocarditis, which is much less than myocarditis due to COVID-19, if you compare the two, COVID-19 myocarditis and vaccination-induced myocarditis, whatever has been most of the data reported are from the messenger RNA vaccines like Pfizer, Moderna, which are not available, which were never marketed in India. Are there any data on Indian vaccines and myocarditis?
That quite robust, because the large data is available from the mRNA vaccines. It was seen that the vaccine-associated myocarditis, when it was compared to COVID-19 associated myocarditis, the COVID-19 associated myocarditis, it was almost 6 times as compared to vaccine-associated myocarditis. And the mechanism was almost same. The inflammatory cytokine levels increase. So that's why it was observed that vaccine-associated myocarditis, it was more prevalent in the younger patients because they have a more active inflammatory response after vaccination.
And that was with Pfizer, Moderna, which were used in Europe and America, North America.
Yes.
Shamshad, the list of vaccine is more in compared to the pediatric population. It is not possible to prescribe these all vaccination. What are the most important vaccines that we prescribe to the patients? Probably pneumococcal and influenza I prescribe. Other vaccine you prefer?
Basically, I said that in pediatric patients, the recommendation is for influenza and pneumococcal vaccination. It is very important, especially in those pediatric patients who are at high cardiovascular risk, especially those pediatric patients with congenital heart disease. Those pediatric patients who are healthy, so routine vaccination with influenza and pneumococcal vaccination, it is not recommended with a healthy pediatric population who is not having any cardiovascular disease.
For adult population?
For adult population, what I said that annual influenza vaccination, it should be done to almost everyone.
Thank you, Samsad. We conclude the session. Samsad is here. We can ask questions. Dr. Sinha, please. Next speaker is Dr. Vikas Singh. Please. He is speaking on atherosclerosis timeline, how and when to intervene. Very important topic, how to prevent atherosclerosis by early intervention. Currently, too much, too late. We have to change the paradigm early intervention. Dr. Vikas, please. He doesn't require any introduction. He is well known in Bihar, and presently he is Director of Universal Cardiology and Intervention Cath Lab. Thank you. Vikas, please.
Thank you for the introduction, sir. A very good morning, respected chairpersons and delegates of DIAS. And let me thank the organizers for entrusting me with a topic which is not only very basic and which forms the basis of most of the work that we do in cardiology, but this is also a very futuristic topic in the sense that a lot of work is being done in this direction, and I'm sure in times to come, every one of us is going to hear more and more on this topic. So this is a very basic slide from our pathology days, development of atheroma, and we know how LDL particles that enters through the damaged endothelium that gets converted into oxidized LDL, that is taken up by macrophages, changes into foam cells. The entire cascade of inflammation goes on there. Then there is migration of vascular smooth muscle cells across the internal elastic lamina, and the whole process of atherosclerosis takes place, very much like what is shown in this video. The accumulation of LDL particles, the formation of foam cells, and ultimately narrowing of the lumen, which forms the basis of atherosclerosis. Now, we are more concerned about subclinical atherosclerosis, where atherosclerosis has not given rise to any clinical condition as such, but that has started taking place in the arteries, and this is considered to be the precursor to important ASCVD events. It is gaining critical importance because of the escalating global prevalence of ASCVD. So we want to get deeper into it. What else can be done to prevent it right in the beginning? Now, detecting the presence of atherosclerosis in otherwise asymptomatic individuals is now possible with imaging techniques like vascular ultrasounds, CT coronary angiography, and coronary artery calcium scoring. We know plaque progression precedes cardiovascular events, and that is the basis of entire understanding of this topic, why we want to intervene early before cardiovascular events has occurred. Now, initially the cholesterol deposition that occurs, gradually the fibrotic plaque occurs, and then because of the rupture of the plaque, an acute episode occurs. If you go by the plaque definitions, you have initial lesions, then fatty streaks that we talk about, intermediate lesions, atheromas getting converted to fibroatheroma, and then complicated lesions, which is the immediate precursor of any adverse cardiovascular event. Important word would be not all plaque is modifiable, so it is important to address changes early in patient's life. Now, if someone has developed a complicated lesion, type 6 lesion, and you want to revert it from there, that is not possible. Yes, initially, if you want to control the fatty streak and the intermediate lesion, that can be done with the tools that are available. Now, just have a look at the typical timeline of development, and that will open up the minds of many. Atherosclerosis begins in the teenage years as early fatty streaks. So it all starts very early in life. Don't think that your child is 18 years of age and he cannot develop atheroma. Now it gradually develops over decades into advanced plaques. The timeline varies because there are so many factors which are acting in tandem, not only the genetic factors, but also the environmental factors. So there cannot be one rule for each and every individual, but it all starts very early in life and then goes on progressing unless and until you do something to stop it. So if you look at a healthy artery, it has a smooth endothelium which has a normal blood flow, but still here, you should be looking at promoting a healthy lifestyle. So every point of time, you have an opportunity to keep on doing something that will make you or that will keep you healthier in times to come. Now, early stages, the teenage years to 20s, that is where fatty streaks comes. That is the earliest sign. It can be found in the aorta in the first decade of life. In coronary arteries, it is usually seen in the second decade. These are not clinically significant, but mark the start of the disease. Lipid deposits begin under endothelial lining. And here also, you need to go for lifestyle modifications and risk factor modifications. So it's never early, I would say. You should be starting wherever you get an opportunity to address the lifestyle and to address the risk factors. Then comes the middle stage part, 20s to 40s, where these fatty streaks are now changed to fibrous plaques. characterized by fibrous cap enclosing a lipid-rich core. These are larger deposits and starting to cause narrowing of the lumen, leading to reduced blood flow and may cause angina. Here is the role for more aggressive therapy like statins, antihypertensives, in addition to the lifestyle measures. And then 40s and beyond, you get plaque complications, more complex plaques, calcification, ulceration, ruptures, plaques hardening, artery losing its elasticity. So the entire story now gets complicated at this point of time. And here you not only require aggressive medical therapy, but many a times you need to go ahead with angiographies and revascularization. So across ages, if you talk about teenagers, they can show signs of fatty streaks. Adults over 40 have a 50% chance of developing serious atherosclerosis. And over 60, most of these will show some degree of atherosclerosis. But as I highlighted in the beginning, this is not a rule for each and every person. There are many factors which are acting in tandem, including the genetics, the risk factors, the inflammation, all of these hampering the overall development of atherosclerosis. Now, this was a very interesting paper that came up recently in JACC, personalized intervention based on early detection of atherosclerosis. And many of the things that I'm going to discuss is based on this state-of-the-art review which came last year. And it talks about the lack of precision in existing risk factor-based ASCVD risk assessment. So at present, what are we doing? We are calculating a risk score for the population based on the traditional modifiable risk factors like LDL cholesterol, systolic blood pressure, smoking status, age, sex. Whereas on a population level, this can be useful, but on an individual level, this is very imprecise. And that is the whole idea now to move towards precision therapy, including many things which is not incorporated in the existing risk factor-based guidelines. As atherosclerosis develops over decades, there is potentially great opportunity for prevention of associated events. And that is the time window where we need to act. Subclinical atherosclerosis has been identified in young individuals. And given the growing burden of CVD, now a paradigm shift is required, moving from late management of atherosclerotic CVD to earlier detection during the subclinical phase with the goal of potential cure or prevention of events. So this is a very interesting slide, I would say. The current practice is primary prevention based only on risk factor assessment, and that is done till an event occurs. And once an event occurs, we now move towards secondary prevention. The whole idea or the whole change that we are talking about now is trying to look for atherosclerosis. If there is evidence of atherosclerosis, start management like secondary prevention from there. So it's more proactive approach that we now talk about. And that is occurring, or that is possible only because of the imaging tools that is now available. Imaging tools are currently the only available methods to directly identify the presence of atherosclerosis. And it has the advantage of directly demonstrating atherosclerosis. So you have modalities like carotid ultrasound, CT angiographies, MR, ankle brachial index, coronary artery calcium. All of these can detect different stages of atherosclerosis. So a lot of emphasis was on CIMT some time back, but we know it's a suboptimal surrogate for atherosclerosis and does not provide clear incremental value over the risk factors that is currently available, and so that is why it is off favor now. Coronary artery calcium has its own advantages. It's a surrogate for non-invasive arterial imaging, but for younger patient population, it has a low sensitivity and specificity because it is unable to diagnose non-calcified atherosclerotic plaques that have a higher propensity to rupture. So we need to move ahead from coronary artery calcium. CT coronary angiography is a wonderful addition because it allows not only detection of significant coronary artery stenosis, but also the non-obstructive coronary artery plaques. However, there is lack of evidence for the impact of CT coronary angiography on patient outcomes in asymptomatic population as of now. So for symptomatic population, this is a totally different ball game. Asymptomatic, this still needs to be substantiated. Now, there are certain trials which are underway, the SCOT-HEART 2, DANE-HEART, where there is a direct comparison between CT coronary angiography and validated cardiovascular risk score. The results will throw more light on how we can better utilize CT coronary angiography. But having said that, this is a wonderful modality. Not only gives you an idea about the type of coronary plaques, the coronary plaque burden also, then the high-risk features like low attenuation plaques. This can be used non-invisively to quantify plaque burden, and thus can give you an idea in which patients you need to be more aggressive in terms of managing them. There is an additional benefit of imaging. Once you are able to demonstrate to your patient that, look, you have blockages starting in some part of your coronary artery, that makes clinician-patient risk communication probably better. And these patients have been seen to be more compliant to whatever advices you give them. So that is just one benefit of imaging. Now, there are certain drawbacks with imaging as well. Radiation and then dye-related renal risks are there. In the future, better methods may become available as the development of non-contrast CT angiography comes up. Then the users might pick up without fearing for the side effects that can occur. Now, one problem with imaging, if you only rely on imaging, is over-treatment. You can't just find atherosclerosis in each and every patient and go on treating each and every patient, because that would be economically not feasible also at this point of time. So what we do is we combine imaging with certain biomarkers which are now available, and a lot of work is being done in this area. Some biomarkers are already available, like C-reactive hsCRP, NT-proBNP, high sensitivity troponins. But in addition to these, a lot of other biomarkers are being explored. Genomics has a definite role. They can help you identify which patients you need to be aggressive in terms of finding out regarding the atherosclerosis and managing them with high-dose statins. Now, this is the whole pictorial representation of how things move from here. You go for health advocacy and health motivation, then early personalized atherosclerosis is done. If there is no plaque, lifestyle optimization has to be done. If there is plaque, then apart from lifestyle optimization, treatment or interventions need to be taken care of. LDL cholesterol at this point of time, lowering LDL cholesterol has definite role in slowing plaque progression, and not only plaque progression, it also modifies the entire disease course by slowing the atherosclerosis progression. You can address LDL cholesterol by lifestyle, statins, or now even the combination therapy like ezetimibe, PCSK9 inhibitors, inclisiran, and bempedoic acid. The recent guidelines has emphasized the role for other therapies in addition to statin therapy, where for some reason you're not able to reach a goal. And combining all these modalities will give you a wonderful reduction in LDL cholesterol. If you combine high-dose statin with ezetimibe and PCSK9, up to 84% reduction is achieved. Now, let me quickly move to the coming slides. So for LDL cholesterol, there is the risk reduction continues even at very low levels without threshold. And the rationale for early intervention of atherosclerosis as put up by WHO is to detect CVD as early as possible so that management with counseling and medicines can begin. Now, LDL cholesterol, without any doubt, is the most important part when you talk about atherosclerosis. If you look at the familial hypercholesterolemia patients, and even patients in which genetic mutations of PCSK9 genes are there, where LDL cholesterol levels are inherently low, the chances of developing ASCVD in these patients is much low. So the future of ASCVD protection lies in precision medicine-based approach, where you screen for subclinical atherosclerosis, use biomarkers, use traditional risk factors also, and in addition, take care of the psychosocial and potential other phenotypical risk factors. Combining everything with genomics will give you a patient-centric or a precision medicine like never before. So there has been many articles regarding stopping stenting and starting to reverse atherosclerosis. That would be an overstatement. Each has its own role, but yes, it's high time that we now start thinking of atherosclerosis. And not only that, the concept that needs to be introduced and accepted is that atherosclerosis is a disease that can be halted or cured if tackled early. Thank you so much.
Rajan?
How to monitor this atherosclerosis progression? Regression, sorry. Imaging or lab finding? Which one should we prefer that in a practical one?
Sir, without imaging, you don't have any other option to find out how your plaque is regressing. So at present, only imaging is the modality that can be used, sir. So that has not found to be very in tune with carotid and coronary atherosclerosis. CMRI can be a tool, sir, but CIMT is not a very sensitive tool to address that. OCT is there, but those are all again invasive, sir.
Yes. I have a question, Vikas.
Sir.
Has HSCRP or homocysteine level estimation got some role in assessing the regression? Do you find it useful?
So that is just a marker of inflammation, ma'am. So that would be very unreliable if you only rely on HSCRP levels.
I have a question, Vikas.
Sir.
He has been, I've known him for more than 20 years now. If you mentioned two non-invasive techniques, CT angiography or CCTA and coronary artery calcium, CAC. Which would be better in detecting?
CT coronary angiography, sir.
Yeah.
Coronary artery calcium only looks at the calcium, whereas in younger patient population, CAC becomes all the more non-important because here calcification is not a problem. The vulnerable plaque, the lipid-rich part, that cannot be picked up by coronary artery calcium, sir, but that can be taken up very beautifully by CT coronary angiography.
Okay.
Yeah, I entirely agree with Dr. Vikas that CT coronary angio is the only way, but that is not practical in persons, say 20 years, 25 years belonging to high-risk group. So we have to see in future what modalities are coming. Thank you, Dr. Vikas, for a very, very nice lecture.
Thank you, sir.
Thank you.
Any comment from the house? Dr. Sawan is here. Any comment? बैठ के ही बोलिए सर.
Now this is time to think new and newer, and this presentation is one of the examples that we are always been talking about plaques and calcium, and we see the imaging of the vessels and the changes in the tunica, intima and media, but everything is not settled. We have not got the final answer as yet. So I think this presentation will add a lot to our understanding and certainly make us to go further. Thank you.
Hello. We could pass on to the next session. I would request Dr. Sanjay Pandey on cardiac rehabilitation for aging heart under 40. Dr. Pandey, please.
Good morning, respected chairs, respected panelists and delegates. At the outset, I would like to thank Dr. Nishant and Dr. Ashoka for inviting me and giving me this opportunity to talk about this cardiac rehabilitation. And also thanks to the previous speaker, Dr. Ajay Sinha sir, who talked about this under 40 year of age, this case, and Dr. Alam regarding the vaccination, and Dr. Vikas regarding this atherosclerosis. So coming to cardiac rehabilitation, the topic of my talk. So I am going to show you few pictures. You might get disturbed a bit, so apology for that. This is the case of Jariwala. Siddharth Shukla, under the age of 40. Again, Puneet Rajkumar, 46 year of age. KK, age 53. Siddharth, age 46. Now Raj Kaushal, age of 50. One of our own colleague, 39-year-old. Now this recent case, 90-year-old, newly married woman, doing Garba. So your heart needs your attention. Actually, our heart needs our attention. Every one of us listen to our heart. This is Ayushman Bharat statistics, maximum claims for angioplasty procedure. Again, in 2005, it was 380 per lakhs. Now it's 641 per lakhs. So, what is prehabilitation? It refers to the proactive, preventive approach, enhancing a patient's functional capacity before a medical or surgical intervention. And the objective is to build resilience so the body and mind are better prepared to handle stressors like surgery and immobilization. Heart attack in people under 40. It has been significantly increased in India over the past decade. 25 to 40% of heart attack patients in some studies are being under 40. A trend often described as an epidemic. And this shifting epidemiological CVD trend in India is undergoing a profound and concerning demographic shift. And once considered a condition primarily affecting the elderly, an alarming trend has emerged over the last decade, that is, heart attack and other severe cardiac events are now striking young adults, often with fatal outcome. And the key statistics is very alarming, as it is definitive and alarming increase in cases under 40. And this is a silent epidemic. Silent epidemic, it's not like COVID and not like others, but it is a silent epidemic, driven by a complex multifactorial etiology, predisposed by distinct genetic predisposition, sedentary stress, and COVID-19. Actually, it's not a significant, it's served as a significant accelerant, exacerbating existing risk factor and bringing this long simmering crisis to a critical point, so that now we are talking here about this silent epidemic. These are the worrisome trend from various studies. Even the IHA corroborate this trend, reporting that 25% of all heart attack in Indian are under the age of 40. And these figures are exceptionally high when compared to global statistics, where heart attack in individual less than 40 constitute only 6 to 10% of all MI. But in our case, it's 24 to 33%. So you can understand the severity of the condition if you compare with the global statistics. This cardiac aging is specifically affecting Gen Z. Their heart is affecting their heart in so many ways. They are biologically aging faster than chronological years, driven by factors like urbanization, diabetes, obesity, and non-modifiable factor also there are. So, recognizing both modifiable and non-modifiable risk factors is crucial, like early detection, lifestyle changes, and managing existing conditions. These can significantly reduce heart attack crisis. And we need to adopt a multi-pronged strategy for prevention that need to be proactive, prevention-centric, and built on early and aggressive screening, comprehensive public health education, systemic reforms in the workplace. Comprehensive public health education means we need to make our public aware about what is coming to them if they are not listening to their heart, not caring about their heart. And systemic reforms in the workplace to reduce the stressful conditions there. Stress is a factor which affects heart in so many ways, and still we don't assess the severity of the stress and its implication on the cardiac health. So we need to have a better stress and sleep management, prioritizing getting 7 to 9 hours of quality sleep per night. And we should not just advise our patient to have a good night's sleep and don't take a stress. They are not going into the market to buy the stress. And it's not like a smoking. They need to just stop the smoking. It is a silent thing coming into their life without their notice and without even their knowing about it. So we need to take a proactive approach, rather, how to manage the stress itself, and need to emphasize in our prescription itself, not only advise them. They will forget after getting out of your clinic. So this is the hidden heart crisis. We need very much early and aggressive screening, particularly for young individuals with a family history of or known risk factor. So what is the prescription for proactive health? Dietary modification, we all know. Physical activity is very much important, because inactivity is a leading modifiable risk factor for chronic diseases, including heart disease. How it helps? It improves your hemodynamic, favorable metabolic and lipid profile change, and enhance vascular health through improved endothelial function. AHA, WHO, CDC, everybody tells 150 minutes of moderate intensity or 75 minutes of vigorous intensity aerobic activity per week, supplemented by muscle strengthening activity, at least 2 days. Data provide a practical and progressive framework. It offers a perspective on the risk of physical activity, because we have heard in many news channels and somewhere like people are doing activity in their gym, exercise in the gym, and they are having this cardiac arrest. But the rare incidence of adverse cardiac event during exercise is overwhelmingly outweighed by the well-documented long-term risk of sedentary lifestyle. This report positions physical activity not merely as a lifestyle choice, it's not your choice, it's not optional, but as a powerful tool, a non-pharmacological intervention that profoundly influence cardiovascular and systemic health. So it's not optional anymore. It's as mandatory as the medicine you prescribe, as mandatory as the intervention you do. This modern epidemic of inactivity and its cardiovascular consequences, we can see associated with alongside high blood pressure, dyslipidemia, that as a cardiologist you are taking care of. This report is framed as a detailed exploration of physical activity as a primary evidence-based tool for addressing this epidemic and promoting long-term cardiovascular well-being. An importance of endurance training for cardiac health, also known as aerobic exercise, is a cornerstone of cardiovascular fitness. It involves activities like elevate your heart rate and respiratory rate for a sustained period, keeping your heart, lung, and circulatory system healthy. It strengthens the heart muscles, it improves circulation, and it reduces the risk factor for heart disease. It lowers your BP, lower LDL while raising HDL, manage sugar, insulin level, and reducing the risk of type 2 diabetes. It boosts your stamina and energy, promotes overall well-being. The oxygen demand during endurance training is measured as MET. MET is equal, you all know MET, so we need to understand MET and oxygen demand. MET is the energy cost of sitting quietly at rest, which is 3.5 ml of oxygen per kilogram of body weight. So we need to advise our patient regarding the light intensity activities, moderate intensity activities, and vigorous intensity activities. Depending on your assessment of, based on Bruce protocol, Borg rating scale, or 6-minute walk test, you just cannot blindly prescribe anything to them based on their cardiovascular assessment or assessing their the capacity of their heart. So endurance training like distance running can significantly increase VO2 max and potentially reaching MET value of 18 to 24 or higher for elite athlete. And the heart benefit is it improves cardiorespiratory fitness level indicated by more MET and inversely associated with the risk of coronary heart disease. How to use MET for training? Assess your fitness. Your current VO2 max in MET can be determined through an exercise test. Set intensity goal. And prescribing endurance training by MET score for cardiac fitness. This endurance training program should be designed to achieve level of exercise capacity that correlate with a lower risk of cardiovascular disease. Endurance training for cardiac fitness generally focus on activities in the moderate to vigorous intensity range, which correspond to higher MET scores. So there is a steady state training, moderate intensity. This is the most common and often recommended type of endurance training for general cardiac fitness, which increases heart rate and respiratory rate. It involves maintaining a consistent moderate intensity for a longer duration. What it is? You should be able to hold a conversation while performing the activity, but feel warm and slightly out of breath. The goal is to elevate your heart rate about 60 to 70% of your maximum heart rate. Brisk walking, jogging, cycling. These are long, lower intensity activities. These are workouts that last for an hour or more at a lower intensity. The focus is on duration rather than a speed or intensity, and you should be able to comfortably carry on a conversation, long bike ride, hiking, a round of golf. And these are vigorous intensity for more than 6 minutes. Example are running, single tennis, and competitive soccer. And this is the high intensity interval training, involves short burst of very vigorous exercise followed by brief recovery period. Sprinting up a hill or stairs or circuit training or jump squat. Health Organization recommends brisk walking, that is 5 minutes for 30 minutes, 5 days a week. So monitor your progress, increasing your peak weight capacity through regular endurance training signify improved cardiac fitness. Personalize your training, which activity are within your safe and effective intensity zone based on their MET value. Understanding MET and recommended for a well-balanced routine. To achieve the best result, combination of different type of training is often recommended. Get at least 150 minutes of moderate intensity activities and broken down in various ways such as 30 minutes of moderate active 5 days a week and a stress management time for yourself. So take home from my side is, in your prescription, when a patient visits to your OPD or your chamber, you must ask him if he is feeling any sort of breathlessness while walking uphill, while climbing up stairs, or while even doing the household chorus. And any of these things are positive, you need to evaluate him for his cardiac fitness. It's not only ECG, not only CT angiography, and not other invasive procedure will tell you the right thing. You need to assess the cardiac endurance capacity by performing different clinical tests. What we do at our AIMS Patna, we run this cardiopulmonary rehabilitation clinic. So we have this 6-minute walk test, this Bruce protocol we follow there, and bore rating scale we ask in our reception seat. So it's to your patient, and just don't tell them you need to walk. Might be he's not able to walk due to arthritis. Why you are suggesting him to walk? He's not able to walk. Then why you are suggesting him to walk or run? He's not able to do that. So you have to provide them other alternative. How can you have this met without affecting your physical health? Then many times the patients are not willing to lose their weight. Not willing to lose their weight. Then you have to signify, tell them, counsel them regarding the benefit of this. Otherwise you are putting your life in danger. It's not only the prescription, you are putting your life in danger. Then he might be able to listen to you. So spend time with your patient. And regarding the stress, we all need to manage our stress level. Many things we cannot do, so don't think about it. And the thing we can do, rather than do the thing, start doing the thing rather than thinking about it. So these are my references. And thanks for listening. Any questions, suggestion, please. Yes, sir.
Most of the time we talk of rehabilitation, but you have talked regarding the prehabilitation, and there are four key pillars of this topic, and you have covered the diet and nutrition, you have covered the physical exercise, smoking cessation, and also the psychological management. Thank you very much once again.
Just one word of comment, and I wanted to know from Professor Pandey. Basically, we were focusing on the younger individuals who are having these events and how can we make them healthy. And one of the core group is our younger physicians. There has been spate of death in doctors, young doctors dying suddenly in OT, dying suddenly in their OPD. So I think it's what he was suggesting is very important for first doctors to apply on themselves. And this endurance testing is just not about walking, it's about maintaining your cardiovascular fitness. So what will you suggest for younger doctors? What activities should they do to maintain that level of endurance, that level of cardiac fitness?
Look, you all are very much busy about your schedule. Even if you don't want to walk or don't have a time to walk, you can do every activity in your house, walking. Walk stairs, we all know. Even in your clinic, if you have spent 6 to 7 hours in your clinic, you just remove your sitting chair. You don't do consultation by sitting over the chair. You can very well remove your chair for 1 or 2 hours during your this consultation. So this will also add to your this foot step or whatever you say. This will also add to your MET score. Basically, you are trying to get MET score of 70 to 100 MET per week. So that should be your goal. And regarding even if you are watching TV, you can. I am not suggesting that you watch TV and do this dumbbell and do this strength training. But even if you don't have time, if you are watching TV, even keep some dumbbell in your room, consultation room, and do some core strengthening exercises. That will also help you. In any way, if you do some physical activity, that will add to your cardiac endurance and it will boost your heart muscles and endothelial functioning. So don't lose any moment of physical activity, whatever the busy schedule you are having. But your goal should be have at least minimum 70 to 80 METs per week, in any form, anywhere. Do a static cycling or whatever it is.
Thank you.
Thank you, Dr. Pandey. You have given a very useful practical tip.
Thank
Sir.
you,
Sir.
Pandey. Regarding the, am I audible?
Yes, sir. Audible, sir. Please, sir.
Audible. Regarding the issue raised by Dr. Nishant, that how our young population can remain active. Apart from the standard suggestion, morning walk and other things, one thing I think is very useful, that for every 1 hour, if one can spare 5 minutes for physical activity, that is enough. Physical activity, you have not to do any extraordinary thing. You can take help of any stairs. You can go one flight and you can come down. You can talk to one phone on walking. Yeah, you can do some cycling. Or you can take recourse of what is called chair yoga. Even on sitting on your chairs, you can do some flexion and other activity. And that is how we can remain active. So the modern concept is सक्रिय रहें, be active. वो morning walk ritual की बात खत्म हो गई. वो आप करते रहें ठीक है, लेकिन हमेशा ये attitude develop कीजिए. I should remain be active, and that is an important point, I think.
Thank you, sir. Thank you, Dr. Pandey.
Yes, sir. Standing itself is a very great exercise. The way you just standing make all of your core muscles very active and very functional. Just sitting and standing 50 times a day will help you a lot.
There is one report of Italy, a very important physician. वो अपने चैम्बर में एग्जामिनेशन टेबल है और एक अपना पोडियम रखे, कोई चेयर नहीं है, not for the attendant, for himself. खड़े मरीज देखता है और खड़े दवाई लिखता है.
Thank you, Dr. Gupta.
7 to 8 hours per day.
Thank you, Dr. Gupta, and thank you, Dr. Sanjay. We are already late, and the next topic is from Dr. Gupta itself. Yeah, please. So I invite Dr. Gupta to come over here.
The topic is impact of meditation on cardiovascular disease and health. And the speaker is none other than Dr. Professor A.K. Gupta. He is a very senior teacher of ours, and he is a teacher of many teachers practicing in Darbhanga, and is a senior diabetologist and cardiologist in Darbhanga. Over to sir for his presentation on impact of meditation on cardiovascular disease and health. Sir.
Thank you very much, Dr. U.S. Prasad, for your kind words. Apart from my usual introduction, I would like to add a couple of points regarding myself. That apart from interest in clinical medicine, I am also, my favorite topic have been a lifestyle medicine, yoga and meditation. And I'm very happy that the organizers have included this topic of meditation for scientific session in cardiovascular system. And I was requested by Dr. Nishant to have a practical demonstration of meditation for all of you that I will try to do in the end of my presentation for a couple of minutes. So let me start without wasting time. I will talk on art and science of meditation. And the first question that comes to our mind, what is meditation? It has been defined in several ways by different people in different ways. And for many, it is, for the restless mind, it gives a solace. For the sick, it is a boon. For the common man, it is a fashion of the day. For some use it for developing memory, intelligence and creativity. And spiritual seekers use it to unfold deeper layers of consciousness in their move towards perfection. Scientifically speaking, meditation is a state of total relaxation of body and mind complex, not only physical but mental also. It is an art of living in the present moment, and regular meditation helps to overcome addiction. It can help to reduce hypertension, insomnia, migraine, depression and other psychosomatic illness, and it also improves brain function by enhancing a balance between two hemispheres of the brain. Now, once I asked my spiritual guru, by whom I was initiated in yoga, I think you know, he is Padma Bhushan Paramhans Swami Nandranand Saraswati of Bihar School of Yoga, that Swamiji, what is meditation? And he answered that any work done with complete awareness is meditation. Even while you do an intervention and you are attentive, you are aware, you are not only doing a procedure, you are also doing a meditation. If you are eating and you are physically and mentally there in eating, what is called mindful eating, you are doing meditation. Any work can be taken as meditation. At the moment, you are all listening, not hearing me. If you are listening me, you are all doing meditation. And when I asked a further question, why don't you promote very widely meditation? You only promote lifestyle, yoga and asanas and pranayam. You seldom promote meditation. He told, meditation ध्यान कोई किसी को सिखा नहीं सकता है, ध्यान हो जाता है, ध्यान लग जाता है, प्रेम कोई किसी को सिखला नहीं सकता है, प्रेम हो सकता है. It was his version, and I think he was very correct. Meditation is the ultimate guide to managing negative thoughts and reducing stress. Now, a big question is it relevant to total health? If you recall the definition of total health, it refers to a holistic state of encompassing physical, mental, and social well-being as defined by WHO. And to ensure or to train in mental health, meditation is one of the best tools. Now, the second question which comes to our mind is, what are the benefits of meditation? And to name a few, it is a best tool for the healthy heart. It improves sleep. It is helpful to focus mind. It has got capacity to enhance immune system, and it is the best tool to reduce stress. It can improve memory, and number of studies are there. It can improve memory also. It can control especially the chronic pain, and it can increase energy level. Now, why should we meditate? The factors are number of factors by which we can consider it is a very important thing. It is helpful in reducing stress, anxiety, to increase focus and concentration, cultivating mindfulness, relaxation, calmness. It can improve emotional regulation. It can increase self-awareness, spiritual growth, and and it is helpful in improving overall well-being. There are lots of references and scientific work in the field of meditation, which I've given a list of here. Now, next question which comes to us, what are the varieties or types of meditation? Several, numerous. It is very difficult to count it. To name a few, transcendental meditation and mindfulness meditation. These are and Vipassana meditation. Transcendental meditation is very popular in Europe, and it was designed by Maharishi Yogi in 1950. It was started in 1958, and it is still very popular way of meditation in European countries and India also. And the most easiest way to practice meditation is mindfulness meditation. Now, what is a mindfulness meditation? If it helps to focus on the present moment, often through attention to breath, and it is very easy to watch and regulate your breath. You can focus on sensation, emotion, and it helps to improve awareness. Transcendental meditation uses a specific mantra. Mantra is not used in mindful meditation to quiet the mind and assess a deeper state of consciousness. And chakra meditation, it is a higher form of meditation, often and practiced by those people who are interested in advanced form of meditation. Vipassana is very popular in Buddhist population, and it is a very popular center at Bodh Gaya. Number of people come every year, go to Bodh Gaya to have a training in Vipassana meditation. They take around 10 days rigorous training for Vipassana. It was designed or rediscovered by Gautam Buddha. The practice involved observing the breath, body sensation, and mental phenomena with equanimity and awareness. Now, coming to our main point of discussion, impact of meditation on cardiovascular disease. In this regard, the first Indian trial was reported by Dr. S.C. Manchanda, who was a ex-prof of All India Institute of Medical Sciences, Delhi, and especially interested in yoga, retardation of coronary atherosclerosis with yoga and lifestyle intervention, which was published in API journal in 2000. The next study was reported from Mount Abu by S.K. Gupta and H.K. Chopra in 2011 on regression of coronary atherosclerosis through healthy lifestyle in coronary artery disease. Again, Dr. S.C. Manchanda published a very good paper on yoga, a promising technique to control cardiovascular disease in year 2014. And the result were the meta-analysis studied the effect of transcendental meditation on BP in 9 well-controlled conducted randomized trial, and it was associated with reduction of systolic BP by 4.7% mm and diastolic BP by 3.2 mm of mercury. At 1 year yoga group on coronary atherosclerosis by S.C. Manchanda, significant reduction in number of anginal episodes, improved exercise capacity, and decrease in body weight were observed. Serum total cholesterol, LDL, and triglyceride level also showed greater reduction as compared to the control group, and revascularization procedure, angioplasty or bypass surgery were much less. Coronary angiography repeated at 1 year showed that significantly more lesions regressed, 20% versus 2%, and less lesions progressed 5% versus 37 in the yoga group. The compliance to total program was excellent and no side effect were observed. So now coming to meditation and neuroplasticity. Neuroplasticity is the brain's ability to adapt, change and reorganize itself. Regular meditation practice can lead to significant changes in brain structure and function, enhancing cognitive function, that is memory, emotional well-being, and overall brain health. Key effects of meditation are many, apart from increasing gray matter, it can lead to increased self-awareness also. Difference between, some people ask what is the difference between sleep and meditation. If you notice the difference, you will find meditation generally takes 10 to 30 minutes, while sleep takes around 6 to 8 hours. And in meditation, we remain alert even at the end of the session. EEG, alpha and theta waves occur during meditation, while delta wave, they are seen during deep sleep. How to do meditation, I will talk little bit. The first, you should know the place.
Sorry to interrupt, sir. Actually, we are already 15 minutes late. I'll request you to please conclude it.
Time should be fixed, and this is the prerequisite of meditation. You must practice a disciplined lifestyle. You must cultivate a positive attitude. Stay away from the substance abuse. Regular practice of yoga and pranayama will bring early success in meditation. Learn to respond and not to react. Regarding positive thinking, it is not about expecting the best to happen every time, but accepting that whatever happens is the best for the moment. Now,
sir,
one should...
Sir, please conclude, sir.
Yes. I'm just taking
please
1 minute more. You can protect yourself from 6S: stress, social media, sedentary lifestyle, sugar, salt, and smoking. And this is my final slide. And after that, I will conclude. मेरा कहा न सुनो, दिल की बात तो सुन लो. दिल का फ़ोन आया, कहने लगा, बॉस, मैं तुम्हारे लिए बिना रुके 24 घंटा चलता हूँ, परंतु तुम मेरे लिए 1 घंटा भी नहीं चलते. कब तक ऐसा चलेगा? अगर मैं रुक गया तो तुम रुक गए, और अगर तुम रुके तो मैं गया. क्यों न ऐसा करें कि साथ साथ चलें और साथ साथ रहें जीवन भर. बॉस, अभी भी वक्त है. कल से तुम 1 घंटा मेरे लिए चलो. मेरा वादा है कि मैं बिना किसी रुकावट के 24 घंटे चलता रहूँगा. तुम्हारा अपना दिल. This is the essence of thing. I think it is the entire session in preventive cardiology. Thank you very much.
Thank you, sir. Thank you very much. Now I request Dr. Arvind. Dr. Arvind needs no introduction over here. He is currently practicing at Jiva Heart Hospital, and prior to that he was at Indira Gandhi Institute of Medical Sciences. He will speak on clinical practice guideline for dyslipidemia management and executive summary. Dr. Arvind, please.
Thank you, Chairperson, sir. My talk is on the CSI clinical practice guideline of dyslipidemia management executive summary. In fact, I will present a bird's eye view of the executive summary because it's a very vast subject. This guideline was published in Indian Heart Journal 2023 in December. And this is very helpful for our practicing physician to practice the management of dyslipidemia for the prevention and treatment of coronary artery disease. You know, dyslipidemia is the most important risk factor for atherosclerotic cardiovascular disease, including coronary artery disease. And most important lipid abnormalities are raised total cholesterol, raised LDL cholesterol, raised non-HDL cholesterol, decreased HDL cholesterol, increased triglyceride, increased ApoB, increased lipoprotein A. All these are the things. And the focus of treatment is targeted towards LDL cholesterol. But nowadays, this guideline shows that non-HDL cholesterol should be the co-primary target, not only LDL cholesterol. And there are a lot of challenges in the management of dyslipidemia. For example, we have higher incidence of premature coronary artery risk factor, premature CAD, and lack of awareness among clinicians and populations, and low level level of the guideline-directed medical treatment. These are the challenges. These are the barriers for the proper management of dyslipidemia in the society. The CSI had made a great effort to develop a consensus guideline for the dyslipidemia management for the primary and secondary prevention. And this guideline is based on many international guidelines, mainly European, and the expert opinion from the leaders of dyslipidemia management from our own country. But this guideline cannot replace your own clinician's own individual judgment. You are the best judge for your own patients. So the overall, all guidelines focuses on the dictum, early the better. You have to start early, intensive lipid lowering agent, lower the better, the target should be the lowest, as low as possible, longer is the better, longer duration of management, and together is better means statins and non-statin drugs should be combined as and when needed. A few standard lipid profile earlier did not include non-HDL cholesterol. Nowadays, they have said non-HDL cholesterol is the better predictor of CAD compared to LDL cholesterol. So this non-HDL cholesterol has been included in all guidelines, Indian guidelines. Triglyceride is a major risk factor. It is very common in Indian populations. And apolipoprotein B is a critical structural component of atherogenic lipoprotein. ApoB is a direct measure of all atherogenic lipoprotein, and it is measured more accurately than LDL cholesterol, and it is a better biomarker in predicting CSD elevation in secondary prevention of ASCVD. So currently most international Indian guidelines on dyslipidemia management recommend ApoB for testing in case of, particularly in case of familial hypercholesterolemia, and to estimate ASCVD risk in younger populations. So this is the epidemiology. India ICMR study have shown that the prevalence rate of various dyslipidemia varies in our states. In South India, higher LDL. In some states of North India, higher LDL. But triglyceride and HDL level are same across all the states. And these things are declining in the developed country, and while it is increasing. Coming to the lipid profile measurement, you know the most important thing that doesn't require fasting lipid management. Non-fasting lipid measure is the acceptable nowadays, because it gives you an early estimation of the risk and to guide treatment properly. So in clinic or in emergency, this will help you early estimation of CAD and a repeat initiation of lipid lowering therapy. But the problem is that we need to have a standardization of lipid estimation in our medical laboratory across India so that everyone gets guideline directed lipid lowering therapy. So this is the most important slide. We must estimate the cardiovascular risk to identify the goal and to guide the therapy. 5 categories has been identified. Low risk means there is no risk. So the LDL cholesterol should be less than 116, and non-HDL, just add 30 to the LDL cholesterol. It will give the picture of non-HDL cholesterol. So this is the co-primary target. Moderate risk means any presence of any one single risk factor, either diabetes or hypertension or smoking or premature CAD, and the target should be less than 100 for LDL and 130 for non-HDL. High risk, very high risk. High risk means diabetes with multiple risk factors, CKD, hereditary FH, and multiple risk factors. Then the target should be less than 70, and non-HDL target should be less than 100. But very high risk and extreme high risk, acute coronary syndrome always belongs to very high risk and extreme high risk. Here, patient had established ASCVD, patient had diabetes more than 20 years duration, FH, familial hypercholesterolemia with established ASCVD, CKD, and all these, the target, you must remember, target of LDL less than 55, 55, 55, and non-HDL 85, less than 85. And extreme high risk means genetic dyslipidemia, and if you have recurrent events within 2 years, second events within 2 years, you belongs to extremely high risk, and the target should be less than 40, and non-HDL less than 70. So these are the targets of the various LDL. I have spoken in this. ApoB target has not been included. ApoB target has not been included. And then coming to the management of acute coronary syndrome. Acute coronary syndrome, these are the algorithm, but the key features are non-fasting lipid profile assessment should be done. Goal should be less than 55. Principle is hit early, hit hard. Hit early, hit hard with a combination of high dose intensity statins, means 20 to 40 Rojuva and 40 to 80 Atorva, along with ezetimibe. Ezetimibe should be added day 1 in acute coronary syndrome because statins did not achieve LDL cholesterol in majority of the patient despite high intensity statins. So ezetimibe should be added day 1 in acute coronary syndrome. And if goal is not achieved within 4 weeks, then you add bempedoic acid. Again, the goal is not achieved, then you add PCSK9 targeted therapy, either PCSK9 inhibitor monoclonal antibody or incicredine, which is a small interfering messenger RNA. So these are the key features. Chronic coronary syndrome, again the target is less than 50 LDL, and for HDL, non-HDL 85. Indian diabetic have atherogenic dyslipidemia, and in this patient high intensity statins along with ezetimibe should be given even in coronary syndrome. It belongs to atherogenic dyslipidemia. Statins, drug of choice for all clinical settings of dyslipidemia. Some Indians are hyper responder, means doesn't require high dose. Even moderate intensity statin is able to control the LDL, achieve the target. But these are the patients where the side effects are more. Musculoskeletal side effects are more in hyper responder. So potent statins, I have told, water soluble, Rojuva, fat soluble Atorva, dose and types depends on self. It is well tolerated, but reversible muscular and liver toxicity is there, reversible. Second thing, it is contraindicated in pregnancy. Pregnancy, do not use statins. And new onset diabetes is slightly higher with statins, but the benefit outweighs risk. So do not have fear to start statins in diabetes. Routine monitoring of LFT CAP is not indicated unless the patient is symptomatic. And even up to 3 times SGPT, do not reduce the dose. If it is higher than 3 times or CPK higher than 4 times, then you have 4 options. Either you temporarily stop the statins, reduce the dose, switch over to the another low potent statins, or you can use alternate day statins. Every alternate day, every third day, you can use low potency statins to prevent or treat statins-induced symptoms. Ezetimibe 3 indications. When the goal is not achieved with high intensity statin, you should add ezetimibe with statin. Second, statins intolerant patient. You can use ezetimibe and bempedoic acid in all statins intolerant patient, because ezetimibe 50% reduction in LDL, bempedoic 25% reduction in LDL, together they can reduce 40% LDL reduction. High intensity statins causes 50% LDL reduction. These two cause 40% reduction in LDL. And third is, it can be used in hereditary familial hypercholesterolemia as a bempedoic is same. You know, it acts upstream on the pathway of statins in cholesterol synthesis. Advantage, pro-drugs metabolize in the liver, no musculoskeletal side effects. So when the target is not achieved, it should be used along with statin ezetimibe. Statin intolerant, it can be used. HEF, it can be used. Advantage, no increase in diabetes mellitus, no increase muscular side effect, but slight elevation of uric acid is there with bempedoic acid. Inclisiran, these are the newer drugs. Messenger, a small intervention RC. It can cause 50% reduction in LDL cholesterol. It can be given subcutaneously, so compliance is better, but the cost is barrier. And though there is no adverse side effect, it is very safe. So few word about PCSK9 inhibitor. It has come before inclisiran. Same 50% reduction in LDL cholesterol, no side effects. It is very safe. Target is not, but disadvantage is that it has to be given monthly. Fish oil reduces triglyceride by 25%. Only icosapentaethyl has been shown to reduce cardiac events. Other omega-3 fatty acids did not reduce cardiac event, but icosapentaethyl fibrates lowers triglyceride. Only definite indication when the triglyceride more than 500 to prevent pancreatitis. In less degree of hypertriglyceridemia, it reduces. Except diabetes, mixed dyslipidemia, you can use statins and fibrates. Otherwise, definite indication when TG more than 500. There are newer drugs which, in the market. Triglyceride, I have already discussed. So, lifestyle modification, foods already discussed. And diabetes, I have discussed. It belongs to 3 categories, and the target depends on the category. And you can use statins along with non-statin drugs. Chronic kidney disease, very important. A statin is a drug of choice in CKD when GFR is low. Even GFR is normal, but UACR is high. It should be used. Only precaution, use low dose of statins in CKD patient, low dose. And other drug, fibrates should not be used. Ezetimibe monotherapy should not be used, but bempedoic acid, PCSK9 is safer in chronic kidney disease. Stroke and peripheral vascular disease, target same, less than 55, as in chronic coronary syndrome, and there is high incidence of coronary events, so it belongs to high risk category, both stroke and peripheral. So statins, ezetimibe, bempedoic acid, PCSK9, all drugs are indicated in these two. Pregnancy, only drug safe is lifestyle modification and bile acid sequestrant and omega-3 fatty acid. Only 3 drugs are safe. No statins, no ezetimibe, no fibrates, no bempedoic acid. Pregnancy. Liver disease, drug of choice, statins in MSLD, up to 3 times SGPT, no need to, is not contraindication, except when you are using antiviral drugs, you have to take care of the drug-to-drug interactions. A combination of ezetimibe and rosuvastatin reduces the fat, liver fat, no other drugs. So very important combination, rosuvastatin, ezetimibe in liver disease. Seroglitazole is proved in NAFLD and it is being evaluated in MASLD. Elderly, above 70, indications, goal, everything same. Only dose needs to be lowered. But patient going for the first time dialysis, do not use statins unless patient has established ACVD. Above 80, no role of statin in primary prevention. Secondary prevention, yes. Primary prevention, above 80, no role of statins. And young, universal screening should be started at the age of 18 years. This can detect increased LDL due to genetic dyslipidemia. So, otherwise, between 18 to 40 young, established ASD, ACVD, target, drug of choice, everything is same. Genetic dyslipidemia, lipoprotein already discussed. Hereditary familial dyslipidemia is really belongs to high use. Goal is less than 55, less than 70, depends on statins, ezetimibe, bempedoic acid, PCSK9, all are drug of choice. Homozygous hereditary familial hypercholesteremia, they are newer drugs, lomitapide, mipomorsan, plasmapheresis, etc. These cascade screening should be done for familial screening and LPA. And this is the algorithm for this is okay. So to cut short, this is my last slide. Thank you very much. So this is a bird's eye view of the executive summary of CSI practice guideline, which help you physicians to practice the management of dyslipidemia, both primary and secondary prevention. Thank you.
Thank you, Dr. Arvind Kumar, for your brilliant presentation. I have a small query. In a very high-risk patient, can we go LDL to 5 milligram or 10 milligram?
So there is no recommendation. One study has shown that you can go up to 15. Extreme high risk may be a variety type B. You can go further beyond 30. Some said it is, I'm not sure whether 15 is acceptable, but up to 13. Up to 13 it has been recommended.
Any level is safe. As you said, lower the better. You don't know the exact, lower the better. Whatever the lower. No neurological side effects.
But recommendation is up to, below 40 means up to 30. Yes. Some say it is 15.
Yes, I have just one comment. Sure. Partly you have also already answered it, that according to CSI and most of the international guidelines, that extremely high risk, you go up to LDL 40. Lipid Association has recommended even lower levels, more intensive, up to 30.
30.
And I have one question, that suppose you have a patient with ACS, you have to start with high-dose statin. What would you prefer, Atorva or Rosuva?
Sir, both are equally good. It's not, it is better than other. Both are. Rosuva 20 to 40, Atorva 40 to 80. Both are, my practice, both are equally good.
Okay. But then if...
Rosuva is more potent. It is super statin. Earlier it was said that it is super statin.
Yes, if you have a patient with CKD and the patient needs statin, then probably Atorva might be better because Rosuva is excreted by the kidney and therefore higher.
That is water soluble, one is fat soluble.
Yes.
That could be a reason, sir.
Yes.
So thank you, sir. Time is very short.
Thank you, Dr. Arvind.
Thank you.
I thank all the speakers in this session. All the speakers spoke well. And the message is very clear that earlier intervention is needed. As Dr. Vikas told in his presentation, you have to intervene early. Lower is the better, as Arvind suggested in the guideline. And Dr. Sinha is speaker, as a first speaker, target LPA. Residual risk is to be addressed. So thank you all the speakers in these sessions. And Dr. Pandey from the AIMS, he has spoke very well. And rehabilitation, we are aware of the new terminology. Thank you, everybody. Thank you, my co-chairs and panelists together. Thank you.
Once again, thank you very much, organizer, for honoring us to chair this session.
Thank you, everyone. We'll just have a lamp lighting program. And then we will go ahead with the second session. So I will request the chairperson and panelist of the second session to be ready. We will begin shortly.
Good morning. After such an educational, enlightening, illuminating, and edifying session, first session, please be seated. All of you please be seated. Now, अब समय है कि सरस्वती का आह्वान करने का साइंटिफिक प्रोग्राम का उद्घाटन. We'll start with the inauguration of scientific program, for which I invite the Chairman Scientific, Dr. Nishad Tripathi, to be here, the President of CSI, Dr. K.K. Barun, the Secretary of CSI, Dr. UN Singh, and the very senior members sitting here, Dr. U.C. Samal sir, Dr. B.P. Singh sir, Dr. A.K. Gupta sir, and Dr. Ajay Sinha sir. Please come on the stage. Chatterjee sir, Dr. Chatterjee sir, please. I thought you were going, sir. And the organizing chairman, Dr. B.P. Sinha sir, please. Ashok तो ही है. अच्छा. सर इधर से. Quickly moving to the second session of today. May I request all speakers, as requested earlier by Dr. Arvind, to please stick to the time. So time allowed is 12 minutes to speak and 3 minutes for question answer session. And chairpersons are requested, if the speaker exceed to 15 minutes, then please do not allow question answer session. That will be done during the lunch. So may I have the privilege to please call upon the chairpersons, Dr. Pramod Kumar, the senior cardiologist from Medanta Hospital. Is he here? Dr. Ajay Kumar Sinha, cardiologist from Medanta Hospital, Patna. Dr. Ashok Kumar, our dynamic professor, PMCH Medicine. Dr. Ashok Kumar, sir, please. And Dr. Lalit Kishore Prasad, Dr. L.K. Prasad, the professor of medicine, ex-professor of medicine at NMCH. Please come for chairing the session. And our panelists today are Dr. Ram Sagar Rai, the cardiologist from Siwan and Patna. Dr. Rajesh Kumar from Patna. Professor P.K. Agrawal, sir. Dr. P.K. Agrawal from PMCH Patna, the professor of respiratory medicine. And Dr. Pandit. Ashok. Dr. Pandit hai? Dr. B.N. Pandit from Patna. Please come on the stage. Now hand over to the chairpersons to start the session.
So, good morning. We have 4 very important topics, and this is dedicated to hypertension, the most important reversible factor for cardiovascular disease. And the first talk is by Dr. Alok Kumar, and this topic, his topic is 20-year-old with hypertension, how to evaluate and treat. Alok, please. Alok is a brilliant cardiologist working with us, and he will be speaking on 20-year-old with hypertension, how to evaluate and treat.
Good morning, everybody. Today we will discuss a 20-year-old with hypertension, that is a patient of young hypertension. So, which patients are called young hypertension? That is the age less than 40 years of age. A prompt investigation and management is very important in these cases, because the early detection and treatment of the secondary causes can be curative for such patients. And early normalization of BP may reduce the risk of end organ damages, thus reducing the lifetime risk of cardiovascular events. Now coming to the epidemiology, according to the Framingham study, the incidence is around 3.3%, and according to the Cardia study, the incidence is around 16.4%, and that is more common in the men than in women, and the black are affected more than the white. Some of the socioeconomic factors like socioeconomic deprivation has more incidence of hypertension, and the patients with high BMI, that is obese patients, have a more incidence of hypertension, and obesity has become a common problem, and it has tripled its numbers in the last 4 decades. Now coming to the prevalence of secondary hypertension among young adults, coarctation of aorta, pheochromocytoma, Cushing syndromes, and thyroid disease are rare. The prevalence is less than 1% in young hypertensives, but the incidence is around 10% in patients of primary hyperaldosteronism, renal artery stenosis, most common fibromuscular dysplasia, Takayuki arthritis, or neurofibroma, rather than atherosclerosis or renal parenchymal disease. Now coming to the pathophysiology, the hypertension patterns of BP elevation are of 3 types in young hypertensives. It may be isolated systolic hypertension, isolated diastolic hypertension, and systolic diastolic hypertension. These all 3 have different types of mechanism. In isolated systolic hypertension, it is most common in the young adults. It is more common in the males with higher BMI, and the main mechanism is the increase in cardiac output, which is driven by increase in stroke volume. Small number of patients also have increased aortic pulse wave velocity, that is a measure of aortic stiffness. Now coming to the systolic diastolic hypertension and isolated diastolic hypertension. It is most common in the young females. They are characterized by increase in PVR and in some cases increased aortic stiffness. There may be a raised cardiac output, but it is mainly due to increase in the heart rate rather than the stroke volume. So young females display a predominantly cardiac BP phenotype, and the young females predominantly show a vascular BP phenotype. Now, secondary hypertension according to the age, in the age less than 12 years of case, there are almost 70 to 85% of the cases showing underlying secondary causes, the most common being renal parenchymal disease, coarctation of aorta, and monogenic disorders. In adolescents, that is 12 to 18 years of age, 10 to 15% have secondary causes. The same causes are more common: renal parenchymal disease, coarctation of aorta, and monogenic disorders. In the young males, that is 20 to 40 years of age, there may be renal parenchymal disease, fibromuscular dysplasia, and undiagnosed monogenic disorders. And at the later age, primary aldosteronism, OSA, Cushing syndrome, pheochromocytoma, etc. are there. So how do we evaluate? First of all, we must confirm the diagnosis and rule out some of the dietary and drug causes of increase in BP. All the patients must have a proper investigation of and CV risk stratification. In age less than 18 years, we have to rule out renal parenchymal disease, coarctation of aorta, and monogenic disorders with the help of renal ultrasound, echocardiography, and genetic studies. In 20 to 40 years of age, fibromuscular dysplasia must be ruled out by renal ultrasound, Doppler ultrasound, MR angiography, and CT angiography. And in the later ages, hyperaldosteronism, Cushing's, pheochromocytoma, etc. must be ruled out. So coming to the clinical assessment, first of all, a medical history is important, and we must rule out some of the common drug and concurrent use of medicines, causes of hypertension, like concurrent medicines, oral contraceptives, hormonal substitutes, over-the-counter preparation, some of the herbal medicines, and recreational drugs. These are some of the common drugs which can increase BP, like fludrocortisone, immunosuppressants, chemotherapy, erythropoietin, steroids, psychiatric drugs, ketoconazole, sympathomimetics, etc. These are drugs which can increase BP. Now coming to the obstetric history, we must find if there is a history of pregnancy-induced hypertension or fetal growth retardation restriction. These are the independent risk factors for the development of hypertension in the postpartum period and associated increased CV disease risk. We must also ask about the symptoms of OSA, because obesity is becoming a great problem in the younger ages also. Family history must be taken of fibromuscular dysplasia and other renal disorders, pheochromocytoma, neurofibroma, thyroid disease, hyperaldosteronism, and monogenic hypertension. An family history of early onset hypertension, sudden death, stroke, myocardial infarction at a younger age in the first degree relatives may suggest there is a presence of a secondary cause or monogenic hypertension. Now, we have to rule out secondary causes on the basis of signs and symptoms. Suppose we have pheochromocytoma, there are 5 P's: palpitation, pallor, etc. for the diagnosis of pheochromocytoma. Hyperaldosteronism, there is a hypokalemia and muscle weakness. In hypothyroidism, there is elevated diastolic hypertension. In hyperthyroidism, there is isolated systolic hypertension. In Cushing syndrome, there is a truncal opacity with buffalo hum and moon faces. In neurofibroma, we have cephalospots. In acromegaly, there are facial changes and enlargements of the hands and feet. In chronic kidney disease, there is weight loss, hematuria, ankle edema, and shortness of breath. In preeclampsia, there is history of BP elevation in the previous or present pregnancy. And in case of renal scarring, there is history of repeated urinary tract infection or urinary stones. Now, how do we assess for end organ damage? In the case of heart, there may be clinical heart failure, CAD, arrhythmias, and subclinical findings of LVH, LV dysfunction, dilated atria, and raised enzymes of BNP. In kidney disease, we have chronic kidney disease and subclinical findings of albuminuria, declining GFR, and reduced cortical thickness. In eye, we have visual impairment and subclinical findings of hypertensive retinopathy. In brain, we have cerebrovascular accidents, TIAs, and on subclinical findings of lacunar infarcts and microbleeds. And in blood vessels, we have diseases of peripheral vascular disease and aortic aneurysm, and subclinical finding of thoracic aortic dilation, aortic stiffening, and reduced ankle branchial index. Now, how do we diagnose the cases of hypertension? Ambulatory and home BP recordings improves the accuracy of BP assessment, and it is mandatory to confirm a diagnosis of hypertension. Now, these also help to diagnose white coat hypertension and white masked hypertension. In white coat hypertension, high office or clinic BP with normal ambulatory or home BP records. It is more common among the women. And masked hypertension, there is normal office or clinic BP, and the ambulatory or home BP recordings are high. These are more common in men with higher BMI and smokers. And white coat hypertension occurs in 15 to 25%, and masked hypertension around 10 to 20% in case of secondary hypertension. This is the graph showing the white coat hypertension, showing high BP in the clinic, and later it decreases. The masked hypertension has lower BP in the clinic and the home BP recordings are high. Now coming to the examination of urine, albuminuria and or hematuria, these indicate renal parenchymal disease or hypertension associated end organ damage. The UACR is the better recommended as a more robust measure of albuminuria than the dipstick. Now coming to the biochemical investigation, renin and aldosterone help to isolate primary aldosteronism and metanephrines for pheochromocytoma. 24-hour urinary collection helps to estimate daily salt intake and exclude Cushing syndrome and hyperaldosteronism. Hyperreninemic hyperaldosteronism is a classical finding of renal artery stenosis, and the screening is done by CT angiography and MRI angiography. DSA provides a definitive diagnosis, and therapeutic angioplasty can be done by this. Caucasian is mainly found in childhood and accounts for 5 to 8% of congenital heart disease. Echocardiography is the main screening investigation, and CT and MR angiography helps to confirm the diagnosis. Now 5 to 10% of patients with hypertension have raised aldosterone, and aldosterone-renin ratio greater than 40, and who underwent imaging have shown that 4.8% have aldosterone-producing adenoma and 6.4% have idiopathic hyperaldosteronism. Idiopathic hyperaldosteronism is known as Conn syndrome. The aldosterone-renin ratio is high. The treatment is by spironolactone. Those who do not respond, adenylectomy is being done. Fibromuscular dysplasia, it is a segmental renal artery stenosis, more common in females, and CT angiography or MR angiography is better for diagnosis. OSA is more common in males, obese, diagnosis by polysomnography, and CPAP usually reduces the BP but by a small margin. Pheochromocytoma is a rare tumor arising from chromaffin cells of the adrenal medulla. There are 5 P's are associated with this, and testing is done by 24-hour metanephrine and CT scan. Cushing syndrome, mainly the use of iatrogenic corticosteroids. 20% of these patients have hypertension, and testing is done by 24-hour urinary free cortisol and low-dose dexamethasone suppression test. Coarctation of aorta, this is mainly found in the children and young adults, and this testing is done by echocardiography, and MR angiography is used in adults. Monogenic hypertension, this is a specific gene mutation. It is present early in life. And factors that are responsible are young onset low renin, electrolyte abnormalities, brachydactyly, disorders of adrenal steroids, and some of the examples are Liddle syndrome, which are treated by amiloride, Gordon syndrome, Geller syndrome, and hyperaldosteronism type 1, 2, 3, and 4, and hydroxylase deficiency. These are treated by different medicines. There are 2 well-established strategies to lower BP. Number 1 is lifestyle modification, and number 2 is pharmacological treatment. In the lifestyle modification, we must reduce salt intake, maintain a healthy weight, incorporate exercise in the daily routine, eat a balanced diet, alcohol in moderation, caffeine in moderation, and smoking must be stopped. Now, when do we start treatment? Grade 1, grade 3 hypertension, greater than BP 180 by 110, immediate drug treatments must be given along with lifestyle modification. In grade 2, immediate drug treatment and lifestyle modification. In grade 1 hypertension, we must assess the cardiovascular risk and end organ damage. If these 2 factors are present, drug treatment is given. If these are not present, we must follow after 3 to 6 months of lifestyle modification. If BP is controlled, we can go for ambulatory BP monitoring, and if the BP is not controlled, the drug treatment is given. The drug is 2 drug treatment, ACE inhibitors or ARB plus CCB plus diuretic. Second line, 3 drug treatment, and third line, there is resistant hypertension. We must add alpha blocker or beta blocker in the case of post-infarct angina, heart failure.
Can you summarize, Dr. Alok?
Thanks.
Thank you. So, can I have a quick comment from our very senior sir?
Oh, Dr. Alok, you have very nicely enumerated the causes of hypertension in young patients. What I want to say, there are 2 correctable vascular causes. One is the renal artery stenosis, and for that clinically, you should always try to, in younger patients, if you find hypertension, to just put your stethoscope just a little away from the umbilicus on both sides. You may hear a systolic murmur. That is brute. Second is the coarctation of aorta. The earlier it is diagnosed, the better, before it becomes goes to the left ventricular hypertrophy, other thing. So radiofemoral delay is the answer. If you have got if you go to clinical medicine, radiofemoral delay is the answer of coagulation aorta. So I think you have done very nice work. So thank you so much.
Thank you, sir.
Any questions and comment?
Quick comment by panelist. You know, quickly you can have one comment each. Because just keep on. Okay. Thank you.
I invite Dr. Yuan Singh, next speaker. He will talk on resistant hypertension and management strategies. Dr. Upendra, please.
Very good evening to all the chairpersons, moderators, and delegates, friends and colleagues. So my topic is current management strategies, resistant hypertension. You know that hypertension is a very common problem, and it accounts for the prevalence of hypertension varies from 25 to 35%. It is more common in urban India than in rural India. And it is one of the most important risk factor for the cardiovascular disease. And it's a significant cause of morbidity and mortality. It's also a risk factor for the congestive heart failure, CKD, stroke, atrial fibrillation, dementia, and many more. So we know we need to discuss resistant hypertension separately because it carries a very high morbidity and mortality compared to hypertension which is well controlled. So to whom we call the resistant hypertension. Resistant hypertension is defined as the blood pressure that remains above the contemporary goals in spite of concurrent use of 3 antihypertensive agents of different classes, including 1 diuretics. And all the agents should be prescribed at the optimal dosage amounts. So optimal dosage amounts means at least moderate dosage and not necessarily the maximum dose. And those patients who requiring the 4 antihypertensive medication, and even if their blood pressure are controlled, are kept in under the classification of resistant hypertension. So this is a new blood pressure category as defined by European Society of Hypertension and was published last year. So there are 3 basic categories: non-elevated blood pressure, elevated blood pressure, and hypertension. So hypertension is defined by office measurement if systolic BP is more than or equal to 140 and diastolic more than or equal to 40. And when we go by the out of office blood pressure measurements by home blood based blood pressure monitoring or ABPM, if the systolic BP is more than or equal to 135 or diastolic more than or equal to 85. And normal non-elevated blood pressure is called when the systolic BP is less than 120 and diastolic less than 70. So the true prevalence of resistant hypertension is unknown, and in one series it was about 10 to 15% were diagnosed to have a true resistant hypertension. So whenever a patient of uncontrolled hypertension is encountered, we first need to rule out the apparent causes of the hypertension, that is pseudo-resistant hypertension. The causes of the pseudo-resistance are the poor adherence, improper blood pressure measuring technique, or the white coat effect. So you have to rule out these apparent causes of the hypertension. So now comes the true resistant hypertension. That is truly resistance. We have already ruled out the apparent causes. So the causes for the resistant hypertension are high risk patient, the poor lifestyles, drug-related causes, and the secondary causes as already discussed by the previous speaker, Dr. Alok. So blood pressure measuring, though there are 2 frequent errors that are encountered in our daily day-to-day practice. So whenever patient come to our office, we don't allow them to take the proper rest, and we measure the blood pressure harshly, and so that can lead to falsely elevated blood pressure. And one other is the cuff size. when we measure the blood pressure in the obese individual, if you use the standard size cuff in the obese, we can get the falsely elevated blood pressure. So while measuring the blood pressure in children, we need to take the separate cuff, or lean or thin individual, there should be separate cuff. Otherwise, there will be overestimation of the blood pressure in these individuals. And the poor adherence is also an important cause of the pseudo-resistance hypertension. So we have to rule out that the poor, about 40% of the patient stop taking medicine within the first year of the life. And the fewer than 40% continue the medicine after 5 to 10 years of the life. Other causes of the pseudo-resistance is white coat effect. The studies have shown that the white coat effect occurs just as frequent in the resistant hypertension as does it occur in the broader hypertensive populations. And this phenomena affects about 20 to 30% of the individuals. And those who have white coat effect tend to have the fewer cardiovascular event when compared with those whose blood pressure is well managed. So these are the factors contributing to resistant hypertension. So drug-induced, these are the culprits. So many a times patients come to our office chamber and they say that my blood pressure is recently uncontrolled. So we must take the history of the NSAIDs. And NSAIDs are one of the very common cause of uncontrolled hypertension. Other drugs are sympathomimetics, cocaines, amphetamines, oral contraceptive pills, adrenal hormone, erythropoietins, immunosuppressant like cyclosporin or tacrolimus. Others causes like excessive alcohol intake, volume overload might be due to excessive sodium intake, or the lack of inadequate diuretic therapy or kidney disease can cause resistant hypertension. So the factors related to lifestyles like obesity, diabetes, and older age can lead to secondary resistant hypertension. Other identifiable cause like a secondary hypertension already have been discussed. These important are the renal parenchymal disease, renovascular disease, primary aldosteronism, obstructive sleep apnea, endocrine causes are common cause of the secondary hypertension, which are potentially treatable. So these are the form of the secondary hypertension. Obstructive sleep apnea is the most common comorbidity found in resistant hypertension, 60 to 70% of patients, and is a potentially treatable conditions. Other are primary aldosteronism, renal artery stenosis, renal parenchymal diseases, drug-induced or alcohol abuse, endocrine problems can lead to resistant hypertension. So OSA, is observed in 30 to 40% of broader hypertensive population, and as common as 60 to 70% of patients with the resistant hypertension. And diagnosis should be suspected in the obese individuals who have history of loud snoring, daytime dizziness, and resistant hypertension, difficult to control. We should be very suspicious and must not to hesitate in ordering the polysomnography, because it is potentially correctable, potentially treatable with the help of CPAP therapy. The other important cause is primary hyperaldosteronism. The recent studies indicate that the primary aldosteronism is much more common than it was previously thought of. And basically in hypertensive clinic, it accounts for 20% of patients with resistant hypertension. The diagnosis of PS should be suspected in young individuals with the resistant hypertension having hypokalemia, or who develop hypokalemia at the very low dosage of diuretics. And when suspected, should go order for the aldosterone PRA ratio more than 30. We need to go for the some suppression tests. The renovascular hypertension is important cause of resistant hypertension, and it's very common finding in patients who are going cardiac catheterization study. It accounts for the 20% of the patient either have unilateral or bilateral renal artery stenosis. However, the role of such lesion in causing hypertension is not very much correlated. So the two important causes of the renal artery stenosis is a bimodal peak. One presents in the elderly population more than 50 years, and in this group, atherosclerosis is the common cause, present more in male, and there is ostial involvement. While in younger patient, FMD, fibromuscular dysplasia, but in Indian context, Indian scenario and Indian subcontinent, aortoarthritis is the common cause, commonest cause, particularly in Indian setting. We know that the CKD is both a common cause and the complication of the poorly controlled hypertension. In ALHAT trial, CKD as indicated by serum creatinine level 1.5 milligram per decil was a strong predictor of failure to achieve the blood pressure goal. And the treatment resistance in this patient is related to increased sodium and the fluid retention and consequential intravascular volume expansion. So we need to confirm the adherence and the blood pressure techniques and rule out secondary causes, as well as we have to assess the target organ damage. So this is a good flow chart. First, the treatment confirmation of the true resistance, rule out the exclude the pseudo causes of the pseudo resistance, and assess for the secondary hypertension. And we should also need to take care of the assess for the target organ damage. So where comes the role of ABPM? Now it's more recommended by the new European guidelines and everywhere. This is mandatory for the diagnosis, risk identification, as well as for the workup in patient with the treatment resistance, because it can reduce the incidence of this treatment resistant hypertension less than 10%. And treatment resistant hypertension by ABPM is defined when the blood pressure is more than 130/80. And the absence of nighttime drop, as well as reverse nocturnal dipping, absence of dipping and reverse nocturnal dipping also. So management includes, as we manage in other broader populations, so lifestyle modifications ensure low sodium diet less than 2.5 gram, and maximize lifestyle interventions, more than 6 hour interrupted sleep, overall dietary patterns, weight less exercise should be emphasized. And if the blood pressure is not controlled, because by definition patients are already on the 3 drugs, including a diuretics. So if the patient is on other type of diuretics, we need to replace it by thiazide, a thiazide type of diuretics. And if the blood pressure is not controlled, we need to add some mineralocorticoid receptor antagonists like spironolactone or eplerenone. But even in some patients, we may not have blood pressure under the control. We can add beta blockers, alpha blockers, centrally acting sympatholytics, direct vasodilators, and hydrogens, minoxidil we can add on. So this is the best proven non-pharmacological intervention for the treatment of the hypertension. So we have already discussed, for each 1 kg reduction in the body weight can decrease the blood pressure by 1 millimeter of Hg, and that there should be promotion for the healthy diet, rich in vegetable, whole grain, and low dairy products.
Can you conclude now?
Yes, sir, coming. So apart from, the now emphasis is more given in spironolactone and eplerenone for those patients who have potassium level less than 4.5, and those having potassium more than high, the diuretics dose should be increased. Now newer drugs have in the markets, not in market, but in the advanced phase of the trial, phase 3 trials, that are aldosterone synthase inhibitors like baxdrostat and lorundrostat, and aprocitentan is a dual endothelial receptor antagonist. These all are very, in the phase 3 trials are likely to come into market next year. So the interventional therapy are also important. Basically, catheter-based therapy, radiofrequency ablation therapy, which were studied in simplicity trials. They have shown the good result in reducing the BP, but in simplicity trials, which was sham control, was failed to show the difference. So, as of now, it cannot be advocated for the routine use, but the current status is that the two system, Paradise renal denervation system with the help of ultrasonography and the simplicity spiral radiofrequency system should be done in selected patient of resistant hypertension. Other therapy are the carotid baroreceptor stimulation, but due to higher rate of complication, this cannot be advocated in routine practice. So to conclude, the diagnosis of true resistant hypertension is important by excluding the pseudo-resistant hypertension. The initial drug treatment should be diuretics followed by ACE inhibitor, ARB and CCB. There is convincing evidence that the spironolactones should be the fourth line of drugs. Other drugs then are the alpha beta blockers, vasodilators and the centrally acting sympathetolytics. At this point of time, the benefit of the renal denervation, carotid receptor, baroreceptor stimulation, and the central arteriovenous anastomosis remains inconclusive, and these procedures should not be adopted in the routine clinical practices. Thank you.
Thank you, Dr. Oten, for delivering a beautiful lecture on the resistant hypertension.
Thank you, sir.
Due to shortage of time, I am not allowing any questions. And I invite next speaker, Dr. Ashish Kumar Jha.
Thank you, sir.
And his talk will be a very good one, precision medicine in hypertension, along with genomic profiling for targeted therapy. Newer thing.
Respected chair and so respected chair, and first of all, many thanks to organizers for giving me an opportunity to speak on a topic which I was also very less aware of. When I was given a topic of precision medicine hypertension, I thought it's only for monogenic Mendelian hypertension. But when I went through this few articles, mainly an article published in JACC by V.D. Jha in 2024, then I got to know that how many research works are going on in precision medicine, and whatever I am talking, this is a peek into the future. So none of this, these things are in reality at present, but probably this might be the future medicine. So when I'm talking about future medicine, the buzzword is 4P of intervention. What is 4P of intervention? It is prevention, precision, participation, and prediction. Actually, this is a paradigm shift from reactive one-size-fits-all approach to proactive customized approach where individuals are actively involved in their own treatment. So the pioneers in 2011, this term was first popularized and given by Dr. Francis Collins and Dr. Harold Vermas, and they published in a paper in NECM emphasizing the need for tailored medical treatment based on genetic, environmental, and lifestyle factors. So what is the background? We all know hypertension affects more than 1 billion population globally. The control is, optimal control is seen in less than 1/5 of population. The common problem is the poor adherence. And poor adherence is because of lack of awareness, but also due to the often complex medication regimen as well as associated side effects. Whenever we are, the guideline also says that target 2 therapies, for example, ARB with CCB, so that you can combine the 2 modalities and then can achieve an optimal control, if not achieved at third drug with another mode of action. So the problem is the current approach fails to take into account the diverse hypertensive population. Whatever existing drugs are, they are limited to targeting one of many mechanisms, and thus their effectiveness is variable in different individuals and population. So actually, hypertension can only be managed by precision medicine approach. Precision medicine approach is an approach to hypertension prevention and treatment that considers the unique gene and environment of each hypertensive patient. And this definition has been adapted from NIH definition of precision medicine. This approach recognizes that hypertensive individuals may respond differently to same treatment, whatever the reason is. It might be due to genetic variation, it might be due to environmental factors, or it might be due to their personal lifestyle factors. So this precision hypertension will use the analysis of genomics, omics, molecular profiling, health information, environmental factors, including the lifestyle and big data analysis to gather and analyze vast amount of information about an individual health. This also aims to provide more accurate diagnosis, predict disease outcomes, and develop targeted therapy that are more effective and have fewer side effects. It holds the potential to control and even cure hypertension by providing personalized and precise treatment that can improve the individual outcomes and reduce cost. It also holds the potential to control and even cure by targeting the root cause of hypertension in each individualized, personalized, and precise treatment. So what are the pillars of precision hypertension? Genetics is the central pillar of precision hypertension. We all know it's great for monogenic Mendelian hypertension like Liddle syndrome or Gordon syndrome or 11-beta hydroxylase deficiency, where it can be curative by gene therapy or gene editing. But what happens in primary hypertension? We all know it's polygenic, with small effects combined with the epigenetic factors. Epigenetics means the effect of environmental factors on the gene. So this becomes a complex thing. Treating a polygenic factor by a gene editing is a complex thing. But treating multi-gene hypertension using genetic intervention would be more complex. So what has been done? Now researchers are doing complex disease genome-wide association studies which seeks to identify disease-associated single nucleotide polymorphism. And it has been found that there are more than 1,500 SNPs have been identified. Even when we are taking all these SNP together, then they also account for less than for around 1/3 of the heritability of hypertension. So certainly more studies are needed. Moreover, these are heavily skewed for white race because in our country or in third world countries, it has not been done. To overcome this, polygenic risk scores are being developed, which was discussed by Dr. Vikas also in ASCVD also. To sum it all, technology is in nascent stage and needs many more refinement before it can be practically applied to primary hypertension. But where it can be applied? So we all know the small interference RNA or microRNA. We all know that in 2024, Victor Ramos was given a Nobel Prize for the discovery of small interference RNA, and we know the serans for inclisiran, olpasiran, and similarly, small interference RNA has great potential for treatment of primary hypertension. The most advanced seran which has been targeting hypertension is the gilebesiran. Gilebesiran is a SERNA therapeutic that specifically targets angiotensinogen synthesis in liver. It has successfully passed phase 1 trial, and Cardio 1, Cardio 2 are ongoing phase 2 trials. It has not, the safety profile is not known because if we are inhibiting angiotensinogen, then the response to hypovolemia might be impaired in many patients. So we don't know the safety profile, but still the trials are going on. Moreover, SERNA are also being used for many other receptors. For example, beta-1 adrenergic receptor, AT1 receptor, endothelin receptor, some of which has been told by Dr. Yuan Singh. And then mineralocorticoid receptor, galactin-3, GPCR kinase type 440, all reduce BP in mouse models, but they are likely to be subject of further development in later trials and later researches. Alternative to SERNA is antisense oligonucleotide. One oligonucleotide which has been tested against is Ionis angiotensin LRX therapy. It also acts on angiotensinogen, mRNA in liver, and phase 1, phase 2 trials are being conducted. So most of these drugs are in the trial stage. Then comes the gene editing. So CRISPR-Cas9, as we all know, is a gene editing modality, but this has been mainly useful in the monogenic hypertension, as I earlier told, but again, monogenic hypertension are rare. Gene editing of angiotensinogen in liver, the source of systemic angiotensin, is also likely, and this study is also going on. The advantage of angiotensin gene editing versus angiotensin target like SERNA is that zilebesiran is the permanence, because zilebesiran will be effective for 6 months or 1 year. So you will have to take jab every 6 months or 1 year, just like we are taking a jab for inclisiran. But whenever gene editing is done, and if angiotensin gene is the cause of hypertension in that individual, gene editing treatment will be lifelong and permanent treatment. So the other pillar is the importance of big data and AI analysis. We know that with advances in the large data analysis, it is now becoming possible to analyze large real-world data. RCT have been inherently defective by the controlled method of data collection, which doesn't replicate the real-world scenario. And that is the glaring example. We have seen the difference in the outcome of ACCORD and SPIN trial. ACCORD didn't show any benefit. In fact, it showed harm. And SPIN trial showed around 35% benefit in the strict BP control. It was because of less statistical power in ACCORD than SPRINT. Moreover, the heterogeneous treatment effect was seen in both SPRINT and ACCORD trial. And this can be corrected through the AI-directed data handling. So these facts highlight the importance of real-world data rather than simply those from controlled data to generate evidence that is relevant to real lives. Similarly, the AI tools involve the use of computational algorithm. They also take BP value from home measurement, and then it can be used to predict the incident hypertension in persons who doesn't have this. And it also used to diagnose the secondary hypertension, evaluate effect of antihypertensive therapy. It can be also useful in data randomization. But the more important discovery is their recent discovery of Janus kinase 329. And this inhibitor showed good activity. However, the amazing fact was that due to AI, these inhibitors were discovered and validated in weeks. So the use of AI in precision hypertension is going to be more and more. The polygenic risk scores comprised of all significant BP-associated SNP showed a significant association with stroke, CAD, heart failure, left ventricular mass, but not for kidney function. But more evidence is required to calculate the polygenic risk score. This could be potentially
please conclude now.
Yeah, 2 minutes is there. So, I still have time, sir. I will finish within time. So more evidence is needed for polygenic risk score, and this could potentially be addressed through novel AI algorithm with greater predictive power. So pharmacogenomics is another study which shows how an individual's genetic variation affect their response to medication, and this will help in selecting right dose and adjusting drug doses. But what are the technical challenges? Technical challenges in data integration and quality. Strategy to improve data quality should be there. Interpreting genetic variation is very difficult in polygenic hypertension. AI has potential to streamline the interpretation of data, but again, it needs better understanding. However, significant progress is needed to reduce the cost and improve the speed of genome-based diagnostics. Clinical integration and adoption is also very much required in practicality of practical application of these data. What are the future trends? Research trend, current research in precision medicine is focusing on the integration of multi-omics data. Innovations are there in the CRISPR-based gene editing, single cell sequencing, and wearable health monitoring device are opening new avenues for personalized intervention and continuous health monitoring. Additionally, the development of advanced diagnostic tools and imaging technology is improving early detection and treatment of diseases. So summary, precision medicine holds the promise of revolutionizing healthcare by providing tailored treatment based on individual genetic profiles, environmental factors, and lifestyles. As advancement in technology and data integration continue, precision medicine will increasingly become a cornerstone of modern healthcare, paving the way for more proactive and preventive health strategy. Thank you.
Thank you, Dr. Ashish, for very good lecture.
Request the panels to speak something. Sir, few comments on whatever is being spoken. So, I'll like comment from Dr. Chatterjee on this issue. Sir.
I don't have much knowledge about it, but what I can see is that there are certain very good things which are coming up. But this will take a long time, And at the moment, as you see in each patient, what I personally feel that if you treat all the patients individually, I mean, ask the patient to take the home blood pressure and see the result and modify your regimen accordingly. That will be the most important thing at the moment. Future we do not know. We can have you can have an open
quick
sky.
comment from Dr. Samal sir. Sir.
Once you have got really into the track of AIE, I think it is absolutely easy for any one of us to do it. Even day-to-day practice, that is even writing a prescription for hypertension, as you put your data and put AIE, you find how beautiful algorithm it comes.
So first thing,
Yes.
sir, you agree that data is the most important thing.
Data is
We
important
are not
and the
doing that.
method is important. That AI, it is not the data you analyze in the typical statistical way.
Yeah.
Thank you very much.
Thank you.
And it's a wonderful talk.
Thank you, sir. Thank you very much. Thank you. So we go ahead with the next speaker, the 2025 hypertension guidelines. None else than other than Dr. Nirav Kumar from Apollo Hospital, Patna. He's a brilliant guy, a dynamic cardiologist. Over to you.
Thank you, sir, for your kind word. Good morning, everybody. I must say thanks to organizer for giving me the chance. So my topic is the guideline. I should speak about the guideline, although it is very difficult to summarize all the guideline and salient feature. I will try to do justice. So these are the two important guidelines, the ACC and AHA and ESC guideline. ACC, AHA is the current 2025 guideline. So according to this guideline, the prevalence of hypertension is very high. Overall prevalence is almost 50% of population is suffering from hypertension. At the age of 18 to 30, the prevalence in men is around 20% and women is around 9%. By age of 75 to 80, the prevalence rises up to 83%. So almost 8 out of 10 person is suffering from hypertension at this age. So they give proper emphasis for measurement, because measurement is very important for diagnosis, as said by Dr. Chatterjee, sir. So according to this, the cuff size should be appropriate. It should be at the level of heart, and there should be a sitting of at least 5 minutes, and there should be a calm environment, no smoking, no the coffee should be there. So this is the way we should take the blood pressure. So these guidelines approved for use of ambulatory BP monitoring and homebound BP monitoring, because these are the more realistic measurement of blood pressure. So both the guideline favor the homebound monitoring. So even if we are obsessed with the office blood pressure measurement, according to these guidelines, at least 5 minutes seated should be comfortably in the patient, and the validation of the machine is very important. The cuff should be, as I mentioned, the first time we should measure for the orthostatic hypotension also. We should take at least 3 measurements, and last 2 measurement average is important. We should record the heart rate also, and we should measure the blood pressure in both the hands, so that we should rule out some of the possibility like aortoitis. So this should be the norm during the clinic measurement. Home-based measurement also, the validation is very important. The sitting is important for 5 minutes. 2 readings should be taken. At least 3 to 7 days reading should be there. And in ambulatory, it is again the validation is important. The device is usually taking the BP at 15 to 30 minutes interval in daytime and 30 to 60 minutes at night time. And again, the cuff should be at heart level. And the cutoff for ambulatory BP monitoring at night is around 120 to 70 mmHg. So for confirmation of blood pressure, there should be ambulatory BP monitoring as well as home BP monitoring. And if not possible, then repeated clinical measurement is important. So they also emphasize about the etiology and pathophysiology of the condition. These are the factors like genetic factor, behavioral factor. It could be because of physical inactivity, sedentary lifestyle, renal mechanism may be there, hormonal mechanism, the neural mechanism, the vascular theory is there, environmental and socio-economic factor is there. Stress is very important for hypertension. So these are the important factors, and these are the target organ which can be damaged, and we should assess these target organ, because the intensity of treatment depends upon the whether target organ damage is not is there or not, like microvascular remodeling in eye, the hypertensive retinopathy, the changes in brain, changes in heart like LVH and LA-LV dilatation, AF, and the changes in larger artery, in changes in kidney also, and microcirculation. So these are the mechanisms to know whether target organ damage is there or not. Like EGFR, we should assess, we should look for the ACR. In ECG, we should look for the LVH. In echocardiography, we should look for the mass as well as diastolic dysfunction, cardiac biomarker, carotid femoral ultrasound can be done, pulse based velocity, and CT calcium scoring is also there to know that whether their target organ damage is there or not. So always when their new guideline comes, there is change in classification. This time also there is change in classification. According to ESC, there is 3 grade only. The non-elevated, which is below 120/70, elevated in between 120 to 40. That is the elevated range. And for diastole, it is in between to 70 to 90. And in if blood pressure is more than 140/90, it is hypertension. And according to ABPM, it should be more than 130/80 at 24-hour reading, and night time it should be more than 120/70. So these are the 3 classification for the ESC guideline. And according to ACC AHA guideline, there is normal, elevated, then stage 1. Stage 1 is the elevated of ESC. In between 130 to 139 and diastolic 80 to 89. So blood pressure above 130 is hypertension, and it is grade 1 according to ACC-HA. So these are the normal cutoff level as mentioned by Dr. Yuan Singh also. So how we should treat this, the treatment is important. So according to this guideline, if blood pressure is below if blood pressure is in all the conditions, the lifestyle therapy is important. If blood pressure is in between 130 to 190, 130 to 140 systolic and diastolic 80 to 90 should be treated if there is evidence of target organ damage, if high risk scoring is there. So if, like diabetes mellitus patients should be treated with if blood pressure is more than 130. So if blood pressure is more than 140/90, it should be treated with medical therapy. And if so similar thing is sounded with the ESC guideline also. Here you can see if there is high risk ethnicity, a family history of premature atherosclerosis vascular disease, socioeconomic deprivation, autoimmune disease, even HIV. So if these are the high risk condition. If blood pressure is more, it should be treated with. If blood pressure is more than 130, it should be treated. So these are the triple drug which is available for treatment like ACE-ARB, calcium channel blocker, and diuretics. If blood pressure is still uncontrolled, then we can add spironolactone. And regarding beta blocker, it should be added if there is compulsive indication like angina, post-MI infarction, and heart failure. So in these conditions, beta blocker can be added. And ultimately, if blood pressure is still not controlled, then alpha blocker, centrally acting BP lowering agent, potassium aspirin diuretics can be added. So as we discussed, in all the conditions, if blood pressure is more than 130 and there is target organ damage or a high risk, in that condition, patients should be treated. And you can see this chart. If blood pressure is more than 180, then hypertensive emergencies should be excluded. If systolic blood pressure is more than 180, and there is evidence of target organ damage, then it is hypertensive emergency. Similarly, if blood pressure is more than 140, it should be treated. If blood pressure is 130, in between the 130 and 40, it should be treated if high risk condition is there. And target for all the blood pressure should be below 129 to 120. So they also mentioned about the secondary hypertension, and I already discussed if there is drug resistance, if there is abrupt onset of hypertension, if onset of hypertension is before 30 years of age. So in all those conditions, we should think about the secondary hypertension, and we should screen for secondary hypertension also. As we discussed it, the primary hyperaldosteronism is second most common cause of, so it should be evaluated if there is hypertension in younger population. So these are the important causes as discussed by my previous speaker. So in a special condition like pregnancy and hypertension, there is always confusion at what level we should treat the blood pressure and what should be the drug. So if pregnancy is there, the target is 140/90. We should start the therapy if blood pressure is more than 140/90. We should keep the blood pressure below 140/90, but diastolic pressure should not be less than 80. That is very important to maintain the fetal circulation. And we should advise the patient to do exercise. And these are the medicine which can be used in pregnancy, like extended release nifedipine, labetalol, and methyl-dopa. These medicines are safe in pregnancy. And according to ASC/ACHA guideline, hydrochlorothiazide can be used also. So these are the 5th medicine which can be used in pregnancy and hypertension. In eclampsia, we can use IV labetalol, IV nicardipine, and magnesium. The other thing which can be used is IV nitroglycerin if pulmonary edema is there, and intravenous hydralazine is other choice which can be used in pregnancy induced hypertension. So what we should do in hypertension in old population? If age is less than 85 and there is no fragility, in that condition, these patients should be treated as younger population. If age is more than 85 and fragility is there, in that condition, we should use preferably the CC, calcium channel blocker, and renin-angiotensin inhibitor. We should avoid high dose of diuretics and beta blocker and alpha blocker, because these things can cause postural hypotension. So if age is more than 85, we should avoid using diuretics, heavy dose, the beta blocker and alpha blocker also. So if hypertension and diabetic is there, in that condition, the important thing is ACE/ARB should be used to prevent the progression of the renal dysfunction, as well as the BP should be, we should start the medicine if blood pressure is more than 130/80, or systolic is more, if 130 should be treated. So if hypertension and kidney disease is there, in that condition, this is also very important condition what we should use. In hypertension and kidney, the target is around 130/80. If blood pressure is more than 130/80, it should be treated. The target is we should keep the blood pressure below 130, systolic blood pressure. And ACE inhibitor and ARB is indicated in all the stages of renal failure. If proteinuria is there, if proteinuria is mild, or if proteinuria is not there, even in that condition, ACE ARB should be used. We have tendency to stop the ACE and ARB when kidney failure is there, so that is not true. It is drug of choice. In stroke patient, this is also very important. In stroke patient, if there is a stroke, the thromboembolism is there, and we are planning for thrombolysis. In that condition, we should keep the blood pressure below 180/105. If blood pressure, if we are not planning for the thrombolysis, in that condition, lowering should be modest. No more than 15% reduction should be done in first 24 hours. Because the blood pressure is the only thing which is maintaining the blood pressure of brain. Because auto-regulation has been failed, so we should allow higher blood pressure. Again, in the same time, if there is cerebral intracerebral hemorrhage, BP should be reduced as early as possible within 6 hours. The target is below 160 or 140. So if intracerebral hemorrhage is there, keep the blood pressure as early as possible, and it should be below 160 and 140. So in case of hypertensive emergency, so what we should do? So in case of hypertensive emergency, if it is cardiac emergency, like pulmonary edema is there, aortic dissection is there, keep the blood pressure as low as possible, below 140. If pulmonary aortic dissection is there, keep the blood pressure below 120. And if hypertensive emergency is there, and it is not cardiac emergency, in that condition, the lowering of blood pressure should be gradual. If you are getting a hypertension, if you are getting hypertensive in emergency, better to keep the blood pressure slowly. So this should be, and if you are getting a hypertensive, very high blood pressure in OPD and there is no target organ damage, don't give IV infusion, better to continue with the oral medication. So in summary, diagnosis should be there, it should be homebound, and the classification is, we should keep eye on the classification also. Above 130, we should start the medication if high risk is there. In treatment, the appropriate medical therapy should be there, and we should look for the special condition also. Thank you.
Thank you very much. Any comment from the panelist? Quick comment, Dr. Agrawal. Any quick comment on any of the topics? Yeah.
Very good disposition of the subject. I think he has done well.
Ram Sagar, would you comment on anything you want? Anything your choice?
Every aspect of guidelines, treatment management,
every aspect of hypertension, I think.
Thank you. Dr. Bhamani, Dr. Bharti, any comment on any of the topics spoken? Sorry, sir, please, sir. Because, unless you take interest, it will be very difficult.
I've got two basic questions from any of the speakers. How do you validate the machine? Nowadays, nobody is using the mercury manometers, very few, like us. But the machines which are being used for measuring the blood pressure, that's the main thing. You have to have a correct measurement of the blood pressure before taking any decision.
Absolutely, very, very important.
So what machines are validated? Can anybody comment on the models of the validated machines available in India?
So
Yeah.
same question was disturbing me also, how to validate.
Yeah.
So there is website for validation. So they mentioned the website.
Which is
the
the best
guideline.
machine, Nirav?
Can
According to you.
The other thing is, if automatic machine is more than 4-year-old, it should be discarded. The third thing is, if you want to validate in the normally, you can take those machine to the clinic reading machine, and it should be measure if blood pressure difference is more than 10 mmHg in systole, then it is wrong.
What I am doing practically is it's not, I keep both the machines, and at least daily or every alternate day I try to keep one patient, measure blood pressure with both the machines and try to find out how much is the difference. And that's how I am going on. The second question is that in ambulatory blood pressure monitoring, I am doing it very frequently. Some of the patients who have got a normal blood pressure, average normal blood pressure, both daytime and night time. But some of the readings are very high, 160 by 120. What does it mean, and how do you think about it?
So, sir.
Dr. Bhamani, can you answer his questions, comment? Please. Thank you. Thank you.
Sir, for ambulatory BP monitoring, we see this situation that some isolated readings are quite high, but average BP is within normal limits. So I think in those cases, we don't have any answer to this situation. Maybe something we should see is that at what time the BP shot up. So that was in daytime. Was there any precipitating factor, some sudden stress? So if there is a secondary cause for that, so I think we can ignore that as long as the average BP continues to be normal. Second thing is that we should look for dippers. If the night dipping is sufficient, so and also in such cases the best thing to see is the target organ damage, maybe urinary albumin creatinine ratio and presence or absence of LVH. So that can tell us.
Very important issue you have raised, ACR.
Yeah. So if ACR is raised, that means patient is having such high BP episodes repeatedly. So
if you are managing sugar but not ACR, you are doing a crime.
Yeah.
Today's practice important.
Yeah. So I do see in such cases where actually most often some doctor colleagues come and consult me that sometimes my BP is above normal, but then at home when I check it is normal. So I tell them to check ACR. So that tells us if target organs are completely disease-free, that means that probably it is just an isolated episode. So I think we can ignore
Quick comment by Dr. Bharti. Sir.
I totally agree with Dr. Bhamani. The most problem nowadays when the mercury manometer gone, and when you are asking patient to measure the blood pressure in home, most of the very erratic reading, and they don't know about how to measure the blood pressure. The education is the most important. Most important. How the BP should be measured.
Dr. Nishant is here. Nishant, any comment you want to make? Ashok, you want to make any comment? So thank you very much, all the speakers, all the panelists. Sir.
Thank you, chairpersons. Thank you, panelists, for a very interactive session on hypertension. And next one is a very important session. It's a presidential oration by CSI President, Bihar chapter. Before inviting President, I'd like to invite the chairpersons for this session. Dr. VP Sinha, sir, please come on the dais. अशोक, वीपी सिन्हा सर को फ्री कर दो। वीपी सिन्हा सर, प्लीज। डॉक्टर सुनील कुमार सर, IGIC, प्लीज सर, ऑन द डेस्क। Dr. L.K. Prasad sir and Dr. Sanjeev Kumar sir. I invite them to chair this session, and panelists for the sessions are Dr. Sandeep Kumar, Dr. Adil Ahmad Khan, Dr. Neerav, Dr. Alok is here. नीरव कहाँ गया? डॉक्टर नीरव? अरे आपको इधर ढूंढ रहा है। हाँ, नहीं वहाँ संजीव सर। एल के दास। डॉक्टर दिलीप कुमार सर ऑन द चेयर प्लीज।
Hello.
Now I'll request Dr. K.K. Varun sir to come on the stage
This is
and deliver his presidential oration. And
presidential oration, and Dr. K.K. Varun, President CSI Bihar chapter, is invited to deliver his talk.
Respected my senior and the colleagues. CSI बिहार चैप्टर, जो आप वैज्ञानिक सत्र देख रहे हैं, ये वार्षिकोत्सव का रूप है और इसमें पूरे देश के कोने कोने से अनुभवी प्रख्यात चिकित्सक आते हैं और बिहार के विद्वान चिकित्सकों के साथ विचार विमर्श करते हैं। अंततः लाभ बिहार की जनता को ही होती है। ऐसी बात नहीं है कि हमारे चिकित्सक, हमारे बिहार के डॉक्टर काम नहीं करते हैं, मरीजों का ज्ञान नहीं है, ऐसी बात नहीं है। अब बिहार काफी एडवांस हो चुका है कार्डियोलॉजी के क्षेत्र में। अब हर क्षेत्र में कहिए, यहाँ बहुत से कैथ लैब खुल गए हैं, कॉरपोरेट लाइक हॉस्पिटल खुल गए हैं और मुझे इस बात का बहुत बड़ा गर्व है कि बिहार में मुख्यमंत्री नीतीश कुमार जी के नेतृत्व में हर क्षेत्र में जो विकास हुआ है ये दिख रहा है और हर आदमी को दिख रहा है। इसका सबसे बड़ा उदाहरण है हमारा अस्पताल इंदिरा गांधी हृदय रोग संस्थान। एक सरकारी अस्पताल होने के बावजूद भी वहां एक कॉरपोरेट से अच्छी सुविधा उपलब्ध है। किसी भी तरह का इंटरवेंशन हो, इमरजेंसी मैनेजमेंट हो या जांच हो, किसी भी तरह का वो वहां हो रहा है। मैं वैज्ञानिक सत्र का एक छोटा टॉपिक के लिए मुझे ऑर्गेनाइजिंग कमेटी द्वारा बताया गया है। प्रेसिडेंशियल ऑरेशन। प्रेसिडेंशियल ऑरेशन का अर्थ ये होता है कि जो ये कस्टमरी हो गया है हम लोगों के CSI में हर जगह होता है, हर फैकल्टी में होता होगा प्रेसिडेंट का जो संबोधन होता है उसी के लिए मुझे कहा गया है। पहले मैं अपने संस्थान के निदेशक डॉक्टर सुनील कुमार जी को तहे दिल से आभार प्रकट करता हूं, जिनके मोटिवेशन और इनिशिएटिव के रूप में इनिशिएटिव से ही आज मुझे ये महत्वपूर्ण पद पर गौरवान्वित होने का सौभाग्य प्राप्त हुआ है। अब आइए टॉपिक की बात। टॉपिक है टिपिकल एंजाइनल पेन विथ नॉर्मल कोरोनरीज। अब ये कहने में तो बड़ा खराब लगता है कि जब कोरोनरी आर्टरी ही नॉर्मल है तो फिर पेन कहां से आया, लेकिन होता है। आज से 40 वर्ष पूर्व मैंने एक छोटा सा एमसी की बुक पढ़ा था और उस बुक में एक क्वेश्चन था मल्टीपल चॉइस का। द डायग्नोसिस ऑफ हार्ट डिजीज इज डन बाय नंबर 1 ईसीजी, नंबर 2 इकोकार्डियोग्राफी, नंबर 3 ऑल द इन्वेस्टिगेशन, and number 4 history, and the correct answer is history. We must explore and clinch the diagnosis by history. ये हमारे गुरु श्री नारायण बाबू का कहना था। यदि 5 मिनट के भीतर आपने डायग्नोसिस कर लिया तो डायग्नोसिस हो जाएगा, नहीं किया तो जूते रहिए। इसीलिए हिस्ट्री का इंपॉर्टेंस है और यही हिस्ट्री के आधार पर ये जो टॉपिक है टिपिकल एंजाइनल पेन विथ नॉर्मल कोरोनरी आर्टरीज का पूरा हिसाब किताब इसी प्रश्न में छिपा हुआ है। हमने कई एक मरीज देखा है जिनका कि एक्यूट पेन चेस्ट हुआ, हमने उनको एक एसीएस समझा, ईसीजी नॉर्मल, इको नॉर्मल, ट्रॉपी नॉर्मल, अंत में जाकर के जब एंजियोग्राफी हुआ तो एंजियोग्राफी में डबल वेसल डिजीज, एंजियोप्लास्टी वगैरह सब कुछ हो गया। इसीलिए हिस्ट्री को जो मरीज जो बोल रहा है उसी के आधार पर हम लोगों को सोचना चाहिए। ना आपको हार्ट का बीमारी नहीं है, ये बेकार वाली बात है। और जैसा कि मैं तो इंग्लैंड गया नहीं हूं, लेकिन जैसा कि हमारे गुरु कहा करते थे कि इंग्लैंड में लेस देन हाफ एन आवर से जो डॉक्टर हिस्ट्री कम लेता है तो पेशेंट उनको कम टोक देता है कि भाई आपने मेरा हिस्ट्री कंप्लीट नहीं लिया। इट मीन्स कि हिस्ट्री का इंपॉर्टेंस है। इस तरह का मरीज जो है जिसके बारे में हम लोग टॉपिक कर रहे हैं, नॉर्मल कोरोनरीज विथ टिपिकल एंजाइना, कई एक मरीज हम करीब बहुत दिनों से हम इस तरह के मरीज को देख रहे हैं। संजोग से आज तक हमने कोई उस तरह का जेंट्स मरीज हमारे हाथ में नहीं लगा है, लेकिन लेडीज मरीज को तो कई एक तरह का इस तरह का। इसका मतलब है कि ये मरीज का प्रिवेलेंस जो है लेडीज में इन कंपैरिजन टू मेल बहुत ज्यादा है। और बाद में उसको वैज्ञानिक सत्रों के द्वारा, ये स्लाइड्स के द्वारा, ट्रायल के द्वारा इसे प्रूव भी किया गया कि 65% है कॉमन लेडीज में। अब ये जो हम लोग जो टॉपिक है इसको 2 भाग में बांट रहे हैं। एक भाग है जिसको एनोका कहते हैं, एंजाइनल पेन विथ नॉर्मल कोरोनरी आर्टरी डिजीज। इसमें कोरोनरी आर्टरीज नॉर्मल है नॉट बाय द इन्वेसिव प्रोसीड्यूर बट बाय सीटी एंजियोग्राफी। दूसरा है इनोका। इनोका है इस्कीमिक चेंजेज, इस्कीमिया विथ नॉर्मल नॉन ऑब्स्ट्रक्टिव कोरोनरी आर्टरी। अब है क्या कि जो एंजाइना हो रहा है उसका लोग पैथोफिजियोलॉजी निकाला कि भाई क्यों हो रहा है जब सब चीज नॉर्मल है तब। तो उसमें देखा गया कि इंडोथेलियल डिसफंक्शन का बहुत बड़ा रोल है, वैसोस्पाज्म के कारण भी होता है, और जो वैसोडाइलेटेशन है वो नॉर्मल नहीं हो पाता है या ओवर कंस्ट्रिक्शन हो जाता है, वैसो कंस्ट्रिक्शन। ये नॉर्मल कोर्स में इन्हीं सब पैथोफिजियोलॉजी पर हिसाब किताब चल रहा है। हमारा कहना इसमें अब बहुत ज्यादा डिटेल तो इसमें सब्सिक्वेंट सीजन में हमारे जो गेस्ट स्पीकर्स हैं वो बोलेंगे। हमारा कहना इसमें यही है कि इस तरह का जो एंजाइनल पेन है, छोटा, जो हार्ट जो है बहुत छोटा चीज है, लेकिन जब तक चलता रहता है आदमी जीवित रहता है, जिस समय बंद हो गया उस समय आदमी मृत घोषित होता है। इसका मतलब, इसका इंपॉर्टेंस क्या है, वी मस्ट फील। तो इसके हार्ट से रिलेटेड जो भी सिम्टम है, चाहे पेन इन बोथ शोल्डर के बीच में भी पेन हो, या नौसिया हो, या वॉमिटिंग टेंडेंसी हो, या अनड्यू टायर्डनेस हो जाए कि सुबह में हम बिल्कुल ठीक है डॉक्टर साहब, शाम में होते होते 3 बजे के बाद हमारा हालत खराब हो जाता है, इस तरह का जहां सिम्टम मिल रहा है, नेवर इग्नोर। अरे आपका तो ईसीजी नॉर्मल है, इको नॉर्मल है, ट्रॉपियप जाइए छोड़िए, टीएमटी भी नॉर्मल है, अब आगे का जरूरत नहीं। उसको मरीज का जो है बीमारी का नहीं, उसके सिम्टम का भी हमको ख्याल रख के उसका इलाज करना होगा। और उसके आधार पर हम लोग जो है, हम तो बहुत से मरीजों को देख रहे हैं कि इसमें नाइट्रेट जो है, चूंकि रिकरेंट पेन हो रहा है, रिकरेंट एंजाइना हो रहा है, मरीज को बार बार भर्ती होना पड़ रहा है डॉक्टर के यहाँ, मरीज को एंजियोग्राफी कराना पड़ रहा है, मरीज को और सब जांच हो रहा है। ये मरीज के क्वालिटी ऑफ लाइफ पर, लॉन्जिविटी पर इसका असर होता है। सो वी मस्ट टेक केयर कि हाँ, इस मरीज को यदि पेन हो रहा है तो इसका निदान होना चाहिए। अब वो जांच से हो, इलाज से हो, मरीज को ठीक होने से मतलब है। इसीलिए इसमें रिकरेंट पेन जहां होता है उसमें नाइट्रेट बहुत फायदा करता है। जो इंडोथेलियल डिसफंक्शन है उसमें एसी इनहिबिटर हम लोग देते हैं, माइक्रोवैस्कुलर एंजाइना के रूप में जो है, वहीं पर इंडोथेलियल डिसफंक्शन फॉल्टी होता है। डिल्टियाजम में का भी बहुत अच्छा रोल है, वैसोस्पाज्म वगैरह को ठीक करता है। और ओवरऑल द बेस्ट, इन माय ओपिनियन, आई मे नॉट बी करेक्ट, इन माय एक्सपीरियंसेस द बेस्ट अवेलेबल ड्रग्स फॉर दिस इज निकोरेंडिल। धन्यवाद।
हेलो हेलो,
एक सेकेंड सर, प्लीज, as is customary for oration, no
Hello.
questions are allowed.
No questions are allowed.
So
I thank our President, Dr. Barun, for his description in simple and lucid style, which is amenable to all, even lay persons. They will understand what is Minocard and Inocard. Thank you, sir.
Sir, I'd like to request Dr. B.P. Singh sir and Dr. Chatterjee sir to be on stage to felicitate our President, Dr. K.K. Barun sir. And chairpersons, please come forward. Aji Ashok. Aji bhai. Okay. So for the next session, I'll request chairpersons to come up first. Dr. UC Samal sir. UC Samal sir. शमशाद नहीं है शमशाद is here? नहीं. Ajay Sinha sir. Dr. R.P. Srivastava sir. R.P. Srivastava sir. Dr. Pankaj Ranjan, please come on the chair. Dr. B.C. Jha sir, for panelists. Dr. Sandeep Kumar. Dr. Poppy, please join as a chairperson. Sir. I'll request Professor UC Samal sir to start the proceedings for this session.
This is one of the exciting and also useful session for any one of us. And there are three topics: hyponatremia and heart failure, device therapy in heart failure with reduced ejection fraction, and indication of cardiac MRI through interesting cases. That is a case presentation. And luckily we have got also with us some guest faculty. And with this I start the topic by inviting Dr. B.B. Bharti, one of the dynamic cardiologists of ours, and who once upon a time was a student of mine also. So, hyponatremia in heart failure.
Good afternoon, my respected teachers, seniors, junior and friends. The Ashoka has given me topic of some different topic that is not related to cardiology, but very important in clinical practice. We know the hyponatremia is one of the common clinical problem which is facing by many of the patients and going to clinician and cardiologist. In heart failure it is very important because most of the heart failure hyponatremia is a dilutional hyponatremia. And overall in body the sodium is normal, but the water is more as compared to sodium. So it is very important how we tackle, how we treat. This is very important. The major concern about the symptoms, it is usually many of the asymptomatic, many persons with EG fatigability, many causes death due to seizure and brain edema. So they depend on the chronicity and acute onset of hyponatremia. So first of this is complex pathophysiology, how the patient develop hyponatremia and heart failure. We know all the hormones which will become active in the heart failure like RAS activity, sympathetic activity, but also we did not remember ADH. ADH is a very important hormone which controls the blood volume, water level. This leads to excess fluid retention, impaired renal function, and altered fluid homeostasis. Other issue which is concerned is hyponatremia is important. There are many of drugs we are using, like most commonly diuretics, sometimes poor intake, sodium restriction. This may cause the hyponatremia. So it is a very complex mechanism, and hyponatremia developed in many of the patients of heart failure. If there is chronic hyponatremia in any heart patient, it means patient has severe LV dysfunction and in stage heart failure in many of the patients. So there are mainly two types of hyponatremia. Is a hypervolemic, which is also a dilutional hyponatremia. Second is depletional hypovolemic. In dilutional hyponatremia due to excess water retention relative to sodium, commonly seen in advanced heart failure, not only seen in advanced heart failure, also in nephrotic syndrome, cirrhosis of liver. These are the conditions where you get the dilutional hyponatremia. Other hyponatremia and depletion and hyponatremia, it is due to excess sodium loss due to aggressive diuretic loss, sometimes recurrent vomiting, diarrhea, and poor intake. The former due to fluid overload, while the latter is due to actual sodium depletion and volume loss, which is euvolemic patient in which the water and sodium is in normal manner, but in hypervolemic the sodium is compared to water is more as compared to sodium. How will assess, how will diagnose, and how will go further? The most important thing, the plasma osmolality is the first thing we should measure in any patient of hyponatremic, hypervolemic patient. Plasma osmolality is less than 284, it means patient has a hypotonic hyponatremia. And how will, then next most important clinical thing, how will measure the volume? The most important way is JVP, pedal edema, and recent weight gain. Three most important clinical signs which causes the patient in fluid overload. If JVP raised, patient has pedal edema, or the patient recently gained 2 to 3 kg, 5 kg, it means patient has due to dilution hyponatremia. Then second is how the urine analysis is very important to diagnose the hypervolemic hyponatremia or the other cause of hyponatremia. They are very important, they very clinical significant. It always denotes hyponatremia, chronic hyponatremia, always denotes their severity, severe degree of heart failure, and disease is progressive. Even in patient may require the mechanical circulatory support or need the cardiac transplant. It has common complications. We know the hyponatremia can cause ventricular arrhythmia, and it has shown the increase in 60% increase mortality risk compared to normonatremic patient. There are different definitions. Mild means less than 130, moderate means less than between 125 to 129 millimole per liter. Severe means less than 125 millimole per liter. The clinical feature is simple: headache, altered behavior. Sometimes many patients complain of altered behavior. This is one of the common causes of hyponatremia in heart failure patient. There are also confusion. In very late stage, causes severe cerebral edema and seizure and respiratory arrest. This is, I have seen many of the patients develop hyponatremia in ICU setting. If not properly managed, causes cardiorespiratory arrest. The next stage to diagnose the hyponatremia is if patient has a osmolality less than 275, sodium less than, the next is the urinary sodium, very important. The 20 figure is very important. If urinary sodium less than 20, it means patient is hypovolemic. It means more than 40 millimole, it means dilution and hyponatremia. And one of the CADs like heart failure, in which patient develop, in which the ADH hormone is very high, and patient develop edema. But in the CADH, it is due to increased urine osmolality more than 100. So sometimes you may confuse with CADH in heart, that mimic like heart failure. And next, clinical assessment, I have already talked, JVP, edema, and weight loss, weight change is very crucial. Major management goal is the most important fluid restriction in the daily fluid intake should be 1 to 1.5 liter per day in hypervolemic, hyponatremic patient. Modify the dosage of drugs, try to improve cardiac output by any means, decreasing afterload or preload or optimize diuretic dosage. Loop diuretic causes less hyponatremia as compared to thiazide. This is one of the important things. Thiazide causes more hyponatremia as compared to loop diuretics. So any patient of hypervolemic, we should use the loop diuretics with fluid restriction. Avoid rapid correction, very important. If you do the rapid correction in acute phases, it may cause spontaneous demyelination. Not, it should be corrected not more than 10 millimole per 24 hours to prevent the demyelination syndrome. one of the very important Vaptan, I have read Vaptan is a V2 receptor antagonist and improve the excretion of water from the kidney without affecting electrolyte imbalance. Two Vaptan is present in market, Tolvaptan and Canivaptan, and every trial has shown in a patient with heart failure with hyponatremia, it improves the dyspnea, decreases the edema, but not improve the motility. So any patient of hypervolumic patient, you can use any Vaptan that will improve the quality of life. In acute condition like if patient is acute condition and sodium is less than 125, patient is unconscious and history of seizure, you should give the rapid bolus dose of 150 ml of 3% hypertonic saline more than 20 minutes. It will achieve around 5 millimole per liter increase in serum sodium in first hour. And I have already discussed first day you should correct around 10 milliequivalent per liter. From next day you can correct 8 milliequivalent per liter in 24-hour periods. So close clinical and biomedical monitoring is essential to avoid overcorrection. These are the therapy. The Vaptan we have already discussed, hypertonic saline. Now a very novel approach by SGLT2 inhibitor. SGLT2 inhibitor only excrete the water, not sodium too much. So it is a very good drug in patient of heart failure with hyponatremia, hypervolumic patient. The other therapy which will improve the cardiac output like AC inhibitor improve the cardiac output, improve the renal blood flow, inotrope and vasodilation. And in resistant case you can use the ultrafiltration when patient not responding to diuretics. So my conclusion is the hyponatremia in heart failure is very common, involve multiple causes, multiple pathophysiology. Diagnosis is very important, differentiate between dilution and depletion. Hyponatremia for proper management, fluid restriction is very important. Causes diuretic use, avoiding rapid correction. Root cause is replace the neurohormonal dysregulation, involve the rash, sympathetic activity, ABP and fluid overload rather than just sodium loss. Future direction is research is focusing on personal treatment strategy and the development of novel therapeutic agent to improve the outcome. Thank you.
ARBs, ACE inhibitors and ARNIs. These also can cause hyponatremia. These are often overlooked. So I think whenever we are managing hyponatremia in a case of heart failure patients, if patient is not on diuretic and if patient is not very severe, if it's only mild hyponatremia, we should not be very aggressive in treating that. Because if we want to normalize sodium levels, then in that case, the ARBs and ACE inhibitors has to be stopped. So I think mild hyponatremia without any symptoms, patient is doing fine, symptomatical better. Let us continue with, let us stick that hyponatremia. Thank you.
So, any comment from the panelist? Sorry.
Very interesting information, very useful also. 20, 40 and 100. Urinary sodium, what a good example and memory to hyponatremia.
Actually, we are now doing the plasma osmolarity regularly and not common in most of the hospital. So, if plasma osmolarity is very important to diagnose this type of the hyponatremia.
And then 100 ml that is, or how milliosmol will say that this is a case of SIAD. So it's such an important. Last point is most important, that are very impressive and also I have faced in my life. Forget it that whether case of congestive cardiac failure or heart failure, reduced ejection factor, while administering sodium chloride, one should have a lot of caution. As you have rightly said, that different concentration you have to follow. I have seen a patient who was administered with diarrhea dehydration, administered with normal saline, and over enthusiastically 4 bottles. And on the next day they called me to see because he said that he has got heart failure.
So another thing very important,
yeah,
sir.
Absolutely all sensory loss, sensorium loss, and he in coma, and he has a bilateral plantar extension. That means he has already developed severe demyelination. So this demyelination, as he has rightly described, because of osmotic mechanism, so it's very important that you remember never to be over-enthusiastic in administering normal saline, and as you feel that it's dehydrated, that is not the point. What you are going to do, you should study it clearly. Thank you.
One of the pseudo-hyponatremia is one condition. Always be careful in hyperglycemia, hypertriglyceridemia, or hyperproteinemia. These are 3 conditions when you gain false low sodium level. So exclude these things when you are diagnosing the hyponatremia. Thank you.
Very good talk, Bhakti. Plasma osmolality can be calculated. 20 sodium plus glucose in millimole. That is the rough osmolality that you can know clinically.
So we go ahead with the next talk by no less than Dr. Dilip Kumar from Kolkata. He has been a pioneer in device therapy, and I think he has mentored many hospitals of Patna. So over to you, Dilip.
So I think someone has taken my laptop. Thank you, everyone, and thanks to the organizers for calling me, and good to see some old friends, Pankaj, Ajay sir, and everyone. So I'm going to talk on device therapy in heart failure with reduced ejection fraction. I think we have come a long way in last 20 years. The devices has really changed the way heart failure is being managed now. So these are my disclosures. So when we talk about device therapy in heart failure, we have so many options, right from looking at the PA pressures, knowing the patient's heart failure status, to delivering the therapy, to synchronize the heart, to look for defibrillator therapies, and after all, pacing also in conduction system. So let me begin with a case. This was a patient who had in fact, he was an orthopedic surgeon himself, and you can see here he has a kind of a ventricular tachycardia, which was at rate of 150 going on, and he was implanted a dual chamber ICD, and the atrial lead was displaced 5 years back, and then he came to me with ejection fraction of 30% with this ICD lead which is working, but RA lead is displaced, and the patient was having a ventricular pacing. The ejection fraction, effective ejection fraction would be something around 20-25%. And then we upgraded the system, and you can see here this is what we could manage with best of the CS lead position. Now the patient had a VT episode which was terminated with non-invasive program stimulation through the device. He went home. He went to Bihar, and there he had a VT episode. So you can see here. And I was getting transmitted information from the Gallant, CRTD system on my emails. And then I called him to come again and look for, reasons why he's having VT, but he ignored. He's an orthopedic surgeon. We surgeons, we cardiologists, we are very bad patients. Something happens to us, we ignore us like anything. So he ignored. So I escalated the dose of mexiletine to 200 milligram thrice daily. Amidron also increased, beta blocker increased, and then you can see here the transmission date of January 10, 2022. VT was still happening, 29 is still happening. In February, the VT episodes were 0. So this is the device therapy in heart failure. We can treat the patient, we can monitor the patient, we can control the patient's heart from outside as well. Someone who is 200 kilometers away, we can still manage these patients. So if we implant the device as well, then only we get the best benefit. And the first step starts is the the puncture of the subclavian, and it has to be either axillary or extrathoracic puncture. And after the puncture, if we do a correct CRT, let me go through some steps of tips and tricks of CRT. So in failing heart, the CS anatomy is really deranged. You can see it's highly angulated. So you have to take sometimes a quadripolar catheter, which is deflectable, and you can telescope your catheter over that. Or the easiest way is to take the Amplas catheter, look for the ostium, and then you enter into the coronary sinus. Sometimes the RA is very dilated, hugely dilated, and then you have to take an Amplas 2 catheter. Sometimes Tiger catheter works, sometimes JR works. So you have to look for permutation combinations, but it's not easy sometimes to negotiate the catheter once you have taken your Amplas inside because of the huge curve. And there you may have to have a supporting wire like Amplas wire inside your Amplas catheter, and then you can negotiate a sheath over that. So this is how we do in complicated anatomies. Sometimes we might dissect the coronary sinus while going into the CS, but it is not a deterrent. You can still pass your coronary wire, and you can still go with the procedure. Sometimes you can appreciate these kind of structures while looking for coronary sinus, and these are large Sebacean veins, and so should not be feel that you have dissected that. So these are some variants which we should be aware. And many times when the patient has this kind of anatomy from left to right, you are going to upgrade. You have to improvise all these skills, and then you have to continue. And from right side also CRTs can be done effectively. And many times you have to be ready with subclavian interventions before while doing the CRT, because this patient had a complex CABG with CABG done earlier, and then now with double valve replacement, and I had to go for a CRTD. I had to do a subclavian vein dilatation, balloon dilatation. This was a JACC publication, and then we could do a CRTD. So these are some tips and tricks. And many times we have to dilate the the vein in which we try to go in. Like this patient, there was a stenosis in the desired vein, and then we had to dilate this with a coronary balloon, and finally we took the catheter down and we could do the CRT. Also, you can see here the tortuosity is the only good vein that huge tortuosity. So you can't do this case if you are not taking a subselect catheter. So the idea of subselect catheter taking should be very early. The threshold should be low, because it makes the CS lead placement quite easy, and you can see here now we can negotiate and do the procedure. However you try, in these tortuous anatomies, you may not find way to cross the lead without a subselect support. Finally, we can see here again a subselect going and working for us, and many times you can fall in a situation where you have to settle with middle cardiac vein, or this was a situation where a left persistent subclavian vein SVC to LA CS was there. Then we go through right side, you can see here. This is the LSVC to CS to RA. Then we go through right side, and the job is very easy, because your CS is large, and then you take your JR catheter. The flow is very high in these situations. You place your lead, and I think one or two observations you can make here. The wire which is there in the coronary sinus, this wire has gone through collaterals. It has come into the main body of the CS. So the wire can come out also. You can snare it also to increase the support. So these are some tips and tricks of CRT, which is a magical therapy. I tell you, once you do a CRT, the ejection fraction really goes up. And finally come to the conduction system pacing. All these studies which have shown till now, so whichever way you do, be it Medtronic, be it Abbott, be it Boston, you get a ECG like this, a narrow QRS, best possible ECG. And tools and tricks I will not go in detail, and I think this has been discussed a lot, how we choose the position. And this was a lot CRT. You can see the ECG of the patient, 42-year-old ejection fraction of 28%. And this was a lot CRT, and this was the ECG which we got. And all these studies which are there, which have proven that left bundle pacing is better than IV pacing in reducing the QRS complex and increasing the ejection fraction. So just a matter of time when our CRT is going to have a backseat, and first we are going to do a CSP. If we are failing, then we are going for a LOT CRT. So this is the future, or a CRT. And HOT and LOT CRT, they have also some benefits. What we have seen in our patients, we have published that also. In patients with non-LBB morphology, RB with LHB, with QRS between 120 150 millisecond, patient DCM, you can't do anything. Let's try with a LOT CRT, and we found that there are some benefits. We published that. Finally, coming to backbone bundle pacing, which now I am doing and trying to promote this, because if we see notched P waves, this is a precursor for future atrial fibrillation, which can further deteriorate heart function, and if patient has a reduced ejection fraction, it will have further problem. And if we pick the backbone bundle pace, then you can see here chances of AF will be lesser, and the atrial synchronized pacing will be there. The P wave will be unnotched, with no notching, shorter and taller. And we are working on that. And in our lab, most of the patients now we are doing complete physiological pacing, and this is how we do. You can see here the RA-SVC junction, where the blue arrow is there. So this is basically the level where SVC and RA meets. And this is the place where just behind the crista terminalis, below the crista terminalis, you can get this backbone bundle area. And potentials you can appreciate here. These are the potentials. So there is a near field backbone potential, and there is a far field P wave activity which is being seen here. So if you see these complexes, then you are pretty sure you are in that area. And then you pace and see the P wave morphology, P wave duration. From intrinsic P wave, it should be shorter than 10 millisecond. That is all you need to see. And you can also see there is isoelectric line and a backbone potential while being paced also you can appreciate sometimes. So this is how we do. This is first LV lead, LV bundle lead positioned. And now the second catheter, which is also what we call 315 sheath, which is X4 or X5 we take depending on the anatomy. And you drag it to the RA-SVC junction. And in LO and RO we position it. We can also give venograms, some contrast injections to see that our height is proper. Then we screw in. Then we sense. You can see here, this is not the correct potential. This is a split potential. It's crista terminalis potential. So this is what is not backbone potential. This is not a proper place. So we go to the site. This is the proper site. So here you can see here. This is P wave is preceded by this near field signal by 20 milliseconds, and then you screw in there, pace, and you can reduce the P wave duration and the fragmentation of P waves. So, and the further job which is left out is once you screw in, then the job is you have to keep the loop and you have to push the catheter with the lead little bit in, and you make an alpha loop, because otherwise your RA lead will come out. So this is a bigger trick. You finding the backbone potential going inside is not difficult. Bringing out the sheath is difficult in this. So you have to push it forward, make an alpha loop, and finally you have to slit the catheter and then make a normal RA loop and come out. And I will finish in 2 minutes. So you can see here, now I'm pacing, and you can see the P wave transition from P this to the P this. I will again follow this. You can see the fragmented P waves, notched P wave, and once we pace, you can no notching, but there is a taller, shorter P wave. So this is the backbone bundle pacing, and we do all these conduction snare pacing in tower patients who have a low ejection fraction. And I will end my talk with 2 devices which are there, but not used frequently. Maybe in future they have got, they may have better roles. Like this is a CCM. I think 5 CCMs have been implanted, till now in India, and it basically paces the heart in the refractory period and does some calcium channel, modification and some gene signaling which enhances the heart function. We have some studies there, but these are kind of you can do, you may not do. And mechanical circulatory support, this is one case which we have done for a VAD, a HeartMate 2 device. Ultimately, the patient died. A patient had a refractory heart failure, was on ventilation for 3 months, was on ECMO for 3 months. Then we tried out this, but patient didn't survive. And HeartMate 3 has been recalled. So we don't have any HeartMate devices at this moment. So we don't have VAD. We have transplant, we have conduction system pacing, IV pacings, and lot CRTs. That's what we have. Thank you all for the patient hearing. Thank you so much.
Thank you very much. Samsad, you are very active in this field. Will you like to comment or ask any question from?
So what hardware we need? Can it
There
be
is
done
a,
with
just like 315 sheet,
315?
it also has a sheet which is shorter, 26 centimeter, and that is called 315 X4 sheet. So that has designed to go there and reach the backbone bundle area.
So what is the difference between the curve? The
So
curve
it is
just,
smaller and it is not too, there is no primary secondary curve, there is only one curve which goes and fit there.
And second, the number of screws. While we go with the left bundle area, with Medtronic leads, we usually go with 16, 17, 20 screws. What is the screw limit? Because the atrial wall is thin.
Yes, so this is very important, very good question. Where we normally place the RA lead is in RA appendage, which is a very thin structure. And it is not very uncommon to see, especially elderly ladies, where you have done a RA lead, dual chamber pacemaker, and the patient has a little pericardial effusion or tamponade because RA lead has gone and pierced the appendage. But this place of backbone bundle area, this is a thicker structure. And this is 2 to 3 centimeters, more than, the normal appendage. And you can go there inside, chances of perforation is less. But the screw which is there, it has to be, going into, not 2 to 3 millimeter, not centimeter, 2 to 3 millimeter. You can go 4 or 5 turns only, not more than 4 or 5 turns. And then you can pace and see.
So one thing which is confusing, while we negotiate the sheath, because you said that we have to make the loop first, we have to push the sheath along with the leads.
Yes.
So what we have observed with the left bundle area, when the sheath is negotiated, there is slight micro dislodgement most of the time. But with 4 or 5 turns only.
Yeah, risk remains there, but I think, my limited experience of 10, 11 cases till now, so many times I had to reposition. So this is evolving science, and still we are not very clear. And we had a good workshop with Dr. Leventopoulos from Greece, who has a pioneering work on this backbone bundle, and he was very impressed with our center, and we have collaborated to do a study also. We have started enrolling patients also. And he was saying to me, Dr. Dilip, backbone bundle area pacing is a very strange, kind of stage of evolution. Many people talk about backbone bundle, but they are not clear what is backbone bundle, what signals they get. So the bottom line is narrowing of the P wave, absence of notching and slurring, and a shorter P wave. If you get in that area, and the potential which I showed you, that annotation was done by Leventopoulos only. The initial, which was not backbone bundle, you remember when I showed, it was annotated by Leventopoulos. See, Dr. Kumar, this is not a backbone bundle deflection. Sharper, taller, and fragmented. Near field sharper wave, then there is a far field P wave. So this is a backbone bundle. So we need quite a workshop.
So what do you think is the best indication? For what indication are you doing backmans? Because like I was talking to Narasimhan's team, they are very curious to start a project with us. And that is diastolic heart failure.
Absolutely, yeah.
Yeah.
So 6 syndrome patients should not see, the idea of backbone bundle is to preserve atrial contraction, synchrony, and to reduce chances of atrial fibrillation. The basic idea is reducing atrial fibrillation.
So
if atrial fibrillation will be less, FPF will be lesser. And in FPF you synchronize LV,
His
RV.
team, Muthiya Subramaniam and all those people, they are trying to generate a countrywide plan to do backman pacing for diastolic heart failure. Do you agree on that point?
Absolutely, sir, absolutely. So what we are planning, we are keeping 3 arms. One is backbone bundle with left bundle, one is left bundle only, and one is normal dual chamber. And we follow these patients, see how much is the percentage of patients who are getting atrial fibrillation in future, what is the ejection fraction going like that. So let's see how it goes. And it's an evolving science, and it's very, very interesting. Yeah.
So basically, it is changing day by day. Initially, we were more concerned regarding ventricular dysynchrony. But
Yeah,
now we have
absolutely.
achieved that.
It was a great talk by very
now we are
enlightening.
targeting atrial dysynchrony.
Absolutely.
So we are trying to achieve atrial synchrony to get more help in diastolic heart rate.
Everything physiological is better.
Yes.
Thank you, sir. Thank you so much.
I would like to invite Dr. Ranjan Kumar. He will talk on indications of cardiac MRI through his interesting cases.
Let me introduce Dr. Ranjan because we know each other for quite some time, and Ranjan has been very proactive in updating our department of radiology in Medanta. Now we are doing a lot of cardiac MRI, cardiac workup, CT coronary angiogram and cardiac MRI with his vision, and he has been trained, he has been going here and there, and he has been doing a lot of CMRs. So over to you.
Thank you, sir, for kind introduction. Good afternoon, everyone. So in next 12-15 minutes, I'll be showing a few interesting cases of cardiac MRI, which you are getting in your day-to-day practice. And after seeing these cases, you will get to understand the indications of cardiac MRI. So without any delay, I'll go for my first case. This is a 52-year-old female patient presented with shortness of breath for a few weeks. Pleural effusion was found. It was aspirated. It was transudative in nature. Then again follow-up after 1 month. Recurrent pleural effusion, bilateral pleural effusion was found. And on investigation, protein was in urine. Then referred to nephrologist, pulmonologist. And pulmonologist thought that this is not a simple pleural effusion due to local lung or pleural disease. So further investigation was done, and ECG and echo was done also in this patient. And on ECG, if you see, this is markedly low voltage wave in all the leads. And on echo, if you see, there is moderate to mild concentric thickening of the LV myocardium, mild thickening of the RV myocardium as well, and there is biatrial dilatation. So there was suspicion of restrictive physiology, so cardiac MRI was advised for further evaluation. If you see, these are short axis cine image and 4-chamber view showing the thickening of the LV myocardium and RV myocardium. There is, if you see my arrow, yes, the mild pericardial effusion was there. And then there's a T1 and T2 mapping. On T1 mapping, there is diffusely very high T1 value in LV myocardium. It is coming off 1270. My lower cutoff is, normally it should be less than 1100, so it is very high, showing that something fibrotic or edema or some infiltrative disease is going on. So before giving contrast gadolinium, we do nulling of the myocardium, and normal physiology is there is, first of all, there is nulling of the LV cavity and then nulling of the LV myocardium. But in this case, if you see, there is blackening of the LV cavity and myocardium is happening simultaneously. This is very characteristic in this case. And after giving gadolinium, if you see, there is subendocardial, diffuse subendocardial to transmural enhancement, and diffusely there is enhancement. So low voltage ECG, LV thickening, restrictive physiology, high native T1 and ECG value, and subendocardial to transmural diffuse LV enhancement on LG, pleural and pericardial effusion. All these are characteristics of cardiac amyloidosis. So we have given the diagnosis of cardiac amyloidosis, and there is no need of myocardial biopsy if these are the findings what we get on cardiac MRI.
Ranjan, Dr. Samal
Sir.
wanted to see that echo characteristic picture.
Okay.
Yeah, do you have that?
Echo, I think you have to say the more details, sir.
Apical sparing is a characteristic.
On, I think, yes, sir, on the strain imaging, that is, but strain imaging, I don't have that, sir. Okay, sir. And this is immunoelectrophoresis, where the kappa and lambda region were high, and on bone biopsy, bone marrow biopsy, it was amyloid deposit seen. So it was confirmed on these findings. But even this is not required if the typical findings on MRI was there. Next case, 40-year-old male patient, shortness of breath, palpitation, dilated RA and RV was found on echo, but there was no cause for RA and RV dilatation. So to pick up the cause and to rule out the ARVC, cardiac MRI was advised. We did cardiac MRI in this patient. If you see, there is marked dilatation of RA and RV. And if you look this image, there is ASD. This is sinus venosus ASD. And then if you see, this is angio image of the same patient, cardiac angio image of the thorax. I want to scroll this and show you. There is, yes, if you see, there is abnormal draining of the upper lobe pulmonary vein into the superior vena cava, and then it is eventually draining into right atrium. So this is PAPVC with sinus venosus ASD. Commonly, I have seen that on echo, sinus venosus ASD missed out. So whenever you get the RA and RV dilatation without finding any cause, so don't hesitate to advise for cardiac CT or cardiac MR. A very interesting case, 64-year-old male patient presented with shortness of breath and chest pain. On echo, there was mass lesion in right atrium, and for that patient was referred for cardiac MR, and we did cardiac MR. If you see, there is this nodular well-defined mass lesion in right atrioventricular groove. It is not in the right atrium, and you can see there is central bright focus in the center of the lesion. Similarly, in an inferior aspect of the heart, there is oval mass lesion, and a linear bright structure is crossing this lesion. This is a short axis view. The lesions are in inferior aspect again, and lesion, one small lesion was also in anterior interventricular groove in LAD territory. Then I thought that these are the, it is not moving. Slide is not moving. देखना भाई. Slide को next one. But ये नहीं आ रहा, arrow नहीं आ रहा. If you see, these are the post-contrast images showing heterogeneous enhancement in this lesion. So I thought that these are the pericardial lymph nodes. And for this patient, we advised CT thorax also to look for the lymph nodal status and to further characterize the lesion. It was not moving. Can I attach my laptop? इसको scroll करना है. The video. तो दिखाओ ऐसे. ये क्यों नहीं आ रहा? Okay. if you see, there are multiple enlarged mediastinal lymph nodes, and if you see the mass lesion, so difficult to scroll. Yes. So these are the mediastinal lymph nodes, and if we go lower down to see the mass lesions, so this is the well-defined mass lesion in right atrioventricular groove, and in center the right coronary arteries crossing, and right coronary artery has calcified plaque. So in all, फिर रुक गया. So in all these nodular mass lesion, there was crossing of the coronary arteries. So it was not mass lesion, it was mass-like nodular mass-like nodular thickening of the coronary arterial wall. If you see, this is coronary artery crossing through the mass lesion. So a nodular mass-like thickening of the coronary arterial wall and mediastinal lymphadenopathy. So it's a very rare disease. These all findings can happen with IgG4 related coronary artery disease. Patient we have advised for serum IgG4 level and transbronchial biopsy of the mediastinal lymph nodes, but patient was poor and we lost follow-up. Next, my next case is 42-year-old male patient with shortness of breath and palpitation. On echo, there was suspicion of constrictive pericarditis, constrictive physiology, then cardiac MR was advised. We done cardiac MR. If you see, this is a two-chamber view. There is thickening of the, focal thickening of the pericardium, but we are not sure that whether this is causing the constrictive physiology. On fourth chamber view, cine image marked by atrial dilatation, and there is a tubular shape of the RV and LV. So it's a constrictive physiology. We give contrast after LG. You can see there is a mild peripheral pericardial enhancement, and in pericardial cases, we usually do the CT cuts of the patient, and this is the NCCT of the thorax. You can see bulky calcification and thickening of the myocardium, pericardium. So this is chronic constrictive pericarditis. So MRI is very good at picking up pericardial disease. My next case is 62-year-old male patient with chest pain and features of heart failure. Ejection fraction was low. Then catheter angio was done. It was normal in first view. But then NCCT chest was advised, and you can see there is moderate to marked hyperdense pericardial effusion. And minimal bilateral pleural effusion. So cardiac MR was advised to look further, and if you see, there is a focal thinning of anterolateral wall. There is focal thinning and aneurysmal bulge of anterolateral wall, and there is this segment is akinetic. We give contrast, and on fourth chamber view also you can confirm that this is aneurysmal bulge and thinning of the anterolateral wall. And in edema imaging, there is edema in this segment, and on contrast, नहीं चल रहा. These segments on LG, and you can see there is non-enhancing hypointense black areas on 4-chamber view. This is transmural enhancement, and if you see there is non-enhancing thrombus within this aneurysmal dilatation. So it's, and then again catheter angio was reviewed, and there was total occlusion of one diagonal branch. So this is acute ischemic infarct with aneurysmal dilatation, thrombus, hemopericardium, most likely, let's say, contained LV rupture. Another case, 59-year-old male with coronary artery disease, low ejection fraction. Cardiac MR was advised to look the viability of the myocardium. If you see, there is a akinetic anteroseptal wall and thinning of the wall. So after giving contrast, there is transmural enhancement of the anteroseptal wall in basal midcavity and apical region. And you can see there is non-enhancing hypointense black areas inside the myocardium surrounded by transmural enhancement. On 4-chamber view, this is non-enhancing area in the myocardium and surrounding enhancement, transmural enhancement.
Time, sir.
So it's a LG.
Sir, you are done with your time.
Sir.
You are done with your time.
Okay, sir. This is last case. So this is a ischemic cardiomyopathy with most likely intramyocardial hemorrhage or microvascular obstruction. So the last case, 1 second. It's a thinning of the basal septum on echo, cardiac MRI was advised. You can see thinning and akinetic of the basal septum. And on edema, there is no edema, and there is on LG, there is mid-myocardial enhancement, patchy mid-myocardial enhancement in septum, inferior wall, anterior wall. So we have given myocarditis with possibility of sarcoidosis, and we did PET CT image, and if you see, there is uptake in the LV and RA wall and LV, septum and inferolateral wall. And after 5 months follow-up PET CT, after anti-sarcoid therapy, all the lesions were resolved. So this is cardiac sarcoidosis. So we have seen the indications of cardiac MR, HCM, amyloidosis, sarcoidosis, ischemic versus non-ischemic, IgG4 related disease, sinus venosus ASD, pericardial disease, and even cardiac masses. So these are the common indications for cardiac MR. Thank you very much.
Very nice presentation, Dr.
Sorry for
Ranjan.
technical glitch.
No problem, no problem. Although your slides got interrupted a number of times, but presentation was good. We all know that cardiac MRI has drastically changed the approach to the cardiac patient regarding structural as well as functional abnormalities of the heart. Just one simple question, practical question I'm going to ask you. Most of the cardiac patient having claustrophobia or breath holding difficulties, because most of the patients are sick, having shortness of breath. How to overcome for cardiac MRI in such patients?
Because it's very difficult, because in cardiac MRI it's a 1 hour 15 seconds to 1.5 hour scans, and patient has to hold his or her breath for 50 to 60 times for 10 to 12 seconds. So it's very difficult, and you cannot anesthetize and give sedation and then take the MRI. Some sequences are there, they can be more faster than the normal sequences, but difficult to scan. So that those are the limitations for cardiac MRI.
Take care of other modalities. Take help of other modalities.
Yes.
You wanted a comment or something? Yeah, please.
Thank you, sir.
She is an electrophysiologist working with us. Poppy.
Thank you, sir, for your brilliant presentation, sir. I just want to add one more indication. Before we do electrophysiology and RFA, especially ischemic VT, we routinely do the MRI for the location of the scarring,
yes.
and where actually the load of scarring actually, sir. How thin is there? So this is one of the most important indication also in our cases.
For scar burden, even in dilated cardiomyopathy, HCM and VT, MRI is the modality of choice.
From anybody any comment? So thank you all. Thank you very much.
Okay, thank you very much, chairpersons and panelists. And I request everyone, we break for a while for lunch right now. Lunch is being served back. And we will meet in, we are already short of time, but we'll meet at 2 p.m. Okay, thank you. Be there as a panelist. Upendra, please, because it's an important session, I'll like to invite you as a panelist. Come. I'll request everyone to assemble in the hall and please inform someone to, we are starting the session. So I'll request the chairpersons to start the proceedings.
For this session, the speaker is Dr. Pramod Kumar Sinha. Dr. Pramod Kumar. So is there a speaker, Dr. Pramod Kumar here available? Welcome, sir. Topic of discussion is vulnerable plaque stenting, pros and cons. Sir, you can start.
First of all, thanks to the organizers for giving me an opportunity to come and speak to you all. So I'm sure you're all aware of what a vulnerable plaque is, a plaque which is prone to give complications as far as the coronary artery is concerned, ACS, MI, anything can happen. So these plaques, it's not that every vulnerable plaque will go on to develop ACS or MI. So, but there is a theory that so I'm just showing you a typical prevent trial angio. This lady had an angioplasty done yesterday on her LAD lesion, which was very tight, 95% block. And her angiogram showed this in her right coronary artery. So how many, and we did an FFR, which was negative. So this is the classical prevent trial angiogram. So how many of you would like to proceed further? We didn't do any IVUS. How many of you would like to proceed with IVUS, OCT, or NIRS? How many of you? Not even a single of one. Oh? So prevent trial has failed here. Okay, all right. So the hypothesis behind prevent trial was that, as I told you right at the beginning, that vulnerable plaque identification is a big challenge. whether you identify those patients as a vulnerable patient and you presume that they will have vulnerable plaques, or by CT. That is one of the upcoming modality where you can actually see the attenuation and remodeling, and then you can see whether it's a vulnerable plaque or not. But there are more definitive, definitions that have come through imaging. IVUS, OCT, and the recent one, the NIRS. So they have definitely changed the whole scenario. So there were two trials, Prospect 1 and Prospect 2. I'll just give you a brief. So this Prospect 1 was done in 2011 in ACS patients, Prospect 2 in 2020, where all the coronary arteries were imaged. In a patient who was in the cath lab, all the coronary arteries were imaged, and there were identified as vulnerable plaques based on their imaging quality, what was the morphology and everything. And then they were followed up, and they were found to have a definitely higher risk of ACS, MI, cardiac death. So based on that hypothesis, the PREVENT trial was conducted in South Korea, Taiwan, Japan, and New Zealand, where they defined the vulnerable plaques. I'll come to that. And then they stented those plaques in one arm, and the another arm was continued to be on GDMT. So this was the Prospect trial findings, as I have shown you here. The different lesions characteristics was, thin cap fibroatheroma, thin cap with minimal luminal area, then plaque burden. If everything was mixed, if everything was present, you can see that the MACE rate was as high as 19% in those patients over a follow-up of about 4 years. So this is the basis of the PREVENT trial. So in PREVENT trial, what they did was that in all angiograms, which were more than 50% stenosis and negative FFR, that's exactly what I showed you right at the beginning. And if they met two of the following criteria, image-defined vulnerable plaque, that is MLA less than 4 millimeters square, plaque burden more than 70%, thin cap fibroatheroma by OCT or radiofrequency IVUS, or a lipid-rich plaque by NIRS. That is the index, they call it lipid core burden index, which has to be more than 315. So there were about 1,600 patients, and they were divided into two categories. One was preventive PCI was done in those, plus optimized medical treatment. Another was only optimized medical treatment. And the primary endpoint was composite of death from cardiac cause, target vessel MI, ischemia-driven target vessel revascularization, or unplanned hospitalization due to unstable or progressive angina. So this is what I have already shown it to you. This is the one on the can I, is it working? No. Anyway, कोई बात नहीं. So one on the where the arrow is the IVUS, which shows you. The second is the virtual histology, which is also through the IVUS. The third one is the OCT, and the fourth one is the NIRS. You can see here. This is how they have defined it, and these are the pictures which they got. So inclusion criteria was again men or women at least 18 years of age, patient with angiographically significant stenosis, and any of those features on imaging. This is how the patient flow was. So 803 patients underwent preventive PCI plus OMT, and OMT alone was in 803 patients. The core lab imaging analysis showed that majority of them had a minimal lumen area less than 4. Plaque burden was again more than 70% in majority of them, almost 90% of the patients. NIRS measurement was present positive in about 41% of the patients, and by the thin cap fibroatheroma was defined either by RF IVUS or by OCT, was present in about 13 to 18% of the patients. So this is what the follow-up at 2 years. So they have 7 years follow-up now available. And as you can see here, that the curve started diverging very fast, and at the end of 2 years, it was very highly significant. As you can see here, that the preventive had just 0.4% of cumulative incidence, where OMT alone had 3.4%. There is a, you can see that even in OMT, the overall MACE rate was very low compared to the general statistics that you have. And this is what they have shown, that the target vessel failure at 7 years follow-up continued to be better in patients who underwent preventive PCI plus OMT. Again, death from any cause continued to be less in patients who underwent preventive PCI plus OMT. You know, one of the controversies which was raised when this trial was presented was that, was GMT really an OMT? Was it really? So you can see here that majority of those patients were on very high intensive statin therapy, and the average LDL level was about 60 in those patients. That was an era where the PCSK9 or inclisiran was not available, but still they were able to achieve an average of about 60 milligrams of LDL. Smokers, as you can see here in the beginning, and they gradually less and less number of smokers were present. So they did try to control the risk factors as best as they can, and both arms had similar findings. Out of all the the imaging, the parameters which they measured, the two came out to be really very important. One was plaque burden, which showed a continuous hazard ratio as the plaque burden increased, which is for a person who is most of us are dealing with angiograms, it makes a lot of sense to us that if it is 90%, definitely the hazard ratio will go up. But one of the surprise finding was that minimal luminal area was not associated with long-term prognosis, which was a little surprising. The other one was the NIRS finding was again very strongly related to the overall incidence rate. The limitations of the study, this is from a slide from the investigators. It was an open label introducing the risk of placebo. The observed rate of primary outcome was substantially lower than expected. The selection of imaging modality to assess plaque was left to operator's discretion. 9% in the preventive PCI group and 1 crossed over. The study did not collect data to examine the cost effectiveness. DAPT use was greater in the preventive PCI group, which also makes sense. We understand that person who has had PCI will definitely have a dual antiplatelet. But these are the other limitations as observed by the experts. It was not a blinded trial, So that is again a very strong point against. This is very important. The primary endpoint was mainly driven by ischemia-driven target vessel revascularization. No statistically significant difference was found in death and myocardial infarction. This was mainly an East Asian population, and as they have also mentioned, cost analysis was not done, which has again a very strong implication. This is again a South Korean cardiologist who had sent this slide to the presenters when it was presented. And this is some of the cons which he has mentioned is that atherosclerosis is a panvascular process. Plaque phenotype changes over time. 3/4 of plaque regress with medical therapy. Subclinical plaque disruption and healing contributes to plaque progression. Plaque erosion is responsible for 25 to 40% of ACS. That means that even plaques which are less than 50%, they are prone to develop ACS. And sometimes you may not be able to even see them on the normal angiograms. So again, the role of CT angio has become very important. So I continue with the limitations. Definition of vulnerable plaque is still evolving. We still don't know whether these criteria are correct or not, because I'm going to tell you is that, like what that South Korean cardiologist said, that it's a very dynamic entity, the vulnerable plaque. It doesn't remain vulnerable throughout its lifetime. In fact, this is what I was going to tell you, is that is a chronic inflammatory process, and vulnerable plaque is of dynamic nature. There was a study published in 2020 which showed that they have identified 20 and then again reimagined them after 12 months, and they found that only 25% retained that morphology on repeat imaging at 12 months later, which proves that a vulnerable plaque is not one-time vulnerable. In the prospect trial, 596 thin cap fibroerythema were identified, but only 4.3% MACE were related to VP. In Scott Hart VP identified by CT, the event rate was only 4.1. Similar finding in PROMISE trial, only 4.8% event rate over 25 months. Just goes to show that a vulnerable plaque imagined at one time is not going to remain like that, and doing something against it, whereas you know that there are inherent complications associated with angioplasty. There is annual mortality of 2% is associated with stenting. And in the best case scenario, for every 100 patients undergoing PCI of a presumed VP, 95% will derive benefit. So it's very important for us to identify. So in conclusion, I would like to say this is a very good, very well conducted trial with a robust positive outcome, but this is still a hypothesis generating trial. It definitely starts the renewed efforts to identify vulnerable plaque and thus the vulnerable patient. Systemic treatment with more powerful lipid lowering and probably anti-inflammatory agents, along with better management of all risk factors, might be a more acceptable and practical solution. Well, what is the role of DCB in such cases? This is again open to discussion and assumptions. So I would like to conclude here and tell you all that we should not jump and start stenting.
Sorry, sir, time is over.
And rest is up to you. Thank you very much.
Thank you, sir. Sir, I have a question. During proposed stenting, the poor sensitivity and specificity of the currently available diagnostic modalities like IVAS, OCT, and NIRS, near infrared spectroscopy. In spite of all, there is simply not enough data or evidence to justify the stenting in VP vulnerable plaque individuals. Despite of all trials like PREVENT trials, Scott Hart trials, and PROMISE trials. So, in my view, this topic is still controversial and conflict of interest.
Yeah, this is what I have been trying to tell you all, that this is just one trial. In fact, they have started a trial called PREVENT 2 trial, where they are going to look at the hard endpoint of myocardial infarction and death. The only problem with that trial is that it needs a huge number. The number which they have predicted is about 8,000 to 10,000. So unless until we have results from that, this is just like I told you, this is a hypothesis generating trial, and it has led to opening of many other trials being conducted on these lines. So at the moment, we are not practicing that. Nobody is practicing that. I think majority of, I will request our friends from Kolkata, are they? Devbrat and Dilip?
Yeah, yeah. I think it is a interesting trial because it tells you about certain patients who will benefit. It is not that no one benefited. There were a small group of patients that benefited. The overwhelming modality of investigation was IVAS, and there were two modalities that were followed in IVAS, but we actually do not practice that. Anyone greater than 70% plaque burden and less than 4 millimeter, we do not stent them always, especially if they are non-proximal location. So that was your point, that we don't practice it, and the speaker also agrees that that is not what we do, but we want to enhance our insight into which artery not to leave and come out. So for example, we know that if you are doing a STEMI, and if there is a 70% stenosis or 80% stenosis in another vessel, which is a proximal artery, then probably it makes good sense to do it. Because if you don't, then there is around 30% chance that you will get an event from that artery. I think this, we did not study those arteries with intravascular imaging, so we can't tell you about whether they had a high lipid core burden index or not. But the advent of NIRS has actually given us new insight. So what the trial actually showed was if you combine the ultrasound and IVUS and NIRS together, then you actually can identify a small group of patients who are at very high risk of further events. I think that is what the trial says.
Yeah, right.
Sir, as there are multiple data points to identify vulnerable plaque, and it is not cost effective to go for all those investigations. So what is, in your opinion, best investigation to identify these vulnerable plaque in our clinical practice?
CT angio. That is the best. Apart from the risk factors, which we call a vulnerable patient, a diabetic, a smoker, hypertensive. But CT at the moment is, with the new algorithms coming up in CT, especially AI assisted CT reports, the CT is now coming as a big identifier of vulnerable plaques. So we should be using it more and more. And I'm sure in coming times, with the newer CT modalities available, we will be able to identify those patients and we will be able to treat them more aggressively. Right now, CT coronary calcium score is already part of your algorithm, whether you should be giving high intensity statin or you should be giving moderate or low intensity statin. So CT has now found a place in cardiology very much. So CT is the best.
Sir, I have one question. Suppose the patient has got anterior wall MI, and on angiogram we see that the lesion is 40 to 50%. Stent it or not?
I won't. If the flow is good, I won't.
Any other modality required to see beneath the artery, sir? Whether you will go for any additional like IVUS or with virtual heart histology or OCT?
In a 40 to 50% lesion?
With, if suppose a lot some thrombus is there or...
If the flow is good, I won't.
Okay, sir.
I won't.
Thank you. Thank you, sir, for your illustrative talk. Now moving to the next topic. A 55 years old lady presented with non-ST elevation MI with having platelet counts 35,000. This is very puzzling and worryful conditions. And speaker is none other than Dr. Ravi Vishnu, is the head of Department of Cardiology, IGMS Patna. Now, welcome. Over to you, sir.
Good afternoon, respected chairpersons, panelists, faculties, delegates. First of all, I will be thankful to organizing committee for giving me the problem. The problem is the 55 years old female presented with non-ST elevation MI, platelet count 35,000, and how to proceed. We are dealing with a dual challenge. The non-ST elevation MI needs antithrombotic therapy. Whether the patient is having ongoing chest pain or is in a failure is not given to me. The patient is having severe thrombocytopenia. The risk for bleeding is high. And how to balance the ischemic versus bleeding risk, and we have to identify all the risk factors. Before going, we have to risk stratify the non-ST elevation ACS patient, whether the patient is very unstable or very high risk. These patients should go for the immediate invasive strategy. For the high risk non-ST and the intermediate risk, we should go for the routine invasive therapy, and the lower risk, we can do the medical management. Before going forward, we have to check the platelet counts because it may be the laboratory error. or there may be the pseudothrombocytopenia, which occurs when the ethylene reagent is used, and we have to give the lab that we have to use the citrate reagent so that the actual platelet count should be calculated. Also, there is a causes of decreased platelet production is there, whether the patient is suffering from viral infection, alcohol, or any B12 or folate deficiency. And also there is a drug-induced thrombocytopenia is occurred during the course of the non-acetylation MI, which is mainly due to the unfractionated heparins, GB2B3 inhibitors, even clopidogrel and antibiotics and thiazides. So thrombocytopenia is both the risk factor for the both bleeding and the ischemic complications. And the baseline thrombocytopenia refers to the thrombocytopenia that is present before the PCI. And this patient was having a severe thrombocytopenia because the platelet counts were below the 50,000, and the mildly defined as the between 100 to 149, and moderate is between 50 to 99. And these thrombocytopenia patients are underrepresented in the various randomized trials, and even if they are taken, only the mild thrombocytopenia were included in the trials. And the bleeding risk, all you know, is proportional to the degree of thrombocytopenia. So we have to take the precautions. There is no minimum platelet count to perform any diagnostic angiography if the need is there. And the aspirin administration should be used when the platelet counts are at least 10,000, and the clopidogrel should be used when the platelet counts is between 30 to 50,000, and the prasugrel, ticagrelor and GB2B inhibitors should be avoided unless the platelet counts become more than 50,000. And the unfractionated heparin is given at the dose of 50 units per kg body weight. If my patient having no ongoing ischemia, then adapt the conservative management, hold the antiplatelet temporarily if the acting bleeding is there, and correct the reversible causes, and avoid the other drugs with bleeding risk like non-steroidal anti-inflammatory drugs. And hematology referral should be done for the platelet support. There is regarding the role of the platelet in transfusion, if the patient is having the active bleeding or any invasive procedure is needed, then the role of platelet transfusion is there, but it should not be prophylactically done. Once the patient is going for the PCI or after developed bleeding during the PCI, then you can do the platelet transfusion. Now, if the PCI is needed in my patient, then what are the measures to reduce the bleeding risk? Basically, this patient falls in the high bleeding risk. This is the high bleeding population, which is difficult to manage, very complex, and the poor prospect. And these patients are usually excluded or largely underrepresented in the landmark trials. And also the long-term risk is unpredictable. These are the factors which are associated with the increased bleeding risk: age more than 75, renal disease, liver disease, anemia, no platelet, patient on the oral anticoagulants, patient having bleeding diathesis. There are the various classifications which are bleeding classifications are there, and each trial have cited one classification. The commonly used are the ISTH, Gusto bleeding classification, TB classification, and the recently which were published in the 2019, the BARC trial, the BARC bleeding score classification, which are uniformly is well known in all the trials. Coming to the risk stratification score, this is the used only for when we have to predict the long-term bleeding risk in the patients who are taking the antiplatelets. As you all know, the DAT score, when you have to give more than 30 months, from 12 to 30 months, the precise depth score at the time of discharge, and ARC HBR criteria. So this is the most commonly used for criteria for diagnosing the HBR. At least one major or two minor criteria to diagnose the HBR. There are the 14 HBR criteria and the 6 minor criteria are there. And my patient falls in the major criteria, that is the moderate or severe baseline thrombocytopenia, that is platelet count less than 1 lakh. So proton pump inhibitor should be used in all the patients. It is the class 1 indication indicated in the patient with previous GI bleeding or any diathesis, even in the old age, even the patient is taking the anticoagulants. The proton pump inhibitor should be regularly used in Now, if the patient is going for the peri-procedural anticoagulant and the antiplatelet therapy, the selection of anticoagulant and the antiplatelets with the low bleeding risk should be chosen. Aspirin should be indicated in my patient, and if the patient is going for the PCI, we should recommend the ticagrelor, or if ticagrelor is not available, then you can switch over to the clopidogrel. Avoid GB2B3A inhibitors only. It is used only for the bailout when there is a large thrombus or when there is a no reflow or slow flow, but generally it is avoided. Regarding the parenteral anticoagulation, when the patient is going for the PCI, then you could give the unfractionated heparin, or if the patient is going for the conservative management, either give the IV enoxaparin or the fondaparin-ox. Vascular access site should be chosen, mostly the radial route, because it is associated with the lower rate of bleeding, vascular complication and death. Smaller sheath should be used, and timely removal of sheath is used. If the femoral puncture is used, then the precise puncture and the use of vascular closure device is recommended. If the lesion is not in the proximal segment or the left main, then you can do simply do the balloon angioplasty and get away. Regarding the stent implantation, previously it was done in the HBR cases. You can put the drug-eluting balloon, BMS balloon, but the recent trials from the leader-free trial, JS trial, and Onyx Fund trial, even the senior trial, they have used the DES with the new generation, have shown the superior safety and the efficacy. Avoid unnecessary PCI and avoid the high-risk PCI. Avoid double stenting in bifurcation. Check for the edge dissection. Usually you should use the intravascular imaging to whether the stent is well opposed or not. Also, there is a role of drug-coated balloons in my patient, in the HBR patient. Although the ISR was the class 1 indication, but it is the evidence is broadening. It is also used in the de novo lesions, acute coronary syndrome, bifurcation, and the small vessel disease. When the patient is already on the anticoagulation, if the patient is waiting for the elective PCI, the recommendation is to wait for till the INR is less than 2 or 1.5 when the patient is on the vitamin K antagonist, or NOAC between 2 to 3 days when the patient is on the NOAC. If the urgent PCI, switch directly to the unfractionated heparin. What should be, if the patient is, once the patient gone for the PCI, the HBR patient, what should be the DAPT strategy for the first 12 months? The recommendation are, there should be the short duration dual antiplatelet therapy and early de-escalation therapy, meaning that you should give the dual antiplatelet aspirin or ticagrelor for 1 to 3 months and switch over to the ticagrelor monotherapy. This is a class 1 indication. Another 2B indication is that you give the aspirin or ticagrelor or prasugrel and de-escalate the potency of P2Y12 inhibitor to the aspirin, to the clopidogrel. And once the patient is on the triple antiplatelet, give the dual antiplatelet plus oral anticoagulant for 1 month, and then switch over to the single antiplatelet, that is clopidogrel, and the oral anticoagulant. These are the various trials which show the P2Y12 immunotherapy after a short course of dual antiplatelet, the TULITE study, TICO studies, and the ultimate DAPT study. One concept was that we should go for the aspirin-free single antiplatelet therapy just after doing the PCI, but this was not beneficial. In fact, it was harmful. So the DAPT remained the strategy 1 month at least after the coronary stent implantation. Now the future for these HBR patients are, we need the more advanced stent platforms and the more refined techniques and technology to optimize the stent implantation. We should target the inflammation, that is anti-interleukin 1 beta or anti-leukin monoclonal antibodies. Also we can use the factor 10A inhibitors, which have shown the better result in the thrombosis and less effect on the bleeding. Also there is a new formulation of aspirin that the aspirin is not dissolved in the stomach, it directly absorbs in the, dissolves in the duodenum. So these are the possible actions to mitigate the bleeding risk in my patient requiring revascularization. Regarding the antithrombotic therapy, I would prefer clopidogrel over the new generation P2 vital inhibitor. Revascular strategy, we will use the POBA without stent implantation and try to de-escalate the P2 vital inhibitor within the after the 1 month, and I would use the new generation stents to lower the dual antiplatelet therapy. And also we try to raise the platelet count in accordance with the thrombocytopenia so that we can give the full dose antithrombotic approach. Once the patient is having, my patient is having this active bleeding, then there is no PCI should be done, it should be managed conservatively. Also we have to alert on the major bleeds, on the minor bleeds. And this is the guideline which discussed by the BARC. Each BARC bleeding have the support regarding what is the management. So to conclude, the prevention represents the most effective and the cost-effective strategy in our HBR, and the bleeding prevention strategy, like we have to risk stratify the patient, what is the bleeding risk in the patient, and whether the patient is going for the invasive or high-risk procedure, and we have to personalize the antithrombotic therapy, and the more data are required in dealing with thrombocytopenia during ACS, and more trials are needed in this subgroup. So greater the difficulty, the greater is glory in the managing this patient. Thank you.
Thank you, sir, for nice question. If any question from the audience side, Dr. Ravi Vishnu will answer. Question, please. Otherwise, we'll switch over to next speaker.
I want to ask my colleagues from Patna whether they have observed anything odd about the platelet counts in their patients. Because in Bengal, I mean, we are the same region, we consistently find that our patients who come from angioplasty, their platelets range between like 1 lakh, 150,000. I mean, they are never really very high. And there is a neurointerventionist in our hospital, a South Indian guy. He came and he pointed this out to me, that didn't you know that this is Bengal thrombocytopenia? Hamare South mein there is much higher platelet counts. So I am asking whether you have noticed it as well in your patients.
Similar finding here also, and I think manual platelet count is more reliable than those CBC count.
Yeah.
One practical question.
But your patient has severe thrombocytopenia.
Severe thrombocytopenia.
It is rare, and it is, as you said, all those steps. All the steps are very good steps. You have to think on your feet and do whatever you can for these patients.
One question, sir. We are living in an endemic zone, sir, for the dengue. So suppose we have done angioplasty on dual antiplatelet drugs. One is ticagrelor and ecosprin. On 7th day, patient has fever, and the patient comes with the platelet of 40,000. So in this situation, how to deal with the?
We have to give at least the dual antiplatelet for the 1 month, because you have put the stent in that patient now.
But there is chance of falling the bleeding also, sir, in the dengue
You
patient.
have to, every patient is different. You have to manage.
So what do you have to continue the dual antiplatelet, or we can stop? Is there any level platelet counts so that we can omit one drug at least?
There are some data in this regard. After 14 days, even after 14 days, we can switch to single antiplatelet, and then if platelet improves, we can switch to dual antiplatelet.
It all depends upon the physician who is treating. It depends upon 14 days, or even you can stop and go for.
Yeah, I mean, if it drops to 5,000, you'll have to stop it.
TB?
Sir?
In such cases,
If your platelet count drops to 5,000, you will stop it. I mean, otherwise your patient will bleed and bleed to death. I mean, if you stop it for 2-3 days, it won't matter.
So I think what Dr. Ravi Vishnu mentioned, you have to follow the platelet counts. You have to do it morning, evening.
Okay,
You know, and you see how what the plate, if it remains above, first thing is that you stop ticagrelor or change it to clopidogrel. And you count, do the count every day, morning, evening, and see what the platelet trend is. If it is falling below 50,000, change to 1. Same guidelines. You know, if it falls below 10,000, stop everything. That stent will not close. If a platelet is 10,000, it's not going to close. It will definitely not close. So you can rest assured about that.
Yeah, actually,
so
this
you
is the
just
point.
Follow the guidelines.
This is the point which I wanted to emphasize. We are giving antiplatelet drugs to decrease the thrombogenicity. Now you have already got a very low platelet count. So even if you stop in a very serious condition, probably it will not go harm. But one thing is very certain: the number of platelet and the tendency to bleed, they do not match in a very proportionate way.
So more the platelet is decreased, it is more thrombogenic the platelet is. Number into volume. As the platelet counts are decreasing, the volume of the platelets are going to increase.
That depends
and
upon
this
the
is
size.
Thrombogenic.
That depends
Sorry.
upon the size of the platelets.
We are going to conclude this session. So, thank you, sir. Now moving ahead, next topic is update on MCS, mechanical circulatory support in ACS, acute coronary syndrome. And the speaker is dynamic Dilip Kumar from Manipal Medica, Kolkata. Now over to you, sir.
Thanks again, and can I have my slides, please? Yeah. So this was the news in 2021 when Protect 3 trial came. It was presented at TCT 2021, and before that, there was a 5-fold increase in MPLI use in cardiogenic shock in acute myocardial infarction. It was US data. 21. Now this is 25. It must have gone 10 to 15-fold in USA. But in India, we are still struggling because of logistics and various reasons. But nevertheless, we should know the indications and where we can use it. So let's look at 3 cases which I will be showing you. This was a patient with acute coronary syndrome, and the patient was on ventilation, and it was a surgically turned down patient. You can appreciate here. There was a left main disease, LAD, barely flowing circumflex, which was dominant, ostial disease. And then he was just, surgically turned down, and we were just planning what to do with the patient. Finally, with high-risk consent, we took the patient on IBP. This was IBP done in 2016, and that time still Impella was not available in India. And we did the, 2-stent strategy. And finally, we could save the patient. So this was on IBP, which is still used in many left main cases. One circulatory assist device. Now look at the second patient. He was a 46-year-old male with diabetes, and he had an interval MI of 12 hours. Just beginning of COVID, second wave, the patient came, and his BP was 98/60, heart rate of 110, saturation of 91, 10-liter oxygen. And he was having chest discomfort. So it was a little late, 12 hours, 14 hours. He was transferred to us. This was the ECG, you can appreciate here. So they still elevated. And this was the echo of at that time. And the angiogram reveals moderate disease in RCA, LAD cutoff. And we could do the angioplasty. Patient was not ventilated. On BiPAP we could manage. And with everything, cocktails and all, we could get this flow. And patient was getting restless. We removed the patient. Patient did well next day, and we thought it should be okay. His BP was 110/70, heart rate 100, no inotropes. But a day after, he developed severe pulmonary edema. Patient was ventilated, IBP was put in, augmented BP was in 70s. pH was 7.21, lactate was 4.1. So we thought, let's wait. Let's see, the patient was doing well last day. He should be through with all the support. This was the ECG at that time. Patient had atrial fibrillation also. And we thought, let's check the angiogram. So this was the angiogram on IBP. You can see the LAD now flowing. Now the LAD is flowing. Patient is still in cardiogenic shock with BP in 80s, 90s on IABP. In 12 hours, the pH deteriorated to 7.16, lactate went up to 7.3. What will you do with this patent stent and a good TB3 flow? Patient was going downhill. So we put ECMO in this patient. Now the patient was on IABP, now ECMO. And IABP ECMO was kept for 9 days. Every day the ECMO flow was checked whether we can come down or not. And finally this was the echo at 9th day. You can see here the muscle mass still preserved, there was some function coming up, and we could decannulate the patient. This ECG is well formed, ECG is still narrow, ST more or less settled down, and he made it in the COVID. So this was the importance of ECMO in this patient, MCS, because the patient needed time, the heart needed time. It was a stern myocardium, and sometimes it takes 7 days, 8 days to recover, and it was still viable. So this was a second category of MCS. And let's see the third case. He was a 66-year-old male with a bypass surgery done in 2015. All grafts closed. I had to do a bailout LED stenting in 2016. And his ejection fraction was hovering around 30%. He has RCS CTO. Many times I counseled, you get it done, RCS CTO. Now in staged manner, he was doing well. And he just ignored. Then he landed up with a severe chest pain with EF dropped to 20%, and this was the angiogram. Left main looked dicey, RCS still CTO, and then troponins were very high. And you can see here the osteoproximal left main syntax was 25. And then we put the patient on Impella, and then we did the quick LED angioplasty, left main angioplasty. It was a very clear cut, and then RCS CTO. This was the first RCS CTO was open CTO on Impella support in India. So this was an acute coronary syndrome managed on Impella with complete revascularization. We could never have imagined without Impella if we could go ahead and upfront in a ACS patient with a 20% ejection fraction, fix LMC as well as a RCS CTO. So these are patients which can be salvaged only and only with MCS, and it has a definite role provided we choose our patients right. So MC has a role in cardiogenic shock, and I will show you some evidence. Protected PCI, malignant arrhythmias where the patient is planned for some ablation or a bridge to transplant. So these are the devices available, not a tandem heart in India, but other devices are available in India. IABP gives a support of 0.5 to maximum 1 liter, and seat size is 7, and still it is being used. A lot of cases of protected PCI, LMCA, and also in patients who are in borderline cardiogenic shock during primary PCIs. Impella CP gives us 3.5 liter of support. Sheet size is 14 French, and with the kind of experience with TAVRs and all structural heart interventions, the large bore access experience has reduced the chances of bleeding complications with Impella, and it has overall improved the mortality and the survival rate. So Impella 5, it is not for us. It's surgeons, they implant, and RV support Impella RP for right side protection, and then ECMO, which gives us a flow can up to 7 liter per minute. But sheet size is very large, overwhelming, and this is arterial is 15 to 16 French. So 16 French is the arterial size which is used. But when and how we have to do a MCS, we have to calculate the cardiac power output. If the CPO is less than 0.6, then you have to calculate the PAPI index. If the PAPI is less than 1, it is RV which is the culprit mostly. You support the RV first and then see how the patient is behaving. Still the cardiac CPO is less than 0.6, you go for left support. And if the PAPI is more than 1 but CPO is less than 0.6, you go for a left ventricle support in form of Impella or ECMO. So ECMO has got, it's easily available nowadays in many centers, unlike Impella, which is which comes at a huge cost. And you have to ask a vendor to bring in the Impella. It takes 1 or 2 days time. So cardiogenic shock patients, besides metro, it becomes a little difficult. But ECMO is available in many centers where cardiac surgical program is going on. And with Impella, with IABP, ECMO can be added. And but the fallacy with the ECMO is in cardiogenic shock, it increases the afterload. So the LV, recovery becomes little difficult. You have to unload the heart. That is a problem, and there is a problem with north-south syndrome. Impella, ECMO is pushing blood inside the body. Lower limbs is oxygenated. Upper limb is not oxygenated. The brain is not getting proper oxygenated blood because it is coming right from the heart. If the heart is dysfunctional, you have to vent the ECMO. And then there are winning parameters, so I'm not going into it, but let's look at the evidence. Evidence from Impella, we have got some evidence, registries, but finally we have got a danger shock trial, which is the first randomized controlled trial which has shown benefit. This is the historical advancements in the treatment of cardiogenic shock. The survival rate has gone up, and the danger shock trial is still, there are some controversy, it took 10 years, but still it gave us a mortality reduction, and it gives a kind of some light at the end of the tunnel that still in cardiogenic shock we can do a trial can be done, and then the trial can be, it can give you some inference as well. And then we have protected BCI, protect group of trials, protect 2, which gave us an idea and clearly established that IABP is very clearly outplayed by Impella in Protect 2. Protect 3 was even better because it was Protect 2 like patients, and here the kind of experience of the operators were more. I will end my lecture here by showing this clinical expert consensus document. Fortunately, I was also part of this document when it was made. The meeting was done in Delhi, and it was chaired by Rajiv Tayal and Sanjog Kalra and Dr. Soksheth. And there a consensus was made. We have to risk stratify patients who are going for high risk PCI, be it acute coronary syndrome, be it not acute coronary syndrome, but these are the factors. We need to take care of hemodynamic status, patient characteristics, renal function, age of the patient, whether the patient is having ACS or valvular heart disease, severe ASAR, coronary anatomy of the patients, and whether it is protected or unprotected left main, and a single conduit or not. And then we score these patients. If the score is 3 to 5, consider support. If it is more than 5, strongly consider support. So the less than 3, you can definitely go on with a normal support or maybe a quick procedure. And this is how the consensus was made. And I think this is a time for Asia Pacific to adopt this kind of strategy with this scoring system, and which can help salvaging patients who are essentially practically unsalvageable, like the 3 cases which I showed. And most importantly, identifying shock in the early stage is important. If it is in A, B, C, it's still good, but D and D is definitely it's not going to come back. And protected PCI helps salvaging the unsalvageables. Ongoing emergence of evidence has increased the faith of physicians in MCS device. Thank you so much for the patient hearing.
Thank you, sir, for showing such high-risk cases and use of different mechanical circulatory agents. I have one query. In setting of ACS, patient is in cardiogenic shock, we are using mechanical circulatory support. Should we go for complete revascularization, or we should tackle only the culprit artery? As in one of your cases, you went ahead with this CTO, RCA CTO. So whether we should routinely do such things, or we should wait for stabilization?
Absolutely. This is very good question. The consensus is in cardiogenic shock, you have to take care of only culprit vessel. But this consensus is not very clear because use of MCS in cardiogenic shock is still not in very clear, clearly in guidelines. So 90 to 95% of cardiogenic shock patients, if they are going to be intervened, they are intervened without proper MCS like Impella. IBP are used, but IBP is with IBP shock 2 trial has gone out of favor. It is not recommended. So at this moment, it has to be non-culprit vessel angioplasty only. But if you have Impella in place, the guidelines is not clear, and I think in these cases we should vouch for complete revascularization, because Impella is going to take care of our kidneys, which is the maximum, which leads to the maximum fatality. You try to open most of the vessels, and the patient deteriorates for some time, and kidney function gets knocked out, and this is how the patient will lose in cardiogenic shock with complete revascularization. But with Impella in place, you can salvage these patients. So without Impella, you can go with only culprit vessel angioplasty. With Impella, I think you can vouch for complete revascularization.
Thank you, sir.
Thank you, sir.
Any other question or comment?
Little difference between the first case that he showed and the last case. So the last case was not cardiogenic shock, if I am right.
Yeah.
It is a case of ACS with a very poor LV function and very bad coronaries. So that is actually different from cardiogenic shock. So we should not mix the two, because the prognosis is much more different. in India, what is happening is we are doing like Protect PCI. It is in very few cardiogenic, as the Dilip said, that it is very difficult to get hold of the impella when a patient comes in with STEMI and cardiogenic shock, because there are so few devices and consoles around. So it is more that what is happening is Protect PCI, like the case that he showed, and that is different from cardiogenic shock. In cardiogenic shock, if you have a lactate of 7, that is a totally different kettle of fish than someone who has come in with ACI with a poor ejection fraction and very bad coronaries. But I mean, all his cases, they are very instructive. He is saying, and I mean, after the shock, IBP shock 2, people are saying that IBP is useless, but I don't think it is totally useless. And I think Dilip will also agree. Even in his first case, in the second case where he had to use the ECMO, the IBP still helped. It is not that it was only the ECMO that took the patient out. And in that patient, it was really myocardial stunning. The coronaries were flowing, but it was still, the patient was in cardiogenic shock. And the young patients, they are likely to benefit more with this type of therapy, like what he showed, because they have less vascular complications. If you look at the danger shock trial, these patients live longer. There is no doubt about that, but at a cost. And what is the cost? Peripheral vascular complications and renal complications. These and sepsis. So they have a much longer stay in hospital, something like 90 days. So if in a private hospital they stay for 90 days, it is easily 1 crore. In addition to what you have already spent on the impella. So it is costly therapy, and one should be careful in actually giving this therapy to our patients, because we know what our patients can afford.
Thank you, sir, for your brilliant talk and nice discussion. Now we are going to conclude this session successfully. Thank you.
Thank you, chairpersons. Thank you, panelists, for this wonderful session. And thank you, all the speakers who have spoken so well on such complex topics. So for the next session, I'd like to invite chairpersons, Dilip sir. Dr. Dilip, you stay back for chairing this session on this side, on that side. Dr. Anupam Pamani ma'am, Dr. B.B. Bharti sir is not here. Dr. B.P. Ajad sir, please. And for the panelists, Shamshad, Dr. Shamshad is here. Dr. Shamshad is here. Dr. Vibhu Prasad, Dr. Prashant Kashyap, please. And Vineet. विनीत को बुला लिया. 3 लोग ठीक है, 3 लोग ही कर लिया. And I'll ask the chairpersons to start the proceedings. Dr. Dilip, you can start the session.
Thank you. Yeah, so this is, I think we invite Dr. Devato Bhattacharya to talk on IVAS, how IVAS changed my PCI strategy.
Okay. Thank you very much, respected chairpersons and dear friends. So, can we go to the slides? Okay. Can I have the slides, please? Yeah. So, I'm going to talk about my journey in IVAS and how IVAS has changed me as an operator and helped me gain insights, and how in various situations, I have changed my strategy due to the findings that I have seen on IVAS. So our journey in IVAS began in 2011. During my training in England, which was between 1993 and 2000, there was an IVAS machine, but not a lot of IVAS was going on because Our consultants were not very familiar with IVUS at that moment, and we were still learning IVUS. And it was not until quite late that IVUS began to pick up. If you had been to the various conferences, American and European, you would have noticed in the first decade of this century that IVUS was not a lot talked about. And there was a lot of resistance. All the major European operators would come up and say that IVUS is not necessary. And it was the Japanese and the Koreans who came up with all the evidence initially. And it was at least another 12 years from the beginning of the century, before we came up with major trials. And one of those trials was the ADAPT-DEST trial. And there was a follow-up of the ADAPT-DEST trial, which came out in 2018. And what did it show? It showed that IVUS was better than angiographic guidance alone for MACE, for definite or probable stent thrombosis, for myocardial infarction, and for clinically driven TLR. So it was an eye-opener at that moment, but still there were not a lot of takers. Even in the second decade of this century, there were a lot of doubters, and even in left main, people were not convinced that IVUS was a useful thing, despite the evidence, and despite the evidence that IVUS guidance versus angiographic guidance in all respects. If you looked at diabetes, 3 vessels, left main, 2 stent strategy, 1 stent strategy, in-stent restenosis, CTO, total lesion length, in all of them, IVUS guidance was better than angiographic guidance alone. And this was another very large systematic review and meta-analysis, which came up with the conclusion that it was beneficial, meaning IVUS was beneficial not only in patients with complex lesions or acute coronary syndromes, but also patients with mixed lesions or presentations. And the benefit of IVUS was significantly pronounced in patients with complex lesions or ACS with respect to death. This was further followed up by the ultimate trial. This was a Chinese trial, again, which set out to answer the specific question about whether IVUS was useful or not. And there were 2 arms, 724 patients in each arm. And the IVUS defined criteria, this is very important. People were using IVUS for a very long time, but they did not have defined criteria. There were no endpoints. In other words, it was like go as you like. It was a fancy dress party. People did not have endpoints or benchmarks that much later Ziad Ali brought for OCT. And people did not know where to start and where to stop. So this was a trial which came with a defined criteria. MLA in the stented segment greater than 5 or 90% of the MLA of the distal reference segments. Plaque burden 5 millimeter distal or proximal to the stent edge should be less than 50%. And there should be no edge dissection which involves the media with a length greater than 3 millimeters. And if you followed all of this, then your target vessel failure was less, your cardiac death was less, your clinically driven TLR was less, and target vessel myocardial infarction was less. This was the conclusion of the trial. So if you did an optimal PCI, your overall event rate was 1.6. If it was suboptimal, it jumped to 4.4. So which are the following types of vessels where I think, where I have felt that IVUS is useful? So left main, I think nobody will contest this anymore. Diffusely diseased LAD, this is a paper that we published back in 2016, and I'll show you how the thought process has changed. Chronic total occlusions, again, I will show you a few cases. In-stent restenosis, I will show you a few cases. Calcified lesions, I do not have the time to show you. So as also with bifurcation stenting with 2-stent strategy. But if you believe that left main stenting needs IVUS, then you will also believe that bifurcation stenting also with 2 stents needs IVUS. So let's look at the left main. So this is the landmark paper. with which we are all very familiar. This is the 57678 criteria by Kang. I won't go into it in detail because I'm assuming that you all know it. But let's see what are the questions answered by IVUS in LMCA stenting. Is the lesion significant? 1 or 2 stents. Pre-PCI IVUS dimensions of the LMCA, LAD ostium, and LCX ostium and plaque morphology. This is very important. A lot of the time we do left main stenting and IVUS, but we don't do pre-PCI. And this was the fault of also of many of the trials. Even in the Excel trial, only 50% of the patients had pre-PCI. So we actually want to know what we are dealing with before we start doing angioplasty. Are the implanted stents well opposed, expanded? That is the question that comes next. Have 5, 6, 7, 8 been achieved? And I'll show you how this has been revised further. And angiographically, if all of the above questions are vitally important, because angiographically significant disease sometimes appears non-significant. If your IVUS MLA along the left main is greater than 6 millimeter, don't do a PCI. It's not necessary. In bifurcation, 1 stent strategy has notably better outcomes than 2 stents. So if IVUS solves that problem, all the better. Pre-IVUS dimensions and plaque morphology help in bed preparation and decide on stent sizes, and both under expansion and malapposition are diagnosed easily and rectified. And on top of that comes a third thing, which is stent deformation, which IVUS picks up after you have done left main angioplasty. So let me show you a few cases. So this is from a long time back. This is probably 2013. I was doing an ostial left main, and this was my initial experience in left main angioplasty, and you can see that I had stented it and the stent looks reasonably well. If you look at the 4th panel on your right, and I thought that this was fine, but we had just started doing IVUS, and you can see that the stent is not fully expanded. So we went on and we expanded it, and we achieved a much larger lumen area. So this, we now know that this is vitally important to do it in the left main. If you don't do it, you will get more recurrences, and you don't want a recurrence in the left main, because with left main and proximal LAD, there is no hiding place. If you have messed it up, the patient will come back and you will have to do something again. So better do it well the first time. So this is a distal left main, and here often we are faced with the problem, or we are faced with the question, is it 1 stent or 2 stent? And here you could probably say that I am like reasonably certain that it is, we are going to go into the LAD, but what are we going to do to the circumflex? And if you place your catheter in the left circumflex ostium, so you can look at that angio where we are coming back from the LAD, and you can look into the circumflex ostium, and you can see very well that there is no disease in the circumflex ostium. So it is very, very safe to just stent into the LAD. And this is what we have done. And then after we have done it, again, this is a circumflex ostium post-PCI, a pullback from the circumflex that we are seeing. And we are seeing, what we are seeing, that this actually looks fine. So I will show you one of our papers. So we were discussing why we are inferior to the surgeons, because the surgeons, they tackle the left anterior descending artery better than us. We cannot beat the lima to the LAD by stenting, and we need to look at our practice as to why that is the case and what we can do to improve it. So why do we fail? Do we sometimes undersize our stents? So look at this LAD. If you look at this LAD, this is a diffusely diseased LAD. You have to find a landing zone first, and you have to make sure that you have achieved a good lumen, good stent area at the end of it. And you will never achieve it. You will never achieve it if you go by angiography alone, because you will consistently undersize your stent. These are the QCA. See, it is proximally 2.6, and the tightest 1.1. At the landing zone, it is 2.2. So at the most, you will put a 2.75 stent. That is what we do. That is what we have done. And we have come up with consistently poor results. But if you do IVUS, you'll immediately see that this is not a small artery. This is an artery with a large plaque burden. And the media to media, the EL to EL is actually quite big. And based on these measurements, you can then pre-dilate the vessel with adequately sized balloons. And then you can stent it and post-dilate it again with high pressure, with non-compliant balloon, big diameter, especially in the ostial LAD. And it is the osteoproximal LAD which really matters. So at the end of the case, you can achieve a result something like this. And then we looked at 50 cases, similar 50 cases, and what we found was in all of these cases, these are all Indian patients, the proximal LAD diameters, if you look at EL to EL, they were consistently 3.5 millimeter or above, irrespective of height, weight, sex, body surface area. So the message is, if you are landing a stent in the ostial LAD, please make it 3.5. Please dilate it with a 3.5 millimeter balloon. It will not rupture the LAD, and your results will be better. So I think I don't have much time. I will finish. So this is a study that we did with diffusely diseased diabetic patients, and the findings are exactly the same. So whatever you do, if you are landing your stent in the proximal LAD, dilate it with a 3.5 millimeter balloon. And a high pressure dilatation will not cause any complications, which we did in all of these cases. So I will show, with your permission, one or two cases, Dilip. So this is an under-expanded stent. So I'm showing some cases of instant restenosis, and I will stop there. So look at this LAD, which has been stented with a 2.75 by 30 millimeter stent. Looks reasonably good on angiography. Comes back after 6 months. Do the IVUS, you can see that the stent is really undersized, and then re-PTCA with a 3.5 by 38 millimeter DES. This is a long, someone who has come back after a long time, instant restenosis, and you can see the calcific area around the stent. This stent was back in 2015. There were no high pressure balloons at that time, and I failed to expand this stent. We now have high pressure balloons, so this is the last case. I will finish with this case. This is a 90% ostial RCA, which was done in another center, 50% residual stenosis at the end of it. Patient comes back in 6 months with a 90% stenosis. The IVUS, you can see there is a large chunk of calcium to the right of the frame, and it is very tightly stenosed. This segment of the stent is just beyond it. So the ostium is stenosed, but just beyond it, this is the area of the stent. So we try with a 3.5 by 10 cutting balloon. It produces some lumen, but not enough. We know the IVUS measurements. We go with a 4 by 10 OPN Ultra at 45 atmospheres, and now you can see what we have achieved. Now we have cracked it. And now after that we have stented it, and you can see that an MLA of 14.12 square millimeter is achieved. So I think, and this is the final case, so a focal ISR, what appears to be a focal ISR, we do an angiogram, we do an IVUS, and what we see is thrombus in that stent. So we aspirate that thrombus and do a POBA, and that is enough for this patient. So I think I have other cases to show, but I'm way beyond my time. So I'll stop here, and with the concluding remark that if you do IVUS, it really changes your view completely about the vessel, about especially the size of the vessel, the type of the plaque, and you know much better what balloons to use, how much pressure you can give, and before you implant the stent, you can prepare your bed better. After you have implanted the stent, for example, if you have implanted a long stent, what I do based on IVUS measurements is I do differential balloon dilatation. So if it is a 48 millimeter stent, the distal 24 millimeter I dilate with a slightly smaller balloon, and the proximal 24 millimeter I dilate with a bigger balloon. And I try to produce a funneling of the vessel as it is in normal life. So these things I have learned from my experience with IVUS, and if you do it, you will come to the same conclusions. It is not very difficult. You just have to observe the vessels and then act on them. Thank you very much.
Thank you, Dr. Bhattacharya. That was a brilliant talk. So when you do IVUS, so whilst deciding on the size of stent from the distal vessel, for reference, you prefer media to media or lumen to lumen in the normal, or you round it up to?
Yes, absolutely. That is the most important question. So if you are looking at a very diffusely diseased LAD, one thing I have learned, and I think you will all agree, is do not stent the distal part of the LAD. That is a very bad idea. Try to avoid it. Sometimes we end up putting more than 48 millimeter of stenting, but that is a bad idea. And these patients, they do not do well. RCA is different. RCA, you can put 70 millimeter of stents. Until it bifurcates into the two major vessels, you can do a lot of stenting. It doesn't matter. But the LAD sort of funnels down like this. It gives up diagonals, septals. And if you stent the distal part, then if the patient has a restenosis, the surgeon can't do anything. So in these diffusely diseased vessels, what I try to do is I try to find a landing zone in the mid-LAD, round about the second diagonal artery. And I see what the plaque burden is. Okay? So if the plaque burden, and what also happens is if the vessel is very diffusely diseased, often the vessel is undergrown. So actually at that point the plaque might not be that much. Okay, so plaque might be much worse above, but because I have not treated the vessel, that vessel has had no chance to grow. So I look at that, and if I see that the plaque burden is less, I start dilating the vessel from above it. And what usually happens is there is flow-mediated dilatation. So after a while, you will see that same segment, which was looking very small, it looks bigger. And I try to land it there. And as you were saying, what is the size? I sometimes go back and reassess the EL to EL after I have dilated it. So there was a lot of discussion about whether we should treat the vessel before doing the IVUS. And there was this, the Japanese used to say first do the IVUS. So there was a Japanese proctor who came to me, and we were doing a case, and he said, put the IVUS in, put the IVUS in. I said, but this is a very tight vessel. As soon as I put the IVUS in, the patient will develop slow flow, which happened. So now this has changed. So you always pre-treat a little bit, at least with a 2 millimeter vessel. Allow the vessel to grow a bit, give some nitro, and then assess your distal landing zone. And obviously, if your distal landing zone is like 2.5 or 2.75, choose a stent like that. Even if it is EL, so let's say it is it looks 2.5 EL to EL, and there is a plaque burden, residual plaque burden of around 40%. I would choose a 2.5, and I would deploy it at slightly lower pressures so that it doesn't dissect the edge. And then I will go up gradually. And the proximal vessel, I know what to do. Much bigger stent, much higher pressures. So that is how I approach the LAD.
Thank you.
So, sir, is there approach for hybrid? Because usually I prefer, when I get a diffuse LAD disease, so I place a stent in the proximal part and I do a deb in the mid part.
Yeah, you are, Samshad, you are much more modern than I am. So when you are doing it in this much more better era of drug-coated balloons, I am talking about like stenting, the generation of stenting. Yes, of course, we have changed. We would, so if you want me to, if you have some time, I'll just take 2 minutes. So what we do now is, as I said, the philosophy is not to stent the distal part of the LAD and try to do DEB. Okay, but DEB is not easy because you have to have lumen gain. If you don't have lumen gain, then the DEB doesn't work. So again, intravascular imaging comes in there. So you need to know whether it's fibrotic, whether it's calcific, whether it is just an undergrown vessel where you don't need to do anything. If it is fibrotic, then again we measure the EL to EL and we choose a cutting balloon that is slightly below the EL to EL. So if it is a 2.5 EL to EL, we'll choose a 2. And we will treat the part of the vessel that we want to do DEB with a cutting balloon and try to get a good lumen gain without actually producing a bad dissection. It doesn't always work. If it works, then absolutely that is what you should do. Put a DEB there, treat the proximal vessel with a DES and come out. Unfortunately, we have started to do it. We have done around 50 cases, so I cannot tell you the long-term experience. So beyond 1 year, I don't have the experience. Maybe I will be able to tell you after another year. I haven't had any of them coming back. So 2 things can happen. One is that you have a dissection and you're obliged to stent, or you have sent the patient to the ward and the patient develops chest pain and you have to bring the patient back. That has not happened yet, but it can happen. So you have to be a little careful about these patients. When to leave the dissection, that is the most important question. Which is the dissection that you will leave? And you will just do a DEB and come out. So there are certain clues. I asked Antonio Colombo that what is the dissection that you will leave, and he was very, very sure about his answer. He said that where there is TIMI3 flow, even if there is a flap, even if there is a visible flap, I will leave it.
So bells are ringing.
If you're doing intravascular imaging, if your true lumen is bigger than the false lumen, I'll leave it.
So we have been asked by the organizers to go on. So move on to the next speaker. Sorry. But before I invite him, just a quick word from you, Dr. Debdatta. In the meantime, may I request Dr. Vikas Majumdar to come up on the stage?
I have taken up too much time, Dilip.
Just one. So the debate of IVUS versus OCT will remain there. But what you see in bifurcation, OCT has certain edge on over IVUS. You feel from your ideas, or
the OCT will tell you better about how you have crossed into the side branch.
It looks like
yes, it will tell you, but IVUS can. I mean, if you are a good IVUS operator, you can still guess whether it's a distal cross or a proximal cross, even with IVUS. So you need to look at the long view layout, and you will be able to make a guess. But it is not as good as OCT. Yes.
So Dr. Vikas Majumdar is senior cardiologist
left main ostium, sir.
Apollo Hospital. So
for the left main ostium, definitely IVUS have some extra edge compared to the OCT.
Absolutely. Yes. Yeah, please go.
Good afternoon, chairpersons. Good afternoon, delegates. Today I'm going to talk about a purpose-built stent for left main stem angioplasty. Now, before we embark on doing an angioplasty on the left main stem, there are a few points that we need to be aware of. Before we start even, that what is the vessel size? That's very important. And before doing any angioplasty, that is important. But in left main, that is even more important, because angiography doesn't tell you all the time the correct dimension of the vessels. And as Dr. Debdatta Bhattacharya just finished an IVUS lecture, so imaging often plays an important role before doing a left main angioplasty. Again, there is another important vessel which is coming out apart from the LAD from the left main is the circumflex. So we need to be very careful about what is going to happen after the left main angioplasty to the circumflex, whether it is important to protect that branch or not, and if it is, then how we're going to do it. Second, how much calcium we are dealing with it in the left main, how much fibrosis we have in the left main, and whether the ostium is at all involved in not or not. These are the few things. And once we analyze the angiography properly, then definitely one important thing is which stent we are going to use. Because here we are looking for a stent which has got higher radial strength and longitudinal strength, and it has got an expansional capacity, and it conforms well within the left main in order to achieve that proper area that what we want to achieve. So this is a case which I am showing some still pictures. You can appreciate there is a severely calcified LAD, long segment of disease, which involves the proximal LAD as well, including the mid LAD. And you agree that if we want to stent this particular vessel, we have to come up to the left main in order we can't just leave the stent in the LAD and finish the angioplasty. So initially we did some rota ablation in order to modify the calcium. And the first stent, which was a drug-eluting stent, 3 by 38 millimeter, put into the the mid part of the LAD, and the proximal part was stented with 4 into 32 millimeter drug-eluting stent, which can be expanded according to the manufacturer's guideline up to the 5.75 millimeter into the left main. And then we started doing post-dilatation, distal part with the 3 millimeter balloon, then in the proximal part of the LAD with a 3.5 millimeter balloon, and at the left main we took a 4.5 millimeter balloon and went high pressure, and that's where the result is. And you can see the left main part of the stent is completely deformed with some of the struts hanging as if it is getting separated and detached outside the left main ostium. So this is a nightmare that sometimes we face if we are going for a high pressure post-dilatation in a left main stent, and stent get absolutely deformed. So this is not a situation that we want to be in. And we rescued the situation with another stent inside this fracture stent and eventually rescued. But we don't want this kind of situation. So beforehand we need to actually find out what stent we are going to use, what will be the expansion capacity of the stent. So selection of stent is very important to prevent deformity while doing the left main stenting. The stent should have adequate radial strength and longitudinal strength and should withstand an aggressive post-dilatation. So if a stent doesn't withstand an aggressive post-dilatation, we should not be choosing those kind of stent, particularly when in a case there is a huge mismatch between the LAD and the left main. And we have to be careful about the interaction of the stent with the guide catheter, because that can often result in longitudinal shortening. So we inflate the stent in the left main, and then we started manipulating guide, and we started passing a post-dilatation balloon. This all get actually interactions with the proximal strut of the left main stent, and then you get deformity of those stents at the end. So often it is important that after putting a stent in the left main, we do the port properly so that the stent is properly expanded in the left main, and then it is easier to pass the further hardwares through the left main stent, and which prevent deformity. So high radial strength and axial strength is very important if you are treating patients in the left main with some fibrotic lesions. And maintain stent integrity when adjunctive devices interact with the stent is critical, which requires extra axial strength. That is very important. Larger over expansion is needed. As I said, the LAD can be 3 millimeter, but left main can be 6 millimeter. So we have to choose a stent accordingly, whether it can withstand that over expansion in the left main. And also it is important that we get optimized scaffolding in the larger diameter in order to prevent late luminal loss in those tissue prolapse in those kind of stents. And placement accuracy is also very important, particularly if the ostium of the left main stem is involved. So we need to see it properly. So it has to have good visibility. So these are the few criteria that a stent should have if we are choosing for left main angioplasty. So Synergy Megatron is a stent which has got some unique design which helps in doing left main angioplasty. It has got 12 peak design with a shorter strut length. That 4 connectors in the proximal 2 segments. So the proximal 2 segments had 4 connectors. You can see it here in the proximal 2 segments. And all the other segments have 3 connectors. It is a platinum chromium alloy. And because of these connectors, it has got higher radial strength and unmatched expansion and uniform vessel scaffolding inside the left main. So compared to Resolute Onyx or Giant Sierra, its radial strength and axial strength is quite higher, which is helpful in treating the left main stem. And you can see the uniformity of the scaffolding, particularly when you are going for a high pressure, it maintains the integrity of the stent. And if you can actually expand the stent from 3.5 to maximum up to 6 millimeter, if you are taking a 3.5 stent, you can go up to 6 millimeter in the left main, and that's the way it actually accommodates over expansion, and you can get a good conformability within the left main when you are doing an angioplasty of the left main. Also gives an access to the side branch, and this is if you want to do some procedures in the circumflex after doing a left main stenting, you can actually have a good side branch access as well with this particular stent. I will show another case. This is a primary PCI, which I did few days ago. It's a 70-year-old doctor. He presented with an ostial LAD, acute thrombotic occlusion. We took some thrombus out, and you see there is a significant vessel size mismatch compared to the LAD and left main. And here I choose a 4 millimeter Megatron stent, nicely expanded from the LAD to the left main, but you can appreciate the left main size is even more than 4 millimeter. So first thing I did actually, even doing the post dilatation of the distal part of the stent, I actually took a 5 millimeter balloon at 18 atmosphere to do the post dilatation. It's a very proximal part of the stent because I wanted to have it opposed properly to the left main, because otherwise if I take a lot of hardwares, the guide can actually interact with the left main stem struts, which is not properly expanded and can cause stent deformity. And then after I perform that proximal post dilatation, you see this nicely maintained integrity of the left main stem stent, and the final result, so a very nice result in the left main stem without any stent deformity, and the side branch is patent as well. Next case is a 65-year-old gentleman, and here you can actually notice that there is a significant osteoproximal disease, and if you look at the spider view, you will appreciate the size mismatch between the LAD and the left main. It's a huge size mismatch here. And you can also see there is a big diagonal which is coming out just from the proximal part of the LAD. So RC was normal. So before doing this angioplasty, there are a few issues that I had to take into consideration, because there was a significant plaque burden in the proximal LAD. The vessel size mismatch was pretty obvious, and it was important to protect the side branch as well, particularly the diagonal branch, which was a big branch, and we need to think about which kind of stent we are going to choose in this particular case to ensure optimal stent expansion in the left main. Now we took a CLS3 guide and pre-dilated gradually with 3.5 millimeter balloon, and then with the 4 millimeter balloon, which was a semi-compliant balloon. We also did an IVUS. An IVUS, you can see that LAD part is actually about 5 millimeter in diameter, but in the left main was absolutely huge left main, and the diameter of the left main is about 6.6 millimeter. It's a huge left main here. So you are actually trying to oppose a stent up to a 6.6 millimeter, which is a huge challenge, you would all appreciate. And it is very important that what kind of stent that we will actually choose in this particular gentleman. Would you send this patient for a bypass operation? That is another question here, because we don't have a 6.6 millimeter stent in our hand. So anyway, this is the result after the first pre-dilatation, and you see that huge left main in this particular gentleman. I choose a 4.524 Megatron in this particular patient, and this is after the implantation of the Megatron. And obviously, though angiographically you wouldn't, you experience that the stent is not quite matched with the left main. But if you do an IVUS, you see the proximal part in the left main, the stent struts are actually hanging. It's not quite opposed to the left main wall after the implantation, though the distal part is nicely matched. So what I did first is I took a big balloon, a 6 millimeter balloon. I took a 6 millimeter balloon and went up to 18 atmosphere to do the pot at the very proximal part of the left main stent to start with. Before doing anything, I didn't, because I didn't want to have interaction with the guide and the under expanded stent, so put a 6 millimeter balloon, and then once I am pretty sure and happy about the proximal part post dilatation, I went on doing the post dilatation of the distal part of the stent with the 5 millimeter balloon in the proximal LAD. And then what we see, it is the final angiographic result, and if you see at the stent boost, it's a nice conformability. In the left main, it's just like a funnel, and gradually tapering it down with the Megatron. So that is the result we got with the Megatron, and this is the final IVUS of the left main, where you can see the stent is nicely opposed, and the final diameter which I could manage is about 6.37 millimeter, which is giving about 28.86 millimeter square area in the left main. So that was possible with Megatron. Otherwise, I wouldn't have been able to achieve this with the other stents. And then I should have sent this patient to a surgery. This patient is doing very well after 1 year. So in conclusion, selection of stent is important while doing a left main PTCA. Stent with better radial and longitudinal strength and proper expansion character should be ideal to prevent deformity and to maintain the integrity of the left main. And use of IVUS is important to understand the size and to determine the optimum result of the PTCA. And Megatron is a perfect choice in this type of situation where it maintains its shape without deformity in spite of aggressive post-dilatation at a very high pressure. Thank you very much.
Wonderful, wonderful cases, and two very strong kind of messages. Never tried to nail the ostium, as in both his cases, has brought the stent to the left main and given a good, done a good pot. He didn't want to, go for a nailing of the ostium, which is seldom a kind of situation. You can't nail the ostium because it's quite an angulated structure, and the idea is we have to come and give a crossover stent. So, but by the way, which balloon was used? 6 mm balloon we don't have in our lab.
We have in our lab.
So we have maximum 5 to 5.5. So which company makes 6 balloon?
We have.
Okay, so it's the 6 balloon do you have, and which company makes?
We don't. The question I wanted to ask you was when you are doing your post dilatation, do you go up all at like 18 at one go, or do you?
In this particular case, as I had the IVUS before, and I knew that the left main is huge, so I went up to 80 with the 6.
All at one go. I mean.
Yeah.
Okay.
Because I knew that left main is 6.6. So
yeah, I know. I know. I appreciate what you are saying.
That was the confidence that IVUS gives me. Otherwise, I wouldn't have.
Yeah, I am asking you because the first case that you showed, where you went up with a 5 mm balloon, it was an ACS. Isn't it?
No.
Yeah. There was an occluded. One case you showed.
That was second one was the ACS.
ACS. Yes. So the ostial LAD was occluded, and you stented it, and you post dilated with a 5 mm balloon at 18 atmospheres again. Okay. So these two are different patients. I mean, so in those patients, do you do the same approach or
no? In the ACS case, you don't go straight away that high pressure because there is the chances of slow flow and no reflow, and even sometimes the thrombus can migrate into the circumflex, and then you make the situation much worse. So in the ACS case, we generally don't go for that high pressure, but the second the last case which I showed.
Last case was not ACS. So, and the other thing that I noticed in your IVUS is that although the EL to EL was 6, there was part of that plaque in the left main, which was actually causing a much smaller lumen area. So in those cases, probably you don't need to. I mean, you don't always need a 6 mm balloon. If you had a 5 mm balloon, 28.8 is humongous. I mean, you achieved it, but I think 20, yes, Dilip would settle for 20 or 25. So anyway, I mean, you demonstrated it very well how the stent maintains its integrity. That is the most important thing. And the first case that you showed where the stent fell apart, and we have seen it with Synergy stents, the proximal. So that is why they have brought this change in design. Even without anything, the proximal part of the Synergy stent used to fall apart.
That is the Synergy to start with, and
yes,
the second one was the Megatron.
Yes.
So
there is a difference
same company, two stents.
Thank you, Dr. Majumdar. I think it's time to move on. May I request Dr. Pramod Kumar from Hyderabad to deliver his talk. It's a DCB, so a lot of questions will be coming.
Good afternoon, everyone. Thank you very much, Dr. Tripathi and CSI for giving me this opportunity. I come from Hyderabad. The topic I am going to address is drug-coated balloons in native coronary arteries. And as Dilip has mentioned, more and more people are resorting now to DCB. So I'll go through a little bit about it. Historically, as you know, many years ago, Andrea Grunzig has laid the foundation for balloon angioplasty. and he had a very durable result in this proximal LAD with a simple balloon in those days. How does it help? Actually, the balloon produces barotrauma, causes plaque rupture, and also it causes a vessel dissection, and then overstretches the vessel wall when appropriately done. And as you know, there are some limitations for this called plain old balloon angioplasty. Most important problem was abrupt vessel closure, which occurred in about 5% of those cases. In those days, when the patient had abrupt closure, the patient has to go for emergency bypass surgery. That was the main limitation for the plain balloon angioplasty. And also in the long run, there was a restenosis rate, clinically about 25%, angiographically much more, 30 to 35, mainly in diabetics as well. And there were some predictors. Residual plaque burden was an important thing, and achieved minimal lumen area was also a predictor for restenosis. And interestingly, when a dissection occurred, it had a protective effect because it caused subsequently vessel enlargement, so-called remodeling, which we now talk about. And the main mechanism of balloon angioplasty is a negative remodeling rather than neointimal hyperplasia. So subsequently, we will talk about the stents which cause neointimal hyperplasia and late lumen enlargement, as opposed to late lumen loss, which occurs with stents. With the plain balloon angioplasty, there is a late lumen enlargement. This is having a salutary benefit of the PCI. And there are some historical examples of POBA you can see in those days in the early 80s. You can see that with the plain balloon, there is a dissection definitely. And in some cases, the dissection can be more significant. So these dissections are classified into 6 types. And type A and B are milder forms of dissections, which have practical application now for the drug-coated balloons. So C to F, they are more advanced dissections, which may need a mechanical scaffold. Now, as you walk through the stent era, if you look at this, we had a problem, then a solution was invented. The solution caused a problem, again another solution was invented. So like this, the story goes on. First, there was a balloon angioplasty, restenosis and abrupt closure was there. To prevent it, bare metal stent came in, and subsequently, because of bare metal stent, there is increased restenosis because of inflammation and other reasons. Then we came up with multiple solutions like brachytherapy, oral therapies, etc. Finally, the benefit came in the form of drug-eluting stents. But drug-eluting stents also had problem of stent thrombosis and prolonged DAPT. And subsequently, to get away with the metallic stents, bioabsorbable stents came in for a brief period. But I think because of over-enthusiasm, it faded off because people started using everywhere, including bifurcations, and therefore it caused more deaths. It went away. Now the concept is to come back without stent. So what is called as a stentless or metal-free angioplasty. That is now the in thing which we are talking about. And what are the situations where we avoid a stent? So where you cannot advance a stent, especially if it is a very calcified lesion, there may be difficulty. Of course, now we have other debulking devices, calcium modification, we can take the stents, but sometimes it is becoming difficult, and sometimes we also strip the stent. You lose the stent trying to put the stent into calcific lesions. Secondly, in tortuosities, generally there is a problem in delivering the stent. Of course, now we have the guide extensions or other things, but in general, it is difficult there. And small and diffusely diseased vessels, it is also going to cause more restenosis, because if you put a small stent, the 50% binary restenosis will be much more for that small vessel. And large thrombus burden in STEMI, we don't go with the stents at the same setting, because if you put a stent, it may cause distal embolization, no reflow, no flow, and hemodynamic instability in those patients. And in few cases where side branch, you don't want to do a 2-vessel stent or multiple stents there also we avoid stents. So in those situations, the option is drug-coated balloons. So this is basically about the cell cycle. There are anti-proliferative drugs which are implanted onto the stents. Sirolimus and paclitaxel are the mainly used one. The Limus family, of course, we have other drugs, but basically paclitaxel is cytotoxic. It kills the cells. It causes apoptosis. Whereas sirolimus puts them to rest into G0 phase, and it is a cytostatic. There are differences between these two. We will talk a little bit about that. Now these are the differences between the drugs. The green one is favorable. For example, sirolimus, it is cytostatic, and safety margin is much more, therapeutic range is wide, and it has got anti-inflammatory action. That is one of the advantages of sirolimus. And also it impregnates the entire wall. And if you look at paclitaxel, it goes more into the adventitia. And if you look at the loading and other things, it is simple with paclitaxel. Tissue absorption is faster, retention is longer, and it is highly lipophilic. Now these are some of the available DCBs. We have Agent, Boston, which we have experienced regularly. Medtronic has a Prevail, and Protege is from Translumina, and we have Essential Pro Eye Vascular. I have used almost all of them except Pantera. And we have Magic Touch from Concept Medical, it's available. And Merrill has 2 drug-coated balloons, that is Mosaic and Mural. So if you see there, mainly they are paclitaxel coated drugs, and the literature is also abound with all the trials that are done with the paclitaxel. With sirolimus, we have only limited stents and also limited data. Now the drug dosages I have mentioned, the advantage is that the DCB will go there and it will impregnate the vessel wall with the drug. So it is transient, but it stays there. That is the important thing. And when we do the DCB, we have to be a good angioplastic guy. So you should know how to do a good angioplasty. Then we can use the drug-coated balloon. So intravascular imaging, we have discussed just now. Bhattacharya has mentioned how it helps. So before doing it, if you have an idea, if there is a lot of calcium, lot of plaque burden, then you have to do a good angioplasty and go for it. Then predilate appropriately, then take the drug-coated balloon and then deploy. So you have to know that the drug-coated balloon is only a vehicle for drug delivery. It is not going to do a expansion of the vessel. So first, preparation is very important. We can use adjunctive devices also, like cutting balloon or other things, atherectomy or rota, those things. Subsequently, you can do a drug-coated balloon. So what is a good result? If you have a TIMI grade 3 flow, residual stenosis less than 30, and a dissection of type A or B, which I have shown, then it is a good result on the angioplasty. Subsequently, you can go with DCB only PCI. If not, then you have to go for a bailout stenting. Now current applications are there, expanded, small vessels less than 3 millimeters. In some studies it is 2.75, bifurcations, chronic total occlusions, acute coronary syndrome, large vessels, and high bleeding risk patients. If you don't want to continue the antiplatelet for 1 year or 6 months, in those cases, you can use a DCB, because with the DCB, the antiplatelet therapy is abbreviated. You give only for 1 month. In some cases, you can even do away with 2 weeks of therapy. There are a lot of clinical trials. I have picked up only some of those which are RCTs. You can see in different subsets, small vessel, bifurcation, CTO, ACS, and large vessel also. If you see in large vessel, it was a negative trial, but otherwise in most of the cases, DCB is non-inferior to the comparators like drug-eluting stent or metals. And now I told you about 2 drug-coated balloons, which one to choose. So there is no major difference between the two. Transform 1 is the trial which compared sirolimus eluting versus paclitaxel, and it showed superior angiographic outcomes with PCB. But however, a meta-analysis showed that there is no significant difference in target lesion failure over 1 year between the 2 groups. But MLD was larger with paclitaxel balloon. So choice between the 2 depends on the specific patient, lesion characteristics, availability in your hospital, and also your clinical preference. So here is one example. This lady is 60-year-old with a history of ACS and an intracranial bleed. And you can see that there is a large diagonal aneurysm, and the LAD ostium was getting hidden under the aneurysm origin. So I tried to wire it. Always the wire was going into the diagonal, but I could manage it. Subsequently predilated with 2.75 NC, and then did a 3x20 sirolimus eluting DCB, and here is the result. Good lumen enlargement. The patient was discharged the next day. This is another case, 65-year-old male, diabetic, hypertensive with CKD. I think this is the case which Dr. Bhattacharya and Shamshad were referring to, where you can do a hybrid procedure. So in this case, LAD is diffusely diseased. And here, proximal part we stent, and then the distal part you can do a drug-coated balloon. So here it is a 2.75 into 30 SCB, dilated all the way up to the bottom, because you don't want to stent all the way up to the apex. Sometimes we get cases where up to the crux there is a stent that is deployed. So here this patient did very well. Now bifurcation lesion is another common problem which we encounter. There are several techniques, two-stent strategies, etc., crush and all those things where you put a lot of metal at the bifurcation. For this, there is a blended approach where you do a DES for main branch and DCB for side branch, and no final case. And second is a puristic approach where you do DCB for MB and also DCB for side branch. So this is a DCB only approach. And simplistic approach where you don't touch the side branch, just to do a DCB for main branch. It is also shown by imaging studies that if you just do a DCB to the main branch, the side branch lumen area also enlarges and remodels. Here is a case of bifurcation, left main bifurcation. This is a proximal LAD disease. So I stented left main to LAD and subsequently did a drug-coated balloon. This is a 3x15 agent balloon. And the result was good. There was no dissection, the flow was good. This is another case I did as a proctor. LAD primary PTCA was done, and subsequently pre-discharge I did this case, balloon dilatation, and somehow these pictures are not running. So I think that concludes the talk. Nowadays the expanded indications are there. In future we may have more hybrid drug-coated also. Both sirolimus and paclitaxel coating is also there. And there are many nanoparticles that are used to deploy the drug at the vessel site. And also in more and more complex lesions, we are gaining experience and long-term results are promising with the drug-coated balloons. Thank you very much.
Thank you. Thank you. It was wonderful talk on DCB. So I think it will take some time when we are totally used to and accustomed to doing DCBs in large vessels. Recently a meta-analysis was published. So the things are very clear in smaller vessels. ISR is a class 1 indication. Yes. Bifurcation also, it has got a very good kind of theoretically very strong advantage as you do the drug DCB in side branch and main vessel you stent, or you do a kind of both DCBs. EBC is planning a study on bifurcation. But the point where large vessel comes in, left mains and bifurcations, left and bifurcation, still we have to to get more and more evidence. Vineet, any question?
Sir, for that left main circumflex ostium we are using very commonly. How you are justifying it, sir?
Yeah, so in bifurcation, because the other strategy is also not very clean cut and very good. So even if you do a two-stent strategy, you will bound to get 15-20% of ISR in circumflex ostium. And better to choose this way of DCB in circumflex and watch the patient and see. So because the other approach is also not very quite effective, 95-98%. This strategy is also not very kind of unhealthy, and we have done left main bifurcations with DCBs because both the there was a lot of diffuse disease. So you put a stent there and still the MLA you get 6 or 7 with DCPs, it is good enough. There is no dissection.
Yeah, actually, so if we look at the cases, most of the times the ostium of the circumflex is a really problematic issue.
Whichever way you go, there is a problem. So it's a good idea.
It is always difficult. Yeah. I think in those cases we can bail out ourselves safely by doing a drug-coated balloon. And of course, there are some questions there, whether to do the drug-coated balloon first and then put a stent across or go the other way around. But that is debatable and you can choose your option.
So for LAD D1 bifurcation, for example, would you like to do the DCB first in side branch or put the stent in main branch first? So for left main, as you said, that this is debatable.
My practice is to put the stent first into the main and then cross. Because you have to open the struts. Anyway, you have to pre-dilate the side branch. So you can do a semi-compliant balloon, go in and then dilate. Subsequently, you have to take the drug-coated balloon.
Yeah, but the only problem...
The transit time is 25 seconds. Yes. So you have to go fast with the drug-coated balloon. Therefore, lesion preparation is very important.
Only problem is that in case it dissects, then you have to do tap. You're not left with any other option of crush.
That's right.
So then only tap remains the option.
Yes. Yeah. That is why.
One more issue is there, sir. If you are doing it better, they are still if you are crossing with that
Yeah. No, that issue is there. It is not yet very clear. Just like bifurcation strategies,
Yeah, it's
nothing
been-
is clear. So you have to go across and then do it.
It's being done both the ways, and that's what EBC is studying.
Yeah.
Whether put a DCB first in this, side branch, putting a main stent, or DCB both, or main branch followed by crossing and doing DCBs. All these three arms are there. So we'll come to know.
Inside the folds.
No,
if you are putting a drug-coated balloon in that. So if you have done a good preparation and you don't go up the, the balloon, pressure in the balloon, very rarely you will get a dissection. But you have to be very careful. These are semi-compliant balloons on which we don't still have NC drug-coated balloon available
There is.
in India.
NC drug coated is also.
There is it has come, but
With
we
mosaic.
haven't yet received it, so we don't know. So they are very prone to dissections.
Yes.
If you go even by 1 or 2 atmosphere than the prescribed, it will dissect. It goes up like mad. So you have to be very careful how to dilate it. Never go. You choose your size properly and then go what is prescribed. Nothing more than that.
yeah, so this is not for dilatation, it's just for painting and touching the vessel. Yeah, yeah. So I think, yeah.
Actually, sir, it also depends upon my strategy. If I am going for a no-kiss strategy, then obviously I will use a DCB first, then stent second. If I am planning for a kiss strategy, then I will use a stent first, then do a DCB and do a kissing with the DCB. And
Actually, when we use the DCB, kiss is not advised. So you have to, that should be always the final step. Because I spoke to Colombo once in one of the meetings.
so
he said once you do the DCB, no other procedure should be done. Just one final injection and come out.
And then when kissing with the DCBs are not recommended. Like if you are taking 2 DCBs and trying to kiss with that, it should not be done. Rather, it is sequential inflation.
No.
What
And
about the carina
like what Dr. Pramod is
So
saying.
carinal shift does not happen. If you are doing balloon dilatation, carina shift doesn't occur. But when we put a stent, there is a possibility of carina shift and plaque shift. But with the balloon, anyway, you are doing a plain balloon. Subsequently, you are taking the DCB. So you are taking care of the ostium of the side branch and impregnating the drug there.
Yes.
They have actually shown with angioscope that if you put anything in that area again, the drug actually comes out of the wall.
Yeah.
So they say that don't even do an IVUS after you have done the balloon.
True.
Don't do anything. No second balloon, no IVUS, nothing should be done. I mean, that's what.
That is one school of thought.
Let's see.
So
Let's see.
many of the operators, they don't even inject. So that is not maybe not a correct idea. So we can definitely inject, do IVUS. We can even OCT studies are there.
Yeah, they
so
are
I think we'll
crystals
come
have
to
been
know in
shown.
next 5-10 years more about DCBs. And wonderful session, wonderful discussion. And thanks everyone, all the speakers. Thank you all. Yeah, David is there. David, I don't see David.
And quickly moving to the next session, the session 7 of today. Is Dr. Rajiv Krishna here? Moderator Dr. Rajiv Krishna is not here. Okay. Then may I like to invite the chairpersons for this session. It's Dr. Ajit Pradhan from Patna. Is not here. I may request Dr. Dilip Kumar for Kolkata to stay back. Dr. Dilip Kumar from Kolkata to stay back for chairing the session. Dr. S.S. Chatterjee, sir, you are the chairman of this session, please. It is printed here, sir. And Dr. Rajiv Ranjan, if Dr. Rajiv Ranjan is here. And then Dr. Lakshmi Sinha, the cardiothoracic and vascular surgeon, assistant professor at AIIMS Patna, to please chair the session. And the panelists today is Dr. Manmohan, the cardiothoracic and vascular surgeon from Patna, Dr. Malmohan, please come for panelist. Dr. Sheila Avnish, is he here? Dr. Sushant Kumar Pathak from Patna. Dr. Sushil Kumar from Patna. Dr. Shreyash Trivedi from Patna. May I request Dr. R.P. Srivastava, sir? You are missing in your session, so please come to chair the session. Dr. Manoj Kumar Chaudhary, the faculty medicine of IJMS Patna. Nitish Ranjan from IJIC. Dr. Nitish Ranjan from IJIC, please. And Dr. Shambhu Kumar from IJIMS Patna. Dr. Shambhu, please come as a panelist. So now over to the chairpersons to start the session.
Hello, I would like to invite Dr. Vineet Kumar for valvular heart disease and when to intervene. He is the topic.
Very warm good evening to everyone. Valvular heart disease, when to intervene? It's a very boring type of entity because everything is data and number. We all have mug up from our MD time only. Whatever we have incorporated, it's the European Society of Cardiology guideline just came this year only. Valvular heart disease affect one or more of the heart valve and it can lead to the heart failure, arrhythmias and death if untreated, and that intervention is going to improve the outcomes. Our focus is on aortic stenosis, regurgitations, mitral stenosis and mitral regurgitations. The lesion, it is either narrowing of the valve orifice or there is a regurgitations, that is backflow of the blood. So we'll see there is general indication that is applying for every lesion. That lesion should be severe. There is a definite criteria for that. And that severe lesion, if have symptoms, if there is a evidence of LV dysfunction, dilations of the left ventricles, pulmonary hypertension, some arrhythmias is also going to help. Even in some asymptomatic individuals also guidelines is recommended to intervene in selected cases. Earlier it was not much. Nowadays due to evolvement of the surgical procedures and other non-surgical options, the risk is becoming less and less, and in that scenario the guideline is also recommending similarly, and they are decreasing their criteria. First we'll see the aortic stenosis. Severe aortic stenosis, valve area should be less than 1 centimeter square, mean gradient 40 millimeter of mercury, velocity more than 4 meter per second. Indications broadly, symptomatic severe aortic stenosis. Even in asymptomatic severe aortic stenosis, if the ejection fraction is started decreasing. And even asymptomatic severe AS, undergoing other cardiac surgery like CABG or aortic root surgery. There is abnormal exercise testing, just like developing hypotension on exercise. These are few indications where we can go in case of asymptomatic individuals also under surgery. This is for symptomatic aortic stenosis. If there is symptomatic severe aortic stenosis, this is class 1, level of recommendation B. Symptomatic individuals with low flow, low gradient and reduced ejection fractions. After careful confirmation that aortic stenosis is severe, it again class 1, level of recommendation B. Similarly, in the symptomatic individuals, low flow, low gradient AS with the normal ejection fractions, we can undergo surgery, but the recommendation is slightly weaker compared to earlier. It's class 2A recommendations. In the asymptomatic individuals, earlier we have seen, if the severe aortic stenosis with the LV ejection fraction is started decreasing, again it becoming the class 1 indications. But here we need to understand that reductions in LV ejection fraction without another cause, it should be ruled out. Again, severe high gradient AS with the ejection fraction more than 50%. We can advise for surgery. As alternative to close active surveillance, it was advised earlier to closely follow up that individuals, but nowadays guideline is advocating we can go for surgery as class 2A indications, especially the procedural risk is low. In that scenario, definitely we can go for that. Even if there are asymptomatic individuals, severe AS, LVEF is normal, procedural risk is low. If one of the following parameters is there, again we can go for surgery. If there is a very severe aortic stenosis, mean gradient is 60 mm of mercury or more, severe valve calcification or disease progression is very rapid. In that scenario, or markedly elevated BNP or anti-pro-BNP levels, where there should not be any other explanation for the same. Or even the LVEF is in the normal range only, but started decreasing, that is also again one of the factor. If any one of these is present, in that scenario, again, that individuals can undergo aortic valve replacements. Intervention should be considered in asymptomatic individuals with the severe AS if there is a sustained fall in BP during exercise. Next is aortic regurgitations. Here we can classify them severe as the regurgitant volume 60 ml or more. Regurgitation part is more than half, or the LV end diastolic diameter is 65 mm or LV end systolic diameter 50 mm. Again, symptomatic severe AR, class 1 indications. In asymptomatic also, if the ejection fraction start decreasing or LV start dilating. In that scenario, it's becoming indication for the surgery. Severe aortic regurgitations, if it is symptomatic, class 1. Even in asymptomatic, if the LV end systolic diameter is more than 50 mm or the ejection fraction start decreasing, class 1B. Even if it is asymptomatic individual, but if undergoing any other cardiac surgery, again advised class 1, but level of recommendation is C. Aortic valve surgery may be considered in asymptomatic patients with the severe AR. If the LV end systolic volume index 45 ml per meter square or the ejection fraction 55% or lesser, again it level of recommendation is becoming class 2B, but surgery can be advised. Mitral stenosis, severe mitral stenosis, it's defined valve area less than 1.5 centimeter square. Indication, symptomatic severe mitral stenosis, pulmonary hypertension. If valve is good, we can go for balloon mitral valvotomy. If there is any contraindications for that, we can go for surgery. Balloon valvotomy is recommended in symptomatic patients in absence of unfavorable characteristics, class 1, level of recommendation B. Mitral valve surgery is recommended in symptomatic individuals who are not suitable for the balloon valvotomy, and PMC should be considered as initial treatment in symptomatic individual with suboptimal anatomy, because always we are not getting very good anatomy, but there should not be any unfavorable clinical characteristic for balloon valvotomy. The level of recommendation is 2A. Even in asymptomatic individuals also without unfavorable clinical and anatomical characteristics, if there is a high embolic risk, like history of systemic embolisms, dense spontaneous contrast in echocardiography in LA, a new onset or paroxysmal AF, definitely we can go in asymptomatic individuals also. Also, if there is a high risk of hemodynamic decompensations, just like need for the major non-cardiac surgery or pregnancy can be planned. Mitral regurgitations. Effective regurgitant orifice area 0.4 centimeter square or more, or regurgitant volume 60 ml or more. Symptomatic severe mitral regurgitations with ejection fraction should be in moderate range. Even in asymptomatic individuals if with LV dysfunction, here the LV dysfunction is defined as LV ejection fraction is less than 60% or LV volume started dilating. New onset A for pulmonary hypertension. In secondary MR there is a not much indications, usually need to treat the underlying causes. Mitral valve repair is recommended surgical technique to treat individuals with the severe mitral regurgitations when the result is expected to be durable. Mitral valve surgery is recommended in symptomatic severe mitral regurgitations. Even in asymptomatic individuals, again that LV dysfunctions or LV started dilating. Surgical repair is recommended in low risk asymptomatic individuals without LV dilations or LV dysfunction if there is at least some of these three factors is there, either it's the atrial fibrillation, pulmonary arterial pressure is increasing, LA dilations, concomitant secondary tricuspid regurgitations with moderate or more. One thing we have need to see some symptom status, we need to see the LV function, valve anatomy, surgical risk, comorbidities and multidisciplinary heart team involvement should be there to decide. So early recognitions and interventions are the key. Severity, symptom, LV change is guiding us the management. Multidisciplinary approach is essential, and advancement in newer therapies is broadening the options, not only surgery is there. Very much thank you for the patience listening.
Thank you, Vineet, for taking us through the indications of surgery. So, if we have any comments and insights from chairpersons, panels?
Thank you, Vineet. You have nicely explained the indications and all that. As a surgical person, I'm just to say that yes, the stenotic lesions, they present early. The regurgitant lesion, they present a little lately. And in regurgitant lesion, we have to see even the ejection fraction. Sometimes people only see that, okay, ejection fraction is good and you are not more symptomatic. Then we get the patients when the LV is very dilated and severe AR and more than 6.57, and then we have to go for the surgery. We go, but the result is not good. So for the regurgitant lesion, we have to look for this dilatation of LV. If you are having a patient of moderate AR like that, and you are following him, and even if he is not very much symptomatic, but LV is gradually dilating, the intervention should be earlier.
One change, whatever I have seen, sir, earlier there severe aortic stenosis, asymptomatic, there is not much indications or not much vocal for the any interventions. But nowadays for the asymptomatic severe AS is also advocating for the intervention as a class 2A recommendations. Yes.
Yeah.
Only one question. What about the tricuspid regurgitation correction of the valves? That's coming up.
Yeah,
What is the
definitely.
criteria for tricuspid valve revision?
No, no, definitely if there is a severe TR and if the aortic annulus is dilated, definitely need to do something. Otherwise, it's not going to revert properly.
Yes, sir.
I think sir will answer is
for the severe TR. If it is
I'm asking severe TR.
yeah, sir.
Not AR.
Not severe TR. If it is severe TR, even it is isolated, and patient is getting the RV is getting dysfunction or patient is symptomatic, it should be intervened. Whether it is percutaneous or surgical, it should be intervened. And if it is associated with the other valves, then it must be.
Best way to treat tricuspid valve is when we are dealing with the other valves. Suppose you are treating with my MR for going for MVR, and then you are seeing moderate TR, you need to fix it.
Right.
And even if it is mild plus, you need to consider what is going to happen, because tricuspid valve intervention anyway we do like percutaneous or surgical, the results are not good. And the timing is very important. Before the RV starts failing or the PA pressure beyond a threshold, the results again takes a back seat. So it's very important question when to intervene in tricuspid.
Yes.
So we need to have a sweet spot.
When it is associated with the other valves, you have to tackle it. Otherwise, sometimes what happens, you replace the mitral valve and wait, and after sometimes the patient will come with the TR, ongoing TR, and that makes the patient...
This is the only and best way to treat tricuspid valve.
Right, sir.
Yeah.
Right.
So, and also when you are seeing a patient with severe AR or severe MR, still the patient is not at threshold of indices where we go for surgery. How frequently we are going to monitor these patients? This is a very important point.
no, sir. Severe lesion definitely every 3 to 6 months we need to re-evaluate and reassess.
Every 6 monthly we need to evaluate.
Yeah, definitely.
So thank you, Vineet, and now we'll move on to next talk, an approach to asymptomatic severe aortic stenosis, which is gaining a lot of noise and kind of discussions. Dr. Bipin Kumar Dubey from Delhi.
Bipin is a son of the soil. He has passed from PMCH, and it's very nice to see him on the dais, and he is head of a very, very good institution in Delhi, Max Hospital.
Thank you, sir. Thanks, Dr. Ashok, Dr. Tripathi, and others to invite me for this talk. And I know that this is my first visit to Patna after 35 years to deliver a talk, just 3.5 decades. So I'm able to see Dr. Chatterjee, who used to be our teachers, because I remember my final years days when we used to go to learn some cardiology from him in the Indira Gandhi Institute of Cardiology. So this august audience, Dr. Vineet has already told that he has allotted a very boring topic. So it's my responsibility to make this boring some interesting. So this is my first visit to Patna, and ये जो माहौल है बाहर का, अच्छी सी बारिश, अच्छी सी चीज़ें हमें वापस अपने पुराने दिन की तरफ खींच रही हैं. तो मैं 2 लाइनें उनके बारे में कहना चाहूँगा आपको. ये शोहरत भी ले लो, ये दौलत भी ले लो, चाहे छीन लो मुझसे मेरी जवानी, मगर मुझको लौटा दो बचपन का सावन, वो कागज़ की कश्ती, वो बारिश का पानी. So today's topic is approach to asymptomatic severe aortic stenosis. So this is a very hot topic nowadays. So now we have given some data to you, and for asymptomatic severe aortic stenosis, I will use AS. For very severe aortic stenosis, VSAS, and for conservative management CM, because a severe word but lamba sa hai. So prevalence of non-rheumatic severe aortic stenosis is 2 to 5% over the age of 65 years. 50% of the severe aortic patients are asymptomatic at the time of diagnosis. That's a very, very important. Means once we are diagnosing the patients of aortic stenosis, 50% are absolutely asymptomatic. So this is another data showing that at least 12% of the patients over the age of over the age of 75 years, they may have some kind of aortic, some kind of the valvular heart disease, and 4% of them are definitely, yes, they are having severe aortic stenosis. So at this background, we know all this, which is the severe, this is a classification of that, this is a sub-classification of the severe aortic stenosis. And this picture I will show you, everybody is knowing that. This is a hypertrophy of the myocardium is a compensatory mechanism of the aortic stenosis to deal with the afterload, high afterloads. What is happening? The myocardium is very thick, this cavity is small, so this small cavity is causing low flow, low gradient, paradoxical low gradient type of situation. And if you look at here, you may see there is some high islands of fibrotic changes here, there, and everywhere. So once the hypertrophy is, it's a compensatory mechanism, but over the period of time, it causes problems. Some fibrosis develops, some collagen fiber elements accumulates in this, and some inflammation also happens. So all this creates problem in future. So this is a classical diagram all of us are knowing that this is a aortic stenosis, long period, it is asymptomatic, very slowly progressive disease. But once the symptoms start, downhill course is very fast. So in 2 years, 50% patient dies, and in 5 years, only survival rate is just 20%. It is much more, survival is much less as compared to the so many type of cancers, like breast cancer, prostatic cancer, and so many cancer. So deadly disease it is. If the patient is having angina, the survival is only 5 years. If they are having syncope, the survival is 3 years. And if the patients are having symptoms of heart failure, the survival is less than 2 years. So this is for the symptomatic patients. So all of us are knowing symptomatic severe patients, the treatment of choice is SAVR or TAVR. No doubt about this. All classification are all the recommendations of the various society are the same. But what about the asymptomatic patient? Asymptomatic severe ASS is not a benign condition. Why it is not a benign condition? So many small observatory studies have published, and they are showing that the patients are dying early. So one of the good studies was published by Pelka et al. Observational is 622 patients follow up for 5 years, and the freedom for death or AVR. Look at here. 1 year, 20% patient is dying. 2 years, 40% patients are dying, and at the end of 5 years, 75% patients are not surviving. That means the asymptomatic patients are carrying the same future as the symptomatic patient. 5-year survival in symptomatic patient is 20%, and here the 5-year survival is event-free survival is only 25%. So there is a meta-analysis published, meta-analysis of the 10 observational study, US, Canada, and European Union, and they have the similar finding. The survival, 3-year survival in this case was only 33%. So very deadly. So it's not a benign condition. Asymptomatic severe aortic stenosis is not a benign condition. Then what should we do? So the management of the ASS could be challenging. Why it is challenging? Difficult in assessing the symptoms, especially in the elderly sedentary patients. Many times, elderly patients, they are saying, oh, no, they don't have any symptoms. But if you ask them categorically, you may find some breathlessness or some angina kind of things. On the top of that, other comorbid conditions like COPD, CKD, and coronary artery disease, all those are having the similar symptoms of angina, similar symptoms of breathlessness, palpitation, and all. So differentiating between these two are very difficult. And this point is also important, variability in the progression of the disease. Some patients are progressing, disease is progressing very fast, in other it is slow. I have a patient 2 years back, the aortic valve is just it's an incidental finding on the echocardiography. The valve area was 1.2 and patient was absolutely asymptomatic. 2 years later, she came last month having breathlessness, and we repeated the echocardiogram, and we found the valve area is 0.9, and the gradient has reached the 60 plus peak gradient. So it's a significant. So the third point is, as I told you in the previous pictures, that because of the hypertrophy, so much of pathological changes, irreversible pathological changes, morphological changes, and functional changes occurs in ASS. So because of that, the patients are having problem. And the top of that, the last point is very important. The risk of sudden death is 0.6 to 1.4 annually. Why this sudden death? The cause is obvious. The myocardium is hypertrophied, and it has the inflammatory activity inside of the myocardium, fibrosis, collagen formation. So that is the those are the points where the different kinds of arrhythmia happens in aortic stenosis patients, leading to ventricular tachycardia. VF and atrial fibrillation is the commonest arrhythmia which is occurring in severe aortic stenosis. So now what to do? Should we go for either SAVR or AVR in all patients of ASCS? Is it justified? No, not like that. Because as I told you, some of the patients are doing fairly well. They are surviving years together. That means we have to find out other risk modifier factors which is responsible for the deterioration in the conditions of the patients. What are the risk modifiers in ASCS? These are echo. If LV function is less than 50%, severe aortic stenosis like Vmax more than 5, and this valve areas less than 0.6. If you go for the exercise testing, symptoms of angina, breathlessness, drop in the blood pressure, and this is only the Japanese guidelines are highlighting the pulmonary artery pressure. If the pulmonary artery pressure is more than 60, that means patient is going to have a bad future. The biomarker, this is something recent. These are the BNP increased by the 3 times. Anti-pro-BNP, one of the guidelines, they have suggested that you should also go for the anti-pro-BNP. Troponin I, and this is also came into the picture, but not very much studies. This is a new echo that is called GLS, less than 15%, the very important point, but still the guidelines has not included this one. CMR, this is a new thing. Radiology is coming everywhere. Every cardiac field, you may have some radiologist comment. So the CMR, mild valve fibrosis, mid valve fibrosis is a risk factor. One of the studies has included these parameters. So we know that this is a serious condition. So recently 4 landmark trials has came up which compared the medical management with that of the TAVR or SAVR. So these landmark studies are, one of these is the early TAVR. This is published just 1 year back. Total number of the patient 901, and 83% of the patients are low surgical risk. That's also very important, favoring the early TAVR. And 87% of the conservative management patients in 4 years, they went for some kind of TAVR. So now the results are here. The composite endpoint of death, hospitalization, stroke, putting all together, there is a significant improvement, that is 26 versus 43%. The p-value is significant. Again, the hospitalization for CV causes 20.9 versus 41, again significant. But the cardiac death and stroke, no significance. That means, conclusion, the early TAVR significantly reduces the primary composite endpoints, all-cause mortality, hospitalization for CV causes and stroke, and no difference in the MI or cardiac mortality. This is another trial that is called EVOLVE trial. 226 patients, follow-up 43 minutes, and they have used CMR, cardiac MRI, mid-wall LGS to find out the fibrosis. And this majority of the patients, they have received SAVR, only 2 or 3 patients they have gone for the TAVR. So composite endpoint, all-cause death, unplanned hospitalization. This is the only randomized trial which does not show any benefit. So no significant differences in the TAVR in this study. AVATAR trial is again another trial which is comparing the surgical valve replacement with that of the conservative treatment, and the event rate has reduced significantly. No difference in the all-cause death, mortality, and hospitalized individually, but putting together there is a benefit. So this is early recovery, again SAVR with the conservative management, and it has shown, this is the only study which has shown the cardiac death has reduced significantly in the SAVR group of the patients. So to refine this more, we have gone for the meta-analysis for all these four trials, which was published just last month this year. And these meta-analysis They have included 1,427 patients, and they have gone for the early SAVR or TAVR, and the results are here. They have used a separate thing that is called risk ratio. We know that relative risk and absolute risk and so many things, but here they have put another thing that is called risk ratio. And according to that risk ratio of one, more than one is non-significant, less than one is significant. So the composite endpoint, you just see that it's significantly improved, all-cause mortality improved. So it reduces all cause of mortality, hospitalization for CV causes and a stroke. No difference in MI and cardiac death. So now, meta-analysis of this randomized trial. This is for comparing SAVR and TAVR. So this studies has included more than 5,000 patients, and half of them for TAVR and half of them for SAVR. So this is very interesting. It is favoring TAVR over SAVR. So low risk patient TAVR is better than SAVR. A 20% reduction in all cause of death in the TAVR group in comparison to SAVR, and 19% in death and disabling a stroke. So both them are p-value. But in the TAVR group, the number of pacemakers were more. Around 5% patients required permanent pacemakers, and 3% patients severe, that's PVL, paravalvularly. So now, what is the management schedule right now for the asymptomatic severe AS? You know that so many guidelines are there. These guidelines are like European guidelines, American guidelines, Japanese guidelines, NICE guidelines, so many. So I will take 2 minutes more. I think you may allow me. So this is the last but one slide. So the
he has to compensate for 35 years.
Sir?
So he must get 5 minutes.
Thank you, sir. Thank you. So, so the management of this, what they have done, they have studied all these 4-5 guidelines, and they presented a summary of the early intervention in these guidelines. So that's very interesting. All समस्या दूर की कौन से guideline में क्या है, इसको आप जान ले, बस कुछ और जानने की ज़रूरत नहीं है. So conclusion, they have concluded the major adverse event reduces significantly in AVR group, that is hazard ratio 0.52, and unplanned hospitalization of the CV causes also reduced, that is hazard ratio is a 0.41. So that's the conclusion of them, and now they have presented with this. So what is this? Asymptomatic severe aortic stenosis, asymptomatic ASS, no doubt go for the surgery or TAVR, whatever you want. Second, those patients who are not having symptoms, but they are going for the other surgery, like mitral valve surgery, CABG, they should also go for the aortic valve, surgical aortic valve replacement. And those patients who are not symptomatic, no other cause for surgery are there, then here is the role for your echocardiogram. Echocardiogram, assessing this LV dysfunction and criticality of the CVRAS. LV dysfunction, less than 50%, directly go for the intervention. And if the LV function is less than 55%, that is ESE and the NICE guidelines, they are saying, okay, you can go. And the Americans, if they are saying that consecutive 3 echos, they are showing gradual reduction in the ejection fraction, and if goes less than 60, those patients also can go for the surgery. But now if these 2 things are okay, then what to do? Then you have to look for the severity. So very severe asymptomatic aortic AS, VSAS, the maximum velocity 5 meters per second, and the valve area 0.6 cm square, and mean PG is more than 60. Our experience is convincing us it is not 60, but even 50 you can go for that. So echo is absolutely normal, then what to do? The symptoms, you have to go for the exercise test, and if the symptoms occurs, go for SAVR, and if the symptoms are not there, but there is a drop in the blood pressure, 10 to 20 millimeter of mercury, again go for that. Even the echo and exercise test is normal, then what to do? Now the role of the biomarkers comes. BNP elevated 2 to 3 times, again go for that. Progress in the severity of the AS 0.3 mmSg per year, again go for that. And the Japanese has introduced the pulmonary artery pressure more than 60. So even all those things are normal, then what to do? These are the patients you have to follow periodically every 6 months to 1 year. about SAVR and TAVR. So many guidelines are there. Just 1 minute for that. American guideline and European guideline. American guideline is considering two things. One is the severe age of the patient, and second is the symptoms. Age of the patients less than 65, whether symptomatic or asymptomatic, SAVR is the treatment of choice. More than 80 years, symptomatic, even for the asymptomatic, TAVR is the treatment of choice. In between, between 65 to 75 or 80, you have to consider all the other risk factors, like high risk for the surgery, like STS score or PROMS or something like that, high risk for the TAVR, and depending on that. The European guidelines, they have not considered symptoms at all. They have not considered symptoms at all. Only age. Age less than 75, TAVR is the first choice. More than 75, the SAVR is the first choice. This is how we are progressing it. So the take-home message is intervention for ASS less than 50%, critical AS, exercise test positive, and raised in the BNP, pulmonary pressure more than that, and ASS going for the other surgery. So the conclusion is timely interventions can improve composite endpoints and all-cause death, unplanned hospitalization for CV causes in the prior in the appropriate patient of the asymptomatic patients. Asymptomatic severe AS patient should go for some kind of intervention. So before I will go to the last slide, one more is there. So again burst of the emotion. So if you allow, I can take 20 seconds, 10 seconds. It's something different, not the study is over. So 10 seconds, अभी जब मैं आ रहा था आप लोगों से मिलने, उस समय के जो जज्बात हैं उसको मैं बयान करना चाहूँगा। न जी भर के देखा, न कुछ बात की, बड़ी आरज़ू थी मुलाकात की। मुसाफिर को कुछ पता ही नहीं है कहाँ दिन गुजारा, कहाँ रात की, न जी भर के देखा, न कुछ बात की। And the last time, thank you so much, so much.
Sir, one thing I have to ask, that does the TAVR role differs in cases of bicuspid and tricuspid? Do you get some challenges when you are operating for a bicuspid and you are doing TAVR then? So do you get some extra challenges?
Yes, ma'am. First thing I will tell you, in Indian patient, the 40% patients of the severe aortic stenosis is a bicuspid aortic valve. Nowadays, not rheumatic heart valve. That's the first thing. The bicuspid aortic valves are challenging in many ways. Number one, first of all, the decision for the size of the valve is difficult. Valves are usually the eccentric, so entry of the valves are difficult, and majority of the bicuspid valves are heavily calcific and heavily fibrotic, so it is not opening properly. Again, this position of the valve in bicuspid is a difficult task. Aortic dilatation is there. So you have to have a lot of experience to deal with the bicuspid aortic valve, not the tricuspid. Easy to go for tricuspid. Bicuspid, these are the challenges which we have to address.
Yes, most of the landmark trials like Patna trial and Certavi trial, they have not included bicuspid valves, but the meta-analysis and registry data have shown almost similar results if we choose the patients properly. So bicuspid has their own problems. So we will have some discussion on TAVR and in coming next topic. But this is very, very crucial when to intervene. And on 1st of May 2025, Edwards valve has got FDA approval for asymptomatic severe aortic stenosis. So we are moving towards, even if the indices are not showing up, what we all discussed, the PA pressures and ejection fraction lesser or kind of severe, very severe aortic stenosis. Severe aortic stenosis with asymptomatic patient can also get a TAVR, preferably
So
with
for
the evidence
that-
like
for
early
that,
TAVR and all. We are
yes.
moving towards in
Sir,
that
for-
direction, and the goalpost may be changing.
Yeah, for that you have to have the other risk factor
Absolutely.
modifier included in that.
Yeah,
This what I was talking is that just this data is published 2 days back. 2 days back in the Journal of American Heart Association.
Absolutely.
So this is the latest one, 48 hours back.
Thank you. Thank you, sir, for the
Thank you,
wonderful
sir.
talk.
Thank
And
you.
we can move on to the next session. Dr. Joy Som is here. He's going to speak on transcatheter aortic valve replacement. And hopefully there will be more questions and discussions. Dr. Joy is in Kolkata, BM Birla Heart Hospital, and he does structural work there. Yeah, over to you.
Thank you, Dr. Dilip. Thank you to CARDICON 2025 and all the organizers here. Very grateful for the invitation. So I work in BM Birla Heart Hospital in Kolkata, and thank you for the opportunity to speak on TAVI, which already you've had a nice session underway, I believe. So I'm very privileged to be in this great land, and I mean it with all my heart. We must not forget where we come from, and this was really the seat of power and learning and everything for many, many centuries. And mera saubhagya hai yahan aane ka. I really mean it. And I think what this land has given us is the great seed of learning. And I think we must all be inspired from this very, very great land where, where so much of knowledge exchange has taken place. It was the seat of learning for centuries from scholars from all across the world. And when I was reading about it, I was really moved. And I have my own personal little connection. My mother grew up in a place called Maurya, which is near Rohtas district. She went on to study medicine at Ranchi Medical College. That's the lady singled out there in the red. And my grandfather had to raise 6 children. And in the early 1960s, for my mother to become a doctor, right, I think it was only possible because of his efforts and because of the place where he was working in Rohtas, in the ropeways, and I can never forget this, because this is an integral part of my life. So thank you very much to be part here. So coming to the topic, aortic stenosis, as you all know, is a narrowing of the aortic valve, and it can be rheumatic, it can be calcific, it can be congenital, bicuspid, but when it happens, the outcome of these patients is not good. So as many of you may have seen this slide in Braunwald, that the moment that symptoms start, and we were just hearing Dr. Dilip speak about, and the previous speaker speak about asymptomatic aortic stenosis, that the moment symptoms start, that the outcome is really, really bad. And if you look at the graphs here, clearly that a Vmax of more than 4 meters per second portends a bad outcome, but even moderate aortic stenosis is not benign. And even with a Vmax between 3 and 4, the outcome actually in the longer term is not that great. And if you look at on the right, the higher the peak velocity, the worse the outcome. And if you compare this with certain metastatic cancers, actually severe aortic stenosis has a very bad mortality, has a very bad outcome. So what are the treatment options? Well, we all know about surgical aortic valve replacement, and this has been done for decades and is a very good treatment. But we now have TAVI or TAVR, and this is transcatheter aortic valve replacement. You can see here there's a balloon expandable and a self-expandable valve on the right. And this has really changed the way we treat aortic stenosis today. And in many ways, in many patient subsets, has replaced surgery. So what is the scope of the problem in India? Now this data is a bit old, but as you can see, that in the year 2017, there were almost 5,000 deaths due to isolated calcific aortic stenosis. This is degenerative. And about 10 million people over the age of 80 in 2013, of 5 to 6%, more than 65. This is a Census of India website, again, old data. But if you extrapolate this, the prevalence is almost 2.5 to 3 lakh patients who may be eligible for transcatheter valve implantation. So what is TAVI? It is an established treatment for severe, both symptomatic and asymptomatic aortic stenosis today. It is non-surgical, it's minimally invasive. It is done with pretty much many centers only with local anesthesia, if at all, sometimes with conscious sedation, early mobilization, 4 to 6 hours, early discharge. And it is definitely today an alternative to surgical aortic valve replacement across risk groups. I'm not saying everybody should have TAVI, but properly planned and properly offered to the patient with good counseling, this is an appropriate alternative treatment. What are the types of valves? We've got balloon expandable valves. You all know this already. The My valve is something that we're really proud of. This is our own indigenous valve, and the new version of the octocore has come where you have much less foreshortening, therefore predictable deployment. And you've got the Sapien platform and the other self-expanding platforms, the Evolute, Allegra, Hydra, and the Navitor, which is an intra-annular self-expanding valve. So the treatment is urgent. Without timely intervention, mortality is high. And median survival is about 50% at 2 years. So whichever treatment you choose to give, that does improve prognosis. So these are old guidelines. As you can see, in Europe, the cutoff was about 75 years. In America, less than 665 was SAVR, more than 80 were TAVR. And who should have, so these are new ESC guidelines, and who should have intervention? So those with severe symptomatic AS, we know that, class 1 indication. Those with true low flow, low gradient AS. What's new? Asymptomatic patients, severe AF, LVF less than 50%, no attributable cause, that's a class 1 indication. So that's something new that we should watch out for, going from those prognosis graphs. So there's been a change in how we recommend now. This is European data. Earlier it was greater than 75, now it's TAVI is recommended in patients greater than 70 years of age, so the age is coming down. So what should we do? What should we do in India? I think in India, it may be given the slightly lesser life expectancy. Again, that is debatable given which socioeconomic strata the patient comes from. But more than 60 years of age, perhaps TAVI ought to be kept in mind and considered. 50 to 60, perhaps a good discussion, and less than 60 perhaps would be the right age for, less than 50 would be for SAVR. So what are the challenges that we face on a daily basis that is not so commonly seen in the UK? Well, there's a high prevalence of small annuli, there's a small aortic root, low coronary heights, bicuspid anatomy, and small caliber peripheral vessels. So I'll show you a few cases that we've done where we illustrate some of this. These cases are to show that TAVI actually is today mainstream therapy, and it can be delivered to everybody. And the key question here, the key point here is to have meticulous planning, pre-procedural planning and counseling of the patient, and that will definitely give us good outcomes. So this is a 70-year-old approximately gentleman with conventional high gradient AS. He's got multiple, he's had previous stents for coronary disease, good LV function, small aortic annulus, bicuspid anatomy, low left main, and a horizontal aorta. That's the CT, essentially encapsulating the features I've just said. So you can see the horizontal aorta there. So we went ahead and treated this patient with a balloon expandable valve. That's a micropuncture guided right femoral access. That's the aortogram, as you can see there. So the valve was pre-dilated. And this is a 21.5 millimeter my valve being taken across into the aortic root. And we position it. We have a pigtail catheter from the right radial to visualize the aorta. That's the valve being deployed. And that's the final result with hardly any AR. The patient went home on day 1 without a pacemaker and with intact coronaries and with a good option for future TAV and TAV. And that's the final closure with 1 ProGlide and 1 AngioSafe. The second case, this is a gentleman who's 75 years old. He's slightly different. He has got he's had previous CABG, functioning lima, end-stage renal disease with 2 failed previous transplants, and he's now living on a live donor transplant from his sister. He's got peripheral vascular disease with intermittent claudication, severe symptomatic aortic stenosis. We discussed him at the heart team meeting, and he was deemed suitable for TAVI. Now you can see he's got severe calcific disease in his right femoral. And on the left, as you can see there, he's got a transplant kidney with the circulation coming from the left iliofemoral. So we did not want to touch the left iliofemoral. You can see a significantly calcified STJ. And here again, given the diameters, we opted for a self-expanding valve. So this is the ultrasound pictures. As you can see, a very hostile anatomy. So that's the calcium you see ringed in red, and that is the micropuncture access. So what we did here is we did an SFA access. We punctured, because we cannot do a self-expanding system without an imaging guide unless it's a valve-in-valve, and therefore we punctured the superficial femoral artery to allow for the imaging catheter to go through. So that's our 14 French sheath going in. And you can see here this other tube is the imaging catheter. So we've got two tubes here. One is the pigtail, and that's the aortogram tricuspid valve. You see that the transcatheter heart valve is being negotiated across. That's the 80% deployment, and the valve being released. And that's the final result, which is quite satisfactory. And this is the DSA of the leg, and you can see that lump of calcium with the catheter going below it, and the closure is actually above the calcium, and it's all good. So this, again, this case illustrates that, you know, even with very hostile anatomy, with proper precautions and using the right valve, we can deliver the results that we need for our patients. This is a lady who was 80 years old, came in with possibly cardiogenic shock, you would say. And this patient was acute decompensated heart failure, previous Biocon 19 millimeters, aortic root enlargement in 2013. Independent till 3 months ago, but now with multi-organ dysfunction. After careful thought and counseling with the family, we took her on for TAVI because we did not feel there was any other option to improve her prognosis. We tried to have peripheral protection, but unfortunately we couldn't even pass a catheter, and she also had a low left coronary. So this is, you can see that this was mainly a failing bioprosthesis which was regurgitant, causing the heart failure. The valve was crossed. We used a 23 Evolut Pro Plus with coronary protection. So we had a stent there just in case the coronaries had to be were compromised. So this is the valve being deployed. That's partial deployment. We had to reposition it once. And then we thought this was an acceptable position, so we released the valve at this stage. And there's a very small valve with a true internal diameter of only 17 millimeters, so we were bound to have a gradient. So you can see the full release there. I'm just going to fast forward that a bit. And so we went on to fracture this valve with an Atlas Gold balloon. And there's a long inflation, but right at the end you can see that right on the outer curvature, the valve frame straightens out. And this is the final result. We did not need to deploy the stent, so that was all taken out. The groin was closed. And thankfully we didn't need any of any major complication. So, and finally this lady, she's 82 years old. Came to us in extremis with rest pain, breathlessness. It's a very high gradient of about almost 120 millimeters mercury, unstable angina, good LV function, but severe calcific disease on her in her left main. Again, small annulus. We decided to go with a balloon expandable valve here, but treat the coronaries first. So I initially opted for balloon valvuloplasty and then rotational atherectomy and stenting of her left main. So she almost crashed during the balloon valvuloplasty, but we thankfully got her back, and eventually we had a satisfactory stent result. So she came in 2 weeks later for a staged TAVI, like in right femoral access. And you can see there we did protect the coronaries because the coronaries were on the lower side, and we were mindful to make sure that we did not go far above the STJ with the upper end of the valve outflow. And so it was an intentional slightly lower deployment, but that was because to preserve her left main and preserve coronary access as much as possible. And so the guide extension was pulled out, and you can see that the negative shadow of the leaflet is just about here, just below the coronary there. And I think she will have reasonable access to a coronary should it be required in the future. So this is her final result. And at 4 months of follow-up, she had a mean gradient of 17, which I think is acceptable given all the things we had to contend with. So what are the take-home messages? Well, TAVI is established therapy for severe aortic stenosis for all risk groups. So low, intermediate, and high risk. All risk groups today can be considered for TAVI, especially the intermediate and high risk groups. It is minimally invasive, efficacious, safe, and has got quick recovery. Sick patients with high or extreme surgical risk are not a barrier. Often these patients will benefit the most, so we should be offering therapy to them. And evaluation and treatment at an experience center is crucial. So this is the lady who had the bioprosthetic valve fracture. This was on the 29th of June, and her son sent me this picture just a few days ago. And this is not to show off, but this is just to really, demonstrate that, appropriate planning and appropriate therapy to the right patient really makes a difference to their lives. There she is, attending the puja pandal, on Saptami day. I never thought that she would be able to do that, but sometimes the will of the patient to live is much more than our optimism. And I think, if we respect that, then we're probably able to do our job better. Thank you.
Thank you, Dr. Som, for a wonderful talk on transcatheter aortic valve replacement. I think we are a little short of time, but a small comment, with every passing year, the TAVI is becoming safer and safer. And but still, there are some subset of patients we should be a little conservative, like a patient with bicuspids with a low coronary heights and hostile peripherals. It's better to give these patients to surgeons if the patient is even less than 70 years, rather than going after TAVI with taking a lot of risk. So a safe TAVI is the way to go now. TAVI has established its efficacy in low-risk patients, but even then a subset of patients is to be chosen. So if there are no comments, any comment, Dr. Manmohan?
My just a question, that it's established therapy. Why there is age barrier? Means the cutoff age 65, Americans say 75, 65, like that. What is the reason of this age barrier? Why don't you go for the TAVI in lower age of 45, 50, like that?
It's basically, so it's the TAVI valve has a kind of life, 10 years, 11, 12 years.
That's I want to highlight that. So when it is established, it is good for those patients who are having limited lifespan. And those patients who are having long lifespan, says they should go for the surgical.
Absolutely.
That's my message only.
Absolutely.
You agree or not?
Absolutely. So only two things. Sir, one comment from here.
We have to individualize
two things. We have to look for two things. The survival of the patient, number one, and number two, the durability of the valves. This is a bioprosthetic valve. So usually the durability is at around 10 years. So, and the second thing all of us are knowing that if you are going for the bioprosthetic valve in the younger age group, less than 60%, then degeneration of the bioprosthetic valve is faster. So that's what the 65 years age is there. So Americans are a little aggressive, 65, but Europeans are still conservative. They are making cutoff of 75. And the disease in the European, whether it is a coronary artery disease or degenerative valve disease, it is happening in the later age group of the European population as compared to American, as compared to Asians. So that's what they have put it at 75 as a age of cut point.
Right, sir. Means it was my point, because while we were describing this TAVI, we do not mention that it is a tissue valve, and tissue valve has a lifespan which is less than the metallic valves.
Yes,
so
no doubt.
This age cutoff is due to the longevity of the valve. In lower age group, it is better to have a metallic valve, and in the later age of group, it is surgical. When the TAVI was not established, this was a practice. But while
second point is
this was the practice,
yeah,
but while we were describing this TAVI for the mass, I'm saying that we used to forget to say that it is a tissue valve, and it has a limited lifespan.
Yes, we have to see that. And age is also important. Like
Right,
if
sir.
some patient is
yeah,
having
I
cancer,
understand this. I
cancer
understand this.
patient having 5 years lifespan,
Right,
you can
sir.
go for
Very,
TAVI
very
even
good
after
comment,
25,
yeah. So we
30
can
years of age.
invite the next presenter, Dr. Sumanto. He is from Apollo Hospital, Kolkata, and he does structural work there. And you see, the life expectancy in US is 77, 78 years. In many countries of Europe, it is more than 80 years. So, and that could be one reason why they have, and they're a little, conservative on TAVI front, European countries. So over to Sumanto.
So good evening, everybody, and thank you for giving me the opportunity and inviting me to speak today. So the topic is TMVR, transcatheter mitral valve replacement. So these are all my disclosures. So when coming to TMVR, it is actually, sorry. So it is actually when TAVI came, and the same TAVI valve has been used to treat high-risk patients for initially failing mitral valve, like those who had a bioprosthetic valve. This is when TMVR concept came. Following that, TMVR was done for valve in rings. That is a failing ring who had a previous surgical ring done, and then it was again, can be treated by implanting a new valve. And right now we have advanced to even treating valve in MAC. So if there is a severe mitral annular calcification with calcific MS, or severe MR where you can't do a transcatheter edge-to-edge repair, then we can evaluate these patients for having a transcatheter mitral valve implantation within the mitral annular calcification. Now, TMVR, the valve is the same. The only difference is we have got right now only 2 choices. That is the 2 balloon expandable platforms. You cannot use a self-expandable in a mitral position. So I will go through a case, and probably that would highlight what all we need to do in order to plan a TMVR, and as well as what are the steps involved. So first I'll go through an usual case of where it's a valve in valve. So transcatheter mitral valve implantation within a degenerated bioprosthetic valve. So this is a 71-year-old lady, history of previous MVR with a 25mm epic bioprosthetic valve in 2007 for rheumatic mitral stenosis. Presently with NYHA class 3 dyspnea, echo showed severe MS but normal LV function, normal coronaries, a high surgical risk, and not willing for a redo surgery due to previous prolonged protracted course in the ITU after the valve replacement. So when we look at the most important part, whether it is any transcatheter valve implantation, be it TAVI, be it TMVR, be it transcatheter pulmonary valve implant or tricuspid, the most important part is to understand the imaging, do the CT analysis, and look what you want. So here the 2 concepts are, one is definitely you need to, does that work somewhere? I don't think, anyways, fine. So what we can do is, you can see there, so this is where is the mitral valve. So we need to do a CT to get the dimension of this mitral annulus or the mitral valve. It has to be confirmed. Even though you know the surgical valve, it has to be confirmed what is the internal diameter, what is the external diameter, and how the mitral valve is oriented. Second important thing is, what happens initially here is, can this pointer work? Then it will be helpful if this pointer can work. Oh no, this one. ये पॉइंटर काम कर सकता है क्या लेजर?
The arrow there, pointer of the.
No, I can.
You can see there. Yeah.
So what happens is when you implant a valve here, it will jut out into the LV. So part of it is in the LA, part of it into the LV. And because of the aortomitral continuity, what happens is this part of the valve lies in front of the LVOT. That is the left ventricular outflow tract. Voila, okay. The left ventricular, this is good, thank you. So the left ventricular outflow tract. So what happens is, if you protrude too much and there is no gap between your new valve and the septum, then you completely occlude the outflow tract. And this is a fatal catastrophic event that can happen. So if you occlude it completely, patient will have on-table arrest, and there is no way almost to salvage it. Apart from, you can try a rescue, alcohol septal ablation, but rarely you get time for all that. So this is something that is important to understand, that what are my valve sizes, what the LVOT looks, what is the aortomitral angle, and how much of my LVOT would be occluded when I put a new valve in. Because what happens is, if we have this LVOT less than 200 millimeters square area wise, then there is a significant LVOT obstruction or risk of obstruction, and you need to do something to increase your LVOT or have to send the patient for surgery, because you can't implant a valve just by going there. So this is the CT analysis of the same patient. You can see the internal diameter of the valve is lesser than what 25 is. And if you look at, once you put the valve in, your LVOT is quite restricted because it protrudes quite a lot into the LVOT. So this part is the LVOT that is remaining, and that is less than 100 millimeters square. So the cutoff is 200, high risk. Less than 150, you don't go ahead and do a TMVR until and unless you enlarge the LVOT. So for LVOT obstruction, there are a few things you need to look at, but as I told you, if there is a small ventricle, very hypertrophied ventricle, or patient has got a very perpendicular aortomitral angle, or patient has an asymmetrical septal hypertrophy, or very elongated anterior leaflet, then these are the features that will portend increased risk for LVOT obstruction. This is what is a static obstruction. Then there is something like a dynamic obstruction, which can happen when, if there is an increased, like on Valsalva and all, the gradients can go up and cause further obstruction because of the dynamic movement of the anterior mitral leaflet, particularly in patients with valve in MAC and valve in ring. Valve in valve, it is not that much because it is not free to move. So these are the various things that we look at on the CT and plan our procedure. So in this patient, we know we have a valve that is around 24 internal diameter, but the LVOT is small. So we have to do something to increase the LVOT before we go for TMVR. Now if you look at the steps of TMVR, first and foremost, as I told you, is the workup and the CT valve and assessment of the risk of LVOT obstruction. Then you go for, take the patient to cath lab. This is ideally done, no heroics. It is always better to do it under GA, do a proper transeptal under TE guidance, deploy your valve coaxially with a TE guidance. So better to go for GA, short GA, do a transeptal, cross the mitral valve, place a stiff wire in the left ventricle, prepare your valve, dilate the septum, because this valve will require at least a 14 millimeter hole. So you need to create an iatrogenic ASD to take this valve across. And then you position the valve coaxially and then deploy it gradually on echo and on fluoro. Make sure it is mostly 20% atrial and 70 to 80% ventricular. Because if you go too atrial, then there is a risk of embolization towards the atria, because all the pressure is from left ventricle towards left atria. Whereas if you go too ventricle, then you will miss out the ring and you will have a lot of bad paravalvular leak, and the patient can die, go into renal failure, severe hemolysis from the paravalvular leak. So the plan for this patient was, we will do a transeptal access. What we need to do is to increase the LVOT. So there's a procedure called lampoon, whereby we slice the leaflet of the mitral valve that is lying in front of the LVOT. While we slice, we know it's a degenerated valve, so there will be a lot of, debris going on. So we put sentinel for stroke prevention, and then we go ahead with the TMVR with a valve implantation. So if you look at it, this patient has, so we do a transeptal. Now the key to transeptal here is slightly different to what you have from a mitral clip. So you want to go posterior, but in mitral clip you want to go mid to little bit superior. But TMVR you want to go as inferior as possible to create a very kind of a smooth trajectory rather than going up and coming down. So you have to be posterior and inferior in the transeptal. This is how it differs from TEER, because TEER you don't want posterior but mid to superior. So if you see on the short axis view, that is the aorta, so you are posterior there, and then you go inferior as well as like previously. And this is what is the sentinel deployment, where there is one basket preventing your right brachiocephalic and the other basket preventing your left carotid, to prevent hold any kind of stroke. Now following that, as I said, the next important is we cross the valve. Usually I don't use any fancy equipment of Agilis and this and that. Most of the times, if you're careful enough, you will cross with a J Terumo and a JR catheter. You don't need Agilis or anything. If you have got your transeptal right, everything will go in smoothly and you'll cross smoothly. So after that, you take a 14 to 16 millimeter balloon, depending on if you're taking a valve above 29 millimeters, take a 16 millimeter balloon peripheral, otherwise a 14 millimeter balloon, and you dilate the septum. This is what you do. And then what you do is, this is called flossing. So you want to take the inflated balloon across the mitral valve into the LV and then come back. Why? One, it will give you an idea that you have a good trajectory, so you don't have to struggle with your valve, which many times you don't have to do any fancy snaring and all that. I would say snaring done maybe once or twice in like over 250 cases now. So all is important is take your time and do a proper transeptal, check your flossing that this is all good. Once you have that, then you are pretty much happy. So now in this patient, what extra step we had to do is, because there was a small LVOT, so we want to increase the LVOT. That is what we want to do is cut this mitral leaflet. So what we do is pass a Swan-Ganz through there and take a wire out and snare it into the aorta. This is not for TMVR, this is only for slicing, that is the lampoon. Through this, what we deliver is something called a flying V. If you look at here, you see there's a V that is coming out through the catheter. And this catheter V is then positioned on the mitral leaflet that is lying in front of the aorta. And then you apply an electrocautery with a high wattage, like 70 watt pure cut, and you pull it through. So what it does is, it will cut through your anterior mitral leaflet. Or in this case, basically the aortomitral leaflet, the one lying in front. So once you have done that, if you can see, is that you will see such a hole on your transesophageal echo, which is important. And this new MR that has come in. So initially, you remember there was only severe MS. So now this has confirms that you have sliced the leaflet, and that gives you, kind of, if you look at that in front of the LVOT, you can see it on there, that cut part, on this part of the echo. So we have sliced it. And then we proceed with the mitral valve implantation. So again, a transeptal 24.5 mitral valve was taken, and it is positioned across this, if you can see that faint surgical valve ring, you position it, and the deployment is much slower than the TAVI valve, and usually I kind of keep a temporary pacemaker backup, but rarely pace, because you don't need pacing, because once you occlude the mitral valve, usually your pressures come down, and then we want to align it coaxially. So if you see, that is the line of the valve, and then we do an LV angio, no MR, and everything going towards the aorta, confirming that there is no LVOT obstruction, and your valve is well seated on the transesophageal, no significant paravalvular leak, and you can see the new leaflets of the valve nicely and no gradients. So once you get this kind of a picture, you are satisfied that the patient is doing well, and it's been more than 1 year follow-up. The patient is doing actually very well. So I think in the event of time, I won't go through any more cases, but what I want to quickly show you is that patients with severe mitral annular calcification also with a LVOT, see, this is the annular calcification, and there is no valve per se. Neo LVOT is small. He had a previous surgical aortic valve done. So we can do something like a lampoon of the native aortic mitral valve and then implant a valve within the MAC. And this is the valve within the MAC, a balloon expandable valve. And we had to close this patient's ASD because of high PA pressures and right to left shunt. So it has now been advanced that even in native mitral annular calcification, where there is no option of TEER, no option of surgery, these patients can also be treated with transcatheter mitral valve replacement. So I won't go through this. So overall, TMVR requires a good heart team approach, good understanding of the imaging modalities, where you need both understanding of CT, in some cases CMR, definitely TOE, and at times you have to think out of the box, to kind of adapt to the challenges and manage complications and do, justice to the patient. Thank you.
Thank you, Sumanto, for wonderful cases you have shown. And any comments? So TMVR is a procedure which is quite streamlined, and if you do a puncture well, the procedure rate is very high, the success rate is very high. You have to go a little slow in inflation. Unlike in transcatheter aortic valve, you go rapid inflation mostly, but in TMVR you have to be slow and you can little bit do some adjustment during the inflation. Yeah. And Sumanto, you showed a case of Lampoon. It was Swanganj passed, and it was not you didn't transverse the.
No, so the valve in MAC is a antegrade Lampoon. Yeah. But valve in valve is a tip to base Lampoon. So we don't transverse, we slice it from tip to base. The valve in MAC actually, which I skipped through because of the time, there you actually need to puncture the base of the anterior mitral leaflet antegradely, and that's why you need an end snare, grab it into the LVOT and then all the way slice it out.
TMVR in native biprosthetic valve also, I think many operators are doing transversing the septum, the leaflet.
Yeah, I think that is one. That is that is the other option, which is called Batman, whereby you can puncture the anterior mitral leaflet and deploy the valve through the anterior mitral leaflet.
You cross with balloon also. You inflate and do it. So things are really progressing well on transcatheter valve therapy front, and hopefully next year we'll see little more. These kind of cases. Thanks, Sumanto. And any other comment? Yes, sir.
Yes. Sir, it is.
What was the reason? What was the
Sir, it is not an LVOT obstruction that I'm saying. What is a projected LVOT obstruction? Because if you get into the LVOT obstruction, the reason why it will get obstructed is because you see the mitral valve is projecting into the LV. You have got a valve leaflet in front of it. So the moment you put a valve there, your native valve or the surgical valve will get completely will become like a covered stent, because the leaflet is lying there of the native valve. I mean to say the substrate. So if you don't have any space, then it will cause complete obstruction. If you can go back once, I want to show the picture just if possible. Yeah. Once you press the valve, that's what I showed you. There was a severe MR, right? The moment you put the valve, there's no MR, because now you've got a functioning valve. That valve anyways was not functioning. So you cut it to make space for you to put a new valve. If I don't make that space and just put a new valve, what will happen is it will completely sit like a covered stent in front of the LVOT. So as like covered stent, there is nothing that is going to pass through. Isn't it?
So this process is done before you put the valve, final valve. So the previous valve which is being put there, the leaflet of that valve will be opposed with the new valve which you put in, and will make it a covered stent kind of thing, and then the LVOT get obstruction. And if there will be LVOT obstruction in these cases, mortality is almost 100%. These patients can't be salvaged. Yeah. So that is very important. A new LVOT has to be more than 15, or it should be 20 to be reasonably safer.
Slicing the tissue and taking it out, or slicing the tissue and
just opposite? So basically, it is like this. So if I slice either from here, one into other, So when when you open it up, what happens is it falls like this.
Like this.
So you kind of have a V-shaped opening through which your valve flow goes. So on the CT, what we do is we do that slicing, simulate it, and then actually I will again recalculate what is my new LVOT or a new skirt area. So supposedly the new LVOT is less than 100. Then you simulate a slice, and then again you look at the CT and see that now if I slice it, if it is more than 200. If it is more than 200, then I will go and implant the valve. If not, then again I will think of something else. That is, then I will think of reducing the septum, particularly if there is a septal hypertrophy. That you can do either by doing alcohol septal ablation or putting a small same slicing in the septum, called a cesium. So then if it is more than 200, then we go. But what is important to understand that you don't do this just because you want to do this. You have to do this only in patients who cannot have a surgery. Okay, it is not that मैंने एक बार patient से बात किया वो surgery नहीं चाहता है, कोई भी surgery नहीं चाहता है. So you have to counsel them properly that this is a high risk procedure. If his surgery is even higher risk, or if he is not able to tolerate medical management because of a very severe MS or MR, then only go for all this. It is nothing like I put a fancy thing and I want to do it. It's not like that.
Surgically turned down patients where no options are working, and then you go with this kind of procedures. Thank you so much. I think it was a wonderful session.
Thank you.
Wonderful discussion. So we are closing the session. Thank you so much.
Good evening, everyone. So we had a wonderful session on valvular heart disease. The next session is that of a mixed bag session. And for chairing the session, may I please invite on stage Dr. Pramod Kumar sir, Dr. Arvind sir, Dr. Vijay Kumar, and for panelists, may I call Dr. B.N. Pandit sir from Delhi, Dr. Javed, Dr. Manas Thakur, Dr. Bhaskar Bhushan, and Dr. Ashok Kumar Thakur. Dr. B.V. Bharti sir. Dr. Sanjay sir. At this point of time, we are running quite a bit late, almost over an hour. So I request all the speakers to please keep the talk to time, like 12 to plus 3 minutes. And for the first talk, may I please invite on stage Dr. Anupam Bhamani, ma'am, on identifying vulnerable plaque.
Thank you, Akanksha.
Dr.
And
Anupam
my
is
sincere.
I will introduce you. Dr. Anupam is a head of department of AIMS and is very dedicated to his work, and she will speak on the identifying vulnerable plaque role of AI and machine learning. Dr. Anupam.
Thank you, Dr. Bharti, and my sincere thanks to organizers for giving me this opportunity to interact in this intellectual meeting. So about 3 decades ago, it was thought, or I should say till about 3 decades ago, it was thought that more severe the stenosis, more are the chances of MI. But then 3 decades ago, Mueller et al., they observed that in retrospective studies, the milder plaques were more often associated with the acute coronary syndromes. Soon after their publication, New England Journal of Medicine published a very beautiful editorial, The Lions and Lambs of the Heart. Severe stenosis was compared to lions and milder stenosis were compared to the lambs. So they wrote, lions are more dangerous or the lambs are more dangerous. But the end of the editorial, the editor wrote that it is the lion wearing the skin of the lamb, which is the vulnerable plaque, which appears milder, but actually that is the one which is causing more MIs. Dr. Pramod already very nicely explained PREVENT trial. This trial clearly showed that preventive percutaneous coronary intervention compared to optimal medical therapy for the treatment of vulnerable plaques. This was a multi-center open label trial. It showed clearly that up to 7 years, the survival benefit, not survival benefit, but the cumulative MACE was lesser in those patients who were treated for vulnerable plaques rather than leaving them on medical management. Another trial published a bit earlier than this trial, the combined FFR-OCT trial, it showed that even in patients where FFR was negative but vulnerable plaque was seen on OCT, when these patients were followed, it was seen that patients having TCFA, which represented quite a high number of FFR negative lesions, they had 5-fold higher rate of adverse event despite the absence of ischemia. So based on these two trials, they provide enough evidence that accurate plaque phenotyping can translate into tangible outcome improvement by changing PCI indications beyond hemodynamically significant lesions. Now it is necessary to recognize the vulnerable plaque, which is not a very easy job. For recognizing that, we have to know what are the features which have to be discerned. These are a large necrotic lipid core, presence of inflammation, thin fibrous cap, presence of neovascularization, and arterial remodeling. OCT, IVUS, or CCTA imaging are essential for the identification, but they require time and expertise. Recent advances in machine learning techniques have considerably improved the automated identification of vulnerable plaque. Artificial intelligence-based plaque characterization models can potentially deliver near-expert results across all the three modalities. They help in prompt vulnerable plaque identification, they lower operator dependency, and they lower the analysis time. Now, what are actually artificial intelligence and machine learning features which help in identification of the vulnerable plaque? First, AI, what actually it is replication of human cognitive capabilities by the machines. So in this process, programs are created and machines are enabled to learn the capabilities with the help of repeated experience, loading lot of data, extensive data trains the machine, so machine develops the capability of analyzing the data independently without explicit instructions, which is called deep learning. So these deep learning capabilities are compared to the actual neural networks of the human brain, because machine develops a pathway depending on the data fed into that, which finally causes some clear pathways which are very close to the human neural pathways. And this processes vast, extensive data sets without explicit instructions. Deep neural networks, during machine training, these connections lead to correct outputs, and the correct outputs are strengthened by the computer programming people, but the wrong outputs are weakened. Through this iterative adjustment, the network refines itself continuously, and with extensive data, when it is fed into the machine, it is fed till the desired accuracy in the performance is achieved. This process enables DNNs to work autonomously and replaces the rule-based techniques. I think this is not necessary to know all these computer terminologies, but only thing what we have to know is that there are three types of learnings imparted to the machine. These are supervised learning, where there is enough data to label something right or wrong. Then there are unsupervised learning, where machine is trained to develop its own thinking from the inadequate data, and there are hybrid paradigms. As the amount of data and computational complexity increase, so does the progression from artificial intelligence to deep learning. Now, recent models showing superior performance in plaque characterization with higher accuracy, sensitivity, and specificity consist of complex neural networks and advanced variants of CNN, such as residual networks, and generative networks. Among these, something which is most important in identifying vulnerable plaque is this convolutional neural networks. Now, what are these? Convolutional actually means that when extensive complex pathways are created and then these pathways are summed up. So computer gets multiple inputs from what should be like what and what it should interpret from the, for example, from the outer border or from different features, and these multiple complex pathways are summed up. Convolution actually means in mathematics when multiple formulas, complex formulas are summed up to get something very complex out of it. This is something like this video. Multiple complex pathways are complexed in the computer program, so it becomes very, very advanced to identify on its own and give particular picture to whatever is fed into that. This way it can tell that this pathway is vulnerable. This is denudation of endothelium. This is thrombus. This is how the CNN works. This is another example of CNN. Suppose computer is fed with picture of an animal and computer is asked, what is this? This is a zebra, this is a dog, or it's a horse. So computer has already multiple programs. One program identifies the outer margin, maybe another the tail shape and the zebra stripes. Finally, the convoluted networks give the idea to computer what is the score of what. So here we can see the maximum score is in favor of zebra, so computer said it's a zebra. Same way, computer also can identify, the artificial intelligence can identify what kind of plaque it is, and same is used in the medical imaging. Advantages of deep learning in vulnerable plaque identification. These techniques have brought notable developments in the field of coronary assessments. CNNs provide significant accuracy, repeatability, and efficiency over conventional manual or semi-automated methods. These models they evaluate stenosis with lower intra and inter-observer variability, optimizing the clinical results. How CNN actually help in identifying vulnerable plaque in OCT? They improve the detection whether it is erosion or it is it's a ruptured plaque. For example, here we can see OCT sees a ruptured plaque, and here there is an erosion without any rupture, but there is thrombus on the eroded endothelium. These pictures are very, very clearly, and in studies it has shown that with high accuracy, the AI can diagnose these pictures and can discern between plaque rupture and plaque erosion. This is another example of OCT image of TCFA, where it can be seen that there is a large pool of lipid from 7 o'clock to about 2 o'clock, and then there are macrophages. Macrophage infiltrates these punctate small shadows, and there is an endothelial disruption. AI can very well diagnose these and can give results within seconds. OCT excels in vulnerable plaque detection by characterization of these features. It also has the capacity, which other modalities don't have, of clearly seeing the thickness, detecting the thickness as low as 75 microns, which is the thickness of the covering of the TCFA. Then there is another thing called OCT-based vulnerability grading system, which can be used very easily with artificial intelligence. It is based on minimal lumen area, the cap thickness of less than 75 microns, and presence of macrophages. So, now coming to the IVUS in identification of vulnerable plaque. Compared to OCT, the evidence is limited on machine learning in IVUS models, but remodeling is something which is very nicely detected by IVUS, even better than OCT, and remodeling has been associated with vulnerability. Scientific evidence for machine learning models in IVUS. There are studies showing automatic detection of plaque and calcification and intravascular ultrasound-based deep learning for plaque characterization. These models they have sensitivity and specificity of 80 and 96% respectively. Another modality is CT coronary angiography in vulnerable plaque detection. These detect positive remodeling with a remodeling index of more than 1.1, napkin ring sign, which is like this. There is a small hypodense area surrounded by a not calcified, but a high Hounsfield value area. Then punctiform calcification can also be seen. These all together result in computational analysis, and they can tell that this plaque is vulnerable plaque. AI and machine learning identifying vulnerable plaque by CTA, there is something called radiomic analysis. It uses sophisticated algorithms to extract a large number of quantitative features. Can I have 2 minutes? Okay. It has shown superior performance compared to the conventional assessments. These are some studies which show that even when compared to the pathological histological specimens, CTCA shows very high specificity and sensitivity for diagnosing vulnerable plaques. I can skip this. So these are all the studies which show that it is very helpful. Advanced deep learning techniques are emerging, proving more accurate than CNN, especially in erosion. So far we have CNN as the most advanced, but new advanced technologies are emerging further. Multimodal fusion, this is something new. Multimodal fusion is redefining plaque assessment by combining the complementary strengths of OCT, IVUS, CCTA. NAIRS IVUS is one of the examples. Co-registered IVUS OCT data sets show deep learning fusion networks which outperform in identifying VP largely by balancing OCT's resolution with IVUS's deep penetration. Addition of near infrared that I already talked. Prospective outcome-oriented trials are essential to demonstrate that AI-driven characterization can refine therapeutic decision-making. Rapid research has a strong potential to accelerate the incorporation of AI-assisted plaque assessment into the diagnostic and prognostic armamentarium, which is likely to be endorsed by future iterations of cardiovascular guidelines. Thank you. आ रही है मुझे
Can you tell me when the vulnerable plaque becomes non-vulnerable after treatment? If we are doing all the things, IVS study, and there are multiple vulnerable plaques, what is the best treatment? If it is less than 70%, what is the best treatment?
So
one of the study had told that the stenting is a good option and is better than drug.
So there are very few studies. Because of limited data, it has still not been incorporated in the guidelines that vulnerable plaques should be stented. An earlier study had clearly shown that stenting vulnerable plaques was not helpful, but recently 2 studies have shown the benefits. One study showed that it is all vulnerable plaques, if they are stented up to 7 years, the MACE is lesser, although survival does not improve. Second study showed that even in FFR negative patients, but if the plaque was vulnerable, stenting resulted in reduction in MACE. But still probably the data is not adequate to be included in the guidelines. So still currently it is just the medical management, the lipid lowering drugs, especially the statins and other risk factor management. Probably there's another thing, inflammatory treatment, suppressing the inflammation. That is also coming up. For this colchicine trial was done, but there are still other trials which showed contradictory results. So we are not very sure how vulnerable plaque should be treated, but so far recommendation is just do medical management.
Thank you. Any comments from the audience? No.
Thank you.
The organizer is very strict. Good. So we come to the next talk, that is approach to cyanotic congenital heart disease by Dr. Major Prabhat Kumar. He is one of our earliest trained pediatric cardiologists this state, and we would.
Good evening, Chairperson, panelists, and my colleagues. Thank you so much for nice words, sir. Thank you, organizing committee, especially Dr. Ashoka, to inviting me here. My topic is not a new. Always do the injustice to me, give the big topic, and to present in a short time. So I'll start my topic with blue baby, cyanotic child heart. Always say blue babies. Before moving to the main topic, it will be injustice to talk on the BT shunt. There was no hope for treatment of blue baby before 1944. When you diagnose the patient having the cyanotic heart disease and saying the parents there is no treatment, then realize what happened to the dead parents. And that time it was called only BT shunt. After 80 years, now it becomes a BTT shunts. We now added the importance of the Thomas, who assisted and incorporated main roles in invention of the BT shunt. And this is the first invention on which has the Hollywood movie that is called Something the Lord Made. So coming to the topic, I'll cover this topic in a few words. How to differentiate cyanotic congenital heart disease from other causes of cyanosis. We have to discuss cyanotic heart disease in all age groups, in fetus, in pediatric, as well as adults. Then I have to classify the cyanotic congenital heart disease based on mainly pulmonary blood flow and its clinical features. There is also need to talk changing trends in diagnosis and making treatment. Nowadays it's rare to see the non-operative cyanotic CSD, particularly in adults. And also I'll discuss the prevention, counseling, and how to limit disability. So whenever a patient came to the OPD, it's not only the cyanotic heart disease. Cyanosis may be because of other diseases like respiratory causes, maybe abnormal hemoglobins, maybe neurological causes, or in neonate we usually find out the pulmonary PPHN, hypertension. So I'm giving one example which came to my OPD. 3 months male child came for the echocardiography, and the referring note was baby getting blue on crying and having history of cough cold. That time SpO2 was 95%, there is no murmur, chest clear, no abnormal in CNS. Did the CVC, X-ray, AVG available? That time, no. Only advice for the echo. I did echocardiography, it's normal. Again, patient came to my OPD for review of the echo. Again, having the cyanosis, low SpO2 on crying and cough and cold. Again, did the echocardiography, told echocardiography normal. Then did the contrast echocardiography. It's also normal. Then came to conclusions. It's may having the intermittent cyanosis due to the cough cold. There is also history of consanguinity. I asked for the X-ray, CVC, and AVG. You can see in AVG, there is a high PaO2 in spite of having the low SpO2 at bedside. So it's presumed to be the methylmaloninemia. And on the further investigations, it came out having 15% of methemoglobin level in bloods. That confirmed diagnosis, and for further management we referred. So I will cover it all age group, not only the pediatric age group. Whenever I standing to talk on the CSD, people think I will talk only on the pediatric age group. It may be the fetus, it may be adults also. The presentation vary from different age groups. In fetal age group, there is some other regions came for the tests, and they having the also preventive options. Not only diagnosis, you can offer for the some termination of pregnancy, and having the advantage, you can transfer the mother in vitro transfer to avoid the complications of the cyanotic congenital heart disease. In pediatric age groups, usually the critical cyanotic heart disease present in early age group, like in neonates and infants. In adult, slightly grown-up children, we can have the milder varieties like pink top and classical tops. We can also get the operated cases with some problems. Rarely you can get the ace major cases like TG with ventricoseptal defect. In adult case, mostly you can see nowadays operated cases, either with or without complications. Now, rarely to see the unoperated cases. It's called the God's palliated cases, having top with a map cast. And we can see the major cases commonly in this age group. If you classify the cyanotic congenital heart disease on the basis of the decreased pulmonary blood flow, having increased pulmonary blood flow, on the normal pulmonary blood flows. So we know the cyanotic congenital heart disease with decreased pulmonary blood flows. Whoever having the critical or pulmonary stenosis can have Fallot's physiology, can have major physiologies, can have absent physiologies. The features will be like cyanosis, cyanotic spills, squatting equivalents, polycythemias, maybe look comfortable in room, may have mild to severe cyanosis, it may present in all age groups. There may be systolic murmurs or some thrills, usually size of heart is normal. In the case of the increased pulmonary blood flow, that is also called the transposition physiology, there may be the features of cyanosis with congestive cardiac failures. Baby will be the sick looking, distressed, poor growth, having mild cyanosis usually, commonly seen in pediatric age groups, may have the diastolic thrills, diastolic murmurs, no thrills. And on X-ray, we can have the cardiomegaly. Coming to the pulmonary blood flow, having normal, we can see rarely the heart is normal, but having the lesion outside of the heart, like heavy fistulas, pulmonary or hepatic fistulas, may have the SVC draining directly to the LA. So in this case, having usual only cyanosis, precordium normal, they may have some systolic murmurs, continuous murmurs in chest. So sometime in older age, older books divided the cyanotic heart disease on the basis of the ECG patterns. So now we can see the congenital heart defect, cyanotic congenital heart defect in adults, mostly non-operated, only fuse, like top pulmonary atresia with MAVCAS, non-top conditions, then absent anomalies, major physiologies, then having the unobstructed PVCs, and cyanotic heart disease normal pulmonary blood flow, like pulmonary fistulas or right pressure VC, is commonly seen in adults. So diagnostic approach is as usual for other diseases. There is clinical presentations, signs, symptoms, look for signs, symptoms, do some bedside tests like CBC, X-ray, ECG, and ABG, and then do the echocardiography. Sometime we have the normal sequence. Sometimes after clinical findings, directly jump to the echocardiography. Then come vice versa back to the ECG, X-ray, or some ABGs. Echocardiography is not only the diagnostic, it also help you to how to decide the treatments. So echocardiography done meticulously. Rarely we require the catheterizations, CT angiographies, or cardiac MRIs. I'll just showing few images. You can see in the first. This is the fetal echocardiography did in 28 weeks of age pregnancy. You can see there is a tricuspid valves. It's not opening properly. This is the RV. It's hypertrophic and smallish. This is the interarterial septums. This is mitral valves. This is LV. You can see the lower image, still image. There is RV hypoplastic. The pulmonary artery is dilated, but the valve is not opening. So this case of the pulmonary atresia with intact ventricular septum, sometimes we call as a hypoplastic right heart syndromes. It's counted as a single ventricle physiology. So at 28 weeks of pregnancy, it's very shocking news to the parents. And unfortunately, that time when I was disclosing the diagnosis, father fainted down in my OPD. You can imagine having the pregnancy after 10 years of marriage and diagnosing 28 is a single ventricle. In second image, you can see this one. This child was roaming in different OPDs, sometimes saying the AV canal defect, sometimes saying the osteoprimum ASD, then turned up to the single ventricle. Guess any diagnosis? Any diagnosis of this image? This is right atrium, this is left atrium. This is left atrium, blood flow towards the RV and LV, both ventricles. There is a atresia, type of atresia. What is this? It is double orifice left atrium. L is opening in both ventricles and counted as single ventricles. All those RV is adequate sized. This cardiac cath image, this is post-op catheterization. Child undergone the intracardiac repair for pathology fellow. But on follow-up, they have persistent cyanosis, SpO2 not improving. Then advise for the go for cardiac catheterization. We see there is a double scimitar syndrome. You can see this here. Two pulmonary veins draining directly to the IVCs, double scimitar syndromes. So sometime we have to think beyond echocardiography. So therapeutic modalities depend on the physiology of the cyanotic heart disease. If fallot physiology, if transfer physiology, there are some drugs only. So in the case of the fallot physiology, we can have the propranolols, prostaglandins in critical cases. In the case of the transfusion physiology, where having the congestive cardio failure, we can use the decongestive, rarely using the prostaglandins if having the physiology, TG-IVs. There are some options of transcatheter interventions. We do the stentings, PD stenting, arbitrary stenting, sometimes MAPCA stenting in adults, if MAPCA is restrictive. Then do the coiling of the MAPCAs if we're planning for the intracardiac repair of grown-up child and having significant MAPCA. There are also the definitive procedures in transcatheter. Nowadays we are doing the post-operated TOF, pulmonary valve replacement. There is palliative procedures in the case of the transfusion physiologies like balloon atrial septostomy, PFO stenting, and sometimes we are using the pulmonary flow restrictor. There are the surgical options, maybe the palliative options, maybe definitive operations. There is BTT shunt, BD Galen in single ventricles, MAPCA focalizations, definitive procedures maybe in the TOF physiology, total corrections, Rastellis, conduits, Fontans in single ventricles. In the case of transfusion physiology, we have PA bandings, atrial or arterial switch, rerouting of TAPVC, and Fontan in single ventricles. So therapeutic approach depend on the severity and type of presentations. One disease may have the different type of spectrums. If you having TOF, the TOF may have blue presentation classically, may have pink TOF, may have critical TOF. It depends on the age and body weight of patients, depending on anatomy of individual CHG lesions. Also depend on the awareness of the problems and prognosis, depending on the financial helps, availability of treating centers, which is available few in Bihar, and also expertization of the treating team. The timing of intervention from the Indian pediatrics guideline, when to refer the patient to the surgeon or cardiologist, they have made some guidelines. In case of TAPVC, you can say if having obstructive TAPVC, symptomatic always, emergency surgery required. In the case of non-obstructive, may have asymptomatic, few minutes, 1 month, 2 years can do if the reversal pH. So they have made some guidelines on the cyanotic congenital heart defects. I'll skip this one. So coming to prevention, after talking on treatment, there are primary prevention, then tertiary prevention. Primary is doing testing for syndrome, do the counseling of recurrence, talk of the prevention and treatment of maternal infections, diabetes, disease, pregnancy control, early fetal diagnosis of complex CST, and think of the option of the MTP. To limit the disability, we have to do regular follow-up, increase the quality of life, do the management of complications, and suitable jobs. Future management, improved cath lab techniques, causing less surgeries. We have now transcatheter ICR, few cases reported, transcatheter Fontan surgery, and TPVR. Minimal access and cosmetic surgery we have to develop. Advanced therapy, pulmonary hypertension, like drugs or ECMOs, availabilities. And there has to have the accessibility and affordability of heart transplantations for some diseases like hypoplastic syndrome, single ventricles, Eisenmangers, or PH. So to conclude, awareness of the disease, prognosis and treatment availability is essential. Think beyond echocardiographies. Early diagnosis and timely treatment is the cornerstone of treating of cyanotic congenital heart disease. Avoid Eisenmenger syndromes, avoid recurrence of diseases by genetic testing and counselings, and offer services for disability limitations. Thank you so much for patience hearing.
Thank you, Dr. Prabhat. Just a quick comment from our surgeon, Dr. Sanjay, who handles all kinds of patients from newborn to the elderly. And after that, we'll request the next speaker.
Thank you, Dr. Prabhat. You presented a very elaborative approach towards cyanotic congenital heart disease, but most importantly is most of the blue babies are having a simple diagnosis of tetralogy of cell. That's the most common diagnosis, and I think that is a treatable cause. So we should take care, and I think nowadays most of the things are treatable in congenital heart diseases, and simple tests are available even in the peripheries, and just what they require is just our attention toward the baby, and if timely we can diagnose, then the treatment is available at the preschool stage. That is the most important concept.
Thank you.
Timely diagnosis and treatment is very important. And even Fontan is not having a very bad prognosis. Even I have done Fontan in 18 or 20 years of age, and now that boy is doing job in hospital itself. So even Fontan and single ventricle physiology, we should not multi-stage surgery that is not like that.
Exactly.
So every patient requires treatment, and in the future, these patients, if come after 40 years, they may be the better candidate for the transplant. So approximately we will be able to give them the life expectancy up to the 60 years as well.
Exactly.
Very true. So we
Thank
now, we have been told that Dr. Manish Kumar Jha is not coming. So pacemaker troubleshooting by Dr. Raghav Bansal from Delhi.
So, thank you for inviting me to the dais. So, first of all, I would like to, at the outset, I would like to congratulate the organizer for putting together such a wonderful program. It's a scientific extravaganza going on here. And I would like to thank the organizer for having me here to speak on the dais. So, my topic is pacemaker troubleshooting. It's a very vast topic and it's very hard to cover in 12 minutes. And this is the reason why it is so hard. Because the pacemakers were first implanted in 1960s, and over the past 50 years they have progressed, and there have been so many advancements in the technologies. The pacemaker algorithms have become very complex, and because of that, those layers of complexities, we have complex problems now, and the troubleshooting also becomes complex. So basically, what I would like to talk about here, important basics. So we need to stick to the basics, try to understand a few basic concepts which will help us in understanding how the pacemakers behave, and we can learn by few examples, and finally we will talk about shortly for programming for surgery and MRI, which is a common conundrum which we see in our clinical practice, and after that I'll end my talk. So regarding the important basics, so regarding the pacemaker design, what we essentially do in a pacemaker implantation is implant a pulse generator in a pocket subcutaneously clavicular region, prepectoral, and we pass the leads to the subclavian or the axillary vein, the atrial lead into the right atrial appendage, the ventricular lead into the septum. These leads carry the currents, and these leads can have a fixation which can be a passive, which are timed leads, or an active, which has a screw at the tip, which acts as an active electrode. Both these kind of leads also have an electrode, which is a ring electrode, which is behind the tip. And thus, since the lead has two electrodes, it has to have two conductors to take the current signals from both the electrodes separately. And these conductors can travel in a coaxial design, where one conductor is outside and another conductor is inside. This is the most common design. Or it can be co-radial design, where both the conductors are wound together around a single core. So, important thing to understand in coaxial design is that the outer core, if there is a lead fracture, the outer core will break first and the inner core will be preserved. So that gives us a chance for programming. So we will discuss it. So, and when we talk about the connectors, it's a universal IS1 connector design between, which is standard across all the pacing devices, the pulse generator and the lead. So when we talk about unipolar and bipolar pacing mode, so what happens is, so these two poles, if the current is traveling between these two poles, the distal tip acts as a cathode from where the electrons exit, and the proximal tip, the ring, acts as an anode from where the electrons go back into the pacemaker. So in this bipolar, the local part of the myocardium is being activated, and the consequent pacing spike is very small because it is not entering inside the body. While in a unipolar mode, the current enters from the cathode at the tip of the electrode and then enters the pacemaker generator here in the pocket, and the current travels throughout the body, giving a larger pacemaker spike. So we can have sensing and pacing in unipolar and bipolar modes. So by default, bipolar is advantageous and used consistently. However, in certain situations, we can also use unipolar pacing modes. So unipolar pacing mode gives us a larger pacing artifacts, and the chance of anodal capturing at the ring electrode is very less, and it is safer in lead insulation defect where the outer core is being damaged, because unipolar will follow only the inner core. While the disadvantage is that if we are actually pacing at a higher output, we may actually capture the pectoral muscle. Sensing, bipolar is definitely hands down better than unipolar, because unipolar will have problems of electromagnetic interference because of a larger antenna. So when we implant a pacemaker in the lab, we have to do an electrogram analysis. First, we have to check what is the sensitivity threshold, how it is sensing the intrinsic heart activity in terms of a sensed P wave or an R wave. We have to check how it is capturing in terms of a threshold and pulse width, and also confirm that the capture is both electrical and mechanical and is generating a pulse. Importantly, this is very important concept, a concept of current of injury. Whenever you are implanting, if you are getting a decent sensed R wave or a P wave, but your threshold is not good, but your current of injury is good, you can be confident enough that leaving the lead there will be good, because with the current of injury, where you get an ST elevation and a very broad EGM, so if you are seeing such a signal on an unfiltered electrogram, so this signal suggests that the lead is in a good position, and even if you leave the lead at a threshold of 4 here, the threshold is going to settle down to around 1. So you need not worry if your current of injury is good. Then we are talking about something called as impedance or resistance, which is the flow opposition to the current flow. And this is the normal resistance, where this is by an example of a water pipe where the water flows well. In a low resistance, if there are leaks in the pipe, the resistance will be low, but the flow of water will increase. And if we tie the water pipe in between, it will be a higher resistance and low current flow. So when we are talking about impedance, so there can be an insulation break where there can be a leak leading to a low impedance, or if there is a conductor fracture, it can lead to a high resistance. And that is what we talk upon on follow-up when we are looking at lead impedances. So if the pacing lead impedance is high and it has happened in an abrupt fashion, it is likely that it is a conductor fracture. And if the pacing lead impedance is low, it has happened as a gradual or an abrupt fashion, it is likely an insulation break. Important thing to differentiate is that when it happens, the increase in pacing impedance, if it happens very gradual fashion, then it is not likely to be a fracture. It is rather likely to be a mineralization or fibrosis at the electrode tip myocardial interface. So that is very important to understand. And the impedance can go haywire in lead dislodgements and perforations. So this is an example of a lead fracture where there is a sudden rise of impedance from a 1200 ohms to more than 2500 ohms. So what we see here, now this is a bipolar impedance which has suddenly gone high, but what has actually happened is that the cathodal conductor is actually preserved. So going back to unipolar gives us a normal impedance. So we can buy some time and there is no urgency. We can program the pacemaker to the unipolar, and if the impedance and pacing is okay in the unipolar, we can keep on unipolar for some time before we have to do a pacemaker revision. When we talk about non-capture, we see ECG spikes which are not followed by QRS complexes. Failure to capture, maybe we have to investigate the pacing threshold. If the pacing threshold is normal, it may happen due to battery depletion. If the battery is near depleting, intermittent loss of adequate current may lead to a failure to capture. If the pacing threshold is high, we have to look at impedance. If it is increased, then there is a fracture or a perforation. And if it is decreased, it is like a lead insulation failure. When we talk about undersensing and oversensing, so it is very interesting. So you have to closely look at the ECG. So you may have pacing spikes at inappropriate places. So when you see pacing spike at inappropriate places, it means that the pacemaker has failed to sense the intrinsic cardiac rhythm. That's why it's pacing unnecessarily. So if the pacemaker had sensed this QRS complex, it would not have paced here. And in oversensing, what is happening is, even when the pacemaker is expected to give a current here, give a pacing spike, it is not giving. So essentially, undersensing means overpacing and oversensing means underpacing. So you need to recognize on the ECG whether the pacemaker is overpacing or underpacing, and then you can recognize sensing issues, and then you can go to the programmer and look what's happening. So this is an example of an electromagnetic interference of a pacemaker, where we see a very high frequency noise on both the channels of a dual chamber pacemaker, both the atrial and the ventricular channels, which are excessively detected, sensed, abnormally detected, and lead to a mode switch because it has been detected like an atrial arrhythmia in this pacemaker. So if it is happening on both the channels, it is most likely to be electromagnetic interference. It is very highly unlikely that both the leads have got damaged. But if it is happening at only one channel, so in this example, atrial lead is clean, ventricular lead is having such a high noise, it means that the ventricular lead is having some problem which is leading to this lead noise. So regarding pacemaker timing cycles, so I'll not go into the detail, just a small concept that after an A pacing or an A sensing, we have an AV interval which is followed by a V pacing, and after a V sensed or a V pace event, it triggers a P warp, which is a post-ventricular atrial refractory period. So importantly, once an atrial event has happened, whether it's sensed or paced, throughout the AV interval, atrioventricular delay, as well as the P warp, the atria remains refractory. So any event which is occurring in the AV interval plus P warp, it will not be tracked or sensed, which means this is called as a TARP, which is total atrial refractory period. So sometimes you may see that there is some abnormal function happening on the ECG, but it is actually a normal pacemaker function. For example, this. So this was a patient who was following up for a dual chamber pacemaker implant, and what we saw that intermittently there is an irregular rhythm, and intermittently what is happening, that P waves are not tracking intermittently and a Venki back kind of a phenomena is happening. So what is happening essentially here is actually it is called as an upper rate behavior or pseudo AV Venki back, because the atrial rate is higher than the upper tracking rate. So if for example, if the atrial rate has gone to 130 or 140 while the upper tracking is at 120, now the pacemaker cannot pace the ventricle more than 120. So the A comes, the V comes, then again A comes earlier. To keep the ventricular rate lower, the pacemaker extends the AV delay, and it keeps on doing that, and eventually what happens is a sinus beat falls into the P warp or the TARP and it doesn't track, which leads to a block. So it is a pseudo Venki back which is happening due to the pacemaker, and it is called as an upper rate behavior. Interestingly, in young children, this was an example of an 11-year-old boy with pacemaker, and he was having excessive fatigue while playing cricket, and we put him on a treadmill, and what we saw that initially he had a good rate response, but in stage 3 he suddenly had a rate drop. So why is this happening? So now from a pacemaker Venki back, from a 4:3, 5:4, it has suddenly gone into a 2:1. And this 2:1 Venki back is very troublesome because it causes a sudden drop in rate. And it is occurring just because that every other atrial event is falling into the TARP. So this is an example what happens in a 2:1 behavior, that the pacemaker tracks the atrial activity near the upper tracking rate, it flattens out, but at the 2:1 block rate, it suddenly dips, and this may lead to it may actually lead to a syncope also. To counter this, we have a dynamic AV delay. So we can actually, just a couple of minutes more, I'll not discuss many examples. So dynamic AV delay, we can actually tune down the AV delay, that as the rate increases, that the AV delay can come down, which will allow us to have a higher 2:1 block rate, or we can actually program a dynamic PVAR, which will also allow a higher 2:1 block rate. Essentially, clinically, we program both dynamic PVARs and AV delays to have a higher 2:1 block rate, so that the patient can exercise well, especially in young patients and especially in athletes who are with the pacemaker. I'll not go into details of fusion and pseudo fusion, and I'll skip this topic and I'll directly jump to what needs to be done for a surgical patient. So patient with a pacemaker going for a surgery, if the surgery is below hip and it is a bipolar pacemaker, it is very unlikely the electrocautery will interfere with the pacemaker, and you actually don't need to program the device. If the surgery is above the hip and you are putting a patch of the electrocautery above the hip, it is likely that the electrocautery may interfere with the pacemaker. Then you have to check, is the patient pacemaker dependent? Again, if the patient is not pacing dependent, intermittent CHP, 6 sinus patients, you can actually go ahead with the surgery without programming the device. And if the patient is pacemaker dependent, you have to reprogram to an asynchronous pacing mode, or you can simply place a magnet. And most of the companies will have that when you place a magnet over the pacemaker, they will become asynchronous, and as soon as you remove the magnet, they go back to the same mode. Lastly, regarding the MRI, most of the devices today in the past decade are MRI conditional, and we just need to enable the MRI mode or program them into an asynchronous mode, because MRI again will produce a lot of EMI and unnecessarily inhibit the pacemaker. For patients who have legacy devices which are not MRI conditional, we have to look for other imaging modalities, and if they are not possible, then we have to discuss and get an appropriate consent. Now we have a lot of data that even legacy devices are actually MRI safe, and we can do MRIs in those patients, but still it needs to be done with an appropriate consent in consultation with the radiologist as well as an electrophysiologist because of legal issues. So key takeaways from today, that it is important to understand basics for interpretation of device behavior. Undersensing is overpacing and oversensing is actually underpacing. Check sensing pacing threshold as well as impedance on each follow-up. Impedance is really important. And not only impedance values, also the trend, how the impedance changes is also very important. It helps to make a differential diagnosis. And it is always useful to understand how pacing timing cycles act to understand normal pacemaker behavior. And it is actually very easy to program for surgery and MRI, and you should not be afraid of sending patients to surgery and MRI with a pacemaker implant. Thank you so much. I'll be happy to have any questions if you have.
Thank you, Dr. Raghav, for an excellent talk. I wish we could give you more time, but we are running very, very late. So I don't think we'll have any questions or comments.
Yeah.
During dinner time, maybe they can ask you questions. So the next topic is myocardial infarction with non-obstructive coronary arteries, MINOCA, a very fancy diagnosis these days. And none other than Dr. S.S. Chatterjee is going to deliver this talk. This audience doesn't need to be introduced as far as Dr. Chatterjee is concerned. He's one of the the senior most cardiologist here in Patna, and we request him to deliver this talk.
Good evening, everybody, and my BJA greetings to you all, the respected chairpersons, esteemed panelists, and the audience. My dear audience. I have been asked to speak on MINOCA, myocardial infarction with non-obstructive coronary artery disease. I don't know how to do it. Next one. How to change it? Yeah. And then, this is working? और ठीक और ये यहाँ से ठीक इससे हम यहाँ से कर लेंगे. Now I'll start my deliberation with two case histories. These are my personal experiences. This was in early 1990. A 65-year-old lady, mother of a very senior police officer, was admitted at IGIC. She used to have recurrent episodes of very severe chest pain with almost 4 to 5 millimeter of ST depression, which used to revert to normal with relief of pain. Her 2D echo was normal LV function. She was given standard treatment and was advised for angiography. Cath lab facility was not available at that time at Patna, so she was referred to Delhi, and she had her angiography, but she did not return for follow-up. What we learned is that her angiography, coronary angiography, was normal, and the family probably thought कि बेकार का डरा दिया था, अब जाके मिलने का क्या काम है, कोई बीमारी तो है ही नहीं. And within a month's time, she had another episode of severe chest pain and a sudden cardiac death at home. Incidentally, troponin was not available at that time, and the first universal definition of myocardial infarction also appeared in 2000 only. And the term MINOCA was not there. The term MINOCA came sometime in 2013. This is the second case, 2005. A 35-year-old male came with classical anterior wall STEMI. All these are true cases. I am not making anything. These are my personal experiences. Given thrombolytic therapy, and subsequently he had his angiography done that revealed a 30% stenosis in proximal LAD, and his LVF was about 25%. He is on medical treatment since then for last 20 years. He is coming to me every year for follow-up, and he is in functional class 1 doing all activities on medical treatment. Of course, he had an ICD implantation, but he never received a shock. As the patient had received thrombolytic therapy before coronary angiography, probably he does not fit strictly with the definition of MINOCA. Now, these two cases very well define the limitation of our knowledge as far as the prognosis is concerned in these two type of cases, where one patient with a normal ECG, a normal coronaries, a normal ejection fraction dying with a sudden death, of course had episodes of chest pain, and another who had a 25% ejection fraction with a 30% stenosis in LAD is living for 20 years in a functional class 1. So what we know is a drop, and what we do not know is an ocean. Now coming to the criteria for diagnosis of MINOCA, features consistent with fourth universal acute MI criteria, meaning thereby the characteristic rise and fall of troponin with at least one value more than 90%, 95% of the population, the presence of non-obstructive stenosis in infarct-related artery, and absence of any other clinically overt alternative cause for acute condition like myocarditis or Takasubo cardiomyopathy, and absence of non-ischemic cause for myocardial injury as anoxia, chemical injury, and probably stress. Its prevalence is found to be around 5 to 16%. In the NCDR CAT PC registry, it is 5.9%. STEMI is 1/3 of the patients belong to the STEMI, and 2/3 belong to the non-STEMI. Susceptible population are slightly different from the usual myocardial infarction patient. They are usually perimenopausal women, younger as compared to those having obstructive MI, or those are having more of anxiety, depression, drug addiction, low level of cardiac risk factors. Dyslipidemia is not very common in this group of patients. They are more susceptible to hypercoagulability syndrome, autoimmune illness, venous thromboembolism, and malignancy, liver, renal, peripheral vascular, and cerebrovascular disease have been reported to be positive predictors. How do we approach for the diagnosis of MINOCA? Nowadays, MINOCA has been considered to be due to three basic regions. One is the disease of the coronary lumen, another is the microvascular dysfunction, and third is the either vasospasm, epicardial artery spasm, or the microvascular spasm. In the coronary artery lumen, if you do IVUS or study, then probably they can have, even if the stenosis is less than 50%, the plaque rupture, plaque erosion, or spontaneous coronary artery dissection, coronary thrombosis, or possibly coronary embolism may be found. So the IVUS can decide, or IVUS or OCT can decide this type of cause of MINOCA. The second is the microvascular dysfunction. This is itself is a big chapter which I'll discuss in a short way. And then the epicardial vasospasm or the microvascular spasm. Now, for these three, you have got different sets of investigation. For this the coronary lumen disease, you have IVUS and OCT. For microvascular dysfunction, I'll discuss in slightly detail. And for this vasospasm, we have to have intracoronary injection of acetylcholine, which we will also discuss. Coronary microvascular dysfunction not only causes ANOCA, INOCA, or MINOCA. In fact, coronary microvascular dysfunction can be present with acute obstructive coronary syndrome, meaning thereby a patient who has got ACS simultaneously may have, or due to ACS, may have a microvascular dysfunction as well, so that even if you open the artery, the patient does not return to normal and can be symptomatic even after primary PCI. It can occur due to it can occur with chronic obstructive coronary syndrome. So the patient who are having angina and a significant coronary artery stenosis, you have done the dilatation PCI, but due to microvascular dysfunction, patient can remain to have anginal symptoms even after proper PCI. It can be present if a post-revascularization or non-obstructive and others. One important factor is that heart failure with preserved ejection fraction. They are supposed to be probably due to cardiac, the coronary microvascular dysfunction. And of course, this can be present in hypertrophic cardiomyopathy and infiltrative cardiomyopathy. Now, what is microvascular part of the coronary vasculature? Coronary vasculature starts with the coronary arteries, the epicardial coronary arteries, then the epicardial arterioles, then the prearterioles, and then of course the intramyocardial arterioles and the capillary system. So from the origin of the epicardial up to 200 microns of the epicardial arterioles are the proper coronary artery system, which can be seen on angiography, but beyond 200, less than 200, and the capillary part and the intramyocardial arterioles are not visible on angiography, and they belong to the coronary microvascular system. And this system can be deranged because of the myocardial abnormalities, diastolic dysfunction, LVH, infiltrative cardiomyopathy, increased intracavitary pressure like due to severe hypertension or aortic stenosis or dilated cardiomyopathy, or there could be either structural abnormalities in the microvascular vasculature, or there can be functional abnormalities. The different non-invasive diagnostic modalities, there are multiple, but in present time, PET and CMR, the resting and stress perfusion imaging by PET or CMR are the modalities by which one can make a diagnosis of coronary microvascular dysfunction. I will not go into the details of that. And for vasospasm, we have to have acetylcholine provocation testing, administration of intracoronary infusion of acetylcholine. And if you get chest pain, ischemic ECG changes, and lumen reduction of more than 90%, this is epicardial vasospasm. And if you get chest pain, ECG changes, but less than 90% of coronary vasospasm, this is coronary microvascular spasm. Other than that, we have to know about coronary flow reserve, the intramyocardial resistance, hyperemic medical resistance, which I will not going to discuss, but these are all invasive procedures by which one can calculate these things. And if the coronary flow reserve is less than 2.5 and the intramyocardial index of myocardial resistance is more than 25, this is structural deformity, meaning there is some problem in the microvascular structure. And if the coronary flow reserve is less than 2.5, and the index of microvascular resistance is also less, meaning thereby the CFR is decreased, but myocardial resistance is not decreased. This is functional element of the coronary microvascular dysfunction. And if the index of myocardial resistance is increased, this is the structural element. So if we see the traffic light algorithm for MINOCA, the red light is the MINOCA, non-obstructive CAD. You have to rule out the myocarditis and Takotsubo cardiomyopathy by CMR, and then the intravascular imaging or intracoronary functional testing to decide what type of MINOCA the patient is having. Coming to therapy, there is not much of treatment, different treatment for MINOCA. If you have a plaque rupture or erosion, by intravascular imaging, of course, you need antiplatelet treatment, high intensity statins, ACE, ARBs, beta blockers, and PCI if evidence of unstable plaque. For epicardial coronary artery spasm, you need CCBs or nitrates or nicorandil, cilostazol. And for intravascular, for spontaneous coronary artery dissection, of course, single or dual antiplatelet therapy and beta blockers, and sometimes PCI for recurrent ischemia. For microvascular causes of MINOCA, we don't have, anything extra. The same, the statins, ACE inhibitors, CCB, beta blockers, nicorandil, trimetazidine, L-arginine, and for coronary embolism, of course, antiplatelets. But newer drugs are coming. As I just want to emphasize few drugs. Newer beta like nebivolol and carvedilol are supposed to be better as compared to other beta blockers in these conditions, because nebivolol gives rise to nitric oxide, which causes vasodilation, and carvedilol is a non-selective beta blocker as well as an alpha-1 blocker, and therefore it causes vasodilatation. That's an additional point for carvedilol. SGLT2 inhibitors are now coming up for the treatment of microvascular dysfunction, and this concept has come from the fact that SGLT2 inhibitor has been found to be effective in treatment of heart failure with preserved ejection fraction, and this heart failure with preserved ejection fraction, one of the most important cause is microvascular dysfunction. Similar way, GLP agonists are also being tried, eplerenone, L-arginine, and another one, the PDE5 inhibitors, the sildenafil and related drugs, they are also being tried and found to be useful. This is the study of dapagliflozin on coronary flow reserve and epicardial adipose tissue, DAPA-HEART 4-year follow-up study, which shows that in 4-year time, the coronary flow reserve increased by 34.4% and reduces the epicardial adipose tissue by 29%, and this epicardial adipose tissue is supposed to be an important cause for inflammatory condition inside the myocardium. And then, of course, now we can consider for refractory angina the sinus reducer, coronary sinus reducer implantation, which can improve the class of angina by class 1 or class 1 or 2 classes. So if now the patient comes of this type of patient of coming either typical or atypical angina, having a recurrent chest pain of different severity, and we have done all the investigations, and then give her the treatment. Some of them they do improve, some of them have got partial improvement, and some of the patients do not improve at all. And when they complain again that आपने जितना इन्वेस्टिगेशन कहा हमने सब करा लिया, जितना दवाई आपने कहा हमने सब खा लिया और हमारा इम्प्रूवमेंट तो हुआ नहीं, what can we do? So my answer will be, इससे ज़्यादा हम लोग नहीं जानते. We must realize and show our humility to the patient that this is all we know at the moment. We do not know beyond this. The more I learn, the more I realize how much I do not know. Thank you.
Very important topic, conduction system pacing tips and tricks. most of the pacing all over the country is still done by non-EP cardiologists. In Bihar, it is 100%. And to speak on this very important topic, none other than Dr. Ulhas has come here. He is one of the stalwarts in the field of electrophysiology in this country and a master teacher. It is always a pleasure to hear and learn from him. Dr. Ulhas.
Sir, thank you very, very much. Very kind of you. Thank you very much, sir, and very kind of you for those words. And it's my privilege and an honor indeed. I'm coming for the first time for the cardiology conference in Patna, so it will have a special place in my heart. In the coming 10-12 minutes, I don't know how much I would cover the conduction system pacing, which now has become actually the trend. It has almost replaced in many of the high volume centers as the mode of pacing. Right ventricular pacing, endocardial, right ventricular endocardial pacing is not good, whether it is at the conventional apical position or septum, high septum, outflow tract. It's not nice because the spread of the electrical activation is from myocyte to myocyte. RV gets activated much earlier than the left ventricle, and it ends up in having both electrical and mechanical dysynchrony. And approximately 20-25% patients who have high RV pacing burden will end up in having something known as pacing-induced cardiomyopathy. His bundle pacing at the right position and at the right output can give rise to almost normal electrical activation even in the presence of bundle branch blocks. You pace at his bundle and the left bundle branch block is corrected if you are at the right position, is because the left bundle fiber is already born in the his bundle. So you pace there, and most often the blocks are proximal, not necessarily distal. So his bundle pacing can produce almost normal QRS, and that is why we call it as a physiological pacing. It has its disadvantages, which we'll discuss soon. Left bundle area pacing is essentially pacing within the interventricular septum, going into the septum through the right ventricular endocardium. So you get into the interventricular septum. The target area is quite large. It is not like left bundle is insulated and remains as 2 or 3 fascicles distinct from right bundle in the interventricular septum. No. There is extensive arborization of the Purkinje system in the interventricular septum. So you touch anywhere inside the interventricular septum, you need not capture the fascicle. You capture the Purkinje, and then there is a retrograde activation of the conduction system. This is little less physiological than the his bundle pacing. Why? Because this is a left-sided conduction system is activated first, and then the right bundle is recruited. So there is a little delay in the activation of the right ventricle, and hence you tend to have incomplete right bundle branch block in left bundle branch area pacing. So that is truly not very physiological, but it is near normal. When his bundle pacing is almost can give rise to almost normal QRS, and it is physiological pacing, why it is losing its favor these days? It's because it's difficult. High thresholds, lead revisions, poor sensing, etc. And why left bundle area pacing is becoming like standard of conduction system pacing? As I said, the target area is quite large. His bundle pacing, it is very small, and usually it is non-selective. Left bundle area pacing, the target is so large, the entire interventricular septum from the right-sided endocardium, just enter in there. That's it. You got to enter in. You will capture something of the left bundle branch, either the trunk or the fascicle. So, because it is not that you capture the left bundle trunk or one of the three fascicles of the left bundle. It could be even a Purkinje system. So all that definitions of selective, non-selective, left bundle branch area pace, left bundle trunk pacing, anterior fascicle pacing, the criteria, they're all actually arbitrary. So advantages, as I said, large target and the durability and etc. is okay. But you know what? There are challenges with the left bundle branch area pacing, because you need to penetrate into the septum. When you are penetrating, well, there are good chances that you perforate as well. So it's very common. It's very common and goes undetected. And fortunately, in the literature, there are not many reports of thromboembolism. Undetected septal perforation is very common. And well, compared to the his bundle, this is a recent concept, learning curve is there. And it poses also sometimes difficulty in fibrotic interventricular septum, infarction, anterior wall infarction involving the septum, even some cardiomyopathies. See, left bundle area pacing, the criteria, one should be broad-minded. They're all empirical. But there are certain things on the basis of the paced morphology. You may say that you have done a conduction system pacing, and that is left bundle branch area pacing. That depends on how is the V1. I told you, it causes a little delay in the right ventricular activation, and hence is incomplete RBBB. And the left ventricular activation time is going to be quite short because you are pacing the left bundle system. And because V1 represents the right ventricular activity, V6 represents the left ventricular activity. So more the time interval, more certain that you are capturing some of the conduction elements. And then the principle of conduction system pacing proof is at the same site, if you produce more than one morphology at a different output, that means you are capturing the tissue, myocardial tissue, as well as another component. Another component is the conduction system. So let's quickly go through 3 minutes. Let's quickly go through the conduction system hardware. Oh. See, the commonest one is the so-called Medtronic hardware, because they came into this conduction system pacing much before the other 3 companies. It is a special lead. It is very thin. It is just about 4 French lead, which has pre-extended helix, and then there is no lumen. So this is known as a lumenless lead. The helix is extended permanently. Unlike the other companies, the Medtronic has only 1 curve. So it is a very low profile indeed. The other companies, the leads for the conduction system pacing is no special things about it. They are all the conventional leads. The same leads are used for the conduction system pacing using different sheets. And unlike Medtronic, all the other 3 companies have 3 or more designs of their sheets. Stellate-driven leads compared to the lumenless lead has several advantages, but then it is not isodiametrical like lumenless. The body and the helix, the diameter is the same, so there is no bump there. In the stellate-driven, here the helix profile and the body profile is different. So it really gives a challenge in penetration. I wanted to go. I wanted to go behind. How do I go backwards? I don't know how to go back. Go some 3-4 slides. Go just one. Wait. Yeah. You see, conduction system pacing requires little more attention and care and really looking at what you are doing. The conventional right ventricular pacing, sometimes you are sleeping and you are doing. Conduction system pacing, you need to be little awake for one particular reason, and that is not only that you are capturing you are looking at capturing or not capturing the conduction system pacing. Most important thing is whether you are perforating and getting into the LV. So for that, you require the analysis of the electrograms obtained from the tip cathode as well as the ring, which is the anode. So those electrograms could be very well deciphered if you have a EP system. And in the EP system, with the jumper cables, you can connect that to the programmer. But it is not necessary. Nobody should be discouraged if you don't have a EP system, because the regular hemodynamic monitors can provide you V1, 2 or 3 limb leads, good enough. V1 is that is more important. Very quickly, I think it is very wise and safe to define the venous axis before you make the pocket. It takes 3 ml to 5 ml of a dye. Even in a chronic renal failure patient, you can use it. So define the venous axis. Be sure that you are not getting into the outer border of the first rib for the safety purpose. Yeah. You take the delivery sheath over a thermowire into the RA, and then remove the dilator, advance the wire. It usually goes into the RVOT or maybe in the apex. And once it is there in the RVOT or in the apex, you push the sheath, push the lead into the sheath, and then in the RAO, it is, my technique is going into the RVOT and bringing it down. While you are bringing it down, you are continuously pacing. The lead is at the tip of the sheath. You are continuously pacing and then looking at the morphology. At which point you start penetrating to the septum. You are dragging it down, and at one particular point you start screwing, right? So which is that point? It is that point when you pace. There comes the notch in V1, and with the notch in the V1, prove that you are not into the RVOT by showing AVR AVL discordance, AVR negative, AVL positive, and wish that most of the inferior leads are positive, and the precordial transition is at V3. If you have obtained these necessities, I think you are there at the septum, and make sure that you are, a little bit of a dye you can use to be sure that you are abutting perpendicularly to the septum, and then from here onwards, it's usually easy to proceed further. Yeah, what is important is you got to monitor what is the tip doing. When you are penetrating, you got to know what the tip is doing, what is the morphology it is producing, and what is the impedance, and what is the current of injury. And if you have the EP system, left ventricular activation time, continuously you should be monitoring. The stellate-driven ones will give you, continuous monitoring of what the tip is doing, unipolar tip electrogram. It's because the stellate, which is within the lumen of the lead, connected. Whereas in Medtronic, it is not possible. There, intermittently you'll have to find out what is the morphology. Sometimes, persistent left SVC, you have to go from the right side. There are many ways of making a shape so that it can take a turn. These sheets are made from the left side, made for the left-sided implants. So the right-sided, in the many techniques, you can expose it to the steam, or put it into hot water and cold water. If you allow me, I would talk 2-3 more minutes, or sure. Yeah, okay. See, what is important in the left bundle area pacing is when to stop. All right. See, that is why you got to be very careful, looking at several of the characteristics: morphology, impedance, current of injury. Current of injury with respect to both the tip and the ring. So, if the notch in the V1 climbs up, and then there becomes a pseudo R, that means you have achieved. Stop there. And when you are penetrating, there are some PVCs start coming. which have got a right bundle branch block, that means what? You are already irritated in the left ventricle. And if there is a pacing impedance drop because myocardial tissue pacing results in a higher impedance into the cavity, lower impedance, and if there's a loss of catheter, etc. Slitting the sheath also requires a little bit of a technique. You need to be careful enough. The lead, when you're slitting, lead is not pushed further perforation, and enough slack so that lead remains there, and then you take the sheath out. And what is also important is you got to document what actually at the end of the day you achieved, because there can occur change in the morphology at a given output day to day. It could be because of micro lead dislodgement or the conduction system behavior itself. So you need to distinguish what caused the change in the morphology at a given output, both voltage and the pulse width. So you please document this. Septal perforation is very common, very, very common. Many and most often not recognized. Clues to identify the septal perforation, these are the ones. Why EP system helps? For example, here you see it is saying ring to tip injury. The unipolar in the ring, look at this injury, and the unipolar tip, look at this injury. The tip injury is much, much lower than the ring injury, certain that you are in the LV cavity. Similarly here, this is the tip and this is the ring. Such a significant difference. Sometimes, this I leave it. Septal vein perforations, well, you know, they look so ghastly, but don't worry, nature takes care. It never led to any tamponade, etc. You know, they really look. I mean, many a times, some of my colleagues have run away from the lab, looking at this, what he is doing. There are certain issues, you know, lead repositioning cause helix damage. So make sure that the stellate-driven leads, if you are using, there are multiple leads. There can occur crimping of insulation. So I wanted to go back here. It's okay. You see, sometimes this is our technique. This is our original technique. What is it showing here is that you can take a stillet which could be introduced into the lumen of the lead. That stillet can be passed into the sheath. And this stillet can penetrate easily into the septum. And then you would know, are you at the right spot? And then it actually helps in further advancing the lead. So imagine this is your lead, and this is your stillet. That's how it guides. And then you can prove that. So this is the stillet, buddy. It's a buddy for this, helps, guides, and makes it easy. And then, and we made a publication on this original technique of ours. We call this as salvaged by the stillet. Very quickly, now that we know conduction system pacing, including the left bundle area pacing, narrows the wide QRS, LBBB. So in a person with cardiomyopathy, LBBB, this is a choice. So I will end here. CSP does not always result in acute QRS. All right? You know why? It's because conduction system pacing means you are pacing the conduction system. If the conduction system is diseased, if you pace, well, it gives you a good result. But intact his Purkinje system, if there's an intact his Purkinje system, and the wideness of the QRS is because of the myocardial disease, conduction system pacing does not help. So, you know, there are many combinations you can club the CSP with the CRT and all that. The last one thing I could, we published recently an article in the Journal of Cardiovascular Electrophysiology, and that is single lead acting like a CRT-D. How is that? Imagine a defibrillator lead gets into the septum, left bundle area pacing. A defibrillator lead, the helix is into it, not the body. Body is too big for the septum. Imagine you have put into the septum. Now it is resulting in left bundle area pacing. It can defibrillate. Imagine this lead has a so-called floating dipole which can sense the atrial activity. One lead which acts like a CRT-D. So that's, I think, is going to be the future. So I think it represents a true paradigm shift. The criteria, you know, whatever they are, we should remember they are all arbitrary. Maybe refinement is required. Of course, each technology requires some time for test. So nothing like randomized controlled trials to find out whether conduction system pacing is actually better or superior or in certain cases inferior. So we currently, for the economic reasons, are falling upon the conduction system pacing. But it has not been shown that it is superior to CRT, it is superior to CRT-D, or it is not yet proven. In all cases of pacing-induced cardiomyopathy, CSP reverses, and it is also not clear whether CSP, conduction system pacing, should be the way of pacing. These are unanswered. Only time will tell, and nothing to beat the randomized trials, which are going to be published in the coming few years. Thank you very much. I don't know how much I exceeded.
Doesn't matter. As I told everyone, it's always a pleasure to listen to you, and a lot of learning. I'm sure a lot of questions are there, but because of paucity of time, we'll request them to personally contact you for their queries. And thank you once again for coming all the way from Chennai. So can we move to the next speaker? Yeah, okay. Thank you, Dr. Ulas. The last talk in this session is Management of Acute Decompensated Heart Failure by Dr. Prakash Kumar from Ranchi. Another very, very important talk for all of us.
Thank you, sir. evening, sir. Good evening, everyone.
Acha.
It is always a pleasure for me to be part of any function of cardiology at Patna. My teachers are there, my colleagues are there. So, without taking any extra time, I would like to discuss the topic allotted. It is about management of acute decompensated heart failure. It is a common topic, and there are different nomenclature. Sometimes we use acute heart failure syndrome, sometimes acute decompensated heart failure, acute decompensation of chronic heart failure, or hospitalization for heart failure. There is very fine line difference between all these. I will discuss later on if I get time. But these are common problems. We see this type of patient in our day-to-day practice. It is one of the most common cause of hospitalization for more than 65 years of age. And prevalence is likely to continue because of aging of our population, reduction in hypertension-related mortality, greater survival after acute myocardial infarction, and greater chances of survival from sudden cardiac death after AICD implantation. Why this topic is still relevant? Because it is increasingly recognized as a distinct disorder with unique epidemiology, pathophysiology, treatment, and outcome. So how to define this condition? Acute decompensated heart failure is the new onset or recurrence of symptoms or signs of heart failure requiring urgent or immediate therapy, resulting in unscheduled care or hospitalization. This prognosis is very poor. As we know, whether it is heart failure with reduced ejection fraction or with preserved ejection fraction, all of them contribute equally. In case of decompensation, the prognosis is equal. It is mortality is almost 50%, with much more chances of recurrent hospitalization, and even 1 year mortality is poor. Coming to the pathophysiology, because this will help us to understand the reason for our lack of what we are lacking. There is a substrate, trigger, and amplifying factor, and congestion is the final common pathway leading to all these situations. Substrate may be a normal heart, or it may be a chronic compensated heart. And the trigger may be massive myocardial infarction, which can lead to acute decompensation in a normal heart, or even a minor hemodynamic change like severe anemia in case of compensated heart failure. So amplifying mechanism are either myocardial, renal, vascular, or neurohormonal. All these pathway leads to final pathway of congestion and in-organ dysfunction. I would like to take 1 minute to discuss two things. One is fluid retention versus fluid redistribution. Fluid retention is the common pathway which leads to increase in LV-EDP and PCWP. But that's why we sometimes, many a times, we suggest our patients to measure weight. But it is not always that gain in weight is preceded, occurs before raise in PCWP. So many a times what happens that there is fluid redistribution between splanch leak and other circulation, and without any extra fluid retention, patient is having the same weight, patient goes to heart failure. So we should understand that it is not always the fluid retention which leads to decompensation, but many a times it is fluid redistribution, sorry for the spelling mistake. And there is one other term, clinical congestion versus hemodynamic congestion. We all see in our day-to-day practice about the clinical congestion, but before clinical congestion, there is a stage of hemodynamic congestion which can be easily detected by looking at echo IVC dilatation and compressibility, or by getting echo E by E prime and getting an idea about PCWP. So hemodynamic congestion precedes clinical congestion, and after treatment, hemodynamic congestion will occur later than clinical congestion. This is a very classical teaching. Our teachers have taught it many a times. So clinically, or we can say hemodynamically, we classify acute heart failure patient based on congestion and perfusion. If congestion and according to congestion, we classify them as wet or dry, and according to the perfusion is warm and cold. So based on this classification, we have 3 or 4 type of presentation of acute heart failure. One is acute decompensation of heart failure. Here the main mechanism is LV dysfunction and sodium and water retention. Main cause of symptom is fluid accumulation and increased intraventricular pressure. Onset is gradual. Main hemodynamic abnormality is raised LV, EDP and PCWP. There will be definitely low or normal cardiac output, and systolic BP will be normal or low. We can classify these patients as either wet or warm or dry and cold. Mainstay of treatment is diuretic, inotropic agent, and in some cases circulatory support or renal replacement therapy if needed. So another clinical presentation is of acute pulmonary edema. Here afterload plays more role, and these are the common mechanisms in valvular heart disease. Here fluid redistribution to the lung and acute respiratory failure is the main cause. Onset is more rapid. Hemodynamic changes is more or less same, and main clinical presentation is wet and warm. Here diuretics and vasodilators are the treatment of choice. I will discuss 2 others in upcoming slides. We have discussed a lot since our MBBS days about the precipitants for heart failure decompensation: infection, arrhythmia, ischemia, drug withdrawal, or stopping of medications, hypertension, or myocarditis are the classical features. One point I would like to emphasize, that despite our best effort and even at best centers, in only 50% of the patient we get precipitating cause. And out of these 50%, about 20% are due to infection, most commonly secondary to lung infection. 20% are because of arrhythmias, 20% are because of ischemia, and 10 to 20% are rest of the cause. 5 to 10% because of withdrawal of regular medication or addition of new drug. So the point is, why does decompensation occur, and why once the patient decompensate, it's become more and more likely to get another episode more frequently. So it is the myocardial damage that occur each time when a patient decompensate. That's why whenever we see a patient of acute decompensated heart failure and we get TROP-T done, it will be more than the upper limit of normal. However, it will not be marginally raised, means 10 times, 20 times, but it will be more than upper reference limit. Another mechanism is hormonal mechanism, like B cell activation or something. We all are aware of symptoms and signs of heart failure. Basically, these are because of congestion, systemic or decongestion, and because of poor perfusion. Knowing these signs and symptoms are important because sometimes we get confused with similar conditions. Like sometimes even a pneumonia can be diagnosed as a acute decompensated heart failure. So knowing these symptoms and signs are important, and these are classical. These are the routine investigations. Each and everything carries major weightage, and we do it in day-to-day our practice. Echocardiography is generally the single most useful test. It can assess systolic and diastolic function, regional wall motion abnormalities, valvular function, hemodynamics including estimates of filling pressure and pericardial disease. We get a hemodynamic idea about PCPW by getting E by E dash. If it is greater than 15, it predicts PCWP more than 15. So coming to the treatment part, because the topic given was the management of. So other than correcting the possible precipitating factor, diuretics remains the mainstay of the treatment. Vasodilators are the second most useful drugs. Inotropes use should be limited to patient with organ hypoperfusion. Coming to the dose of diuretics and choice of diuretics is always an area of interest. Dose trial tried to solve this issue by taking 308 patients with acute decompensated heart failure, randomized to continuous, that is either bolus and low dose versus high dose. There was no major difference. Other than that, high dose bolus was associated with greater decongestion, but it was also associated with a bit more of renal dysfunction. Whether furosemide or torsemide should be a drug of choice. So there was transform heart failure study published in JAMA in 2023. We tried to, I will take 2 minutes stop. So try to resolve this issue, but this trial was also negative, and there was no difference between either it is furosemide or torsemide. So there is a lot of negative trials. We discuss always in acute heart failure. So these all are negative trials, not able to show benefit on long-term randomized controlled trials. So how to manage the acute heart failure patient? So first is the suspicion, we should suspect, and then we should rule out whether the patient is in cardiogenic shock or respiratory failure. Like if the patient is in cardiogenic shock or respiratory failure, we should act accordingly. Then once the diagnosis is established and patient is hemodynamically comparatively stable, then we should try to find out the etiology, precipitating cause, either it is acute coronary syndrome or hypertensive arrhythmia, and then we should go to the original classification according to the presence or absence of congestion and absence of perfusion. So congestion is the most important part. This is the final common pathway. It is present in 95% of the patients. These are wet patients. And then we look for the perfusion. If the perfusion is adequate, then we classify this patient as wet and warm. There are two types of this type of patient. If there is vascular type of fluid redistribution and hypertension predominates, then vasodilator is the first drug followed by diuretic. And if cardiac type of fluid accumulation is there and congestion predominates, then diuretic is the first choice followed by vasodilators. Ultrafiltration has some role. In wet patient, and they are not adequately perfused, that is wet and cold, then we should consider inotropic agents, vasopressors, and in some cases even mechanical supports. Dry patient constitutes only 5% of acute heart failure patients, and we classify them as dry and warm. Means adequate perfusion, adequate congestion, but still there is heart failure. We need just to adjust the oral therapy. And in dry patient, if perfusion is not adequate, means dry and cold patient, we should try first fluids, and then if not responding well to them, then inotropic agents. It is about management, it was about management in emergency. Then how to follow it? The 4 pillars of heart failure has well established role in chronic heart failure patient. But acute heart failure, the data are not so robust and still evolving. So strong heart failure tried to resolve this issue. So all the 4 pillars of drug was given, and in this multinational open label trial, patient discharged following acute heart failure admission, rapid uptitration of DDMT with scheduled follow-up to achieve specific target doses in the first 90 days was associated with a reduction in 100 days all-cause death or heart failure readmission, improved quality of life, and reduced symptom burden. Because medical therapies have failed multiple times, so device-based therapy for acute decompensated heart failure are coming up and getting more popular. So the take-home message is Acute decompensated heart failure is characterized by multi-faceted pathophysiology with involvement of numerous pathways that contribute to its complexity. The management of ADHF heavily relies on reducing preload, emphasizing its critical role in alleviating heart failure symptoms. Treatment with pharmacotherapy shown variable effectiveness, reflecting the need for individualized treatment approach. New devices are being evaluated to enhance decongestion and improve perfusion and overall treatment of ADHF. Thank you.
So that concludes this session, and as per the instruction by the organizers, the last session will be conducted after the inauguration ceremony is held. Thank you very much, Dr. Prakash.
This is a rapid fire round, so we'll just continue with this session so that a few talks can be done. So I'd like to invite the chairpersons, and please don't take much time for this. Arvind Kumar sir, Bibi Bharti sir, I'm here. Dr. Ghanshyam Jha, Anup Singh, Shamshad, Dr. Abhishek, and Dr. Deepa Shri. And I'll request the speakers to be on time.
Chairpersons are requested, please join us. This is the last session. May I, without wasting much time, may I invite the first speaker, Prashant Kashyap, from Begusharai, to speak on the inclisiran. This is a rapid fire round. Try to be very brief, yes, so that we can. This is not 15 minutes. Actual yes, time allotted was just 8 minutes. Okay. By mistake, 5 minutes. So, okay, now the time is revised, 5 minutes. So this is a rapid fire round. Okay. Let us see the conclusion.
HDMI connect.
So, good evening, everyone. I'll just go quick through my topic in inclisiran. It's a novel PCSK9 inhibitor for hypercholesterolemia. Basically, why do we keep on increasing the more and more drugs even after having statins, ezetimibe, bempedoic acid, fenofibrates, and PCSK9 inhibitors? Again, we have more drugs coming day by day. Because despite of these drugs and PCI, cardiovascular disease tends to be the leading cause of death worldwide. And how much actually does cholesterol, LDL cholesterol reduction reduces the cardiovascular death? So every millimole of reduction in LDL cholesterol, there is 20% reduction in CV death. So current therapies which are available are statins, ezetimibe, fenofibrates, bempedoic acid, PCSK9 monoclonal antibodies including evolocumab and alirocumab. The challenges faced are adherence and treatment persistence remains the problematic issue with these drugs, and the long-term therapy and the daily dosing or maybe monthly dosing. So what is inclisiran? So the key features it is first in class the siRNA targeting the PCSK9. It lowers LDL cholesterol via RNA interference mechanism. It is available as a subcutaneous injection, and it has been approved in Europe in 2020 and USA in 2021. The indication being ASCVD, familial hypercholesterolemia, or uncontrolled LDL cholesterol despite being on standard therapies. So what is the mechanism of action? So as we all know, LDL cholesterol, the plasma cholesterol gets attached to the LDL cholesterol receptors which are present on hepatocytes, and then from there it is internalized into the hepatocytes. So this, but PCSK9, it is a serine protease which inhibits this LDL cholesterol receptor present on hepatocytes. So thereby it inhibits the uptake of LDL cholesterol from blood. So thereby it increases the plasma regulated LDL cholesterol. But this drug, the PCSK9 inhibitor, it inhibits the PCSK9 serine protease, thereby increasing the availability of LDL cholesterol receptor on hepatocytes. More of the cholesterol is uptaken from plasma, and so the overall regulated plasma cholesterol reduces. So this drug, it directly acts, it is a small interfering RNA delivery mechanism. It enters into the hepatocytes and interferes with the mRNA of PCSK9 and directly inhibits PCSK9 production. The protein production is directly being inhibited. So receptor recycling is more, as I told, and LDL clearance is also increased through the LDL receptors. The dosing being the baseline dose, the first dose at day 0 is first subcutaneous injection, 284 mg. Then the second dose is given after 3 months, and then after every 6 months. So during this therapy, the effect of 0 dose or the baseline dose can be checked at 30 or 40 days. These are few trials. I not go into details. Orion 9, 10 and 11, it was done on inclisiran, and all of these trials demonstrated significant LDL cholesterol reduction in patients with uncontrolled LDL cholesterol despite statin and ezetimibe therapy. So the studies showed that there is 50% sustained LDL cholesterol reduction, and the target of less than 50 in post-PCI patients or less than 70 in diabetic patients was achieved in more than 50% cases, and the effect was durable, maintained for more than 18 months in follow-up studies, and it worked across all patient population tested. And additive benefit, it was effective as an add-on therapy on statins and ezetimibe therapy. Coming to safety and tolerability, it is very well tolerated across all patient groups, and there is no direct organ toxicity has been documented. The guidelines recommendations are atherosclerotic cardiovascular disease, familial hypercholesterolemia, statin intolerance, and the patient in which we do not achieve target LDL level despite being on standard therapy. The patient selection already I have discussed in previous slide. Trials I'll skip. So the advantages and limitations are advantages. There is 50% LDL cholesterol reduction has been demonstrated. There is 6 monthly dosing is there, so better adherence is there, good safety profile. The limitations are its high cost, clinical administration is required, it is a subcutaneous injection, and the outcome overall CV death long-term outcome data is still pending. Coming to conclusion, it is has a novel mechanism of action, represents innovative small interfering RNA technology, so it directly reduces PCSK9 serine protease production, and durability efficacy is it's excellent. There is 50% LDL cholesterol reduction has been seen. Safety profile is also excellent. So this is just in short about the topic. So thank you.
Thank you. Well done, Dr. Prashant. As it's a rapid fire, I can, if you have any queries, he is here to answer it during the dinner. Move on to the next speaker, Dr. Manas Thakur from Sitamarhi, who will be speaking on Mevacamten. It's also a new drug, and I request Dr. Thakur to be on time.
Good evening all. I'll be speaking few words about the Mevacamten. Coming to the mechanism of action for this drug is these are the myosin inhibitors. These act by inhibiting the cardiac myosin ATPase enzyme, which limits the formation of myosin actin cross bridges and decreases the myocardial contractility. So it's beneficial in obstructive hypertrophic cardiomyopathy. It lowers the contractility and mitigates early systolic ejection velocity, which decreases or eliminates the contact between the mitral valve and ventricular septum. So coming to this image shows the cardiac sarcomere. As we all know, that is a normal sarcomere that repeating units of contraction within the cardiomyocytes. The second image shows that this HCM causing variants leads to gain of function effects, which increases the proportion of cross bridges in the active state and leads to adverse structural, energetic and clinical consequences. So cardiac myosin inhibitors binds to myosin molecules and reduces their likelihood or being in active states, thus attenuating the hypercontractility. That third image shows that on left it shows the normal myosin actin cross bridges, and on the right it increased cross bridges are seen, and the effect of cardiac myosin inhibition in the presence of HCM. So what are the improvements induced by the cardiac myosin inhibitors therapy? That these decrease the left LV-OT gradient, LV wall thickness, LV mass, hypercontractility, cardiac energy requirements, left atrial volume, ventricular filling pressures, ratio of early mitral inflow velocity to mitral annular diastolic velocities. So just a place to, what are the place of cardiac myosin inhibitor in the management of obstructive cardiomyopathy? That it comes after whenever we are giving the patient with oral beta blocker. If symptoms persist, we switch to non-dihydropyridine calcicivs. If symptoms persist, either to add disopyramide or cardiac myosin inhibitor. If symptoms again persist, evaluate for the patient for septal reduction therapy, either surgical myectomy or alcoholic septal ablation. So dosing, coming to the dosing indicated in symptomatic NYHA class 1 to 2 to 3 to improve exercise capacity and symptoms. Starting dose is 5 milligram orally once a day, and allowable subsequent dosing with titration to 2.5, 5, 10 or 15 mg per day. Initiation on up titration patient with LVF less than 55 is not recommended. These drugs may develop heart failure while taking mavacamten, so regular LVF and valvular LVOT assessment is required. Daily dosing takes weeks to reach steady state drug levels, and therapeutic effects as well as genetic variation in metabolism drug interaction can cause large difference in exposure. Coming to the renal impairment, mild to moderate, no dosing adjustment required. Severe impairment and kidney failure, including patients on dialysis, it is unknown. Hepatic impairment, mild to moderate, no dosing, and severe, it's unknown. Caution, first, what are the cautions in myosin inhibitors? Effect on EF, it reduces the LVF by approximately 4% on average, but in some patients, systolic dysfunction may decrease significantly. Reduction in systolic function is reversible after discontinuation of drug. In pregnancy and lactation, it is teratogenic and it can't be used, and mavacamten should not be taken with by patient who take certain drugs that induce CYP 450 systems. AF, it is used with caution. AF is often not well tolerated in patient with HCM, so mavacamten may potentiate heart failure symptoms. Pre-treatment management, screen for contraindication, like we have to take medical history, ECG, echo, assess the barriers to monitoring, and discontinue disopyramide in patients who take mavacamten and are taking disopyramide. Disopyramide is discontinued 10 days before initiating the drug, and initiation and maintenance, mavacamten is also diuretic and it decreases the myocardial contractility, so therefore regular monitoring of ECGs, CVIT and echo should be done. Just few trials. This is a trial Pioneer, Explorer, Valor. And another slide is showing the other few trials. Just I will explain that conclusion in Explorer. It was that Explorer had HCM trial. The mavacamten improved exercise capacity, alveolar obstruction, NYHA function class, and health status of the patient in the obstructive hypertrophic cardiomyopathy patient. And in Valor, it also showed the positive results, but in Odyssey hypertrophic cardiomyopathy trial, it was did not result in a significantly greater improvement in peak oxygen uptake. Thank you.
Anup Singh, sir, from Patna. He'll be discussing about BHARAT.
Good evening, and thank you, CARDICON, for giving me opportunity to present this seminar. I will discuss about the role of BHARAT in heart failure. First, we have to know the natural history of heart failure. After the diagnosis of heart failure, if we not intervene either by medical therapy or by any device therapy, it gradually deteriorates and leads to worsening heart failure. What is worsening heart failure? It is characterized by escalating sign and symptom of heart failure, which require IV diuretic therapy at the hospitalization or in emergency. Then with each hospitalization, the condition gradually deteriorates and there is more chance of worsening heart failure. one of the US registries shows that after 18 months of diagnosis of heart failure, approx 17% of patients developed worsening heart failure. And among the heart failure hospitalization, 80% of the population constitute the worsening heart failure. And this is the European Society of Cardiology Guideline 2021, which shows that after the diagnosis of heart failure, all these 4 pillars of heart failure should be started: ACE inhibitor, ARB, beta blocker, MRA, SGLT2 inhibitor, and plus minus loop diuretics according to the symptoms. Then the patient profile divided into 3 parts. First of all, if ejection fraction is less than 35% with QRS duration less than 130, if patient is ischemic, then ICD is the class 1 indication, but it is non-ischemic, then ICD is the class 2A indication. Second scenario, if LV ejection fraction is less than 35% and QRS duration more than 130 but less than 150, then it is class 2A indication for CRT therapy. And if QRS duration is more than 150, then it is class 1 indication for CRT therapy. The third scenario is if LV ejection fraction is more than 35% as not candidate for any device therapy, and still patient is symptomatic, then we can add other therapy like versigouat, which I will discuss, and digoxin, but it is class 2B indication. Other drugs we should consider ivabradine and combination of hydralazine and isosorbide dinitrate, it is class 2A indication. What is nitric oxide? Actually, it is released from the endothelium, which acts on the soluble guanylate cyclase, and that activates the pathway and finally generates cyclic GMP, which has favorable effect on the heart, blood vessels, and kidney. On the heart, it decreases the inflammation, fibrosis, decreases the hypertrophy, and finally decreases the ventricular remodeling. On the blood vessel, it causes vasodilatation, decreases the inflammation, and decreases the vascular stiffness. On the kidney, it decreases the fibrosis, increases renal blood flow, hence increase the diuresis. Then versigouat is a mainly soluble guanylate cyclase stimulator. It stimulates this molecule and propagate this pathway, and finally this cyclic GMP acts on the different organs of the heart, like heart, blood vessels, and kidney, leads to favorable outcome. The versigouat restore this nitric oxide, SGC, and cyclic GMP pathway. That is a novel option for improved heart failure outcome. Low nitric oxide viability leads to reduced activity. This pathway lead to heart failure progression. This pharmacokinetic half-life is approx 30 hours. Viability is 93% when taken with food. Plasma protein is very high, 98%, so not removed by hemodialysis. It is metabolized mainly through the liver and excreted through the urine and feces. There is no specific antidote for this toxicity. Side effects are mainly due to vasodilatation in the form of symptomatic hypotension, syncope, headache, postural dizziness. GI symptom is mainly due to smooth muscle relaxation in the form of diarrhea, nausea, and discomfort. One of the outcome of Victoria trial is anemia, but the cause was not known, and there was no association with the treatment of this versigouat. Most probably this was due to the hemodilution, or the patient which was enrolled in this Victoria trial where is having worsening heart failure. That is in the most of the patient having high volume overload, and that leads to also decreased absorption of iron. So the cause of anemia probably due to the heart failure per se. What are the starting dose and titration? Start 2.5 milligram orally with food. It should be used in stabilized heart failure. Never used versigouat in hospitalized patient with sign and symptom of heart failure which required IV diuretic therapy. And it should be started at least 24 hours from shifting from IV diuretic therapy to the oral diuretic therapy. It should be used in systolic BP at least 100 mmHg. GFR should be more than 15 ml per minute per 1.73 centimeter. Dose should be increased at every 2 weeks and up to a maximum tolerated dose. Target dose is 10 milligram. And a special caution should be used in case of concomitant use of phosphodiesterase inhibitor or long nitrate because of the risk of hypotension. There are 3 main concerns for starting any new drugs in heart failure. These are blood pressure, renal function, and potassium level. So finally, drug dose modification criteria is never use this if BP is less than 90.
Please
and
conclude.
It should be used if BP, at least systolic BP more than 100 mHg. Indication, adult patient with stage C heart failure following hospitalization for worsening heart failure, and contraindication as concomitant use of diuretics, nitrates, phosphodiesterase inhibitor, pregnancy, hypotension, and severe hepatic impairment. This is the famous Victoria trial, which shows that annual event rate is less in comparison to the placebo, and also they compare the previous landmark heart trial, paradigm heart failure, DAPA, Emperor, and Galactic. And one of the peculiar findings is that they enroll the patients having more recurrent hospitalization and worsening heart failure, and the benefit was comparable to that of all landmark trial.
Anup.
And the most of the patient was benefited which have NT-proBNP level is less than 8,000 picogram, and the hypotension is relatively less, approx 1 to 2 milligram.
Dr. Anup, you can conclude, Hana? We are running short of time.
Plus 1 to 2 slide. And the study shows that there is very little effect on the renal function and electrolyte. And the this Victoria trial included the worsening heart failure patient having low, not very high NT-proBNP level. Patient is already on quadruple therapy, having neutral effect on the systolic blood pressure, renal function, and kalemia, and it acts as a facilitator role for GDMT. So do not use versigouat after multiple worsening heart failure as a last resort, but already after the first worsening heart failure. It is class 2B indication and does not decrease the mortality. Thank you.
Ashish Jha, please finish your talk in 5 minutes.
So thank you once again, organizers, for giving me opportunity to speak on Finrenon. I know this is the last topic. I will skip through most of the slides. So Finrenon mainly used in diabetes with CKD patients. We will not go into the diagnosis of diabetes with CKD. One thing I would like to tell you that how Finrenon is different from other mineralocorticoid receptor antagonists. It's more potent. It has less chance of causing the breast-related side effect, and there is a lower rate of hyperkalemia. So there are basically 3 main trials: Fidelity, which is a pooled analysis of Fidelio and Figaro, which both studied the renal outcome and cardiovascular outcome. So what it saw, the Fidelity outcome was that there is some 14% relative risk reduction in the cardiovascular endpoint, but always remember that this was mainly due to the decrease in hospitalization for heart failure. Composite kidney endpoint was decreased by 23%. So this is just the same thing. And then it was seen that with cardiovascular outcome and with the renal outcome, irrespective of ASCVD, LVH patient developed benefit in both these studies. So this is almost the same thing, Figaro and Fidelity. The confidence was study used Finrenon along with SGLT2 inhibitor, and they showed that along with SGLT2 inhibitor, the decrease in UACR was much more. The additive effect of Finrenon along with the dapagliflozin or empagliflozin. Empagliflozin was used in this trial, and it was up to 52%. So what is the approved indications for Finrenon? This is the important thing. So Finrenon is indicated in adult patient with CKD associated with type 2 diabetes mellitus to reduce the risk of eGFR decline, end-stage kidney disease, cardiovascular death, non-fatal MI, and most importantly for a cardiologist, hospitalization for heart failure. These are the indications at present. We now have Fine Arts trial which has showed that Finrenon is also beneficial in patients with ejection fraction of more than 40%. With mildly reduced and even with a preserved ejection fraction, Finrenon is beneficial. The guidelines has not come up yet, but it might come in future. So these are the recent clinical guidelines from all major societies. A patient of CKD with type 2 diabetes mellitus, combination of drug therapies are 3 pillars: RAS inhibitor, Finron, and SGLT2 inhibitor. One thing we should know that how to manage hyperkalemia. Finrenon is started only when the potassium level is less than 5, and we have to start at a dose of 10 mg if the eGFR is 25 to 60. Start at the dose of 20 mg if eGFR is more than 60. Monitor serum potassium at 1 month, 4 months, and then 4 monthly thereafter. If serum potassium remains less than 4.8, increase it to 20 mg. If it is less than 5.5, then 10 or 20 mg. If it is more than 5.5, then stop, and then again re-challenge after 1 to 2 weeks. So with this note, the key takeaway, guidelines recommend both eGFR and UACR testing at least once annually for comprehensive CKD screening. Early stage CKD management is frequently missed, yet appropriate intervention can slow or halt the disease. Despite standard RAS blockade and SGLT2 inhibitor, patients remain at significant risk for CKD progression. Mineralocorticoid receptor overactivation drives inflammation and fibrosis, representing a key therapeutic target for CKD progression. Finrenon targets MR overactivation and effectively slows both heart and kidney progression in type 2 diabetes mellitus. Finrenon demonstrates efficacy in slowing CKD, preventing cardiovascular event with good tolerability across all CKD stages. Thank you.
For finishing in time, I request the organizers to prepare for the organizing inauguration ceremony. And please be seated. Please don't roam around. Daveshji, please ask everyone to sit.
And I would request our audience sitting behind, please maintain silence during inaugural ceremony. It will take hardly a couple of minutes for the preparation of a stage.
Hello, hello, mic check, see, mic check. Hello, hello, hello. Check, check, mic check, mic check. Hello. हो गया. Hello, hello, mic check, 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 check. Hello, hello, check, mic check.
Hello, hello, hello.
Hello, check. Hello, check. Check.
Hello, hello.
Hello. Hello, check. Hello, check. Check, check.
Hello, 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 hello.
Hello, hello.
अस्तोमा सदगमय आज दिन भर the whole day was very educational, enlightening, informative, illuminating and edifying experience for all of us. The CSI Cardiological Society of India Bihar chapter celebrates its 31st annual conference. कार्डियोलॉजी की उन्नति और इसको शिखर पर बिहार प्रदेश में पहुंचाने में कार्डियोलॉजिकल सोसाइटी ऑफ इंडिया, इनके सदस्यों, बिहार सरकार और कई एनजीओ का प्रयास है कि आज नवीनतम तकनीकों से कार्डियोलॉजी के इलाज इस प्रदेश में ही हो रहा है और प्रदेश से बाहर जाने वाले मरीजों की संख्या में गिरावट आई है। तो आइए इस खुशी को दुगना करने के लिए आज हमारे बीच उपस्थित हैं मुख्य अतिथि के रूप में प्रदेश के जाने माने चिकित्सकों के पितामह, भारत सरकार के पूर्व स्वास्थ्य मंत्री और कालाजार में अपनी विशिष्ट पहचान पूरे विश्व में बनाने वाले पद्म भूषण डॉक्टर सीपी ठाकुर सर। सर, आपका तहे दिल से स्वागत है और मैं ऑर्गेनाइजिंग चेयरमैन डॉक्टर वीपी सिन्हा साहब से अनुरोध करूंगा कि ठाकुर साहब को स्कॉट करके स्टेज पर लाएं और दीपक ठाकुर जी, आपसे अनुरोध है कि पिताजी के साथ साथ आप रहें और ख्याल रखें इनका। सर, आपका आशीर्वाद हम पर, पूरी चिकित्सा जगत पर बनी रहे, यही कामना है। और खुशी बढ़ती है जब हमारे बीच सरकार के वरिष्ठ ब्यूरोक्रेट आईएएस श्री लोकेश कुमार सिंह, जो अभी स्वास्थ्य सचिव हैं, उपस्थित हैं और गेस्ट ऑफ ऑनर के रूप में आपका स्वागत है। सर, डॉक्टर श्री लोकेश जी यंग और एनर्जेटिक हैं और इनका प्रमाण मिला था जब हमने कोविड के टाइम में, जब ये बिहार राज्य स्वास्थ्य समिति में थे और मैं एम्स में कोविड सब काम छोड़ के, सारी स्पेशलिटी छोड़ के हम लोग कोविड का इलाज कोविड के लिए समर्पित थे और तब इनकी क्षमता का उपयोग हुआ और देखने में लगा कि कितनी जो इनकी एडमिनिस्ट्रेटिव कैपेबिलिटी है वो हम सबको सीखने लायक है। तो मैं अपने ऑर्गेनाइजिंग सेक्रेटरी डॉक्टर अशोक कुमार से कह रहा हूँ कि श्री लोकेश कुमार सिंह जी को स्कॉट करके स्टेज पर लाएं और हमारे इस सीएसआई की जान हमारे प्रेसिडेंट डॉक्टर के बरुण सर, आप और मैं आशीष झा, डॉक्टर आशीष झा से अनुरोध करूंगा कि डॉक्टर के बरुण को स्कॉट करके स्टेज पर लाएं। फिर इस कार्यक्रम की रूपरेखा तैयार करने वाली साइंटिफिक कमेटी, उसके चेयरमैन डॉक्टर निशांत त्रिपाठी, आप स्टेज पर आएँ। डॉक्टर लक्ष्मी सिन्हा, असिस्टेंट प्रोफेसर CTVS, आपसे अनुरोध करता हूं कि उनको स्टेज पर लाएं। सुनील कुमार सर शायद नहीं हैं। अभी हमारे बीच PMCH के डायनेमिक मेडिकल सुपरिटेंडेंट सर्जरी के प्रोफेसर डॉक्टर IS ठाकुर मौजूद हैं। मैं डॉक्टर अमीर सोहेल से अनुरोध करूंगा कि सर को, डॉक्टर IS ठाकुर को स्टेज तक स्कॉट करके लाएं। हमारे वरीय सदस्य CSI के सीनियर कार्डियोलॉजिस्ट सूबे के जाने माने यहाँ उपस्थित हैं। तो मैं अनुरोध करूँगा कि हमारे इमीडिएट पास्ट प्रेसिडेंट डॉक्टर अरविंद कुमार हैं यहाँ, आप आए। डॉक्टर आमिर, आप इनको स्कॉट करके वहाँ पर। हमारे वरिष्ठतम CSI के सदस्य जो सूबे नहीं पूरे देश में प्रख्यात हैं और लोग बड़े शान से कहते हैं कि हम वहीं पर कार्डियोलॉजिस्ट हैं जहाँ पर डॉक्टर SS चैटर्जी हैं। तो डॉक्टर SS चैटर्जी सर से अनुरोध है कि आप भी स्टेज पर आएँ। डॉक्टर लक्ष्मी, प्लीज़ उनको स्कॉट करके आप ले आइए। और हमारे नेशनल CSI के वाइस प्रेसिडेंट रहे, हमारे CSI बिहार चैप्टर के प्रेसिडेंट रहे, IJMS के पूर्व कार्डियोलॉजी के अध्यक्ष डॉक्टर VP सिंह सर, आप स्टेज पर आए। डॉक्टर आमिर, आप उनको स्कॉट करके ले आए। IJMS में आज जो स्वरूप है कार्डियोलॉजी का, उसको बढ़ाने में वीपी सिंह साहब का बड़ा योगदान है। मैं वॉलंटियर से अनुरोध करूंगा कि हमारे सारे डायस पर वरिष्ठ जनों का बुके देकर गुलदस्ता से फूल से स्वागत करें। CSI के सेक्रेटरी, डायनेमिक सेक्रेटरी श्री डॉक्टर UN सिंह, आप स्टेज पर आएं और गुलदस्ता फ्लोरल बुके देकर हमारे प्रेसिडेंट को, आप इधर से हैं सर, UN सिंह सर, आप इधर से हैं। आप के वरुण सर का स्वागत करके अपना स्थान ग्रहण करेंगे। डॉक्टर निशांत त्रिपाठी, डॉक्टर निशांत त्रिपाठी, डॉक्टर IS ठाकुर सर का, डॉक्टर SS चैटर्जी सर का, डॉक्टर UN सिंह का। और आप सभी गेस्ट से अनुरोध है कि अब माँ सरस्वती का आह्वान करने के लिए दीप प्रज्वलित करके औपचारिक रूप से इस समारोह का उद्घाटन करें। डॉक्टर CP ठाकुर सर, श्री लोकेश सर, बाहर आ जाइए। तमसोमा ज्योतिर्गमय। अब इसके बाद कार्यक्रम का फॉर्मल शुरुआत करते हुए मैं ऑर्गेनाइजिंग चेयरमैन डॉक्टर VP सिन्हा सर, एक्स प्रोफेसर कार्डियोलॉजी PMCH, आपसे अनुरोध करता हूं कि अपना वेलकम एड्रेस दें।
सभी लोगों को मेरा नमस्कार। ऑनरेबल एक्स मिनिस्टर पद्म भूषण and most important our teacher Dr. CP Thakur sir, our chief guest and Principal Secretary Health Department Sri Lokesh Kumar Singh sir, President CSI Bihar Chapter Dr. K. Barun, President Scientific Committee Dr. Nishant Tripathi, Secretary BS at Bihar CSI Dr. Upendra Naran Singh, Organizing Secretary Dr. Ashok Kumar, Senior Faculties Dr. SS Chatterjee, Dr. BP Singh, Dr. Arvind Kumar, and our dynamic superintendent, Dr. I.S. Thakur, other guests and dignitaries and members present in the hall, and our students who are the budding cardiologists present in the hall. It is my immense pleasure to welcome you all in this grand occasion. We organized one CSI state chapter conference and one at national level national conference. Both are like our annual Tirth Yatra. We collect here, we discuss, we teach, we are taught, we update, we are updated with all recent developments in the field of cardiology. We discuss the harm, benefits, and various pitfalls of the newer research. We formulate a strategy for the benefit of the ailing humanity. We discuss various preventive and curative measures. Our present team has also formulated an academic feast for the upliftment of the knowledge of our members. It will nourish and nurture our skills. I again welcome all the dignitaries on the stage and in the hall. We are encouraged with their august presence. I hope this endeavor will prove a boon for the members of the society. Long live CSI. Thank you.
बहुत शुक्रिया सर। अब जिन्होंने बड़ी मेहनत की है साइंटिफिक कार्यक्रम को, इतना यूज़फुल साइंटिफिक कार्यक्रम को बनाने के लिए तारीफ़ करनी चाहिए डॉक्टर डॉक्टर त्रिपाठी। हाँ।
Good evening, everyone. Respected Padma Bhushan Dr. C.P. Thakur sir, Mr. Lokesh Kumar sir, dignitaries on the dais, all the faculties, delegates, and friends. So the scientific program, when we were planning, we were like, cardiology is an ever-evolving field, and technology has made it even more and more, futuristic, and so much of information is coming each day and each day and out. And then there are so many cardiologists, young cardiologists who have joined. You will be surprised to know that in Patna itself, I think there are almost 90 to 100 cardiologists. There are 20-25 cath labs. Not only in Patna, now in various parts of Bihar, new centers are coming up, new cardiologists, budding young cardiologists are coming up. So my focus while devising this scientific program was to give a stage to show that we are no less than any other state, and all these guys are skillful, they are very good. So my purpose was to go with the theme of vocal for local. So, and most of them have done a wonderful job. It has been a very hectic day. It was a very tight schedule, but I must thank all the faculty who have, we are here like from 9 in the morning, even the senior physicians. I must thank our senior respected Chatterjee sir, Pramod sir. They have been like in 9 in the morning, and it has been a wonderful thing. At the same time, we also would like to thank the faculties who have come from Chennai. Dr. Ulhas is here, who agreed to come here on a very short notice. And then there are so many other faculties who come from Calcutta, Bangalore, and Delhi. And this session will continue tomorrow also. And thank you very much.
बहुत धन्यवाद डॉक्टर निशांत त्रिपाठी। मैं बार बार कह रहा हूँ कि बहुत अच्छा साइंटिफिक प्रोग्राम आपने बनाया। सारे लोग सूबे राज्य के दूर से आए, चिकित्सकों को बहुत लाभ हो रहा है। और अब मैं यंग कार्डियोलॉजिस्ट की बात हो रही है तो यंग डायनेमिक हमारे सेक्रेटरी डॉक्टर UN सिन्हा, जिन्होंने पिछले 2 सालों से CSI बिहार चैप्टर को बखूबी चलाया है, आपसे अनुरोध है कि आप संक्षेप में अपना सेक्रेटरियल रिपोर्ट पेश करें।
Our respected chief guest, Padma Vibhushan, Dr. C.P. Thakur sir, our guest of honor, Lokesh Kumar Singh Sahab, our superintendent, Dr. Indu Thakur sir, and all the dignitaries on the dais, of the dais, senior faculty members, delegates, and all other friends who took the pain to come over here in Patna for this scientific program. So, very good evening to all of you. It's my proud privilege and honor to present the secretary report as a CSI Bihar chapter. So, our this society is a non-profitable organization, and it helps in the development of all the members of the CSI Bihar chapter. We not only involved in the academic activity like doing the CME or doing conferences. We have done 2 conferences, one of the Bihar Intervention Council and as well as CARDICON this, which is done on the annual basis, and about 120 delegates participated in the Interventional Cardiology Conference, and more than, you can see here, 300 to 400 in the CARDICON. So, not only this, we also do the awareness program on the World Health Day. Just recently we have did the activities on that. So thank you for this on this program. Thank you all.
थैंक यू डॉक्टर युवन सिंह। अब मैं आप सब लोगों से अनुरोध करूंगा कि आपके सामने एक पुस्तक रखी हुई है। ये पुस्तक कार्डियोलॉजी अपडेट 2025, ये कार्डिकॉन के उपलक्ष्य में CSI बिहार चैप्टर ने निकाला है। ये जो बुक है कार्डियोलॉजी अपडेट, नेशनल CSI हर एक साल निकालती है। पहली बार बिहार ने और किसी भी राज्य के CSI चैप्टर ने ये CSI अपडेट बुक निकाला है। इसमें 59 चैप्टर्स हैं जो कार्डियोलॉजी, कार्डियक सर्जरी के नवीनतम टेक्नोलॉजी और प्रिवेंशन के कई चैप्टर्स इसमें इंक्लूडेड हैं। एडिटर इन चीफ हमारे ऑर्गेनाइजिंग सेक्रेटरी डॉक्टर अशोक कुमार हैं और को एडिटर्स डॉक्टर निशांत त्रिपाठी, डॉक्टर अभिनय भगत और डॉक्टर अरुंधति हैं। तो मैं आप सब गेस्ट से, अपने चीफ गेस्ट डॉक्टर CP ठाकुर और गेस्ट ऑफ ऑनर श्री लोकेश कुमार सिंह से करूँगा कि इसको रिलीज़ करें। सर प्लीज़ खड़े हो जाएं और हाथ मिलाएं। ये CSI अपडेट जो बुक है ये आज लॉन्च हुई, लेकिन ये डिस्ट्रीब्यूट हो रहा है हमारे स्टेशन काउंटर से। सारे मेंबर से अनुरोध है कि इसकी कॉपी, इसकी प्रति प्राप्त कर लेंगे ज़रूर। और अब हम अपने प्रेसिडेंट डॉक्टर के वरुण को बुला रहे हैं कि वे अपना संबोधन करें।
Respected Padma Shri, Padma Vibhushan, Professor Dr. CP ठाकुर साहब, इन्होंने एक चिकित्सक के रूप में केंद्रीय स्वास्थ्य मंत्री के रूप का भी दायित्व संभाला है। ये हम चिकित्सकों के लिए बड़े ही गौरव की बात है। और इन्होंने अपने काल में, जब ये स्वास्थ्य मंत्री थे केंद्रीय में, तो चिकित्सकों के बहुत से प्रॉब्लम को इन्होंने बखूबी सॉल्व किया। जब ये PMCH में थे उस समय भी प्रोफेसर ऑफ कार्डियोलॉजी थे और हृदय रोग से जो भी मरीज आता था इसके ये फाइनल अथॉरिटी रहते थे। इन्हीं के कहने से उसका जो होता था इलाज होता था। हमारे बीच आज पधारे हैं, स्वस्थ हैं, ये हम लोगों के लिए बहुत गौरव की बात है। ये कार्डियोलॉजी के पितामह कहे जा सकते हैं। रिस्पेक्टेड श्री लोकेश कुमार सिंह जी, जो स्वास्थ्य विभाग के प्रमुख हैं, प्रधान सचिव हैं और स्वास्थ्य विभाग में पूर्व से कार्यरत भी रहे हैं, एग्जीक्यूटिव डायरेक्टर के रूप में या हेल्थ सोसाइटी जो है उसके प्रमुख के रूप में, और जो विकट परिस्थिति बिहार में या पूरे देश में या पूरे विश्व में फैली थी, उस समय बिहार में इन्होंने कोरोना को इस तरह से कंट्रोल किया जो सराहनीय रहा। अभी काफ़ी अच्छे से हेल्थ डिपार्टमेंट में हैं, माने प्रमुख में हैं, और हम लोगों के बीच आए हैं। ये हम चिकित्सकों के लिए, न केवल सरकारी बल्कि सभी चिकित्सकों के लिए हमारे लिए गर्व की बात है। देश के कोने कोने से आए हमारे चिकित्सक जो प्रख्यात हैं, व्यस्त हैं, उन आए हैं, ये भी हमारे लिए बहुत खुशी की बात है। हमारे डैश पर अति महत्वपूर्ण चिकित्सक हैं, उन लोगों को भी हमारे बीच हैं, वो अपना समय निकालकर हम लोगों के बीच हैं इस ऑर्गेनाइजेशन के रूप में जो है काम कर रहे हैं। ये हमारे लिए गर्व की बात है। आखिर ये कार्डियोलॉजिकल सोसाइटी ऑफ इंडिया का जो हर एक स्टेट में एक ब्रांच है, अपने स्टेट में भी बिहार स्टेट चैप्टर के नाम से जाना जाता है, और हर साल वार्षिकोत्सव के रूप में जिसे स्थापना दिवस मनाया जाता है, उसी तरह से हम लोग इसके स्थापना दिवस को वार्षिकोत्सव के रूप में मनाते हैं। और वार्षिकोत्सव में कोई कार्यक्रम दूसरा नहीं करते हैं, ये कार्यक्रम साइंटिफिक ही रहता है और इसका उद्देश्य केवल एक है। हमारे बिहार के चिकित्सक काफ़ी ज्ञानी हैं, काफ़ी अनुभवी हैं, अब हर कला में निपुण हैं, तभी तो आज से दिल्ली में जो 45% मरीजों की संख्या रहती थी, 60% रहती थी, आज बहुत घट गई है। ये हमारे बिहार के हॉस्पिटल के चिकित्सकों का ही देन है और इसमें बिहार सरकार का बहुत बड़ा रोल है। यहाँ कॉरपोरेट हॉस्पिटल भी है पूरे बिहार में, बहुत से कैथ लैब खुल गए हैं और अब किसी भी तरह के इंटरवेंशन के लिए बिहार सक्षम है। 90% काम हो रहा है और पर डे काफ़ी काम हो रहा है, ये सभी लोगों को विदित है। और हम लोग का जो रिपोर्ट है, हम लोग हर एक महीना में स्वास्थ्य विभाग को भेजते रहे। ये बिहार स्वास्थ्य विभाग का देन है कि हम लोगों को कोई प्रॉब्लम होता है 24 घंटे के भीतर में उसको सॉर्ट आउट कर दिया जाता है। ये हमारे लिए सौभाग्य की बात है। और हमारे इंदिरा गांधी हृदय रोग संस्थान के चिकित्सक, जो किसी भी कॉरपोरेट हॉस्पिटल से अच्छा है, खराब नहीं है, वहाँ भी हमारे चिकित्सक बहुत ही अच्छी ढंग से काम कर रहे हैं। ये बिहार सरकार स्वास्थ्य विभाग की कृपा से है, उनका सहयोग है और हम उनके आभारी हैं। मैं अब विशेष समय नहीं लूँगा, मैं यही कामना करूँगा कि हमारे स्वास्थ्य विभाग के जो प्रमुख यहाँ आए हैं, हम लोगों का जो है, जो भी चिकित्सा के क्षेत्र में जो कार्डियोलॉजी का क्षेत्र इतना आगे बढ़ गया है कि आज दिल्ली में जो मैक्स है, स्कॉट है, एम्स है, सब जगह जो है आप पता लगा लें कि रेफरल पॉलिसी बहुत कम रेफर होता है, वो बहुत संख्या घट गई है। ये आपके सहयोग से है सर, और बहुत बहुत धन्यवाद। आप हमारे बीच पधारे, इसके लिए हम आपके आभारी हैं। हम कार्डियोलॉजिकल सोसाइटी ऑफ बिहार के चैप्टर की ओर से आप मुख्य अतिथि एवं विशिष्ट अतिथि का तहे दिल से आभार प्रकट करते हैं। धन्यवाद।
धन्यवाद सर, आपने सही कहा, कोई एक सिस्टम पूरे जनता के स्वास्थ्य की सेवा नहीं दे सकता। इसलिए सरकारी क्षेत्र हो या निजी क्षेत्र हो, दोनों अस्पतालों का बहुत महत्व है और सब मिल के काम कर रहे हैं, तब आज इस स्थिति में पहुँचे हैं कि अब कार्डियक सर्जरी के लिए सारी चीज़ें इसी प्रदेश में हो रही हैं और ये एक खुशी का वातावरण फैला है। सब यहाँ उपस्थित हैं, चिकित्सक हैं, फिजिशियंस हैं, कार्डियोलॉजिस्ट हैं, कार्डियक सर्जन हैं, हमारे ड्रग्स ट्रेड के प्रतिनिधि हैं, प्रेस एंड मीडिया के लोग हैं। सब लोगों ने मिलकर एक लाइव संचार किया है। तो हम चाहते हैं सब की तरफ से, CSI की तरफ से, हम सारे जो हमारे मुख्य अतिथि, सम्मानित अतिथि और हमारे सीनियर बैठे हैं, सबका हम CSI की तरफ से सम्मान करें। तो मैं आज के साइंटिफिक चेयरमैन निशांत त्रिपाठी से अनुरोध करूंगा कि हमारे मुख्य अतिथि पद्म भूषण डॉक्टर CP ठाकुर सर का शॉल और मोमेंटो देकर स्वागत करें। ऑर्गेनाइजिंग सेक्रेटरी डॉक्टर अशोक, आप प्लीज आपको तुम भाषण करेंगे, आप श्री लोकेश जी का स्वागत करें शॉल और मोमेंटो देके। CSI की तरफ से एक छोटा सा उसके बाद डॉक्टर के वरुण, निशांत त्रिपाठी, श्री VP सिन्हा सर का, डॉक्टर अशोक, आप डॉक्टर UN सिंह का, IS ठाकुर सर, डॉक्टर अरविंद कुमार, निशांत त्रिपाठी, डॉक्टर SS चैटर्जी, डॉक्टर VP सिंह, डॉक्टर अशोक, डॉक्टर VP सिंह का स्वागत करें। फेलिसिटेशन के बाद एक और फैसिलिटेशन है सर, हम लोग इस बार लाइफ टाइम अचीवमेंट अवार्ड दे रहे हैं। तो लाइफ टाइम अचीवमेंट अवार्ड देने के लिए पहला मैं बुला रहा हूँ श्री डॉक्टर अजीत प्रधान सर का। अजीत प्रधान जो राज्य के अग्रणी कार्डियक सर्जन हैं, इनके बारे में इस समारोह में बताने की ज़रूरत नहीं। इन्होंने पहली दफ़ा कार्डियक सर्जरी की शुरुआत की थी अपने जीवक हार्ट हॉस्पिटल में और उस समय से कार्डियक सर्जरी की एक लंबी यात्रा चली है, जो हम आज इस मकाम पे पहुंचे हैं कि अभी पटना में ही 5-6 जगह पे कार्डियक सर्जरी हो रही है, निजी क्षेत्रों में और कार्डियक सर्जरी में। डॉक्टर अजीत प्रधान सर अविभाजित बिहार में RMCH, अब जो रीम्स है उसके ग्रेजुएट हैं, एलुमनाई हैं, और इन्होंने फिलीपींस में अपनी कार्डियक सर्जरी की ट्रेनिंग ली और वहाँ से आने के बाद राज्य की सेवा में, राज्य के लोगों के लिए हार्ट के ट्रीटमेंट के करने में समर्पित हो गए। चिकित्सा के साथ साथ कला में भी इनका बड़ा योगदान है और हमेशा ये नहीं ये नहीं रोल यही है, सेम चीज़ है। हाँ सर, डॉक्टर अजीत प्रधान सर, आपसे उम्मीद है कि आप, अनुरोध है कि आप स्टेज पर आ जाएं। आ जाइए सर। अजीत प्रधान सर, आप स्टेज पर आ जाएं। सेटिसन है मेरे पास, आप सर आप वहाँ बैठिए। आज लाइफ टाइम अचीवमेंट अवार्ड से सम्मानित डॉक्टर अजीत कुमार प्रधान is a cardiac surgeon at Jeevak Heart Hospital, son of late Sri Pradhan Jwala Prasad and late श्रीमती रमा प्रधान। मैं बता दूंगा कि आज इनका मन भारी है, हम सब इनके साथ हैं। इनकी माताजी का 3 दिन पहले ही देहांत हुआ है और इस घड़ी में वे यहाँ आए हैं। Has a very unique attributes to his personality, his passionate and unrequited love for Bihar. After finishing his training at Philippines Heart Institute, Manila and Royal Melbourne Heart Hospital and Royal Children's Hospital, Australia, he left the luxurious shores of Australia and come to Bihar to establish the first cardiac center in undivided Bihar at Patna, Jeevak Heart Hospital in 1998, where he performed the first cardiac surgery in Bihar, set up the first cath lab in Bihar and established a fully equipped ICU and showed to the people of Bihar that very high-end medical procedures can be done in Bihar. The busy cardiac surgeon, after performing almost 13,000 cardiac surgeries, not only takes care of broken heart with his scalpel, but also decode them through Firak Gorakhpuri and Faiz poetry, and also with the singing of Kishori Amonkar. He handles his love for cardiac surgery and cultural activity with equal passion and established the Navaras School of Performing Arts in 2009. His passion to revive the art of Hindustani classical music in Bihar is second to none and has borne fruit much to the delight of all Biharis. Navaras has conducted more than 154 events in Patna and 5 events in national capital, including the first Patna Literature Festival in 2013, followed by 2 more editions of Patna Literature Festival, which has participation of renowned authors and poets of national and international fame, and also country's first festival of literature on music. His weekly online Hindustani classical music concerts on Facebook weekly for 1.5 years during COVID era was a unique endeavor to help the artists all over the country, a feat which brought him to national level. Dr. Pradhan's write regularly on art and culture, and his articles has appeared as cover story in Outlook. He has transliterated a 100-year-old Urdu Mahabharata by Tarayam Shayan, 500 pages book, which is in publication at the moment. He is a founding member of Society of Minimally Invasive Cardiac Surgery of India and member of European Association of Cardiothoracic Surgery and fellow of Society of Cardiothoracic Surgeons of India. Now it's my privilege to present this Lifetime Achievement Award, which has already been given to him by the chief guest. Would you like to say a few lines? I know your
बहुत बहुत शुक्रिया इस इज़्ज़त अफजाई का। मैं बहुत बहुत शुक्रगुजार हूँ, मशकूर हूँ कार्डियोलॉजिकल सोसाइटी ऑफ इंडिया का, जिन्होंने मुझे इतना बड़ा ऑनर दिया है। आपकी इजाज़त से मैं मुख्तसर में एक छोटी सी कहानी सुनाना चाहूँगा। ये करीबन काफ़ी साल पहले की बात है, 28 साल पहले एक डरा हुआ सहमा हुआ लड़का इंडिया वापस आया with the sole purpose of starting cardiology and cardiac surgery in undivided Bihar. उस वक्त बिहार में कार्डियोलॉजी कार्डियक सर्जरी तो नहीं, एक वेंटिलेटर तक भी नहीं था। मैं आया तो यहाँ ज़रूर लेकिन घबराया कि आखिर पैसा रेस कहाँ से करें। पूरे प्रांत अनडिवाइडेड बिहार में कुछ नहीं था। तो किसी ने मुझे बताया कि एक बहुत बड़े डॉक्टर हैं, बहुत वो कॉर्पोरेट हॉस्पिटल्स वगैरह शुरू किया है उन्होंने, आप उनसे जाके मिलिए। मैंने अपने पिताजी स्वर्गीय प्रधान ज्वाला प्रसाद से कहा कि आप भी मेरे साथ चलिए। पापा कहे कि देखो मैं तुम्हारे साथ जाऊंगा तो इक्वेशन ही चेंज कर जाएगा, तुम अकेले जाओ मिलने। लेकिन एक बात का ध्यान रखना, जब ये बड़े लोगों से मिलने जाते हो ना, इसके पहले कि वो तुमको निकलने के लिए कहें, उनके बॉडी लैंग्वेज से समझ करके छोड़ दिया करो रूम। तो मुझे बहुत मुश्किल से लेकिन मुझे चांस मिल गया उनसे मिलने के लिए। समय पर मैं पहुंच गया। उनकी सेक्रेटरी ने मुझे देखा और कहा कि अच्छा आपको 5 मिनट का समय दिया है, तो सर को बहुत सी मीटिंग है। मैं अंदर गया, देखा मेरे आने के पहले चाय रखी हुई थी। वो उस वक्त भी समय नहीं बर्बाद करना चाहते थे कि चाय आने में समय लगे। मैं गया, यंग था उस वक्त, ये 28 साल पहले की बात है। ऊपर से नीचे उन्होंने मुझे देखा, जीन्स पहने हुए था, दाढ़ी मूछ नहीं थी उस वक्त। तो शायद वो सोचा कि शायद नौकरी वोकरी मांगने आए हैं उनके अस्पताल में। कहा कि देखा हो गया, अच्छा आप कार्डियक सर्जन हैं? जी। कहे कि क्या आपकी मैं सेवा कर सकता हूँ? मैं कहा कि देखिए मैं बिहार में, जहाँ पर अभी एक भी कार्डियक सेंटर नहीं, मैं कार्डियक सर्जरी का सेंटर इस्टेब्लिश करना चाहता हूँ। Well, there was a smoke in his face and he said कि कार्डियक सर्जरी बिहार में इस्टेब्लिश करोगे? जी से मैं सोच रहा था, उस वक्त बिहार काफ़ी लॉलेसनेस के लिए काफ़ी फेमस था, काफ़ी परेशानी थी उस वक्त बिहार में। तो फिर उन्होंने मुझसे पूछा कि कितना पैसा है तुम्हारे पास? तो आई जस्ट मम्बल्ड समथिंग एंड उन्होंने कहा कि यू कांट स्टार्ट अ कार्डियक सेंटर लाइक अ बेगर। अब उन्होंने ऐसे हाथ किया, मुझे पापा की बात याद आ गई कि इसके पहले कि तुमको निकलने के लिए कहें, उठ जाओ। मैं उठ गया और दरवाजे के पास जाने लगा। तब मैंने पलट करके उनसे पूछा कि सर, बट व्हाट इफ अ बेगर हैज अ ड्रीम? ही टोल्ड मी कि डॉक्टर प्रधान, you should realize the difference between dreams and reality. तो हम कहे कि जी बहुत बहुत शुक्रिया। मैं जानना चाहूँ कि सर आप उर्दू से वाकिफ़ हैं, तो मैं एक आपके शेर नज़र करता हूँ। कहे क्या? कहे कि मंजिल तो मिल ही जाएगी भटकते ही सही, मंजिल तो मिल ही जाएगी भटकते ही सही, गुमराह तो वो है जो घर से निकलते ही नहीं। तो उन्होंने कहा कि अच्छा डॉक्टर प्रधान, आई विश यू ऑल द सक्सेस, आई होप यू फाइंड योर मंजिल। मैं चला आया। उसके बाद काफ़ी मुश्किल के साथ मैंने जीवक हार्ट हॉस्पिटल स्टार्ट किया। जैसा बता रहे थे संजीव, पहला कैथ लैब बिहार का स्टार्ट किया, पहला एवरीथिंग वाज स्टार्टेड देयर, फर्स्ट एंजियो, फर्स्ट बाईपास सर्जरी, एवरीथिंग। इत्तफाकन मुझे उनसे फिर से मिलने का मौका मिला 8 साल बाद। एक पार्टी में मिला, किसी ने परिचय कराया कि ये पायनियर हार्ट सर्जन है बिहार के। तो उन्होंने हमको देखा, फिर कहा कि बिहार में हार्ट सर्जरी होती है? हम कहे जी सर, 8 साल पहले शुरू किया। फिर हमने कहा कि सर हम आपसे मिल चुके हैं। तो उन्होंने पहचाना नहीं। हम कहे सर आप तो मेरे से लोग से तो हर दिन मिलते होंगे, लेकिन मेरे जहन में, मेरे दिल में, मेरे दिमाग में बैठा हुआ है कि मैं आपसे 23 जून को मिला था 2:55 में। तो कहा कि अच्छा। क्योंकि जी सर आपने मुझे विशेस भी किया था कि मे यू फाइंड योर मंजिल। तो उन्होंने कहा कि ओह मंजिल वाले डॉक्टर हो? हम कहे जी एंड डिड यू फाइंड योर मंजिल? हम कहे सर आपकी दुआओं से मंजिल भी मिल गई, हार्ट सर्जरी भी स्टार्ट कर दिया। तो मेरी तरफ से देखे, फिर कहे कि क्या कर रहे हो बिहार में? सुनता है बहुत लॉयलिस्टनेस है, किडनैपिंग होती है, वो होती है, ये होती है, चले आओ मेरे साथ, चले आओ मेरे हॉस्पिटल में चले आओ। हम कहे कि सर मैं आपको एक शेर सुनाता हूँ, आप तो उर्दू से वाकिफ़ हैं, मैं यही अंत करता हूँ। मैं जानता हूँ कि बिहार में बहुत लॉलेसनेस है, आप जितना कह रहे हैं उससे ज़्यादा भी है। मैं आपको एक शेर नज़र करता हूँ कि वही जंगल, वही बिजली, वही सयाद का खौफ, वही जंगल है, आई नो दिस लॉलेसनेस देयर, वही जंगल, वही बिजली, वही सयाद का खौफ। सयाद का खौफ है, कभी आपका हंटर आपको मार देगा, मैंने किडनैपर ले जाएगा। वही जंगल, वही बिजली, वही सयाद का खौफ। दुनिया बदल गई तासीर नशिमा। तासीर नशिमा कहते हैं घोंसला को। मेरी तो दुनिया बदल गई, एक छोटा सा घोंसला हो गया, अपने प्रांत में स्टार्ट कर दिया, इससे ज़्यादा और क्या चाहिए मुझे। That the journey was wonderful, that it was very arduous and terrible. It was quite, I'm like, यहाँ तक हो गया था कि मेरा पैसा नहीं था, आई सोच का कि मंजिल तो मिल गई, लेकिन इतना मलाल था इस रास्ते में मैं आई हैड टू सेल ऑफ माय कार टू बाय दैट एक्स्ट्रा मॉनिटर फॉर द हॉस्पिटल। आई टोल्ड हिम गैस पाइप लाइन जो डॉक्टर्स की जानने की चीज़ नहीं है, आई एस्टैब्लिश द गैस पाइप line of my Jeevak Heart Hospital because I couldn't afford to get a third person to do it. But it was a very nice journey. And यहाँ तो सब में हमसे जूनियर ही है, एक दो लोग छोड़ के जो हमसे सीनियर है, मैं बता सकता हूँ कि the whole actually as long as you keep on with the perseverance, I think you can achieve what you want to. And I think this has been a very, very satisfying journey. And thank you, CSI, for giving me this honor. Thanks a lot.
थैंक यू सर। आपकी इस दुख की घड़ी में हम आपके जज्बात समझ सकते हैं, फिर भी आपका उत्साह प्रशंसनीय है और अनुकरणीय है। सर की माता जी का 3 दिन पहले देहांत हुआ है और इनकी मनस्थिति हम लोग समझ सकते हैं। बहुत बहुत धन्यवाद। और दूसरा लाइफ टाइम अचीवमेंट अवार्ड जो है वो डॉक्टर राजेश कुमार अग्रवाल, डॉक्टर RK अग्रवाल, जिनके परिचय को किसी भी कार्डियोलॉजी सोसाइटी में ज़रूरत नहीं है। हमें थोड़ी निराशा है कि सर अभी USA में हैं, वो खुद आ नहीं सके, तो उनके कलीग, उनके जूनियर डॉक्टर विपिन से मैं अनुरोध करता हूं कि आप आके उनका अवार्ड हमारे चीफ गेस्ट और गेस्ट ऑफ ऑनर के हाथों ग्रहण करें। डॉक्टर राजेश कुमार अग्रवाल पटना मेडिकल कॉलेज के एलुमनाई हैं। MD मेडिसिन इन्होंने PGI चंडीगढ़ से किया था, DM कार्डियोलॉजी भी चंडीगढ़ से किया था और इन्होंने उच्च डिग्री MNMS 1982 में लिया। थैंक यू डॉक्टर विपिन। आप सर तक हमारे जज्बात पहुंचा देंगे। अब समय की कमी है। हमारे गेस्ट ऑफ ऑनर श्री लोकेश कुमार सिन्हा, अच्छा सर का मैसेज है, छोटा है। अच्छा, डॉक्टर RK अग्रवाल की तरफ से एक मैसेज आया है जो विपिन पढ़ना चाहेंगे।
Thank you, sir. I have a privilege of working with him for a long time, and sir is not here, so sir has sent a message. Respected dignitaries, colleagues, and friends, I am truly humbled to receive the Lifetime Achievement Award from the Cardiological Society of India, Bihar. To be recognized by this esteemed community is one of the greatest honor of my life. This award is not just mine; it belongs to my teachers who guided me, my colleagues and students who inspired me, and above all, my patients who entrusted me with their lives and taught me the true meaning of healing. I owe a deep debt of gratitude to my family whose support and sacrifices made everything possible. Over the years, I have seen cardiology in India grow by leaps and bounds. The future of our field is in hands of next generation, and I am confident that they will take it to even greater heights. Thank you once again for this honor. I accept it with humility. Thank you.
थैंक यू डॉक्टर विपिन। और अब मैं गेस्ट ऑफ ऑनर श्री लोकेश कुमार सिंह, IAS सेक्रेटरी हेल्थ बिहार से अनुरोध करूंगा कि आप हमारे एसोसिएशन और हमारे सदस्यों के उत्साहवर्धन के लिए कुछ कहें।
इस कार्डियोलॉजिकल सोसाइटी ऑफ इंडिया बिहार चैप्टर के द्वारा आयोजित कार्डिकॉन 2025 के लिए मैं कार्डियोलॉजिकल सोसाइटी ऑफ इंडिया के बिहार चैप्टर के साथ ही इसके ऑर्गेनाइजेशन में जो लोग भी लगा है उन सभी को मैं बधाई देता हूं। बेसिकली मैं इस तरह के कार्यक्रम में पहली बार आया हूँ और ये बहुत विद्वानों की मंडली है। यहाँ के जो लोग हैं वो हमसे ज़्यादा पढ़े हैं, कम से कम MBBS, MD और सुपर स्पेशलिटी लें तो जो पढ़ने का पीरियड है तो मुझसे काफ़ी ज़्यादा है। इसलिए मैं कोई ज्ञान तो आपको दे नहीं सकता, ना आप स्वीकार करेंगे, दोनों बातें हैं, ना तो देने की स्थिति है ना आपके द्वारा स्वीकार किया जाएगा। तो इस कार्यक्रम में उपस्थित परम आदरणीय CP ठाकुर सर का मैं अभिनंदन करता हूं। आपके बगल में बैठ कर के मंच साझा करना भी एक गौरव की बात है। आप हमारे समाज और हमारे राज्य और देश के लिए एक एसेट हैं और हम सभी को आप पर काफ़ी गर्व है। और यहाँ पर उपस्थित जितने भी हमारे कार्डियोलॉजी से रिलेटेड जितने हमारे डॉक्टर्स हैं डायस पे, कुछ लोगों ने हमारे साथ या हमने इनके साथ काम किया है। चटर्जी जी हैं, ठाकुर जी हैं, BP सिंह साहब हैं, तो मैं बहुत लोग को जानता हूं। और इसके ऑर्गेनाइजेशन में संजीव जी हैं, अशोक जी हैं। अशोक जी मेरे से बहुत पर्सनली जुड़े हुए हैं, उन्हीं के आमंत्रण पर मैं आया था। और मैं आप लोगों से यही कहूँगा, और मैं डॉक्टर प्रधान को भी बधाई देता हूँ लाइफ टाइम अचीवमेंट अवार्ड के लिए। लाइफ टाइम अचीवमेंट अवार्ड कोई एक प्रकार से आदमी अचीव करता है तो संतुष्टि का बोध है, लेकिन मेरे को लगता है कि जो आपका फील्ड है उसमें तो अनवरत आप नया नया काम करते रहते हैं और हमेशा जो आपने आज अचीव किया है कल उसे कुछ ज़्यादा अचीव करेंगे, क्योंकि वो कोई एंड नहीं है। तो मैं आप लोगों से यही आग्रह करूंगा कि सामान्यतः सरकारी फोरम में हमारे सरकारी डॉक्टर होते हैं, चाहे वो कितने पढ़े लिखे हों, इसमें भी होंगे, तो वहाँ पे जब सेक्रेटरी साहब बोलते हैं तो ऐसे ही लोग बोलता है बहुत अच्छा बहुत अच्छा, क्योंकि वहाँ का एक सेटअप अलग है। उसमें क्या है कि वो बहुत सारी चीज़ें सरकार में जुड़ी हुई हैं, डिपार्टमेंट के चक्कर हैं, बहुत सारे प्रॉब्लम्स हैं उसके कारण। पर ये जो निजी क्षेत्र में काम करने वाले चिकित्सक हैं, ये अपने दम पे अपने को आप स्थापित करते हैं। और अभी एक हमारे डॉक्टर साहब ने कहा कि यहाँ से रेफ़र होने वाले लोगों की संख्या घटी है, उसमें आपने कहा कि सरकार ने काफ़ी काम किया। तो सरकार तो एक फैसिलिटेशन का काम करती है, पॉलिसीज़ ले आती है जिससे फ़ायदा हो या हॉस्पिटल्स बनाती है, लेकिन बेसिकली इस तरह का अगर रेफरल घटा है तो इसमें योगदान हमारे डॉक्टर्स का है, हमारे सरकार से ज़्यादा हमारे डॉक्टर्स का है। और एक हमारे डॉक्टर साहब ने कहा कि कोरोना को हमने कंट्रोल किया। हमको नहीं लगता कि हिम्मत करेगा आदमी बोलने में डर के मारे कि मैंने कोरोना को कंट्रोल किया, आज भी ये कोई बोल नहीं सकता। तो कोरोना का एक काल था जिसमें सभी लोगों ने मिलकर काम किया और वो एक ऐसा समय था कि पता नहीं चलता था कि आगे क्या होगा, और ह्यूमैनिटी के वर्स्ट रूप को हम लोगों ने देखा उस समय। जब अपने जीवन पर व्यक्ति का आन पड़ता है तो सारे के सारे जो मानक हैं, सारे प्रतिमान हैं, सारी नैतिकता है वो धरी की धरी रह जाती है, और व्यक्ति किस तरह से सोचता है वो कोरोना के पीरियड ने हम लोग को दिखाया है। तो कोरोना पीरियड तो एक तरफ से हम लोगों के लिए बहुत ख़राब रहा, क्योंकि बहुत लोगों ने अपनों को खोया, लेकिन बहुत कुछ सिखा करके भी गया कि चीज़ें बहुत अस्थायी हैं। तो आदमी को गुरूर नहीं होना चाहिए और हम लोग को अच्छा काम करना चाहिए, मानवता की सेवा करनी चाहिए। तो और सरकार से जो आप लोग अच्छा करना चाहते हैं जिससे कि यहाँ के लोग कम बाहर जाएं और यहाँ का इलाज यहीं हो सके, उसमें सरकार के तरफ से क्या आपको सहयोग चाहिए, उस पर एक बात ज़रूर होनी चाहिए। क्योंकि कभी भी एक इंडिविजुअल की शक्ति और गवर्नमेंट एज ए होल की शक्ति में अंतर है। तो हम लोग एक तो डेवलप करें कल्चर समूह में काम करने का, जिससे कि डॉक्टर्स मिल करके काम करेंगे तभी एस्टेब्लिश कर पाएंगे आप बड़े अस्पताल। और आइसोलेशन में अकेले काम करने पे थोड़ा अचीवमेंट मुश्किल होगा। मैं आप सभी को बधाई देता हूं और गवर्नमेंट की तरफ से पूर्ण कोऑपरेशन का मैं आपको भरोसा दिलाता हूं। बाकी आप सभी को बहुत बहुत बधाई।
बहुत धन्यवाद सर। आपने कहा कि हम आपकी बातों को सुनेंगे नहीं, स्वीकार नहीं करेंगे, ऐसी बात नहीं है सर। हम एक दूसरे का अनुभव ही बांट करके आगे बढ़ते हैं। और आपकी प्रशासनिक क्षमता चिकित्सकों ने बहुत नज़दीकी से कोरोना काल में देखा है और हम सब उसके कायल हैं। जो आपने कहा एक सही बात कही कि सरकार एक बहुत मजबूत संस्था है और वो इंफ्रास्ट्रक्चर को और सुविधाओं को या जनता को उपलब्ध कराने में पैसे से या चिकित्सा वो समर्थ है। और हम आपसे यही उम्मीद करते हैं कि सरकार की तरफ से आप हैं तो हमारे प्रदेश की जनता को, जो आखिरी पंक्ति में भी खड़ी जो व्यक्ति है, उसको उसका कार्डियक सर्जरी बहुत महंगी है, हम सब जानते हैं, उसका लाभ मिले, इसके लिए आप प्रयत्नशील तो रहेंगे ही। उम्मीद है कि आप उस स्तर तक पहुंचाने में मदद करेंगे। और अब मैं अपने चीफ गेस्ट पद्म भूषण डॉक्टर सीपी ठाकुर से अनुरोध करूंगा कि अपने आशीर्वचनों से हमें, माइक वहीं पर सर उपलब्ध है, सर आप वहीं से बोल सकते हैं।
ठीक, थैंक यू।
आदरणीय अध्यक्ष महोदय, सारे इतने पढ़े लिखे हिंदुस्तान के बहुत डिफरेंट पार्ट से लोग आए हुए हैं, सभी भाई बहनों को सबको नमस्कार, सबको धन्यवाद। मैं पढ़ा लिखा परिवार से नहीं आता हूँ, इतिहास से आता हूँ। और बहुत दिन पहले तक बिहार में सब जगह पढ़ाई लिखाई उतनी नहीं थी और बचपन में इतना बीमार रहता था कि एक बार क्या हुआ कि वहाँ मीटिंग हुआ फॉर डेवलपमेंट ऑफ बिहार और कुछ एक्सपर्ट्स लोग आए कलकत्ता वगैरह सब जगह से। हमारे फादर भी उसमें थे, हम उसमें नहीं थे, तमाशा देख रहे थे उसका, माने यहाँ पर डॉक्यूमेंट्री कर रहे थे, यहाँ पर हम लोग 10 आदमी बैठे हुए थे। तो वो वहाँ से एक आदमी निकले, तब मेरे पिताजी को कहा कि आप इसको पढ़ाइए मत, बहुत बीमार रहता है, इसको पढ़ाइए मत, पढ़ाई में जो स्ट्रेस पड़ेगा वो बर्दाश्त नहीं कर पाएगा। हम सुन लिए। उसी बीच में हमारे फादर अपना और काम में चले गए, रात में लौटे वो, हमको बुलाए, कहे कि तुम क्या कहते हो। आज वो ऐसा बोल रहे थे कि इसको पढ़ाइए मत। हम कि कल हमको मेरा नाम लिखवा दीजिए पढ़ने के लिए स्कूल में। कहाँ पर, कौन स्कूल? तो हमके बगल का स्कूल जो है सो बहुत अच्छा है, हिंदी अंग्रेजी सब उसमें अच्छी पढ़ाई होती है, मलिकौर गांव है, तो उसमें। लेकिन हमारे फादर मान गए, अब वो लिखवा दिए, उस लोअर क्लास में नाम लिखाया। और उसके बाद से लोअर अपर से होते 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 मैट्रिक, उसके बाद ऊपर गए, उसके बाद ऊपर गए, उसके बाद ऊपर गए, विदेश गए, सब जगह गए और वहाँ से डिग्री ले लिए और उसके बाद आ गए पटना में। तो हम लोग अभी हाल में हमको एक दिन और 2-3 को हमारे दोस्त आ गए थे पढ़े लिखे। हम के भाई हमारा कॉन्स्टिट्यूएंसी है, उसमें कम से कम हम देखें कि कितना पढ़ाई लिखाई का क्या इंतजाम है और कौन इसको चाहता है कौन नहीं चाहता है। पूरे कॉन्स्टिट्यूएंसी में हम घूम गए, एक आदमी उस कॉन्स्टिट्यूएंसी से मैट्रिक पास किया था, माने अभी नहीं मैट्रिक का तैयारी कर रहा था, एक आदमी मैट्रिक पास किया था। तो हमको बड़ा ख़राब लगा कि हम लोग अगर इसको स्टिमुलेट नहीं करेंगे पढ़ने के लिए तो क्या फ़ायदा हम लोग की पढ़ाई से और हम लोग की जो इतना इधर उधर जो पढ़े हैं सब कुछ। तो हम लोग शुरू किए, क्योंकि हम दूसरे दिन गए, घर घर हम घर गए, हम इतना उसमें काम हुआ कि किसी का लड़का है 4th में है, तो हम कहे भाई छोड़ाइएगा नहीं पढ़ना, इसको पढ़ने दीजिए और जहाँ तक कि जा सके आप पैसा दीजिए। कोई जो है सो 8th क्लास में है, हमको ऐसा नहीं हो कि मैट्रिक पास हो पढ़ाई छोड़ दीजिए, सो नहीं, आप बढ़ने दीजिए इसको। आजकल के ज़माना में कोई पढ़ाई छोड़ता नहीं है। और हम लोग जब हम लोग नीरा देहात से आके पढ़ सकते हैं इतना, तो ये बच्चा काहे नहीं पढ़ेगा। तो वो पिताजी मान जाते हैं कहने पर, तो उसको पढ़ाते हैं। तो इसके लिए हम सोचते हैं कि जैसे एक गांव हुआ हमारा कॉन्स्टिट्यूएंसी का, एक गांव, तो एक गांव में जब इतनी कमी मैंने देखी, तब हम सब समझते हैं कि पढ़ाने के लिए आप लोग सब बड़े बड़े आदमी हैं, सब एजुकेटेड आदमी हैं, तो आप लोग भी अपने कॉन्स्टिट्यूएंसी में जा कर के देखिए कि आपका कॉन्स्टिट्यूएंसी में अगर पढ़ाई लिखाई नहीं हो रही है तो उसको आप कैसे मदद कर सकते हैं। एक चीज़ और है उसमें, एक चीज़ और दिमाग में लगाना होगा कि हमको फाइनेंशियल मदद भी इसको कर सकते हैं कि नहीं कर सकते, कि गवर्नमेंट से जाके लिखाइएगा कि भाई फलाना है, नहीं पढ़ता है, इसको नाम लिखा दीजिए, पैसा की कमी से नहीं पढ़ रहा है। ये होना चाहिए, ये होना चाहिए, हर जगह होना चाहिए, बिहार भर में। क्या है कि बिहार, हम बिहार को जानते हैं, क्या है बिहार के रहने वाले हैं, आप लोग भी सब बिहार के रहने वाले हैं। आप लोग सब लोग तो बिहार के नहीं हैं, यहाँ और जगह के भी हैं। तो इसलिए बहुत आदमी पढ़ाई पर जोर हमारे यहाँ नहीं देता है। ऐसा अगर होता तो एक आदमी के एक कॉन्स्टिट्यूएंसी में हम बीए में सब पास उस किए, वो नहीं होता। इससे हमको लगा कि अगर कुछ इसमें हम मदद करेंगे, घरे घरे हम घूम गए, जितना घर है हमारा कॉन्स्टिट्यूएंसी का, एक घर में गए आ कहे कि बच्चा को पढ़ा रहे हैं, उसको छोड़िए नहीं। ये नहीं है कि पढ़ाता है, 8th 9th में गया, सब छोड़ा दिया, 9th 10th में गया, मैट्रिक पास ही नहीं करने दिया, वो छोड़ा दिया। तो ये सब होता है। अब बड़ा गांव था वो, जिस गांव में हम गए थे बहुत बड़ा गांव था। तो भाइयों, आप तो हिंदुस्तान के डिफरेंट जगह से आए हैं, आप सभी लोग बहुत पढ़े लिखे हैं, एजुकेटेड हैं। तो कुछ ये भी होना चाहिए कि हम अपने समाज को कैसे आगे बढ़ाएंगे। हम तो बढ़ गए, पढ़ गए, और लेकिन समाज को कैसे बढ़ाएंगे, आपके इतना आपका समाज वाला नहीं सोचेगा। तो ऐसा सोचना चाहिए। ये हमारा अपने एक्सपीरियंस पर ये रिक्वेस्ट है आप लोगों से कि सभी लोग जो यहाँ बैठे हुए हैं, सब लोग अपने इलाके का भी पढ़ाई पर जोर देना चाहिए। पर हमको दुख हुआ कि एक इतना बड़ा प्रांत बिहार से हम आते हैं, हमारा क्लास में एक आदमी पहुंचा है, बस एक आदमी, वो पास नहीं किया। तो इसलिए हम लोग आए हैं, हम लोग यहाँ से कुछ इंस्ट्रक्शन वगैरह लेके जाएंगे, लेकिन वो जो समस्या जो है उसके लिए तो हम लोग कुछ नहीं करते हैं जब तक कि उसकी जानकारी नहीं हो। और आप आगे बढ़िएगा तो सरकार जो है लाजे सर में आपको मदद करेगा। माने अपने नहीं चाहता है मदद करना, तभी वो ले जाएगा कि ये आदमी हम दिखा रहा है, हम लोग कुछ किए, अब फिर उसको शुरू किए हुए, फिर जाएंगे और फिर करेंगे कि काहे नहीं पढ़ रहा है लड़का इस कॉन्स्टिट्यूएंसी का, दूसरे कॉन्स्टिट्यूएंसी में जाएंगे, अपने कॉन्स्टिट्यूएंसी से उनसे पूछ करके कैसा ना झंझट हो जाए। तो भाइयों, आज का मीटिंग बहुत अच्छा रहा, और इसमें मेरा ये रिक्वेस्ट है कि हम अपने समाज को कैसे आगे बढ़ा सकते हैं। इतना हो जाए तो बहुत बड़ा काम हिंदुस्तान में हो जाए। और एक कॉन्स्टिट्यूएंसी में एक आदमी सीपी ठाकुर पढ़े लिखे होंगे, उससे क्या होने वाला है, उसे क्या होने वाला है। कम से कम 2/3 आदमी नहीं पढ़ लिख जाए तभी एडवांस नहीं होने वाला है, डेवलपमेंट नहीं होना है। तो ये हम आप लोगों से निवेदन करते हैं कि कुछ आप लोग सेंटर में हैं और चाहें तो कुछ इस पर आप लोग भी करा दे सकते हैं अपने अपने क्षेत्र में सबको। तो बहुत अच्छा रहेगा। और इन्हीं शब्दों के साथ आप सबको धन्यवाद, सबको नमस्कार।
बहुत साधुवाद सर आपका। आपकी सक्रियता और स्फूर्ति से हम उत्साह से भर गए हैं और हमारे अंदर भी एक नया जोश आया है सर, और आपके वचनों का हम अपने जीवन में उतारने की कोशिश करेंगे, यही कामना है। और इसके साथ ही अब हम कार्यक्रम के अंतिम पड़ाव की ओर जा रहे हैं और मैं धन्यवाद सर। योगेश सर आप आए, लोकेशन दे दो ना यार, तुमको यहाँ रहना, रख दे दीजिए जाके जल्दी से। अरे आइए शिविर के बाद में जाके क्या कर दिया रवि, जा तो लोकेश जी को दे आओ, लोकेश जी को। मैं ऑर्गेनाइजिंग सेक्रेटरी डॉक्टर अशोक से चाहूँगा कि आज तो हम सब आयोजन समिति का धन्यवाद कर रहे हैं कि आपने इतना अच्छा कॉन्फ्रेंस आयोजित किया, लेकिन मैं अब आपसे अनुरोध करूंगा कि आप अपनी तरफ से CSI की तरफ से, कार्डिकॉन की तरफ से धन्यवाद ज्ञापन करें।
Good evening, everyone. As the organizing secretary, it is my privilege to deliver the vote of thanks and express my profound gratitude at the conclusion of this inspiring inauguration ceremony of CARDICON 2025. First and foremost, our deepest appreciation goes to our esteemed chief guest, Padma Bhushan and Padma Shri, Dr. C.P. Thakur sir. He is former Union Minister of Government of India. Your presence is a great honor, and your address has truly elevated this occasion and set an encouraging tone. A sincere thanks also to our respected guest of honor, Sri Lokesh Kumar Singh, Principal Secretary, Health Patna. Your commitment to public health is invaluable to the state, and we are grateful for your time and support. Society of India Bihar chapter, K.K. Varun, President CSI Bihar, Dr. V.P. Sinha sir, Organizing Chairman, Dr. Nishant Tripathi, Chairman, Scientific Committee, Dr. UN Singh, Secretary CSI Bihar, our patron, Dr. I.S. Thakur, PM, Medical Superintendent, PMCH Patna. And I would especially like to mention name of Dr. S.S. Chatterjee sir, Dr. B.P. Singh sir, Dr. Arvind sir. Thank you for your vision and guidance. My thanks also to our Master of Ceremony, Dr. Sanjeev Kumar, for guiding us smoothly through the evening proceeding. Finally, I thank every single delegate, all the dignitaries on the dais, the technical team, and the staff of Hotel Maurya for making this inaugural function such a grand success. Your presence is our greatest encouragement. Especially industry people, pharma personnel, and media, without their support, it was not possible to conduct such a meeting. I now invite you all to stand for national anthem, following which dinner will be served. Thank you once again, and we look forward to 2 days of exciting scientific deliberations. Thank you.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे